तो 10:28 तो हो ही गया है. So now this is going. So, good morning, everybody, and we'll be starting our seventh Advanced Pediatric Endocrinology Symposium. At the time is 10:30. It's going to be a big academic feast. We have lined up a lot of programs over the next 2 days, and we are also live streaming it across the various regions and countries. To kickstart the program, I'll invite the Master of Ceremony of the program, Dr. Suyesh and Dr. Kirti.
Thank you, sir. Good morning, everyone. Respected dignitaries, distinguished faculty, esteemed guests, colleagues, and dear participants and delegates. My name is Kirti, and it is my privilege to extend a warm welcome to each and every one of you for the 7th Advanced Pediatric Endocrinology Symposium. Over the next 2 days, we come together to not just attend a conference, but to celebrate curiosity, collaboration, and lifelong learning. This scientific program has been thoughtfully curated to include a wide spectrum of topics, ranging from case discussions, clinical challenges, to novel therapeutics and advancements. Whether you're looking for practical take-home messages or a glimpse into the future of our specialty, there is something for everybody. So without further ado, let us begin with our first session, Case Conundrums. To guide us through this exciting session, I invite our esteemed chairs, Dr. Vijay Jaiswal sir and Dr. Sayan Banerjee sir, to kindly take their seats. I invite Anurag Bajpayee sir to introduce the session and share its objectives with us.
Thanks a lot, Kirti, and it's a pleasure that this is our seventh program that we have been running continuously along with many other academic programs. And Advanced Pediatric Endocrinology Symposium is basically targeted towards focusing about various aspects of pediatric endocrinology, in particular about issues which are very practical and relevant, including latest developments on various fields. So for the today's program, we have got extensive faculty who have come from across the country, and there are a lot of interesting topics that we are going to cover off from that perspective. So the overall concept of Advanced Pediatric Endocrinology Symposium is to disseminate knowledge, and our motto has always been together we learn. So the aim is that all of us learn together so that we achieve good outcomes in terms of improving the care and lives of children with endocrine disorders. So over the last 15 years or so, Grow Society and Mediclasses have been working extensively in increasing awareness about pediatric endocrinology. We started off with our first practical pediatric endocrine course in 2012. And since then, we have conducted around 16 practical pediatric endocrine courses across the country. We have developed modules which have been implemented in the form of various workshops. Around 120 workshops, pediatric endocrinology for postgraduates, and 6 advanced pediatric endocrinology symposiums, which have already been conducted in that regards. We also realize that if we want to really have continuous knowledge, having these offline programs may not be sufficient. So we thought of starting off an online portal, which started around now, this was started in 2017. And since then, there has been a work going on in that regards. And for the last 8 years, we have developed various modules which have worked out in that perspective. We have developed programs including fellowship and diploma courses in pediatric endocrinology, along with various other courses, developed mobile applications for point of care management in that perspective. We are also developing personalized intelligent EMR. And off late, we are working in the field of AI and clinical decision support. We'll be discussing about that subsequently as to how it works. We have multiple publications which are there. And today we'll be launching our second edition of the Advanced Pediatric Endocrinology as well. So we will now be starting the case conundrum session. Dr. Arpita has also arrived from Lucknow. So I will invite Dr. Arpita to kindly come up and join the stage with Dr. Vijay. Dr. Vijay is a close friend and a long-standing colleague. He was there in the first practical pediatric endocrine course as well. He is currently the head of department at LLRM Meerut, and he is working in pediatric endocrinology in the region. Professor Arpita is in KGMU Lucknow, and she is also working very actively in pediatric endocrinology. And the third chairperson here is Dr. Sayan, who has been our own fellow, and he then did his DM in pediatric endocrinology from PGI Chandigarh and is currently working as a pediatric endocrinologist in Kolkata at Neotia Hospital. So welcome all of you. We are going to have 6 very interesting cases. We want to have 8 minutes for presentation and 2 minutes for discussion. So request the chairperson and the MOCs to keep the time from that perspective. So we'll start off maybe with the first one.
Thank you, sir. We have an exciting lineup of cases to discuss today. For our first case, I invite Dr. Fauzia Khan to discuss an interesting case of a newborn with persistent hypoglycemia. Over to you, ma'am.
Good morning, everyone. I'm Dr. Fauzia Khan. I am presenting the case on the persistent neonatal hypoglycemia unresponsive to diazoxide, a rare presentation. This is a case of a newborn with a late preterm 36 plus 4 week gestation delivered by elective LSCS, cried immediately after birth, no resuscitation required. History of gestational diabetic mother, birth weight was 2.28 kg, no gross congenital anomaly was seen. Hospital course. During routine glucose monitoring, the RBS was 48, but repeat RBS after 1 hour was 108. Baby shift to ward with glucose monitoring as advised in the infant of diabetic mother. At 12 hours of life, baby shift to NICU in view of low RBS, that was the 40. Neonatal hypoglycemia managed started by glucose infusion rate. GIR raised up to the 10 mg per kg per minute. In view of persistent hypoglycemia, hydrocortisone added after the 48 hours of life, and investigation serum insulin and ketone levels done, and routine workup to rule out sepsis was done. In view of raised procalcitonin, antibiotics added accordingly. Investigation summary, glucose profile and management, initial blood glucose persistently low, that is between 30 to 35, maximum GIR required up to 12 mg per kg per minute, response to glucose infusion, that is partial. Initially it was looks like he is responding to the GIR, but after 4 to 5 readings, it again go to the hypoglycemia. Hormonal and metabolic evaluation, serum insulin is 14.94 MIU per ml elevated, serum cortisol 14.13, urinary ketones absent. Sepsis and routine labs, blood culture sterile, procalcitonin mildly elevated initially, later normalized, hemoglobin 15.6, platelet 2.2 lakhs, transcranial USG abdomen, and 2D echo was all within normal limit. Baby is still showing hypoglycemia on hydrocortisone and can't taper GIR at the 5th day of dive, and then add diazoxide and taper hydrocortisone. Initially achieve euglycemia at diazoxide 5 mg per kg per day, and it is continue up to 2 to 3 days. But initially when we try to taper diazoxide, again hypoglycemia even again, so non-satisfactory result on diazoxide, plan for genetic workup. It is achieve euglycemia up at the 10 mg per kg per day on diazoxide. Genetic workup test performed, whole exome sequencing, evaluation gene involved GYS2, variant detected C73T9P ARCH 246TR, inheritance pattern autosomal recessive, final diagnosis glycogen storage disorder type 0. Follow-up, baby discharge on digoxide, later on gradually digoxide taper off, parents advise frequent sweets, avoidance of prolonged fasting, nighttime feed continuation, and home glucose monitoring. Baby is now off digoxide at 4th month of life, and baby well, and no delayed milestones and nothing any problem. On follow-up visit, baby remained euglycemic and demonstrated normal age appropriate developmental milestones. Discussion. GSD 0 is classically described as ketotic fasting hypoglycemia with postprandial hyperglycemia and typically no hepatomegaly. In this baby, we always observe that the low RBS is before feeding, and after 1 hour when we repeat RBS was taking, it was always normalized. In the seminal series by Ortho et al. At affected children presented in infancy, early childhood with fasting ketotic hypoglycemia, often severe enough to cause neurological symptoms, while feeding relieved hypoglycemia, but could precipitate postprandial metabolic derangements. This baby presented in early hour of life with severe refractory hypoglycemia, a presentation far earlier than typical childhood onset cases. Additionally, our initial biochemical profile shows hyperinsulinemia with low urinary ketones, mimicking congenital hyperinsulinism rather than classic ketotic pattern, and was diazoxide unresponsive, prompting metabolic and genetic testing. Thus, the key difference in our case is the very early onset, neonatal onset, with an initial hyperinsulinism-like phenotype, ultimately revealing as GYS2-related GSD0, highlighting that GSD0 should be considered even in neonates with persistent hypoglycemia when common etiologies and standard therapies fail. There was absence of urinary ketones during hypoglycemia. Classically, GSD0 is usually characterized by ketotic fasting hypoglycemia. However, ketogenesis in late preterm and LBW infants may be physiologically limited. Furthermore, transient hyperinsulinemic state may suppress lipolysis and ketogenesis, thereby masking the expected ketotic response. These mechanisms may explain initially non-ketotic biochemical profile in baby. Importantly, the identified GYS2 pathogenic variant present in heterozygous state, since clinically GSD0 is inherited in an autosomal recessive manner and usually requires biallelic pathogenic variants. The molecular finding alone does not fully explain neonatal phenotype. Therefore, transient neonatal hyperinsulinism related to maternal diabetes, possibly combined with underlying genetic susceptibility, may have contributed to the presentation. Conclusion, glycogen storage disorder type 0 is a rare but important neonatal hypoglycemia and may present much earlier than traditionally recognized. This case highlights that GYS2 related GS2 may present atypically in neonatal period and can mimic congenital hyperinsulinism. Early metabolic and molecular evaluation is important in persistent neonatal hypoglycemia when conventional management fails. Thank you.
Thanks, Dr. Fauziya, for a nice presentation. And yes, if any question from the house, please, you can ask. So just I want to add that this is a really very good case, and we should not be having just because in medical science there is no clear-cut line. So the symptoms and diagnosis can mimic or say mix up of that. Whatever what we have learned that persistent severe hypoglycemia symptomatic, and if there is detectable insulin, Probably you are right that probably we are dealing a probably transient case of hyperinsulinism. One. Second, that this is the era of genetic testing, and that is really required if we have not gone by this genetic testing and redig the history. If the things are not applying as per se, then we have to take again history and examination, and we have to join the link in between what is the missing link. And then probably we are going to make that up. So this was really very good, Doctor. Thank you.
Thank you, sir.
One key point here was that maybe GSD0 will not cause hypoglycemia at this age, but if you have underlying hyperinsulinism, that may predispose to hypoglycemia. So two conditions mixed out and presented like that.
Thank you. Thank you for the wonderful presentation, ma'am. So for our next case, we will be discussing an unusual presentation of DSD. I invite Dr. Namita Sahu to present this case.
Good morning to all of you. So myself, Dr. Namita, and as far as you can see my slides, it details about the DST only. So this is a case of 39-week baby. The baby has come to us at 10 day of life from a local government hospital, and the birth weight was 3400 gram, and the baby was born to a 30-year-old primary mother by LSCS, that was an elective LSCS. In antenatal history, there is nothing significant, but we have to rule out some of the negative histories over here. There are two fetal growth scans were available, but no anomaly scans were available. There is no maternal history of any virilization during pregnancy or any androgen exposure in the form of tumors or drugs. There is no history of consanguinity in the parents. Baby did not cry immediately after birth. However, we don't have any resuscitation details because the baby was born outside our hospital. And in view of birth asphyxia, baby had respiratory distress, which was hypoxic respiratory distress, and the baby needs CPAP support for 4 days. After that, baby was on room air. However, we have no HI gradings or UPGAR scores available at our site. So as I had already mentioned, outside hospital, there is a breathing difficulty, 4 days of CPAP support. Baby had feeding intolerance for first 48 hours, and the baby was started on minimal feeds by day 3. By increasing feeds gradually, baby has reached full feeds by day 7. At day 9, the baby was fully breastfeed established, and by day 10, the baby has received to our hospital for the evaluation of ambiguous genitalia. So on examination, the general examination was okay, except the external genitalia. Vitals are hemodynamically stable, except one thing, that is the BP, which was in the 95th to 99th centile as far as the neonatal Jubros chart for hypertension. Systemic examination was also normal. On genitalia examination, the phallus was short. The stretched phallic length was 1.3 centimeter. As you can see in this picture, the phallus is very short. Also, there is bifid scrotum, and you can also see there is a shawl scrotum. The scrotum is actually going over the phallus area, that is called as penoscrotal transposition or shawl scrotum. So mid-shaft diameter is 1 centimeter, which is, as far as Feldman-Smith chart, is okay for more than 36-week gestation babies. And the labioscrotal folds are fused in the posterior 2/3, but not in the anterior 1/3. Penoscrotal transposition I had already mentioned. The labioscrotal folds are rugated and having good pigmentation. Gonads, it is palpable bilaterally. In the second picture, you can see. And there is hypospadias, penoscrotal in the third picture, which is in the yellow arrow. So Prader scale, we have seen this one is almost stage 3 Prader's. And in external masculinization score, it is coming 5.5, which is very less for a male phenotype. Anogenital ratio, it is 0.69. Obviously, it is more than 0.5. It is suggestive of intrauterine androgen exposure. So after looking at this external genitalia, we have something in our mind, the bulbable bilateral gonad. So we will go for the first Mullerian structures, is there or not. We have seen the electrolytes pattern and also the sugar. Baby remains euglycemic throughout the hospital stay. And serum electrolytes, minimum sodium levels as 136, maximum 144. And potassium is minimum 3.4 to maximum of 5.1. Creatinine was normal. And the baby had hypertension, so we have started on amlodipine. And after 4 days, the BP centils has come down to 50 to 19 centile, and the medication was continued till discharge also. By the time we have also done the LH and FSH, which has come to 13.4 and 13.8 international unit per liter on the day of 11 and 12 of life. So after that, we have done an ultrasound. Ultrasound was showing a normal adrenal in size, shape, and there is no mass, and also there is no Mullerian structures. But even after that, we have done one of the MRI because of the radiologist is thinking something more. So we have gone for the MRI abdomen and pelvis. That also suggests Wolffian structures with proper cavernosa and spongiosum and bilateral testis, but no Mullerian structures. So this is the MRI, and they have done, and they have not found out any contrast enhanced lesion in the anterior superior region of the bladder, which is not suggestive of any Mullerian structure, but gonads are present inside the scrotum. So we have got the karyotype, and the karyotype was 46XY, which has already excluded some of the things, that is 46XX or chromosomal DST. CH panel we have sent. In CH panel, to our surprise, actually we have thinking in the line of CH mainly, but to our surprise, we found that the 17 OHP level was low, 0.59, and also the androstenedione ion and progesterone were low. So if we think in the line of low androstenedione ion, low progesterone, and low 17 OHP, so our probable diagnosis is going to 3 beta HST. But here the DHEAS level is not that much high. So we are in a dicey situation, probably this could be a 3 beta HST. And also we are thinking in the line of LSCG receptor defect because the testosterone is also a bit on the lower side and the LH in the higher side. So we have kept 2 things here and we have ruled out 3 things here. The 17 hydroxylase, alpha hydroxylase, in which we would have get the progesterone as high, and 5 alpha reductase in which we would have get the testosterone as high, and 17 beta HSD3 in which androstenedione would have been the higher side. So after this, we have planned to go for directly whole exome sequencing because the parents could not able to afford all those things. So whole exome sequencing, we are thinking in the line of CH, but we found something strange diagnosis like your persistent Mullerian duct with AMH gene homozygous mutation and Meres syndrome, which is SAMD9 gene, which is autosomal dominant and it is heterozygous in this condition. So now we have narrowed down our diagnosis to either PMDS or Meres syndrome. So PMDS, definitely it is of 2 types, either AMH gene mutation or AMH receptor mutation, and it is autosomal recessive, and it has a varied clinical features. Either it could be normal external genitalia or cryptorchidism, or it could be inguinal hernia presentation, or rarely it could be ambiguous genitalia, which is in our case. So after getting this report, we have thought of to send a AMH level for this child. And we found the AMH level as 24, which is on the lower normal or maybe lower cutoff. If we think of 30 as cutoff, then it is low. And in some of the biological reference, they says 23.8 or 15. So obviously, so this is a case of persistent Mullerian duct syndrome. It is our first diagnosis, but we cannot rule out even Meres syndrome because Meres syndrome is also a rare genetic disorder. It is autosomal dominant, and it is a heterozygous mutation in this case. And it also has G for genital phenotypes. Even in genital phenotypes, most of the Meres syndromes have present. There are only 40 to 60 cases in the literature for this Meres syndrome because the incidence is very less than 1 per 10 lakh. So this syndrome is usually presented with more infections and more pulmonary infections, but also presented with bicytopenia and myelodysplasia. So over and all the genital phenotypes, whatever I had come across the cases, it varies from micropenis to even ambiguous genitalia. So even this is in our second diagnosis. So this child was sent home with the antihypertensive. After 3 months of follow-up, the phallic length was around 3 centimeter. And still also the child required the antihypertensive because the child has lost to follow up for a 1 or 2 weeks, and after that the BP has increased because they have not taking the antihypertensive. So for this hypertension, we are thinking in the line of 17 alpha hydroxylase, but we didn't got in this. So 46 XY DST, obviously most of them were unclassified. So probably this case is a bit dicey, and PMDS might be the first diagnosis. Thank you.
Wonderful discussion, but I would like to make one point. See, you already mentioned that in XYDSDs, even after complete evaluation, you get the diagnosis in only 30 to 40% of the cases.
Yes, sir.
You made a mention of a diagnosis of AMH as a possible case, but I want to disagree with you on this point, is that you got an AMH of 24, but
Yes.
it was mentioned more than 24. So in this,
Yes, sir.
these,
We had confirmed from the lab. They told ki that more than sign was actually, it has printed unlikely, and it is 24 only.
okay, so no issue. But if you think of a AMH defect or a AMH resistance, where did the Mullerian structures go out? So there is,
Sir, for that also, we have talked to the radiologist. The radiologist told he had gone through the many evidences as far as their radiologist articles, and he told as the child grows, we have to repeat the MRI and we have to see again whether some Mullerian structures are there or not.
okay,
So
but-
the child is currently on follow-up.
so, but the increase in BP can't be explained with
Yes, sir.
defect.
So increase in BP, we can't explain. One thing is that the baby has having birth asphyxia, which may lead to the hypertension for at least 6 to 12 months. So we are just waiting for the last 4 months. Actually, the child was lost to follow up. So we will again follow up that case.
I think that's very important point because see, if you have a AMH problem, you should actually have Mullerian structure, but
Yes.
you should not have other atypical genitalia.
Yes.
So this picture is not fitting into that. There is a Leydig cell involvement which is there. Maybe you can think Mirat syndrome may have some of those
May have.
manifestations there, and AMH may be an incidental finding and expression issues which may be there. So I think I agree with that, but very good, interesting case. And this brings us the importance of genetics and how it can confuse us also in most cases.
Yes, sir. As because the incidence of PMDS is almost like there are only 300 cases noted in the literature. So it is more common than Mirror syndrome, which is only 40 to 60 cases. So we have given our first diagnosis as PMDS. Thank you, sir. Thank you, sir.
Thank you, ma'am, for taking us through the nuances of DST. Our next case explores a condition that we encounter frequently in our practice, but with an unexpected twist. I invite Dr. Medha Mittal, ma'am, to present this case.
These are बहुत different है
चेंज करेंगे तो पूरा सिस्टम बोल जाएगा अभी इससे कर दो
नहीं सर बहुत different है मैं आपने कुछ ऐड किया इसको बस माइनस करके इसको प्ले कर दें
पहले तो देखी था आपने शायद लास्ट
नहीं सर रात को ही सारा किया
एक मिनट रुकिए
ये बस अक्षर
which one
Very warm good morning to each one of you. I'll present my case. Precocious puberty with growth hormone deficiency, a paradoxical situation. So the child was 10 years and 6 months when he came to us in December 24, and he complained of facial hair developing for last 2 years, which means at an age below 9 years. So he was presenting with secondary sexual characters, including pubic hair and change in voice. And these changes have been gradually progressive over the last 2 years. He doesn't have acne or hair over other body parts or limbs. They didn't complain of any particular increase in the height. There was no CNS complaints in the form of headache, vomiting, visual complaints, or abnormal movements. They could not specifically tell about increase in penile or testicular size. There was no history of any intake of any long-term medication, any pigmented patches or fractures suggestive of causes of peripheral precocity. There was no generalized skin pigmentation. In the past, he had been quite stable, uneventful past with no admission, no trauma, no radiation. And the parents also did not have history of early onset of puberty. The child has been attending school and scholastic performance is good. On general physical examination, child had no dysmorphism, no craniofacial anomalies, spine was normal. Only he had facial hair and no axillary hair, no cafe au lait spots. And his growth parameters showed a weight of 0.8 st, height of -1 st as shown in the growth chart, a BMI 1.7 standard deviation with a shorter mid-parental height at -1.9 standard deviation. The corrected height standard deviation was 0.84. Looking at his rest of the examination, genital examination showed an SPL of 8 centimeter, testicular volume of 10 ml bilateral, and pubic hair 3. And the rest of the systemic examination was within normal limits. The bone age was consistent with an age of 14 years, while the child was 10 years and 6 months, so clearly advanced. His lab results were nearly normal with normal CBC, LFT, KFT electrolyte. Thyroid function test and stimulated cortisol levels were also done, which were normal. LH was very high at 12.75, FSH was 5.6, and testosterone was 4.5 nanogram per ml. The ultrasound was done to rule out precocity, peripheral precocity, and adrenals were normal. We had planned an MRI considering a diagnosis of central precocity, but it got delayed due to financial reasons. Meanwhile, we started the treatment with luprolide. Later, when we got an MRI after a few months, the child was coming to us all the way from Dehradun. So he was reported as a case of hypothalamic hamartoma, and we tried to discuss with the radiologist that this is an unlikely cause at this age. So they asked for a repeat MRI, which was again delayed. Meanwhile, the treatment was continued. Over this time, we found that the gain in height over next 8 months was only about 2 centimeter. And when the luprolide became not available in our hospital for a short time, there was a rapid gain in height of 1.5 centimeter within 2 months. So we thought of a possibility of concomitant growth hormone deficiency considering the low growth velocity. And then planned a clonidine stimulation test, and the levels were very low with the peak of only 0.337 nanogram per ml. So MRI now repeated showed ectopic posterior pituitary, a thin stalk, and slightly small anterior pituitary, consistent with the diagnosis of pituitary stalk interruption syndrome. So we had a diagnosis of central precocious puberty with growth hormone deficiency due to PSIS. The luprolide was continued and growth hormone was added, which also got delayed due to financial reasons and has been added recently. Now we know that the growth is mediated by growth hormone releasing hormone GH and IGF-1 axis, and this is the predominant regulator of the postnatal growth, and GH is increased by GHRH and while inhibited by somatostatin. And of course, other regulatory factors also regulate the growth. Any disruption of this axis of GHRH-GH would result in GH deficiency. On the other hand, puberty is regulated by GnRH, released by the hypothalamus, which acts on the pituitary gonadotrophs on the GnRH receptors. And all throughout childhood, these GnRH neurons are actively inhibiting the pituitary gonadotrophs, allowing the growth. The GnRH neurons migrate from the olfactory cord, and their migration and localization is essential to allow this inhibitory control. Now we have a paradoxical situation in this child where the GH deficiency is limiting his height and the precocity is advancing it. The bone age is getting advanced by precocity. However, both the things may compromise his final adult height. So this is a rare association of central precocity with GH deficiency, reported mainly in cases of septo-optic dysplasia, arachnoid cyst, meaning thereby there are extensive cranial abnormalities In septo-optic dysplasia, the hypothalamic connections itself are disrupted. And arachnoid says there is pressure on the hypothalamus. And so the regulation of puberty is disrupted, apart from the reduced GH secretion by the anterior pituitary. However, in our case, there are no extra pituitary abnormalities. Possibly the developmental defect that affected the anterior and posterior pituitary also affected the hypothalamus, and the defect caused the reduced secretion of GH from the anterior pituitary. And the gonadotropic axis, the GnRH axis, got activated because of possible neural disruption. Another new entity which has been described recently is the gonadotropin inhibitory hormone. It is a new key neurohormone which has been shown to not only regulate the pituitary gonadotrophs, it also interacts with the regulators of puberty like ispeptin and also influences the GnRH neurons. So possibly this pathway, if affected, can cause early activation of the pituitary gonadotropin secreting cells. Considering the previous cases which have reported septo-optic dysplasia, it has been well described that septo-optic dysplasia and arachnoid cyst may cause GH deficiency along with central precocity. Out of this report of 14 cases, 1 had central precocity apart from GH deficiency. This is another recent case which has described pituitary stalk interruption syndrome cases with GH deficiency as the first presenting sign, and they later developed central precocity. So this series of 4 patients does not have septo-optic dysplasia or arachnoid cyst and no extra pituitary abnormalities, but still having both the things. However, their first presentation was GH deficiency. In our case, the first presentation in this child was central precocity. Our child is likely to have a compromised final height considering both the situations, and this is his recent X-ray, which has shown that fusion has almost begun. So the key learning points from this case would be that any child with precocious puberty on GnRH analog therapy should be carefully monitored for height velocity, and a height velocity less than 4 cm per year may indicate concomitant GH deficiency. And consistent management of both is essential for achieving a good height outcome. Thank you.
Thank you, ma'am, for such a lucid presentation. It was a very well presented and very well worked up case. And here, as you have explained, that the precocious puberty was masking the growth hormone deficiency. We've seen a lot of other patients with septo-optic dysplasia or any tumors or presenting with precocious puberty, as you mentioned, which in this case, it was the other way. Yeah. So the house is open for discussion.
Yeah,
Comments?
question. Thank you for the interesting case. In a child, when we are seeing that it's a 14-year bone age, in a low socioeconomic, low resourceful setting like in India, would we still have advised for a growth hormone injection, considering 14 years of bone age, the height potential is not that high? Like, what do you experts suggest? Thank you.
Probably this is the last time if we can do anything about his growth. So if possibility is there, and of course the family is not going to afford, probably this is the state, probably he is going to be enrolled in RBSK or some other scheme, which they are going to, and even if it is not going to get the guaranteed consistent supply, but something is better than nothing. So at least we can add some centimeters in the final height. That was the thing behind that. But yes, this was really a very interesting case to see that it is going to be.
Thank you, ma'am, for the fascinating presentation. So our next case focuses on the world of chromosomal disorders, where even the smallest variation adds on an entirely new layer to our clinical management. It is my pleasure to invite Dr. Shweta Singh to the dais.
A very good morning, all. Today, I'll be presenting an interesting case of XXYY syndrome, a variant of Klinefelter or a distinct clinical entity altogether. So a 2-year, 6-month-old boy presented to our OPD with chief complaints of small phallus size since birth and small testicular size. On examination, his weight was 11 kg, which was between 3rd and 10th centile. Height was 86 centimeter, which was at 3rd centile. His SPL was 2 centimeter. His SMR was bilateral testicular volume 0.5 ml each, P1. Testes were firm in consistency. Hypertelorism and clinodactyly was present. Other complaints, there was hypertelorism, clinodactyly. There was delay in speech. The child had aggressive behavior. There was no history of any trauma, infection, radiation, or chemotherapy. So this was the child. The child has clinodactyly. His SPL was 2 centimeter. Coming to investigation, the child was screened for systemic diseases, which was normal. On USG whole abdomen, there were bilateral testes, 0.4 ml each. There was no Mullerian structure seen. His karyotype was done, which showed 48XXYY. Serum testosterone was 0.170 nanomole per liter. FSH was 1.41 MIU per ml and LH was 0.22. So this was his report. He had extra X and extra Y. So coming to management, we planned the patient to be started on injection testosterone at a dose of 25 milligram IM monthly for 3 doses, and parents were counseled about puberty and fertility induction. So coming to the differential diagnosis of a case of hypergonadotropic hypogonadism, it can be a case of Klinefelter's, XXDSD, systemic illness, steroidogenic defects, or any genetic cause. So coming to discussion about this case, karyotype is mandatory in hypergonadotropic hypergonadism. 48XXYY syndrome is a rare sex chromosome abnormality, which was first described by Mudal et al. In 1960 as a rare type of Klinefelter syndrome because of the presence of one more Y chromosome compared to Klinefelter syndrome. Although some physical features are similar to Klinefelter syndrome, 48XXYY is typically associated with different neuropsychiatric symptoms and phenotypic finding. Sex chromosome abnormality represent the most frequent form of chromosome number abnormality in humans. Among them, high-grade aneuploidies with more than 47 chromosome and a male phenotype type are extremely rare. Tetrasomies and pentasomies with supernumerary X and Y chromosome arise from a paternal or maternal disjunction during meiosis. So our case is one of that type. Coming to comparison with classical Klinefelter syndrome, tall stature is found in both Klinefelter and 48XXYY. Small testis is present in both. Infertility is present in both. Speech delay is mild in Klinefelter and it is common in 48XXYY. Intellectual disability is mild or could not be found in Klinefelter, but it is very common in 48XXYY. ADHD can be found in Klinefelter, but it is very common in 48XXYY. Autism traits is much more common in 48XXYY, and behavioral issues are much more marked in 48XXYY. So, approach to a boy with hypergonadotropic hypogonadism. First, we'll get all the screening tests, after which we'll go for the gonadotropin levels. If it is high, testosterone levels need to be done. In case it is low, then karyotype has to be done. We did the same, and if it is XXY, it is Klinefelter, or it can be any pentasomy or tetrasomy. If it is normal, we'll go for the AMH level. It is low, so it can be gonadal dysgenesis, or we'll go for genetic studies. If it is normal, steroidogenic defect or steroid precursors can be seen. In case the testosterone level is high, DHT has to be seen. In case it is low, it can be 5-alpha reductase defect, or high, it can be AIS. So a study about 48XXYY, 48XXY and 49XXXY syndrome, not just variants on Klinefelter syndrome, concluded that the more complex physical, medical, and psychological phenotypes of these pentasomies and tetrasomy syndrome make distinction from 47XXY important. However, all of these conditions share features of hypergonadotropic hypogonadism and the need for increased awareness, biomedical research, and the development of evidence-based treatments. Another case report explored the neurodevelopmental phenotypes of 5 patients with 48XX-YY during early childhood years, and they found that there was no evidence of autism spectrum disorders before 3 years, and early recognition of hypotonia, torticollis, and developmental delays may facilitate timely intervention in children with 48XX-YY syndrome. A study by Matato et al. From Klinefelter syndrome to high-grade aneuploidies, expanding the gene doses effect of supernumerary X chromosome, concluded that the more complex physical, medical, and psychological phenotypes of these tetrasomies and pentasomies make distinction from Klinefelter important. However, all these conditions share feature of hypergonadotropic hypogonadism, and the need for increased awareness, biomedical research, and the development of evidence-based treatment. So, X chromosome gene doses effect is the key to understand the pathogenesis of high-grade aneuploidies, premature testicular damage in high-grade aneuploidies compared to classical 47XXY, that is Klinefelter. And many studies have found that there is a link between extra X chromosomes and both gonadal and extragonadal clinical endocrine, metabolic, and cardiac characteristics findings. So, take-home message: detailed history, testicular volume, and texture are important for differential diagnosis of micropenis. Karyotype is must for hypergonadotropic hypogonadism. 48XXYY has neuropsychiatric features that distinguish it from Klinefelter syndrome. Thank you.
So thank you so mumuch for this presentation. I agree with you. Very, very rare. Very, very rare to see this case. We had one such patient in PGI, which was a 48XXXY.
Okay.
And I typically remember exactly very tall, but the differentiating feature is that of extreme behavioral abnormalities. That is the one thing which makes him go to the neurologist and psychiatrist much more than come to us. So thank you for this case. Wonderful. And this was a very early pickup
Yeah.
at 2 years, 6 months. So very good case. Thank you.
Thank you. Thank you.
Thank you for the wonderful presentation, ma'am. So our next case is a reminder that medicine is often like solving a puzzle where unrelated clues can lead to the bigger picture. I invite Dr. Sandeep Paimode sir to present our next case.
Thank you very much. I'm going to present a case of severe hypercalcemia, which was secondary to subcutaneous fat necrosis. So the chief complaint, patient presented at 2 months of age, female infant. She was first product of non-consanguineous marriage, presented to us with failure to thrive and polyuria since last 3 weeks. She was irritable on presentation, and as per the mother, she was taking adequate feeds and urine and stools were adequate. In the antenatal history, it was uneventful. She was born full term by emergency LACS in view of non-progress of labor. Birth weight was 3.78 kgs. She didn't cry at birth, was given bag and mask ventilation followed by mechanical ventilation. She had a STROMI NICU course with mechanical ventilation for a long time. And she eventually had a pressure source over the back and occipital region, which gradually healed. In the postnatal period, at discharge, she was on full breast milk and other supportive care. Weight at discharge was 4 kgs. OFC was 34 centimeter, length 51 centimeter. Discharge on exclusive breastfeedings with adequate feeding and adequate stool and urine. She was though advised as a routine iron, calcium and vitamin D supplementations, but due to some miscommunication, they were not taking any supplements. So at 2 weeks of postnatal age, there was weight loss, though despite of having good feed and adequate urine stool. And again, mother had a good milk supply. Also, mother noticed that baby was gradually becoming irritable and irritable. In the negative history, no history of fever, vomiting, lethargy or diarrhea, no history of seizures, altered sensorium, no history of any hyperthyroid-like picture like prominent eyes, anxious look or shakiness, no history of any hyperpigmentation or genital ambiguity, no history of any formula feed or prelactal feeds, no history of any high-dose vitamin supplementations. She was having a partial neck holding, recognizes mother and cooing was present, turns head to sound and objects. She was the index case, no history of similar illness in the family, no history of any recurrent abortions or neonatal deaths in the family. So on examination, she was irritable, heart rate was 155, peripheral pulses were present, BP was 80/46, which was between 58 to 98 centile for age and height. Signs of dehydration were present, and in the anthropometry, weight was markedly reduced, which was 2.9 kg, which was minus 4.27 SDS. Genitalia was normal female, and in head-to-toe examination, there was significant signs of dehydration. And apart from that, as you can see in this picture, the scalp was showing white plaque, and at the back, we can see a healing ulcer is already there. Systemic examination, apart from being irritable and AF was depressed, rest of the systemic examination was well within normal limit. So we sent a screening in which the CBC, LFT, RFT, electrolytes, CRP, and random sugar was well within normal limits. Calcium was found to be high. It was 17.6. A repeat calcium and ionized calcium was sent, which was again high. So ionized calcium was 2.1. Then we sent PTH, which was suppressed. Phosphorus was well within normal limits. 25-hydroxyvitamin D was normal, 32.4 nanogram per ml. 125 vitamin D was raised for the lab of upper limit 66, and renal ultrasound was registry of bilateral medullary nephrocalcinosis. So based on the clinical features, the history, and lab parameters, we made a diagnosis of severe hypercalcemia, and most likely diagnosis was subcutaneous fat necrosis. The points in favor were history of birth asphyxia, healed pressure source, high calcium with suppressed PTH, normal 25-hydroxyvitamin D with high 125-dihydroxyvitamin D3. So she was given initially a bolus of normal saline followed by 2 times maintenance IV fluid. Then subsequently, after achieving good hydration, we started her on furosemide 2 mg per kg per day in 2 divided doses. Subsequently, prednisolone was added again in a dose of 2 mg per kg per day in 2 divided doses. Even after day 4, day 5 of treatment, the calcium was persistently high. It was more than 14. So we gave a single dose of IV zoledronic acid in a dose of 0.025 mg per kg, which gradually normalized the calcium. At discharge, the calcium was 9.6. In the first follow-up at 3 weeks post-discharge, the calcium remained stable, 10.2, and she had a good weight gain. Second follow-up was done 3 months post-discharge, that is 6 months postnatal age. Calcium was 9.38. Create was normal. USG was suggestive of persistent nephrocalcinosis. She had an adequate weight gain, and developmentally she was doing well. Learning points: subcutaneous fat necrosis is a rare panniculitis, often seen in term and postterm neonates. Usually it occurs in the first few years of life. Risk factors are birth asphyxia, hypothermia, therapeutic hypothermia, meconium aspiration, maternal risk factor like diabetes and preeclampsia. And in subcutaneous fat necrosis, hypercalcemia is usually seen in 20 to 75% of the cases, usually in the first few weeks of life, and often it can be very severe and life-threatening. Pathophysiology: this activated macrophages have 1-alpha hydroxylase activity, which leads to increased production of calcitriol, which causes increased gut absorption of calcium. Again, there are high prostaglandin levels, which causes osteoclast activation. And again, there is direct release of calcium from the necrotic fat. So basically, this is a PTH-independent hypercalcemia. Clinical features: mild will have irritability, poor feeding, vomiting. Moderate will have polyuria, dehydration, hypertension, and in severe cases, there can be seizures and arrhythmias and renal failure. Complications basically due to high calcium in the urine, nephrocalcinosis, nephrolithiasis, and which can lead to persistent renal damage. Management: first line is IV hydration, double the maintenance, then loop diuretics, furosemide, which causes calciuresis, low calcium and low vitamin intake. And in refractory cases, we give steroids, which blocks the 1-alpha hydroxylase activity, and bisphosphonate to reduce the bone resorption. Follow weekly calcium initially, followed by monthly, and USG for nephrocalcinosis. So in our case, there was hypercalcemia. We confirmed it again by sending ionized calcium, and subsequently PTH was sent, which was found to be low. Then we sent 25-hydroxyvitamin D, which was normal. So 125-hydroxyvitamin D was sent, which was higher. And based on the clinical parameters, the history and lab, we made a diagnosis of subcutaneous fat necrosis. Thank you very much.
Sandeep, for such a beautiful presentation. It is a textbook case of subcutaneous fat necrosis, but rare.
Yes.
So congratulations on picking it up and looking beyond the sepsis and what we consider whenever these kinds of babies arrive in the OPD. So we have to look beyond and see for calcium, glucose, and other metabolic workup has to be done. Thank you. Any comments from the audience?
In all these chronic hypercalcium cases, we should target the calcium at lower half of normal. So would have been required to increase the dose or frequency of maybe zoledronate in such cases.
Like once we start the steroids, they will have a good response on that perspective. So zoledronic, maybe one dose is usually enough because it's usually a transient sort of a phenomena. So steroids respond very well. So I think we expect a good response
sir.
on steroids. Any therapeutic
No,
hypothermia?
it was not. It was not offered. It was not given.
Yeah.
But there was history of birth asphyxia and prolonged immobilization and ventilation. So history of birth asphyxia was there in this case.
Severe birth asphyxia for which the child was intubated for a prolonged time.
Yes, ma'am.
So probably this might have met the criteria for therapeutic hypothermia. So they might have given, I
No,
suppose.
ma'am, it was delivered in a peripheral center, and then the patient came to us around
Yeah.
12
So,
hours of life.
Yes. So a similar case, even I was also encountered. The child was delivered peripherally, and those people have thought of it is a severe hypoxia, and they have given manual hypothermia at their level in the form of globes, which contains the ice cubes and ice water. So as far as the picture shows, it is only in the back and the back of the head. So which suggests that they might have given something at the back for the manual hypothermia, and the manual therapeutic hypothermia is much more dangerous than the controlled hypothermia. So in those cases, subcutaneous fat necrosis rate is much more as far as the evidence says. But in case of normal perinatal asphyxia, there is instances of subcutaneous fat necrosis, but is lesser than therapeutic hypothermia.
Yes, ma'am.
Thanks for sharing. So this is really a good case, and so it again reiterated that we should have a teamwork and we should have a good communication from where the patient is coming, and whatever investigation or whatever the treatment has been provided to them. Yes.
So, thank you very much, sir.
Thank you for the wonderful presentation, sir, and for the fruitful discussion. Now, our final case for the session is where we will highlight how clinical findings and genetics don't always end up telling the same story. So I invite Dr. Runa Mazumdar to present this intriguing case.
Thank you, Kirti, and good morning to all of you. I would be presenting a patient with 2 cell lines, a diagnostic dilemma. Case AB presented to me at 11.5 years of age, referred from a colleague with short stature and delayed puberty. Her weight was on the plus 0.5 SDS and her height was minus 2.5, 2.8 to minus 3 SDS with a target height of 153.5 centimeters. She had an uneventful birth history, born at normal 38 weeks gestation. Her mother was 32 years of age and her father was 44 during her birth. She had one older sister who was 14 years old of normal growth and development. And AB had no medical problems since birth, only mild recurrent sneezing for which she was taking some homeopathic medicine. She also had refractive error for which she was wearing glasses. So on examination, she was a phenotypically female with high arched palate, short neck, square upper body habitus, truncal obesity. She had a wide carrying angle with wide spaced inverted nipples. And on examination of her hands, she had clinodictyly with short fourth and fifth metacarpals with a short fourth metatarsal. And also on examination, she was noted to have acanthosis nigricans, and there were no gonads present in the inguinal canal with female external genitalia, normal introitus, and urethra. And her pubertal staging was A1, P2, B1. On investigating, her bloods were essentially normal, her CBC, LFT, her sugars, her lipid profile, her thyroid function test was normal, and HbA1c was 5.4%. And her TTG was also negative. But her FSH was remarkably high at greater than 150, with the LH of 18.08, testosterone was 0.6, and estradiol was 13. Her bone age was 12 to 18 years, and her ultrasound showed a very small hypoplastic uterus with non-visualized ovaries. Her karyotyping, 30-phase metaphase karyotyping showed surprisingly 47XYY in 28 cell lines and 45X in 2 cell lines. So I advised an MRI to look for her Mullerian and Wolffian structures and a FISH for SRY gene. So this is AB, who according to her parents is of a very calm demeanor. She is doing academically well and is very obedient. And this is her on the Turner's growth chart. So her chromosomal cell lines, as you can see, 28 cells were 47XYY and only 2 was 45X. And this is the ultrasound of a uterus and ovaries. So I asked for an eye examination and a ear examination and ultrasound KUB, which were both normal. MRI pelvis reiterated her previous findings of a small and thin uterus with ovaries non-identifiable and no other significant abnormality in her pelvis. Her echo showed a tri-leaflet aortic valve with unequal cusps, and her SRY gene came back positive. I counseled the parents regarding the need for growth hormone therapy and an early gonadectomy in view of the Y cell line. But on discussion, the parents and relatives advised them to go to CMC for a second opinion and gonadectomy. So what is this mosaicism? The 45XY X is a Turner cell line, which usually phenotypically presents as a child with a short stature, with ovarian dysgenesis, web neck, Turner's phenotype, with cardiac, plus minus cardiac anomalies. And the 47XYY is Jacob's syndrome, which has an incidence of 1 in 1,000 male who are phenotypically male, can have normal male genitalia with learning difficulties, sometimes behavioral and social problems, and ADHD features. So the phenotype depends on the cell line which predominates in the gonads, not only in the blood. And the phenotypic spectrum can be very wide, from a female who could be with Turner's features to a male with Jacob's syndrome to ambiguous genitalia with mixed gonadal dysgenesis. So two individuals with the same blood karyotype can present with very different clinical features. And why is this? Why does this happen? Because the blood karyotype may mislead us. The blood can show 90% 47XYY, but only 10% in the gonads can be positive for this. And therefore, these children will develop a female phenotype. But in this, like our case, but in the second case, there could be 90% presenting with the gonads having the 47XYY and only 10% being in the gonads being positive for the Turners. And these will go on to have male phenotypes with the Jacob syndrome. So gonadal cell line determines the sex development and not the blood. And the key diagnostic questions here would be what is the phenotype of the child? What are the internal reproductive organs like? Is there a uterus, cervix, gonads, testis, or streak gonads? What is the SRY status of the child? What is the histology of the gonads? And what is whether there is a Y cell line and tumor risk? And obviously our endocrine blood investigations. So imaging would also tell us whether uterus is present or not, whether the gonads are streak, whether the testis is in a different site, and whether the Mullerian structures or Wolffian structures present. So MRI will help us guide our management. So this 47XYY is a disorder of sex determination, the sex development, not only a pure Turner's Jacobs karyotype. So she was admitted in CMC and she went on to have her bloods. Her FSH again was high with low estradiol and testosterone, and AMH here was minus 0.2. An ultrasound of the abdomen showed similar findings, and she underwent a laparoscopic bilateral gonadectomy. This showed hypoplastic uterus with bilateral streak ovaries with fallopian tubes and epididymal tissue with no definite germ cell component and no evidence of gonadoblastoma or malignancy. There was no testicular component in the inguinal canal as well. So she went on to have growth hormone therapy and calcium and vitamin D supplementation, and she's due to be reviewed in clinic soon. So how does this possible mosaicism occur? So in the first mechanism, which is normally the case, there is a normal zygote during early embryonic development of 46XY, but during early embryonic life, there is a loss of the Y chromosome. So therefore, one cell develops into the 45X and the other retains the Y chromosome to form 47XYY, and this is usually due to non-disjunction. The second mechanism is due to an abnormal sperm being formed in the due to abnormalities in paternal meiosis, and therefore the sperm is 23XYY instead of the normal sperm being 23XY. And the ovum is normal, so it goes on to fertilize a normal ovum, and then this results in a 47XYY zygote, which during early mitotic division, there is again an error of anaphase lag, wherein one Y chromosome is lost. And therefore, one daughter cell goes on to become 45X, and the other daughter cell retains this lost Y chromosome and becomes 47XYY. So two genetically different chromosomes will come into this fetus eventually. Going through the literature, I saw that there were around 12 cases reported till date. And in 1960, the first case was reported of a female with Turner type syndrome, features like ours. And in 1977, there was a female with DSD, an unusual gonadal development. And in 1991, there were 3 patients who were shown, 1 female, 1 male, and 1 with DSD features. And in 2012, this was a surgical series of children who went on to have gonadectomy, and mostly they had DSD. In 22, there were 2 cases, 1 male and 1 female. The male had hypospadias, atrophic testis, and short stature, and the female had Turner-like features. So this mosaicism has a wide phenotypic variability from Turner's to typical male to ambiguous genitalia, depending on the proportion and distribution of the different cell lines in different tissues, especially the gonads. So this happens due to chromosomal errors during early embryonic cell division, and it has a wide phenotypic variability, as said earlier. So don't rely on the blood karyotype solely. Integrate your clinical evaluation, imaging, your hormonal profile, your gonadal assessment to guide your diagnosis and counsel and treat for tumor surveillance risk as well. This is a striking example of how chromosome distribution across tissues can shape human development. And this is an extremely exceptionally rare condition with one of the wildest phenotypic ranges in human genetics. Thank you.
Thank you, Ruma ma'am, for a nice presentation. Again, this is just to stress out that we don't have to order for conventional karyotype, but if you are suspecting, rather it will be great if you are going to have 50 cell analysis. And again, if things are possible, then probably we can do karyotype on stable, say, cell line. So that skin fibroblast, something like that. So it is going to add up on the sensitivity as well.
I think this was a very, very interesting case. And the main issue, of course, is that whether you treat her like a Turner syndrome with Y cell line or you treat more like a Y excess in that perspective. Thanks a lot. It was a wonderful case, and all the cases have been very, very interesting and wonderful. The chairpersons have been extremely insightful in their comments and suggestions. I'll request the MOCs to kindly honor the chairpersons, please.
Thank you for an engaging session. I invite Anurag sir to present the mementos to our chairpersons. Please come forward to receive your mementos. Dr. Vijay Jaiswal sir. Huge round of applause, please. Dr. Arpita, ma'am. I request Dr. Vibha to present Dr. Sayan sir with the memento. Thank you, sir. Now I request our chairs to please present mementos to our speakers for the day. I invite Dr. Sandeep, sir. Dr. Namita, ma'am. Namita, ma'am. Dr. Medha Mittal, ma'am. Dr. Medha, ma'am. Dr. Shweta. Dr. Runa. I request Sayan sir to please present the memento. I thank all the chairs and the presenters. We move.
Dr. Fauziya. Dr. Fauziya.
I thank our chairs and our presenters. Over to the next session, Dr. Suyash.
Good morning, everyone. I'm Dr. Suyash Gupta. I'm from Bhopal, Madhya Pradesh, and I have finished my DM in endocrinology this January. And Dr. Anurag sir has been so kind to permit me to become the master of ceremony along with Dr. Pai today and tomorrow. So as cars have EV, as mobiles and computers are coming up with AI, the next big thing in diabetes management is going to be AID, the automated insulin delivery system. I invite you all for this wonderful workshop, and I request Dr. Sajili Mehta to kindly come on stage to give a talk on initiation of AID.
So Dr. Sajali was one of our initial fellows, and she is now working as a consultant in Pune, pediatric endocrinologist at DY Patil, as well as clinics as well. And Sajali has been really involved in a lot of academic activities, and it's great to have Sajali here. In fact, we have till now 15 fellows who have done our residential training or undergoing training, and 13 of them have come here. So I think only 2 people are not there. So that is good that we have got such a good reunion which is happening. So I'll just, Sajali, you can come, I'll just upload your presentation. So this is going to be an interactive session in which we are going to talk about various aspects of AID. We'll start off first with respect to the overall process of how we initiate. Then we talk about practical issues and troubleshooting issues. Then that will be by Dr. Riddhi Patel. And then Dr. Ganesh will talk about the overall Indian experience. And we'll at the end have some hands-on session as well. So Dr. Sajali, over to you.
Thank you, sir. Thank you for your kind words. Good morning, all. So let's start with today's session. So today I'll be discussing about initiation of insulin pump. So let's see. This is a case where a 10-year-old boy has diabetes for last 5 years, and he has been on multiple daily doses of injections, and he's trying his best to achieve good control. His HbA1c is 8.8, but his time in range is just 42, and parents are really worried. And they ask, can we start the child on pump? So the answer would be yes, obviously we can start, but how do we start and what are the criteria that we need to understand is most important. So first, before going to how to start the pump, what are the advantages of the pump that we have to tell the parents is we all know that it improves the glycemic matrix. It has been shown in multiple studies. It does improve your time in range and overall performance, but also along with that, it improves the health related quality of life. It allows flexible meal timings. It reduces the injection burden. It improves participation in sports and other school activities. It also improves better sleep quality by decreasing the fear of hypoglycemias or causing the parents to wake up in between because the CGM gives alarms of hypoglycemia, disturbing the sleep of the child. So basically, it decreases anxiety not only in the child but also in the caregivers. So it is beneficial for both parents and the child. And it also helps us to understand how the patient is behaving, because when the parents are on multiple dose injections, they only monitor sugars 3 to 4 times a day. So we don't know what happens in between. So we are not able to give we cannot improve our care of management. But if we have enough data to understand when there are peaks, when there are lows, it will help us to understand how to improve our treatment protocols. So the pumps have this advantages. If we explain parents this, it's better because they understand and they will be more looking forward to take insulin pumps. So what are the steps that we need to follow when we initiate insulin pump? So first is we have to find a suitable candidate who has type 1 diabetes. So I'll describe everything in details as we go ahead. So then we need also child to have a complete diabetes education, and also they need to be educated on pump management. We need to calculate the total daily dose. Then we need to have a program pump where we need to feed some program in the pump. Then there is a manual mode which operates initially and when as for 48 hours, and then there is a smart guard, and then we have to review the child over day 1, day 3, and on follow. So how do we do this is what is important. So what is the first criteria or what is the pre-initial assessment that we need to follow is we have to find a appropriate candidate for pump. So if we look at this, we know that any child who has type 1 diabetes is a candidate for insulin pump. But what are the things or which child will benefit more is one who has suboptimal glycemic control despite multiple daily injections, who has recurrent hypos or impaired awareness of hypoglycemias, who has significant glycemic variability. In this case, the pumps will really help improve the control. Those who are motivated to use diabetes technology, and those who are willing to wear both CGM and pump 24/7, and those who also need have an ability to perform carb counting, because in pumps this is one of the essential criteria necessary to operate. And in addition to that, we need a reliable caregiver support for kids who are young. So, are there any contraindications? As such, there are no contraindications for pump, but yes, we should not start immediately if there is poor caregiver engagement, if they are not willing, the family is not willing for pump, if there are recurrent decays because of non-adherence, there is untreated psychiatric illness in the family or the child, and inability to perform proper glucose monitoring. In these cases, we can address these issues and then initiate the pump once we know that these have been taken care of. So only poor glycemic control does not say that we cannot start the child on pump. We need to educate the child first in details, and then we can start him on the pump. So the advanced hybrid closed loop that is available in India, we have is Medtronic 780G. In this, the company gives the criteria that the age should be more than 7 years and the dose should be more than 8 units per day. But nowadays, we are seeing many of us are using pumps for kids who are 4 years, 5 years, and they're doing well. So that depends on center to center. Okay, so how do we initiate pump? So first is we need to know the clinic. We have to do a complete clinical assessment, which involves duration of diabetes, what was the glycemic control before, what was the CGM metrics, what was the time in range, how frequent was hypoglycemia, was it severe, or has the child history of severe decays, recurrent decays, and also we need to know if the child has any allergic histories to the adhesives or any infusion site problems like lipodystrophies or something. All needs to be assessed prior starting the pump. In addition to that, we also need to know how the child is able to take care of himself or the parents are able to take care of the child. So they should be educated on carb counting. They should be thorough with carb counting. Then they should know that mealtime bolusing is important. So the child should have the habit of mealtime bolusing when initiating pump. They should also know how to practice correction boluses. They also should be taught about ketone management and sick day management on pumps. And even if the pumps get disconnected, they should be made aware how to manage those things, how to shift to daily doses if the pump gets disconnected because of any technical issues. And also, they should have the ability to recognize and treat hypoglycemias. So once the parents are well educated and the clinical assessment is okay, one also needs to assess the psychosocial issues like how motivated the family is. If the family is not very motivated, the outcomes with the pump are not as good as we expect. So we need a very motivated family. There should be school support also, because sometimes we have seen schools don't allow pumps and during exams we have to give letters every time for the child. So it is also important. They should have easy access to the supplies, and in any case, if there is any troubleshooting, they have to manage it. So if the pump gets disconnected, or what should they do when they go disconnect the pump when they're going for swimming, all this awareness should be there with the parents so then we can initiate the pump. So education plays an important role before starting the child on pump. But before that, one should set realistic expectations that once we are starting the child on the pump, it reduces but does not eliminate the glucose fluctuations. Meal boluses are required. Even though it is an advanced hybrid closed loop, people need to give meal boluses and carbohydrate counting is must. Sensor wear is essential for every day and it is 24/7. So the child should be willing to wear it 24/7. And the initial few weeks we will require frequent follow-ups because there might be some changes and review that is needed. And also the important parameter that we have to look at is time in range, which is the preferred measure of success. So establishing these realistic expectations improve the satisfaction and long-term adherence to pumps. So these are the various pumps that are available, but in India we have only Medtronic's Minimed 780G, which is a advanced hybrid closed loop, which has a guardian force sensor. So how do we initiate? So when we initiate, we need to start the child from a multiple daily injections to pump. In that cases, we have to reduce the insulin dose. So one needs to calculate the total daily dose over the last 7 days or last 14 days. Because if there are there is glycemic variability, a single day reading may not be reliable. So you have to calculate the total daily dose by taking an average of last 14 days or 7 days. From that, you need to reduce the total daily dose by 15 to 25% when we are initiating the child on pump. And when we are initiating the child on pump, you may reduce the lantus of the previous night by 60%, because once we initiate the child on the pump in the morning, the basal will kick in. So we don't want double dosing. So ideally the lantus should be reduced by 60% a night before, or if the child is taking morning dose of lantus or a basal insulin, we can skip that dose if we are initiating the pump early in the morning. So this is what is most important. Once we calculate the total daily dose, then we reduce 15% to 25% depending on the clinical situation. So clinical situation can vary. If the child is an adolescent and has marked insulin resistance, we may consider little or no reduction. But on an average, we have in pediatrics or pediatric patients, we reduce the dose by 15 to 20%. So for example, I've just cited an example. If the child is on a total daily dose of 40 and we reduce by 15%, then the initial pump total daily dose will be 34 units per day, which is basal plus bolus. And then this reduced dose forms the basis to calculate the initial basal insulin dose, the insulin carb ratio, and ISI for the pump. So this is the dose that we have to consider while calculating all these other parameters and not the previous total daily dose. Okay. So what is most important in advanced hybrid loop pumps is the bolus dosing. So the bolus dosing depends on 4 factors. One is the insulin carb ratio, but insulin sensitivity index, or active insulin time, and the target sugars. Okay, so this is how it looks in the pump. So let's go one by one and understand how we determine the basal bolus doses. So ICR, we all know insulin carb ratio, isn't it? So basically, it is basically the amount of insulin delivered for carbohydrate intake. So how much unit of insulin will decrease the is required for a certain amount of carbs. Okay, so the formulas, there are multiple formulas which have been used. Some say 500, 450, 300, 330, but the standard that we use is 450, which gives us better ICR. But then having said that, it is individualized experience. The centers may have different cutoffs that they can use. So basically, you can decide which number suits better for your center or depending on your experience. But as a rule, we generally use 450 as a cutoff. So when we use 450, what you need to do is you need to divide it by the total daily dose that we have derived from after reduction. So for example, if the total daily dose is 30 and we are using a 450 rule, the ICR will be 1:15. So for every 15 grams of carb, we need 1 unit of insulin to reduce the sugars. So this we need to feed in the pump. Then one needs to feed ISF also. Basically, this is insulin sensitivity index or insulin sensitivity factor. This shows how the glucose lowering effect of 1 unit of insulin. So normally the rule used is 1800 by the total daily dose. We don't use 1500, which was previously used nowadays. But this ISF, once you enter in the initial period, you don't need to recorrect it because the automated pumps, they don't need ISF corrections frequently. Most important is the insulin carb ratio, and ISF gets adjusted by the pump on its own. So what is active insulin time? So in pumps, we normally use insulins like Novorapid or Lispro or Lispro. So we are using rapid acting insulins. So these insulins have an active time of 3 to 4 hours. But in pumps, normally we give active insulin time of 2 hours. This is because this is the basic setting of Medtronics that they have used for initiation of pump. But this is because if the active insulin time is 2 hours, there are stronger autocorrections or earlier autocorrections. So the risk of hyperglycemia is decreased. But in a child who is very young or who has frequent episodes of hypoglycemias, you can increase the active insulin time to 2.5 hours or 3 also. So we do have this flexibility. But this active insulin time is used as a leverage to tune the algorithm's autocorrection. Okay, so basically it determines the autocorrection of insulins that can be given. So basically, when you are initiating any child on 780G, the initial active insulin time that has to be set is 2. Normally, it does not need that frequent corrections, but can be changed depending on the clinical scenarios. So what are the targets that we set? So the target should be individualized based on age, hypoglycemia awareness, and the lifestyle. But the basal targets that most of the times we set are 100 mg per dl. So this is the basic target of a blood sugar that we want to achieve. So when the blood sugars are more than 100, there will be correction doses that will be given to bring the blood sugars to the baseline of 100. The targets can also be changed in certain situations, like when we are exercising. We know that the risk of hypoglycemia is more. Then in that cases, you can have a temporary target of 150 mg per dl. That can be for 1 hour or 2 hours, or if you are having a full day event, you can keep it for full day also. Also, these temporary targets can be used in case of sick day, where you can increase the temporary targets, because we know that we can decrease the temporary targets because we know that the requirement of insulin is more during sick day. So in that cases, you can decrease the targets, or while exercising, you can increase. So this flexibility we do have in pumps, which can be individualized as per the requirement. So, taking into consideration all these above factors, we select a bolus dose. Now we go to basal dose. So, basal dose is basically calculated from the total daily dose, the one which we have reduced. And from that, you use a factor, you multiply it by 0.4. Normally, we use a factor of 0.4 in pediatrics, weight in kgs into 0.4 for the total daily dose. Okay, so that will be the basal rate for 24 hours, which you can divide by 24 hours. So you'll get per hour basal rate. Okay, normally basal rate in automated hybrid closed loops does not have that much significance because it is adjusted by the sensor. So it's only in the initial few hours or few days we used to adjust the basal dose. So if you look at this thing, what is most important in pump setting is the insulin carb ratio, which is most important. Then is the active insulin time, the glucose targets. They are very less important or very rarely we need to change is the insulin sensitivity factor and basal rates, because the smart guard will actually modify the basal rates on its own. So once the smart guard kicks in, the less you interfere, the better is the outcome with the pumps. So this is how the smart guard decides the auto basal targets of 100. In children more less than 15, it keeps the targets of 110 and it gives auto corrections. So what are the common mistakes that we see when initiating the child on pumps or on follow-ups is increasing basals for the post-meal highs. Actually improving the carb ratios, ICRs, will give better response to the post-meal high than increasing the basal rates. And one also needs to understand that delayed meal boluses. Most of the times kids put the meal bolus later after having the food. So that causes the spikes and incursions in the sugar readings, which should be avoided. And most of the times when there is hyperglycemia documented, one should not ignore the infusion set failure. It needs to be checked that if the tubings are right and all. And doing too many changes at a time. Once we have initiated the smart guard or the child has been on pump for more than 48 hours and the smart guard has kicked in, if you see that the required results are not achieved, don't do too many corrections. Don't change the basal rate, don't change the ICR together. Just do one correction at a time, observe for 3 to 5 days and then do the next correction if needed. Most of the times it is not required. Only for strengthening the ICR will improve and solve all the problems. So after setting the child on the pump, you need to follow up the child. So this is how you will see his graphs. I think Dr. Riddhi will describe all this in detail. So you need to follow up the child after 3 days, after 7 days, after a month, and assess and do the necessary settings. Okay, I'll not discuss about this because Dr. Riddhi will be discussing about this in details. So the take-home messages are pump therapy is a tool but not a cure. The success depends on selecting the right patient and providing structured education. Reduce the multi-daily injection total daily dose by 10 to 20% before initiating pump therapy and individualize settings subsequently. In 780G, the ICR plays a most important programmable parameter. Do not increase basal to treat postprandial hyperglycemias. Encourage accurate carb counting and pre-meal bolusing, as SmartGuard cannot compensate for missed meal boluses. And optimize therapy. Particularly, time in range is an important parameter that needs to be looked at on pump. Thank you.
Thank you, Dr. Mehta. Thanks to Dr. Sajali Mehta, we have initiated our patient on insulin on the AID. But how to move forward, how to really read those reports and how to do troubleshooting of the common things that happen. I request Dr. Riddhi Patel to kindly guide us through it.
So Dr. Riddhi is our second batch fellow who is now currently working in Vadodara, and she has been taking a lot of work, and I get a lot of calls from patients who come and the doctors that she is doing a wonderful job there. So I think Dr. Riddhi will take us through from the pump part further.
Thank you, sir, for the kind words. So now we'll move away towards our presentation. So interpreting AID reports and troubleshooting. So what is AID? As Dr. Sajili has discussed, it requires three things: CGM, pump, and controlled algorithm, which provides the glucose sensor data to pump, and the pump will adjust the insulin delivery. So it is basically glucose responsive insulin delivery. And as per the ISPED 2024 recommendation, it is recommended for all with type 1 diabetes, irrespective of the age, HbA1c, and duration of type 1 diabetes. So how AID works? So this is the glucose sensor, CGM sensor, which will send the data to insulin, and in between there is algorithm which determines the insulin delivery as per the glucose value. The pump will adjust the insulin delivery and set the insulin, and it will improve the TIR, minimize the hypo and hypoglycemia, and reduces the burden of care. So what are the available automated insulin delivery pumps? In India, we have only AID pump currently available, which is Minimate 780G, Medtronic, sold by Medtronic, USA. Others are the Camp APS FXTM, which is available in UK, Omnipod again in USA, and Tandem T-Slim X2 in USA. So what are the data sources which is required for the report interpretation? And there are some clinical questions which we have to answer. And to answer those questions, which data to look? So this will be discussed in this table. So is the glycemic control adequate? Are hypo or hypoglycemia pattern present? To answer this question, we have to look at the CGM readings. So what is TIR, TBR, what is the time in range, time above range, time below range, mean glucose, the glycemic variability, and sensor glucose value. Then why and when the glucose excursions are occurring? To answer this question, we have to look at the AGP profile. Is the insulin delivery matching our glucose needs? To answer this question, we have to look at the insulin delivery summary. Are the meal and correction bolus appropriately managed? So as Dr. Sajil has discussed, only two things required from the patient side: to enter the carbohydrate and timely entering of the bolus insulin. And to answer this question, we have to look at the bolus summary. The patient is doing right or not. Is the system functioning effectively? Then for that, look at the percentage of time patient is spending in automated mode. Algorithm driven insulin changes are appropriate or not. Is post-meal hypoglycemia due to meal management? And to answer this question, we have to look at the patient is doing adequate carb counting, patient is timely delivering bolus, or patient is missed bolus doses. And last question is, could technical error explain poor control? And to answer this question, look at the sensor wear, connectivity, alerts, and infusion set issues. Okay, so what are the key CGM metrics we have to understand before interpreting the any reports of AID? So what is time in range? It is percentage of time any individual patient is spending in normal range, that is 70 to 180 milligram per deciliter. And as per the ISPED recommendation, it should be more than 70%. Time below range again divided into level 1 and level 2. Level 1 is still acceptable, that is below 70 but above 54, and that should be below 4%. And level 2 is below 54 milligram per deciliter. This is severe hypoglycemia, and that should be less than 1% of the day. Time above range again divided into level 1 and level 2. Level 1 is 180 to 250, and that should be less than 25%. And level 2 is severe hypoglycemia about 250 milligram per deciliter. That should be level less than 5%. Now GMI, which is not equivalent to HbA1c, but it will give us idea about the average glucose control over the past 7 to 10 days. For getting GMI, we need at least 10 days of sensor wear. And GMI, though the target of GMI is individualized, but it should be less than 7%. Coefficient of variation, which determines how much glucose fluctuations over the time, and that should be less than 36%. And mean sensor glucose, again, the target is individualized, but it should be kept at 120 to 110 milligram per deciliter. And what are the glucose standard deviations? There are the variations of the glucose value around the mean, and that should be low. So what are the minimum data required for interpretation of the any AID reports? At least 14 days of CGMS data, more than 70% of sensor wear. And first review the time in range. What are the glucose variability and hypoglycemia first, and troubleshoot these issues first. Only there are few modifiable factors in SmartGuard use from clinician side. We can modify basal target, and that is customizable anywhere between 100, 110 or 120, and active insulin time that can be kept 2, 3 or 4 hours. Dr. Sajili has discussed in previous session. ICR, that is also modifiable factor, and that depends upon what are the post meal glucose value, and temporary basal target, which is mainly used for sick days as well as exercise management. And these are also customizable as per the need. And from patient point of view, there are only 3 modifiable factor. Enter the carb and bolus before eating. So bolus correction before meal. Respond to alert and alarms for sensor change and infusion set failure. And set up your data with the CareLink app for the synchronization with the Minimed mobile app. So AID report interpretation, we will do in the 3 sets. First, set the target for the individual patient. Then review the therapy and behavior, why the patient is not achieving the target. And third is the change and update the manual mode settings. So recommended target by ISPED, we have discussed this in the previous slide. So GMI should be at least less than 7%, time in range more than 70%, time below range less than 4%, and time above range should be less than 25%. SmartGuard use should be more than or equal to 85%, and sensor use should be more than or equal to 85% to avoid any technical error for the poor glucose control. So first we'll discuss to review the therapy. There are few reports we have to see: assessment and progress report, weekly review data, daily review data, meal bolus wizard, and device setting. So first we'll discuss assessment and progress report. So in this report, there are the 3 columns. Mainly we are looking for 3 columns. First is this ambulatory glucose profile, which will give us idea about this blue color shadow line is the recent data range. So past 14 days, and this orange color shadow line is previous data range. So previous 14 days. So you will get the good comparison between the recent data and previous data with this AGP profile or percentile comparison data. This is here is also shown 7, then 6.5, 7. This is the ICR. This is the adjusted ICR given to the pump. Third is we have to look at the time in range or CGM metrics. So this is the time in range and CGM metrics, and last is the statistics. Okay, so we'll discuss in detail about the assessment and progress reports. First, look at the time in range and CGM metrics data, and these areas are shaded yellow as well as red. So this will give you the idea that first your eye should look on this shaded area. Okay, what is time above range and what is time below range, and then look at the statistics. So first look the what is the what is the sensor wear SmartGuard use, and then we'll discuss in detail what we should look in this statistics report. So what is auto correction? One function is given in this statistics report, that is auto correction. And this auto correction means how a patient is using this SmartGuard system. So here autocorrection is only 2%, suggests that patient's basal as well as bolus behavior is very good. That's why SmartGuard has to autocorrect very less. Okay, and autocorrection rate in this person is 52%, suggesting key patient is not adequately entering bolus data. That's why autocorrection rate is high. So SmartGuard has to work hard to maintain the glucose value. Okay, and so recommended autocorrection target should be at least 22 to 36% of all boluses, not more than that. Then assess the weekly review report. So this will give us idea about the 7 days. So all the days. So here first is the sensor glucose data. So here this green color solid line suggests the what is we have set the sensor glucose target, SmartGuard target. Then this pink color shadow line is the auto basal delivery by pump. Then this vertical purple line suggests the auto corrections given by the pump. And then here in the blue color circle, you can see this is the auto corrections given by pump, how much amount of insulin given and how many times of auto correction given. And this orange color bars or orange color square suggest the patient initiated bolus and how much amount of the carbohydrate enter, as well as how much time they have given corrections. Then look at the daily review report, and this is the deeper looking into the particular day, how the patient is behaving in the particular day. Here we have to focus mainly on the two things. Here total bolus is divided into the two parts: how much bolus patient given by patient, as well as how much bolus given by the system. So bolus here in this patient given by 17% and auto correction is 83%. Okay. So it's very high. And here you can clearly view this auto corrections given by the pump on that particular day. Then second thing, assess the bolus behavior. And in bolus behavior, you have to see the particular bolus. So what is the pre-meal sugar? What is the post-meal sugar? And whether there is preprandial rise, whether there is post-meal rise or post-meal lows, and patient is giving bolusing before meal or after meal. And that you can clearly see in this report that we will discuss in the next slide. So as Dr. Sajili has discussed, ICR should be capped to keep the post-meal excursion less than 60 milligram per deciliter from the pre-meal glucose. Bolus must be delivered 10 to 20 minutes before meal to avoid the post-meal hypoglycemia as well as hypoglycemia. And this is the most common mistakes done by every patient. They are delivering bolus after meal, or sometimes they are missing the boluses, and that's why they are not achieving the target. And if the missed or delayed bolus, then what should do? Deliver the half correction bolus 30 to 60 minutes after start of meal. And if more than 60 minutes has elapsed, then correction bolus based on the glucose trend in your CGM. So this is the, if the patient is adequately taken bolus before the meal. So here you can see that glucose is remained in the range even after the meal because child has taken bolus before meal. Here you can see ki glucose is trending up after meal because bolus is given late. And here you can see ki bolus is missed. Why? Because here there is no sign of the bolus that is entered by the patient, and here system has piled up the auto correction to maintain the glucose. So here this sign suggests the patient has missed meal bolus. Then assess the device setting. For that, look at the basal rate. We have set bolus and basal and bolus wizard, as well as present bolus rate and temporary bolus rate. Also look at the SmartGuard setting, CGM setting, reminders and utilities, and update the SmartGuard setting. So what are the company recommended SmartGuard setting? Basal rate, basal target should be set at 100 milligram per deciliter, but it can be modifiable based on patient hypoglycemia risk, tolerability for the hypoglycemia, and active insulin time anywhere between the 2 to 4 hours. Okay, so if we set the target 100 milligram per deciliter and active insulin time 2 hours, then better hypoglycemia. So we will skip this slide because this will be taken in next session by Dr. Ganesh sir. Update manual mode setting. This is very much important. We are missing this part once we are following the patients because we know everything is done by the SmartGuard setting. But once patient is off the sensor, the manual mode is working. So we have to review and assess the manual mode setting in each and every session. So use the total daily dose, which is given in assessment and progress report, that is in this patient 54.1, and look at the basal rate. It should be less than 50% of the total daily dose. Then look at the insulin sensitivity factor. As Dr. Sajil has discussed, it's not much required. It is taken care by the pump, but once the patient is off the SmartGuard setting or in manual mode setting, this setting is used. So use this 800 divided by the total daily dose. Set the blood glucose target between 100 to 120 milligram per deciliter to match the SmartGuard technology algorithm, and suspend before low should be on to prevent the hypoglycemia. So, manual mode setting updatation is recommended in each and every visit to match the SmartGuard technology setting. So, what troubleshooting is required when the time above range is more than 25%? It means patients glucose more in the higher range. Then optimize the basal target first. Then optimize the active insulin time. Then look at the ICR. It should be strengthened. It should be lower down. And look at the bolus behavior, whether child is giving bolus after meal or they are skipping the meal boluses. Encourage the bolus before the meal, and encourage the adequate carb counting for the proper post meal glucose monitoring. Then what troubleshooting is required when time below range is more than 4%? Either child is giving late boluses or overestimating the carb. So encourage bolus before meal and adequate carb counting. ICR should be weakened because the child is getting lower sugar after the meal. So ICR should be upgraded higher. Increase active insulin time only if there is hypoglycemia following auto correction. So this you will found in weekly or daily review report. If hypoglycemia following auto correction, then increase active insulin time. And if hypoglycemia even without auto correction, then increase the basal target. If there is hypoglycemia following exercise, then increase the temporary glucose target during the exercise time. Now we'll take this case, 16-year-old boy. Recently, I put this child on the AID, and his recent HbA1c is 8.2. Known case of type 1 diabetes since 12 years of the age, started on insulin pump 6 months ago and want to improve HbA1c because patient's main query is, since I am on insulin pump, why my HbA1c is still on the higher side. So first review the assessment and progress report. So look at the time in range. It is below 70%, 100%, and time below range is perfect. It is less than 4%, but time above range is on the higher side, and especially time above level 2, that is that should be less than 5%. It is very high. It is 9% and 16%. Recently it is 16%. Now look at the statistics. So first we'll review the goals. So child is not meeting the goals because time in range is not in target, as well as time above range is higher. Then look at the data advocacy. Are the data adequate or not? Then look at the SmartGuard and sensor wear time. It's perfect, means child is adequately using SmartGuard sensor. Then look at the GMI. What is GMI? So GMI is 7%, not appropriate. It should be less than 7%. Then look at the AIT. What is active insulin time? It is normal, 2 hours. It is set at 2 hours. Then what is the problem occurring? Ki child is not getting into the target goals. Now look at the auto corrections. It's very high, 52%, means system is using repeatedly to achieve the target, and child is not properly giving bolus doses. So we have assessed the bolus behavior, and you can see that many of the meals glucose is on the higher side even after giving the bolus. It means child is giving boluses after meal many of the times. So encourage them to enter the adequate carb as well as bolus 15 minutes prior to the meals. And also look at the weekly and daily review reports. Here you can see assess the weekly therapy. How many times child is not using the sensor. Then assess the daily therapy. You can see that the target is set above the 100. So the system is reducing the sugar in the basal target, but not below the 100. Okay, so update the SmartGuard target. And third thing, look at the bolus behavior in the daily review report. So many of the time child is missing the bolus. That's why there is post meal spikes are there. So encourage them not to miss meal bolus. Also look at the device setting, update the manual mode setting, basal rate, look at the basal rate, look at the smart guard feature and basal glucose target and suspend before low is on or not. Now, after 1 month, we have reviewed the child. His HbA1c is improved. Sorry, his time in target is improved beyond 70 percentage. Time above range is improved. And look at the time above range level 2. That is only 4 percentage. So, child has started using the proper system. Now GMI is also improved to 6.7 percentage. Auto corrections are also less. It means child is properly and adequately giving the bolus doses. So this is child has definitely improved after doing some of the modification. So AID troubleshoot, to summarize my talk, AID improves the glycemic control in type 1 diabetes patients, but comprehensive analysis of report is crucial to improve the glycemic control, and periodic review of device settings encourage timely bolus and carb counting to reduce the HbA1c and GMC. Thank you. Any questions?
Thank you for the talk. I think we can have questions later when we have on-hand demonstration of the AID. For the next talk, I request the expert of AID, Dr. Ganesh Jevalikar, sir, to give us a real-world outcome, the Indian data of actually what happens with use of AID.
So Dr. doesn't need any introduction for the audience. He is a well-known figure, and I think both of us started pediatric endocrinology nearly in the same time in 2008, 2009. So I think we are probably now going into that senior sort of a position. But I think Ganesh has been working a lot, particularly in the field of AID. So it's a pleasure that he was able to come to our program. Welcome, Ganesh.
It's indeed a pleasure for me, and thank you, Anurag, for inviting me, and thank you for giving this topic. Otherwise, I would have never actually analyzed my data and just sat on it because seeing my statuses, people think that I have left pediatric endocrinology. Okay. So before we go on to this session, I would request the Medtronic people to put pumps devices on some of the tables, at least whatever devices you have, please just keep it on the tables. That might be useful for the hands-on portion of it that we want to do. Now, in this, what we are going to do is just review a brief literature about how effective the therapy is. Now, whenever any new therapy comes, and initial drug trials or initial therapy trials show effectiveness, but that may not actually get translated into real world data. You may actually see, because research happens in a very controlled sort of environment, and there might be n number of variables which might affect the results. I myself used to be quite skeptical about insulin pumps and technology usage maybe 10 years ago, but I think I have evolved. The evolution happens once you see that somebody is doing good and the therapy is making a difference to their lives. I think Sajili and Riddhi had beautifully summarized what AID is, so I don't need to go into details. Basically, on one arm, I hope that the people at the back are able to see and hear, and I can engage them in their attention too. So basically, the two arms of CGM and insulin delivery are talking to each other. That is what is AID. Basically, CGM is telling what are the sugars, and the algorithm is using that information to modify the insulin delivery, getting rid of the manual adjustments that we had to do for basal insulin in the previous models of the pump. But the bolus, as pointed out, remains largely user dependent. User has to announce the carbohydrate intake and press a button to take a bolus dose. I think very soon, even that requirement is going to go off, and we will be rendered pretty much useless in the field of type 1 diabetes. So ISPAD, as you all know, recommends that AID could be useful for everybody with diabetes. However, in India, the reach remains very, very less, largely because the expenses are borne by the family themselves. I mean, it is not government sponsored, or no, even insurance support is not there for this. Now, this is the Western data, just to put things into perspective, that how we are doing in comparison to, because we always look up to Western literature and Western data, sometimes even forgetting that we might be actually doing better than them in some of the fields. So this is the data published from several countries in 2024 in Diabetes Technology Therapeutics by Pratik Chaudhary and group. And it shows that there's consistently people using the closed loop pump therapy was able to achieve time in ranges that are recommended for people. So consistently you will see right from the first month of therapy till the first year of therapy, and over a period of time also these results are maintained. And this was replicated across all the countries. So this was replicated across developed countries as well as developing countries in this particular paper. Now, with respect to Indian experience, I think in 2023, in one of the ATTD meeting and also in one of the ISPAD meeting, this data of initial pump usage was was presented in the meeting. I think in India, the hybrid closed loop pump was launched in 2022. And this was presented in 2023. This is the data of about 219 users. Some of them were our patients. And this was downloaded from the CareLink personal data. And the number of children under 15 in this group was 64, and more than 15 years, about 150 patients. So what was done was the data was simply downloaded and analyzed and presented in the form of what was the time in range, above range, below range achieved in this particular group. So you can see that this is the average. So average time in range of the group was 75.4. And the important and consistent observation in clinical practice, as well as the data that I have analyzed of our patients, is that the time below range beautifully comes down. So hypoglycemia has largely been conquered in this therapy, not completely, but largely. Time above range was about 22%. And about, say, 70% of users were able to achieve a GMI, kind of a surrogate marker for A1C, of less than 7%. And these results were consistent throughout the months of usage. So throughout the 6 months, you can see that the 75-76% was maintained in this particular group. I will briefly go through our experience. This is largely a descriptive sort of analysis of the patients that we have seen over a period of time. Max is kind of a group practice. So we are a team of about 7-8 endocrinologists. I'm the only pediatric endocrinologist, rest of them adult. We have about 100 users on pump. Max caters largely to upper socioeconomic group. Even in this age group, you can see that the uptake of technology is limited, largely because of, again, logistic issues, or also because of some other reservations about using or displaying the technology on your body. So about 47 of them are using the closed loop pump therapy. And we could collect the data or download the data for 32 of them after obtaining their consent. And 27 of them have type 1 diabetes. One has post-pancreatectomy diabetes and a Wolfram syndrome each. And 3 of them are latent autoimmune diabetes in adults. 13 of them were switched from the older pump to the newer pump. So, and 19 of them were from basal bolus therapy, directly switched on to the hybrid closed loop pump therapy. This is the description of their latest 90 days of the CareLink data, along with the most recent laboratory HbA1c that was done in the past 3 to 6 months. The data consisted of 15 females and 17 males. with a median age of 23, ranging from 7 to 65. The earliest age group where the youngest child where we started pump was 5.5-year-old, the closed loop pump. And median diabetes duration was 10 years, ranging from 1 to 44 years. And median pump therapy duration was about 27 months, ranging from 3 to 53 months. This is a summary of the data of all the 32 patients. 74% on an average time in range was seen, which is consistent with the Western observations as well as the data that was presented in Berlin. 23% time above range and 2% time below range. So as I said, that there was impressive performance with respect to the time below range. The average GMI was 7 plus minus 0.4. And 26 of 32 patients, like that is almost 81%, had a GMI of less than or equal to 7%. Actually, rest of them also had between 7 and 7.5. So 31 out of 32 had a GMI of less than 7.5%. And the last, that is the 32nd person, had a GMI of 7.6%. So this is quite impressive. This was not able to be achieved with whatever maximum efforts we took in basal bolus, very compliant patients, testing more often. Even then we had struggles with getting a good A1C. Even if we got good A1C, it used to be at the cost of significantly high amount of hypoglycemia. The mean coefficient of variation, which is the recommended measure of variability, was 33%, which is well below the recommended limit of 36% in the consensus statement. And 23 out of 32, that is 72%, had a CV of less than 36%, which is the recommended target. Now, as we say that the GMI is actually a surrogate marker, so the HbA1c is not totally outdated yet. It may become in the future, but as of now, it is not outdated. So we also studied the laboratory HbA1c of these individuals. The pre-pump average HbA1c was 7.88. So it suggests that those of who went for this therapy were not doing that bad in the beginning also. And post pump was a decline of about 0.7%, 7.16%. The optimum settings. Now there's a concept of optimum settings, which means the active insulin time of 2 hours and the blood glucose SmartGuard target of 100. So this was used by about 14 out of 32 individuals. When we compared people who had optimum and non-optimum settings, the laboratory HbA1c was better in those who were using the optimum A1C, optimum SmartGuard settings. The GMI was not different. This is the summary of the changes of A1C. You can see that on an average, there was a decline. Some of them had increase in the A1C. Possible reasons where they were having A1Cs of 6.3, 6.4, etc., which went up to 6.8. Also, that the amount of hypoglycemia that we probably contributed to a falsely, normal sort of A1C got taken care of. So it shows that even if the HbA1c had slightly increased, if you have got rid of the hypoglycemia, that is still a better glycemic management. Coming to how good the system was being used. Now, in Western countries, particularly when the devices are being given by the government, the people don't really respect that, and often over a period of time, the sensor usage and the SmartGuard usage goes down. But in India, I think largely because everybody is paying through their teeth for these devices, the usage somehow seems to be better despite of long-term usage of the insulin pump. So 91% was the average sensor wear, and SmartGuard usage was 92%. The average set change, the recommended set change is about 3 days. On an average, the set change happened at 4.4 days, but it ranged from 2 to 11 days. So some of the people were continuing to use sensor, which could be one of the reason, the patch, the insulin pump patch, which could be one of the reasons sometimes that you have hyperglycemia despite of using automated pump. So the pump patch should be changed at a recommended frequency. Now, till now we had this 72-hour patch. Now we also have the extended wear patch, I think 7-day patch. So according to the recommendations, we should follow the same. In terms of troubleshooting, we had low glucose alerts of about 3.45 episodes per week and high glucose alerts of about 3.7 per week. Just to caution that sometimes you could have problems even when you use the best of the technology. So this is a 10.5-year-old girl with diabetes since 2020 and reasonably well controlled on basal bolus therapy. And they decided to go on insulin pump because they wanted just more flexibility and of management. So it was started after 3 years of diabetes onset. And you can see that on pump, this is sometimes we encounter this problem that there's a weight gain when people are using pump because there is unlimited or unrestricted sort. They think they take it as a freedom to eat anything and everything and at a different frequency too. So weight gain is sometimes a problem. Also, another problem that happened in this particular case was, as you can see here, this dotted green line, you can't see the dots very well, but the dotted green line is a temporary basal rate. Now, this mom was very paranoid about not getting a hypoglycemia in the school. So therefore, she would put this temporary basal rate. And then when either the child has not taken a bolus or the child has eaten something which is much more than the amount of bolus that is taken, there is hyperglycemia. And the because the temporary basal rate is on, the pump is not giving the autocorrection boluses. So pump has not given any autocorrection boluses despite of the blood sugars rising. And the child has ended in hyperglycemia. To correct the hyperglycemia, they have taken multiple correction boluses by entering sometimes the fake carbohydrates. And then at the end of the day, they have also changed the patch or something like that. But at the end of the day, the child has ended up in a severe hypoglycemia. It was not just the first episode for this particular poor child. Again, there was a similar episode. And again, there was a third episode. So this, so when there is hyperglycemia, the mother used to struggle with the hyperglycemia and give multiple correction. At the same time, at the time of hypoglycemia, she would go all guns and overtreat hypoglycemia and something. So this is what happens when there is a conflict between intelligence of the user and intelligence of the algorithm. So if there is a conflict between the two, you will end up sometimes getting these kind of problems. So therefore, we have to kind of emphasize again and again that there has to be some letting go of the control. Now, this problem is more of a human behavior where the parent wants everything to be absolutely controlled, including the device. So there's a conflict between the device. So if there's a hypoglycemia, the pump is also switching off insulin. At the same time, she is also treating. If there's hyperglycemia, both are doing this job. So therefore, the challenges that happened in this particular child. So to end this particular part of my session, I would say that, I mean, I've written a modest figure of 50, but actually it is more than 70% people, Indian users who are achieving the desired glycemic targets with the hybrid closed loop pump therapy. There's uniform improvement of hypoglycemia, even if they're doing badly in terms of hyperglycemia. So there's uniform improvement of hypoglycemia. High sensor usage and smart guard use is seen in Indian users, probably mostly resulting from out-of-pocket expenses and higher degree of user involvement. There are challenges with respect to bolus dosing, such as carb counting or timing of the bolus, as Riddhi showed in her talk about a missed bolus. So missed boluses, delayed boluses, inadequately under-reporting of carbs. These are common reasons why you would have problems even when you're using this technology. In general, if there is a conflicted family, divorced parents, struggling family, or something of that sort of family situation, we also see that these individuals struggle with the technology use. So sometimes crisis can happen, and one has to be, I mean, technology doesn't mean that human intelligence takes a backseat. Thank you. अच्छा, this में वो virtual demo का वो link add किया था उस can
Thank you for the informative talk, sir. I request Dr. Ganesh, sir, Dr. Sajili, Dr. Riddhi, and Dr. Vikas. Okay. For the live demonstration and hands-on.
So Sajili Riddhi ko I can just ask them to be around. Abhi jo bol raha tha.
One thing I wanted to tell, sir. Yeah. So there's an optimistic news I want to share. I'm practicing in Bhopal, and yesterday, not a person from a higher or a upper middle, but a girl, 9-year-old girl from a lower middle socioeconomic strata. I started on insulin pump yesterday. How was it managed? Instead of paying the upfront cost of 6.5 lakhs, the Medtronics team somehow helped her with finances. So she got a loan where she has to pay only 30,000 rupees per month. And just imagine the health benefits in terms of weight gain, height gain over the next 3 years she will have because of her optimum glycemic management. So that is also a good thing we can do. Over to Sir.
I think I would request Dr. Sajili, Dr. Riddhi to be around the tables in case people need help. We are going to, we are short of time, so we are going to just focus on what the doctors do, which is largely to prescribe and calculate the initial dosages. And in this PowerPoint, I would also request you to just scan this barcode from your phone. Sorry. Oh. Yeah. Please, if you can scan it, it will open a virtual device on your phone, and you can actually fiddle with it. You can even do it at your home. You can just select, just follow the prompts, and that will be kind of a practice for you to do the pump training, sort of. Right. So we'll just take a case example just to learn these calculations. Sorry. Yeah. So this is a 10-year-old boy who is having type 1 diabetes from the last, he got it at the age of 3 years. Now he's 7-year-old, doesn't have any other comorbid condition. He's currently on the Degludec and Fiasp. So roughly 16 units of Degludec and about 18 to 20 units of Fiasp in a day. They vary the insulin dose based on the carb count and the blood sugar readings. He is 40 kilos and 135 centimeters, and his current HbA1c is 8.6%. So now they have come to you asking that we want the insulin pump. What will you do? Firstly, you will check the eligibility, whether this person or whether this user is a good candidate for pump or not. So in India, first and foremost is money. So whether what sort of reimbursement or whether the financially capability of the family is there, not just to buy the pump once, but also to buy the monthly supplies. So in this case, that was not a problem. They were the second thing is their basic diabetes education. It is always a good idea, even if you feel that the person is doing well in basic diabetes, it's always a good idea to revise all the basic topics before you go on to the insulin pump. They're familiar with carb counting, although not totally confident, but they know basics of carb counting, and they're more importantly, they're willing to learn and willing to improve. Accuracies in carb counting, particularly with the Indian type of food, is really tough. So it is not easy. And therefore, over a period of time, I have kind of become a little lenient with respect to this particular criteria. The family is cohesive. There's no fighting going on between the parents and no psychological issues per se with the child also. So there has been a regular follow-up. These are the requirements that are there for me to put people on pump therapy. Somebody comes from, let us say, Iraq and wants an insulin pump. And I know that in that country, there's nobody to take care of insulin pump. So therefore, I would be extremely uncomfortable in putting that child on insulin pump. So let's discuss the calculations that are important for us to prescribe the person insulin pump. So this child is on basal bolus. So when we calculate the total daily dose, please remember that you have to calculate basal as well as bolus units. So this is approximately 36 units in this particular child. Now, when we are putting people on insulin pump therapy, because pump delivers insulin continuously, the pump total daily requirements are usually lesser than what they would require on the basal bolus therapy. So therefore, you do a variable sort of reduction of the pre-pump total daily dose to calculate a pump total daily dose. Here, the practices may differ from person to person. For example, with a HbA1c of 8.6, somebody may not just want any reduction at all, may continue with the same dose, or somebody may say 5%, 10%, or 20%. So on an average, if you are remembering that if the A1C is decent, if the A1C is good, you will reduce the pre-pump total daily dose by 20% to get the pump total daily dose. In this case, because the A1C was 8.6, I was not wanting to reduce too much. So therefore, I have reduced it by 10%, which means that 36 into 0.9, 90% of the pre-pump TDD, I'm going to give as a pump total daily dose. There is no place where you actually enter pump total daily dose in the pump. This is just your baseline parameter to calculate rest of the settings that you're going to do in the pump. Out of this, about 30 to 40% is given as a basal dose. Typically, 50% is given in very older young adults or something like that. But in children, the basal requirements are less, particularly if the diet is carb-rich. Again, the basal requirements, but the prandial requirements would be more, and proportionately, the basal would be less. So in infants and toddlers, we keep 30%. In older children, we keep about 40%. So 32 into 0.4, roughly 12 units of insulin is given as a basal insulin in a day. Again, there is no setting in the pump where you are entering the total basal dose. What you are going to enter is actually an hourly basal dose. Okay, so here total divided by 24, that is the number of hours in the day. That is 0.5 units per hour. So this is my first setting, that basal rate is 0.5 units per hour. Subsequently, other settings are for bolus wizard, where we are calculating insulin carb ratio, insulin sensitivity factor, active insulin time, and blood glucose target. Insulin carb ratio is calculated by rule of 450 or 500. You'll use whichever you like. But in younger children, and if the total daily dose is very less, then we use the rule of 300. Then ISF is calculated by 1800 divided by total daily dose, which is equivalent to 55. How many of you are confident in what is ISF? Raise your hands. Who all know what is ISF? I see very few hands. So basically, insulin sensitivity factor or correction factor is the drop in the blood glucose that is expected to be caused by 1 unit of insulin when you are giving this for as a correction dose. So 1 unit reduces the blood glucose by how many milligrams per deciliter? That would be insulin sensitivity factor or correction factor. So that's calculated by 1800 divided by TDD. That roughly comes to about 55. Here somebody may say, sir, it doesn't come as 55, it will come as 56 point something or something. No, we don't have to be that accurate here. We can round up a little above and below. So this is a little rounding up that I've done here. Active insulin time with the HCl, we are keeping at 2 hours. In the previous models, we used to keep roughly at 3 hours, but the HCl gives best results if you keep it at 2 hours. If you're too worried about hypoglycemia, then you could keep it 2 hours, 30 minutes to begin with. And similarly, blood glucose target, the SmartGuard target can be kept only as 300, 110, and 120, as Sajili told us. And the manual settings also, generally, we try to match the SmartGuard setting. So 100 is what I have kept. 100 to 100 I have written like this because actually in the pump, the setting comes as from 2. So if you want a value of 100, then you'll have to either keep 90 to 110 or 100 to 100 or if you want 120, then you can keep 120 to 120. So now I would just maybe if we can, you can have the In this, the website will open. I think these things Sajili and Riddhi have already emphasized that pump for first 42 hours, it works in the manual mode. This is au.https. HTTPS. Medtronic. Acha. Sorry, I'm not that. I'm a technologically retarded person, sorry. I'm just okay with diabetes technology. Virtual met. Sorry, what's the name of the website? That link. The scanner? No, it's my PowerPoint. Where is that PowerPoint gone? Okay, sorry. Virtualpump.com. Is it Safari? Here. Yeah. Would like to share the website. Yeah. Thank you. So you just, I hope you have come to this screen. You just press English. Just go on selecting whatever time and date it suggests. I mean this when you're using the pump, you actually set the right time and right date, because I have had mishaps with that also. Because I have had a patient where there was I was seeing why are there so many high sugars in the night and the daytime profile looks okay. And it turned out that the AM PM settings were wrong. So what I was seeing in the night was actually the daytime readings. So just go on saying okay to everything. We had decided that we are going to give basal units as 0.5 units per hour. So we are going to do that setting. And this is like very easy, just playing with a remote or a smartphone, just like that. Have you come to this screen? Now, if you press the central button, you can see that this is the menu. I mean, this is the insulin this is the insulin that is available in the reservoir. It shows how many units are there and whether the person should refill. If anybody needs any help with respect to the pump models, please take help of Dr. Riddhi and Sajili. Then there are other menus on this, which basically, this is the settings menu. What's wrong? Okay, yeah. So this is the settings menu. This is the reservoir and set. This is the glucose values that you see. This is the smart guard settings. Basically, smart guard is the control algorithm in Medtronic 780G, and these are alarm settings. So we are going to go in the setting menu. You enter here. We go into the delivery settings. Here you can see a menu of bolus wizard setup, basal pattern setup, max bolus, dual or square bolus, and bolus increment. Dual and square bolus feature is used in the older models of the pump. In the automated pump, in the smart guard, we use only a normal bolus. We don't use dual and square bolus. So now we go to basal pattern setup. Then we press the enter button again. So you can see basal 1, which means that you can have multiple basal rates. But this is true for manual modes. Again and again, I'm saying, if you want different basal rates for weekday and weekend, you can have that when you're using a manual pump. Here we are we are putting this child on hybrid closed loop pump. On that, it doesn't matter that much. So when you when you are at the Basel 1 screen, I'm again pushing the enter button. It says options. I'll select the options. It says edit, copy. I'm going to edit these settings to enter the parameters that I want. So in the HCl pump, you can keep it simple. You can only start with 1 or 2 basal rates, or at best 3 basal rates. And then the system will learn itself in 48 to 72 hours, and the pump will manage the basal insulin by itself afterwards. So here we are going to make it 0.5 units per hour. Right now it is 0.025 unit per hour. So because I'm setting only 1 basal rate, I don't need to change the time here. If I wanted to, then I could select, let's say I want a basal rate from 12 to 5. If I do this, then I'll get another slot which says 5:30 onwards. What do you want to do? Okay. But I want to just stick to the single basal option here, just for the sake of simplicity. So I make it 0.5 here. And done. After you have done, you have to click save. If you don't click save, you will just be under the impression that you have changed the setting, but the pump will continue to work with the older settings only. Why are manual settings important? Because even when you're using HCl, manual is the backup. So if for some reasons the sensor has failed, or the sensor is out of supply or not working, inaccurate, or sometimes during sicknesses where peripheral circulation is compromised and the sensor is giving some erratic values. In those situations, manual mode is important. So manual settings have to be checked every time. Okay, so this is how you have set the basal rate for this particular individual. Now you can see that the total basal has come 12 units per day. Now you go to the bolus wizard setup. In many of the users previously, at least, I mean, now it has changed a little, but nobody was using a bolus wizard. They were using pump only as a way of just getting rid of injections. They were not using the bolus wizard itself. So it is like using an iPhone without internet. Okay, so don't do that. You have to use all the features properly, then only you'll get success. So so first thing is you have to turn on the bolus wizard, then enter carb ratio. In this particular case, our carb ratio decided was about, I think, 1:12 or 15, whatever, 1:12. Let's say that we decided 1:12. So again, here I enter. So these changes will be similar. If you want different carb ratios for, let us say, breakfast and dinner. So breakfast, sometimes the insulin resistance is more. So you want, I mean, in that situation, the carb ratio will be actually, the number will be less. So let's say that I wanted, sorry. I'll go again. Let's say that I wanted a carb ratio of 1:10 in the morning hours. Okay, so I'll make it till this child has breakfast by about 8 o'clock. So I am making insulin carb ratio as 1:10 here. And now 10 onwards, I want it to be about 1:12 or 1:15, whatever you want. Okay, so rest of the day. Okay, so rest of it, I mean, I think you've got the general picture of how you change these settings in pump. It's always a good idea not to be dependent on a company representative for this. I mean, at least it should appear for your status that you know more than them. So please make sure that you you use these devices when you have a free time, just instead of scrolling Instagram like me. Please go through the device, go through the settings, play with it, and then you will learn. And also listen to the children who are visiting you. They know much more of technology. Sometimes I have to ask that the child that please show me how you have done it. And they are amazing with respect to technology. I think we can stop here. Any particular question that
I think the overall concept of this workshop was more like we do have a hands-on whenever we have on-site course as well. So this was more to just accustom about the theoretical aspects, starting how to initiate, how to troubleshoot, and very importantly, what the experience was. So I think it was really wonderful to listen to Ganesh and how things have transformed. So clearly what we are looking, the biggest benefit of AID is not HbA1c. The biggest benefit is avoidance of hypoglycemia. I think that is something which we should always be considering. Decreased fluctuations and improved outcome. I think these are the three things we are basically looking at. These now the Medtronic has got wonderful website and other online resources which are available, which you can use to train as well. And thanks a lot for all the team. I think we did a wonderful job. Dr. Ganesh, Dr. Riddhi, and Dr. Sajali went through the overall program very well, and the Medtronic team who was here to support us from there. I'll request Dr. Nimisha to come up and give a memento to Dr. Ganesh.
in case there are any doubts, we can always discuss it over lunch, and all three of us can help in sorting these doubts.
Yes. So please. We'll request Dr. Kirti to give a memento of appreciation to Dr. Riddhi. And I'll request Dr. Ria to give a memento of appreciation to Dr. Sajili. Sajili is there? Yeah. So I think we have had a wonderful initiation of the program. We'll hand over to the MOCs for the next session.
Thanks a lot, sir. So after this incredible, comprehensive and concise talk about AID, let's move to one disease that most of us Indians will say that we don't have, but it is likely that we have it. That is obesity. I request presence of Dr. Mahesh Maheshwari to kindly come on stage and take care of the obesity workshop. The first talk will be on adiposity assessment.
So our association with Dr. Mahesh has been going on for years and years, and Dr. Mahesh has been part of each and every program that we have conducted under Grow Society. We have done programs in Kanpur, in Bhopal as well. Dr. Mahesh is a professor of pediatrics and pediatric endocrinology at Ames Bhopal, and he is running a very successful DM program. And we are happy to have a couple of the students also here in the audience. So I think this is a good initiative of spreading the message. And this workshop is focused more to highlight why obesity is not just a cosmetic issue. It's not just about being lazy. It's more about a chronic disease in which there is a combination of endocrinology, neurology, and many other factors which are playing a role and which has huge impact in terms of the complications. So Dr. Mahesh, please enlighten us about the various adiposity measurements and when do we call somebody as obese?
Thank you, Dr. Anurag, for the warm invite, and at the same time giving this opportunity to interact and come here for this annual very popular APS event. So the task in next 15-20 minutes is just to talk about the adiposity assessment. The rest part, what Dr. Anurag is talking about, the complications or the why it is important, I think my dear friends Chetan and other people are going to talk about this. So adiposity assessment is beyond BMI. Practical tools for clinical practice. That's what we thought of. What we are going to cover in next 10 to 15 minutes is adiposity versus obesity, when we should say obesity and when we should use the what are the different definitions, why adiposity measures matters, BMI as a screening tool and limitations. All of us know that is one of the first and the most important tool that what we usually use. which chart we should use in our practice. Then there is a limitations of BMI. Beyond BMI, what are the other markers which can help in getting the adiposity measurements, and the key takeaway from our practice. So what is the difference between the adiposity and obesity? So when we say adiposity, it is actually the extent of fat accumulation. It is not a diagnosis. It's a continuous biological trait. And so that is the important thing. On the other hand, obesity is a diagnosis. It's a chronic medical condition characterized by the excessive or the abnormal body fat, to the point where it negatively affects the health and increases the risk of the disease. So what is the global burden? Why it is important? We say that there are the two things that in Indian scenario, what we usually see is the malnutrition. So severe acute malnutrition. On the other side is the obesity. It's a growing epidemic. So there is a various data that was published. So in a near universal rise in the childhood and adolescent overweight and obesity across time levels. So this study was published in 2017. There's almost 2,416 studies were incorporated from the 200 countries from 1975 to 2016. And out of that, it was found that 128.9 million children, adults, and adults inducted in this analysis. So they are actually the obese. And from 1975 to 2017, there is a 4-time increase in the rise in the child and adolescent obesity. And definitely we've seen during the COVID time, this incidence is increased further, and there's a prevalence is significantly high. Even in our country, in our day-to-day practice, we are seeing a lot of patients, a lot of children who are coming to us with this particular condition. So why it needed? So this is as per the guidelines given by the obesity guidelines by IAP. So every pediatrician and the healthcare personnel should recognize and treat the pediatric obesity as a chronic disease. This is very moderate recommendation with the evidence level B. The rising prevalence of infantile, childhood, and adolescent obesity of India, including even the rural population, needs to be addressed urgently by all the stakeholders. So this guidelines is also saying the same things. What we can do? So to confirm that this is an obesity, the first parameter what we commonly use is the BMI. But BMI is the starting point, not the destination. It is the most commonly used tool in clinical practice for screening, diagnosis, and grading the overweight and obesity. All of us know that it is very easy to use, inexpensive, and in most cases strongly correlate with standard methods of measuring body fat. The formula what we are commonly use. What are the limitations? Definitely there is a limitations, and so BMI does not directly assess the body composition, and hence the fat content. It is specific, but the sensitivity is not that much. Almost the 50% sensitivity come down. BMI is not equally valid across gender and age group, especially the end of the spectrum. That means in the early age group and at the adults, and when they turned out to be adults, BMI cannot differentiate between the lean mass and the fat mass. This is the reason we need to calculate adiposity separately. BMI alone is not is an insufficient marker of abdominal obesity, and hence can fail to detect cardiometabolic risk. So in fact, 25% of normal BMI is compatible with the excess body fat that is in our Indian population. What we are seeing that even though we are not looking that fat, but the adiposity is there. So very common in Asian population. So these are the limitations from where this BMI came. So it's almost 200 years back when the first time this formula was used by Esdolf Quetelet. It was primarily used to study the human growth distribution. So it was just an observatory study that what it was planned it out. It is now universally used to study the obesity and the health risk. By this, they classified into the undernutrition, overweight, obesity. So overweight is 25 to 29.9, obesity when the BMI is more than 30, and there is a different categories of obesity, class 1, class 2, class 3. Obesity class 3 is more than or equal to 40. So this is the way that decided. But what in 1975, when first time this BMI is used to confirm that there is an obesity, this mortality indices was there. See this relationship between the BMI and obesity and the mortality index. If you see this particular thing, sorry, it is there. Sorry. There you go, pointer. So if you see these two bumps, so there is a two bumps in this particular graph when at 25 BMI and 23. Okay. So in 25 BMI and and 30 BMI, there is a classical bump. So what do they notice? That before 25, the causes of mortality is different. After the 30, the causes are different. So these are the two things that was considered as an obesity, overweight and obesity. What happened in Indian population? In Indian population, we are seeing that there is an we considered is an 23 and 27 adult equivalent to confirm the overweight and obesity as 85 percentile and 95 percentile. So which growth chart should we use? So commonly what we are seeing in our day-to-day practice is the CDC growth charts and then International Obesity Task Force growth charts and IAP growth charts. Commonly we use the IAP growth charts in our setting. Why we are not using the CDC growth chart or IOTF growth charts is because CDC growth chart is primarily meant for the United States children, and the morbidity of is defined as a more than 120% of the 95th percentile. So actually in our population, it underestimates the obesity. Similarly, on this guidelines, the IOTF constructed some charts, that is a multicentric data from 6 different countries. India is not a part of that. It uses the backtracking method and generally performs better than CDC, but definitely this is also underestimating the obesity in our population. They also keep the BMI cutoff is 25 and for overweight and 30 for the obesity. This cannot be expressed in centile. So this is the difference between what is the IAP 2015 charts. This is actually recommended for the Indian children. What they did, so all of us know that blue is for the boys and blue is for the boys and pink is for the girls. The IAP 2015 BMI chart should be used to plot BMI in Indian children. BMI cutoff considers that 23rd adult equivalent define overweight and 27th adult equivalent define the obesity for children and adolescents between the age of 5 to 18 years. In children less than 5 years, we still use the WHO charts to measure the obesity. What are the different other adiposity markers? Because this we already understood there is a limitation with BMI. We can define there is an overweight or obesity, but we cannot actually say what is the adiposity. To find out what is the adiposity measures, that there are other parameters that can be used: the waist circumference, skin fold thickness, DEXA scan, bioelectrical impedance analysis, air displacement plethysmography. There are newer parameters that is also there, but optical body scanning. These are the few new parameters that is there. So what is about the waist circumference? In our population, probably that is one of the most important indicator to assess the adiposity in day-to-day practice. Indian Academy of Pediatrics Obesity Guidelines says that the waist circumference should routinely be measured in all overweight and obese children and plotted on the Indian specific chart. They are available and is a key measure for the cardiometabolic risk. So these are the very strong recommendation from the these guidelines. In Indian children, a waist circumference of more than 70th centile can be used as a cutoff to identify those with central obesity at risk of developing the metabolic syndrome. So that is one thing that the recommendation is not that good to say it is 70th centile. Then skin fold thickness, we can measure the skin fold thickness at various sites, the biceps level, triceps, and subscapular and iliac crest to estimate the subcutaneous fat. That is another parameter that can be used to consider the adiposity. DXA, that is the DEXA, is still in Indian scenario not available in most of the places. There are very few centers that are using. Dr. Anurag Vajpayee's Regency using from a very long time, is having the highest sensitivity and specificity for detecting the fat in the pediatric population, widely regarded as a reference standard. So for research purpose, for scientific creating a scientific content, this is one of the most important tool that can be used. It's accurate, fast, a very low radiation dose, and easy to use. Is one of the most common standard for measuring body composition in children. It is the drawback is it is expensive, not available at most of the places. It's operator dependent. So even if the machines people purchase, but the operator dependency is there. And in India, it's usually largely limited to the research point of view. And then bioelectrical impedance analysis. There are less accurate than the DEXA, routinely used for body composition, and can be used probably in the because this is easy to use, portable, and relatively low cost. So when you want to use in the population-based studies, then in that scenario you can use bioelectrical impedance analysis. Then air displacement plethysmography. This is commonly known to be trade name as a BOT pod, available at few of the highest centers, is highly accurate tool for measuring the body fat and fat-free mass. It works by measuring body volume through the air displacement in an enclosed chamber. It is a safe, non-invasive method, but costly. And yet validation from the Indian population is not there. I am able to find out hardly 1 or 2 studies in Indian population, and that is also not in a pediatric age group. So what are the key takeaway from this initial introduction to obesity? I think everyone is know that how to diagnose obesity, how to diagnose adiposity. All of us are interested actually what are the complications of obesity and what is the treatment that we can give. So treatment part is nowadays is probably as a endocrinology, especially in adult endocrinology, it is a very important practice marks. So Dr. Anurag is going to talk. So what are the key takeaways? BMI remains still in our population the starting point for the screening, but is not sufficient alone to diagnose the excess adiposity. Use IAP 2015 charts for Indian children up to the age of 5 to 18 years and less than 5 years. Use the WHO charts. Always measure waist circumference in overweight or obese children as a marker of cardiometabolic risk. Consider DEXA, BIA, or skin fold thickness or plethysmography or more precise assessment body composition whenever this is available, or you are planning to hold a research in this particular field. Treat the pediatric obesity as a chronic disease that requires early recognition and long-term management. So I think this is just the beginning of this particular workshop, and this will sensitize you that obesity is a very important chronic condition that needs to be dealt in a urgent matter. Thank you.
Thank you for the informative talk, sir. Now for our next talk, once we have identified obesity, our natural question would be why we should treat it. So I invite Dr. Chetan sir for his presentation. Thank you.
Thank you. Thank you, Anurag sir, for having me here. Kanpur has always been a second home for me. And today we'll discuss that why do we need to treat obesity. As a hormone doctor, I must say that we are what we are because of our hormone. If there were no hormones in our body, our condition would be like this. So it's the hormones who make humans. But if you are an obese, that these all hormones will make you worse human. And that's why we'll discuss that why do we need to treat obesity. So when I was doing my fellowship 10 years back, 8 years back, we were writing in the research paper that obesity is a ticking time bomb. But now I realize that it's not a ticking time bomb. It's a bomb which already been exploded. And as we know, being a general pediatrician, you also might have observed that nowadays, the normal patients coming to your OPD are overweight and obese. So it is an epidemic which has been incidence being increasingly rapidly increasing. If you talk about 2016, 10 years back, there were 41 million children who were obese. But nowadays, as Dr. Mahesh has said, that more than 100 million patients worldwide, and approximately half are living in Asia. And India and China are the home of obese children. And another thing that we are currently ranking second number after China, and we have overtook the US as far as the incidence of obese children are concerned. And that's why we need to address this obesity problem as early as possible. And why it concerned? Because the research show that the childhood obesity persists into adulthood. Those children who are into adolescent age group, if they become obese, then this obesity will persist throughout life, as shown by this graph, that if you are obese at 15, you will be obese at 25, you will be obese at 30, you will be obese at 40, you will be diabetic at 40, you will be hypertensive at 50, and all complications will be there with you whenever you cross 50. So this is the reason while childhood obesity is important. If the obesity is less than 6 years of life, 50% might become obese adult, but this figure goes to 80% when it is between pubertal age group and adolescent. All adolescent become obese adults. So why do we need to treat obesity? There is a saying that thyroid affects all part of our body. Similar is true for obesity. Obesity can affect all organs, from your hairs to your skin to your digestion to your reproduction to your bones to your mental intellectual level and all. And the most common being liver, which is affected primarily. We know that liver is the guardian of the body. Liver does metabolic refreshment whenever we sleep. But if fat gets into the liver function gets distorted, and non-alcoholic fatty liver disease, or you can say metabolic dysfunction associated steatotic liver disease, which is the new term, is the first and the most common observation, in which first of all there is hepatosteatosis leading to hepatic fibrosis, and then there is distortment in the cholesterol metabolism. Then you will have dysglycemia, which is due to insulin resistance, which is also contributing to another complications. Like if you have diabetes, if you have type 2 diabetes, that invariably you will have metabolic complications, other metabolic complications, as well as macrovascular and microvascular complications later into the life. So obesity is a multifactorial, which is leading to type 2 diabetes, which is also a multifactorial and which can lead to life-threatening complications. So root of all this thing is obesity, which is nowadays rapidly increasing in the childhood age group. Another important is obstructive sleep apnea. As we know that now we are observing snoring in obese children as well. And we have not recently, but we have seen the death of one music director due to obstructive sleep apnea. And as a pediatric endocrine practitioner, I have observed many obstructive sleep apnea kids in which if we do the sleep study, then we are finding many hypoxia episodes during the sleep, which might damage their brain, which might damage their intellectual level, which might damage their memory, and ultimately fatal hypoxia can also occur if we don't treat. So OSA is the thing. And whenever obese patient comes to you, you should ask the parents regarding the history of snoring. If snoring is present, number one, ENT opinion for adenoids, and number two, sleep study is must. Nowadays, there are many centers in India who are coming up with the pediatric sleep study. So definitely, if child is snoring, then sleep study is must to see the impact of OSA. And last, not the least, but it's a joint issue. Joint issue is happening with two reasons. One is obesity, which is putting load on joints. Plus, these obese kids are not physically active. So their muscle mass is low as compared to their fat mass. So these two factors contributing to early joint erosion, early osteoarthritis. And nowadays in our part of Gujarat, we are seeing joint replacement for the obese adults at approximately 30-35 years of age, who are obese from their adolescent age group. So definitely this is also another issue, because whenever there will be joint pain, physical activity will decrease. And this will lead into a cycle in which there is gradual decrease in the physical activity, which is even more contributing to the obesity. And this obesity again more lead to erosion of the joints. Another thing include hypertension. I will show the data of our own paper in which we found hypertension at a very high incidence. Adolescent obese girls, including PCOD thing, which will lead to future fertility issue as well as cosmetic issue. And first sign is acanthosis as well as tags, which is very hard to treat. And many of these acanthosis patient goes to dermatologist, not coming to us as an endocrinologist. They present only to us after they have tried all skin lotions and blah 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 and supplements and all. So acanthosis is also a concern for the parents, as well as it should concern us, because we know that it is a first sign of insulin resistance. And the last is psychological issue. This is becoming major issue. Nowadays, India is also reporting suicidal behavior, aggressive behavior, mental instability, impairment of concentration in all those obese due to school bullying. Their friends are bullying in their whatever studies and all. So suicidal tendency should also be asked to the parents as well as to the child as well. Mood swings, inability to sleep properly, this all might contribute to the psychological issue which is related to obesity. So this all things, plus there is risk of mortality. So this is the graph showing that the childhood obesity leads to premature mortality. As we know that the BMI cutoffs are based on the mortality. So the obese child will be obese adult, and this obese adult will have earlier mortality as compared to the norm. So not in terms of mortality plus also morbidity, but also mortality, if we see that the obesity plays an important role. We did our own school project here at Kanpur and we examined more than 5,000 students. We did their fat analysis and all, and we found that 31% children were overweight and obese. Those who are school going and those who have not any of the complaints. Out of this, we found the risk factor that junk food intake, cold drinks, and watching screen while eating were the major contributive factor of obesity. And even if you must have observed that even our kids are tend to have this tendency, and this starts from very early, less than 1 to 2 years, when mother wants to feed the child. Mother wants that her child must be sitting appropriately, patiently, and then eat. So she introduces cell phone to a 1 or 1.5 year old child, and from there this bad habit starts, and ultimately leading to overeating and ultimately leading to obesity. So our own data, out of those who are obese, we found that the 40% had dyslipidemia, with low HDL being the commonest. 8% were pre-diabetic and 2% were type 2 diabetic, those who didn't have any symptoms. 32% had high SGPT, and we did intervention and we found that 10% BMI standard deviation score lost will be able to revert all these metabolic complications. So it's not difficult to treat obese if you find them at early age, and if you do proper intervention in terms of diet, exercise, sleep, and screen time limitations, then definitely you will be able to get the results, and you can prevent all those complications which has been discussed, from mortality to morbidity to the psychological issues. So in a nutshell, obesity is rising like anything. So many life-threatening complications, including mortality, and majority will reverse with the BMI loss. So these are the reasons why we should treat obesity. And with this, I would like to end my talk. Thank you very much.
Thank you, Chetan. And Chetan was part of our initial pivotal school studies, which really showed all these complications and what sort of cutoffs we should use. So I think thanks a lot. We'll get back again.
Thank you for the wonderful presentation, sir. We now have a working lunch. Kindly collect your lunches and return to your seats as we proceed with the next sessions. Our next session is on the cornerstone of management of obesity, nutritional interventions. I now invite Dr. Prashant Shukla to deliver the next talk.
So thank you, Dr. Kirti. Yes. This is fine. So good afternoon, all of you. So today I'm going to talk about medical nutrition therapy for obesity management, and with special focus on both childhood and adolescent obesity. And the main message of this presentation is obesity is not just about excess weight. It is a metabolic condition, and diet can either drive the problem or become a therapeutic tool. So my today's focus is not only what to eat, what to avoid, but how dietary pattern can influence the body composition and long-term metabolic health. So let's talk about the burden. So pediatric obesity is no longer a future concern. It is already a present endocrine and metabolic challenge. And if we see the recent data, so India has an estimated 41 million children aged between 5 to 9 years are overweight or obese. And India ranks second globally in pediatric obesity. So the question is not, is the child overweight? The real question is, what is metabolic complication is already developing silently. So, and that's why the pediatric obesity needs active screening, not just lifestyle advice. And we have seen the clinically relevant associations, because due to obesity, we have hypertension seen in around 29%, MSLD around 34 to 47%, pre-diabetes is around 40%, dyslipidemia, insulin resistance around 30 to 40%. So that means obesity screening should not stop at BMI. We need to look complete metabolic parameters. So when if any child comes with pediatric obesity, we should not wait for the symptoms, because the concern is not that the children are gaining weight. The bigger concern is that many of them are already developing metabolic complications. So let's see what's driving this burden. So most pediatric obesity cases are lifestyle associated, but we should not oversimplify it. So measures here around 90% is attributed to lifestyle factors, 5 to 10% due to pathological cause, and 1 to 5% may have genetic etiology. So we all know obesity, most pediatric obesity is lifestyle driven, but every case deserves a clinical lens. So now coming on one practical question, because when two child having a same calorie diet, and one diet is high in carbohydrate and fat and low in protein and fiber, so what do you think? Will the metabolic response be the same? No. Yeah, so calorie matters, but the nutrient composition decide the metabolic risk. And this slide shows exactly where the gap exists. So if you see the recent data by ICMR and National Institute of Nutrition in 2024, so in current Indian diets, carbohydrate is intake around 60%. And the recommended target in obesity management is 40 to 50%. That means in Indian diets, carbohydrate is 12 to 17% above the target. And if we talk about the protein, so the average intake of protein is around 0.6 gram per kg body weight, and the target is around 1.2 to 1.5 gram per kg body weight. That means 40 to 50% is below the target. Similarly, if you talk about the fiber and fat, the fiber is substantially in the lower side, and fat intake is around 30 to 40%. That means closer to or above the target, and the major concern is often the fat quality. Around 30% fat intake is in the form of trans and saturated fat. So, and this nutrient gap has in clinical consequences, because high refined carbohydrate causes rapid glucose rise, which triggers insulin spikes. And when it combines with low protein and fiber, satiety becomes poor, child feels hungry again, snacking increases, and this excess energy redirected to lipogenesis and visceral adiposity. So when you are talking about the diet, you should not only ask about the calories, you must confirm the quality of the calories, because your metabolic response depends on the composition of your nutrients. So at this point, parent will ask very practical question, because when parents see the weight gain, they often look for the quick solutions, and that is where the fat diets comes into the picture. So quickly, I just wanted to understand what are the common questions you generally faced during your OPD sittings while you talk about the diet and obesity. Like, should we try keto? Is the intermittent fasting safe? Which diet gives the faster result? And these questions are common because parents are worried and they want quick solutions. But as an expert, our role to give evidence-based answer. So now this slide will answer these questions. So if you see the left side of the slide, so it shows restrictive meal pattern. And I have taken this ketogenic and intermittent fasting because these two dietary patterns are widely used in obesity and overweight. So if in the keto diet, we'll see that reducing the carb intake, and in intermittent fasting, that reducing the eating window. That means we are reducing the calorie intake. And because of the calorie reduction, initial weight loss can happen. But when we see the another side of the slide that shows a completely different picture, over time, low GI sustainable meal pattern gives you the better management. While restrictive meal pattern shows around 68%, that means 1/3 body weight rebound after stopping it. So fat diets may give you the early result, but the overtime, low GI, high fiber, sustainable diet give you the better management. So far we have seen that how diet can be one of a driver of obesity. But the same diet can be redesigned as a therapy. So diet is not only a risk factor, it is also a treatment tool. So these are so when you are talking about the diet, you always consider a structured based, medical nutrition therapy. And these 4 steps help us to move from general advice to structured medical nutrition therapy, nutrition assessment, then classify the severity and energy planning, nutrient optimization, then finally go for the practical and right diet plan. So now coming on the assessment part, and I'll not go into the full details of the assessment because sir has already explained very well this assessment part. So I'll briefly highlight the nutrition relevant area. So these are the 4 important steps in assessment like anthropometric, clinical, biochemical, and dietary. So anthropometry tells us the severity. Clinical sign like blood pressure and acanthosis gives the practical clues. Biochemistry tells us the metabolic severity, and dietary assessment will tell us like what needs to be corrected. So after management, now coming on the calorie planning and goal setting. So in adults, staging is based on BMI cutoffs, and in children we also use BMI for age percentile. But the key point is BMI tells us the severity, not the calorie need. So we should not prescribe calorie based on the BMI only. First, we need to classify the severity, set a safe goal, then plan calories. So if we talk about the adults, so in Asian adults in Asian population, overweight starts from BMI 23, obesity starts from BMI 25, and in children, overweight is more 85th percentile to 95th percentile. Obesity is more than 95th percentile, and the severe obesity is more than 120% of 95th percentile. If we talk about the goal setting target, so in adults, weight loss target can be based on BMI cutoffs. So in overweight, 5 to 7% weight loss may improve metabolic benefits. In obesity, 7 to 10% may usually more useful, and in severe obesity, 10 to 15% or more may be needed, especially when if any metabolic complication is present. If we talk about in children, so we do not use BMI number directly as we use in adult, because BMI changes with age and sex because during the growth pattern. So the goal is not aggressive weight loss in pediatric. The goal is improve BMI trajectory during growth while protecting height, puberty, muscle mass, and the nutrient adequacy. So the message is simple. Adults weight reduction is based on the BMI, but in children treatment should support healthy growth, not aggressive weight loss. So now coming on the nutrient optimization, and we return to the previous slide as we saw the nutrient gap earlier. So for the carbohydrate, we need to keep the target around 40 to 50%, which is roughly around 3 to 4 gram per kg ideal body weight. And the carbohydrate should be low GI and high fiber. So that improves satiety and reduce the post-meal glucose spikes. And the good sources are basically millets, oats, dal, pulses, legumes. And on the other side, refined carbs like maida, sugar, and the bakery products should be limited or avoided. If we talk about the protein, so they keep the target between around 20 to 25% of total calorie, which is 1.2 to 1.5 gram per kg ideal body weight. And protein preserve lean mass, improve satiety, and promote overall healthy weight loss. So, and the good sources of the protein is egg, fish, dal, paneer, low fat, curd or tofu, and avoid fatty red meat and fried options in the protein. And similarly, if we talk about the fat, so the target, keep the target between 25 to 30% in fat, and always prefer the good sources of healthy fats, which is vegetable oils, nuts, flax seeds, fatty fish also, and avoid trans and saturated fat, cheese, mayonnaise, ghee, butter, processed foods, bakery products, and all. So, and this nutrient optimization benefits are not limited to the calories alone. Better food quality also improve your gut health. So if you see the left side, when the gut bacteria are imbalanced, your gut lining become poor, inflammation increases, that decrease the signaling is SCFA and GLP-1, and insulin resistance and adiposity may increase. And while if you see the another side of the slide, so healthy microbiome keeps the gut lining strong, inflammation decreases, signaling becomes better, insulin sensitivity and the action of improved. So that's why we should not only talk about the diet and the calories. We definitely must focus about the nutrient quality as well. So now coming on the practical approaches during obesity management. So always advise frequent, small and frequent meals or 3+2 formula. So 3 main meals and 2 planned snacks that prevents long gaps, grazing and rebound hunger. Your breakfast must contain protein because it improves satiety, lowers post-meal glucose spikes, and that supports the healthy weight loss as well. And if you talk about the diet, so your plate should contains all the nutrients in the right proportion, as we saw earlier. And the most important thing during the weight loss journey, we often see the lot of fruits, fruit load or fructose load, during the weight loss journey in the diet. So avoid too much fruits during active weight loss journey. You may include whole fruits in moderation, but the extra fructose, like in the form of fruit juices and smoothies, can increase the carb load, and that may increase the hepatic lipogenesis as well. And then finally, choose a plan that family can sustain, because a flexible plan always better the extreme restrictions. So go for the flexible and sustainable meal plan as well. Now, and in addition to the practical approach, always follow the traffic light approach. So green foods are most often, and the yellow foods choose in portions, or sometimes in the red foods should be limited and occasionally. The packed food literacy is also very, very important, because that packed food, most of the time you will see the healthy icons and tags and the line from the front, but the front is the marketing, and the back labels will always give you the truths. So always consider the nutrient composition and the ingredient list in backside of the packet. And the mostly consider the sugar content and the salt content, sodium, fiber, carbohydrate, fats and all. So now coming on the important part of the presentation, when lifestyle is not enough. So definitely lifestyle remains the foundation during your obesity management, but we should be honest. Lifestyle may often provides 5 to 10% weight reduction, but in many patients, like in severe obesity and the obesity with comorbidity, this may not be enough due to the adherence may decline over time, biological adaptation may increase hunger, and energy expenditure may reduce over time. So that's why the main point is when to use pharmacotherapy. So if we talk about, so pharmacotherapy may be used in appropriate patient, and now the current guidelines are we use pharmacotherapy in adults 12 years or older, and the ideal patients or candidates are if the BMI is more than 27 with comorbidity and the BMI is more than 30. So now why medication and the better nutrition therapy gives the better outcome. So if we talk about, so structured meals actually lower energy exposure, and the better nutrient optimization provide the better satiety, and the adequate protein preserve the meal muscle loss. Correct. So that's why we always go with the medication with the nutritional therapy as well. So now when to refer a dietitian. So if there is any poor diet quality, refined carbs and increases, if you see the rapid weight gain, so then you should go for the dietitian. Metabolic risks are present, so then you can refer the dietitian. And also if eating patterns are issues, so definitely we need to refer a dietitian as well. And before medication, structured nutrition plan should be first at the place. So now coming on the take home message. So diet matters because food pattern can drive or improve the obesity, and high GI foods, refined carbs, glucose rise the insulin spikes and decrease the satiety as well, and build better meals. Structure a balanced meal like protein, fiber improves the better satiety and post meal glucose spikes. And keep it practical. Structured and family based plans works better than restrictions, and think long term. The goal is metabolic health, not the just weight loss only. So thank you very much.
Thank you for the informative session, sir. Now, with rapid advances in pediatric obesity therapeutics, we have a lot of options at our hand. So it is very important to know when, whom, and how to use the drugs. To take us through this evolving landscape, I now invite our organizing secretary and program director, Dr. Anurag Vajpayee, sir, to speak on therapeutic interventions.
So I think the stage has already been set with regards to why do we need to treat obesity, what is obesity, and now the big question is how do we treat it? And now we need to understand is that the way obesity has progressed, we cannot just rely on lifestyle. If you look at this child who came to us recently with a height of 165, and what we can see, his BMI is plus 3.2. This is not unusual. If you do any study on obesity, we see a mean BMI SDS of plus 2.5, plus 3, which is very, very common. Now, what's happening in this case is already we are seeing MASLD has happened, diabetes has happened, and this child, because of a weight of 127.5, has been referred for bariatric surgery. Now, this was something which was quite commonly done and we didn't have any option. The problem is at 16 years, how many patients will go for bariatric surgery? What will be the complications? The question will always be, what can we do before that and how can we prevent in that perspective? So I'll talk about therapeutic options in obesity, the why, what, and how. Why has already been covered, but we know that there has been a dramatic increase in obesity. The whole BMI has shifted by around 1.5 points if you look at the mean BMI over the last 20-30 years in that perspective. This is our own study which Chetan was alluding to. 36% individuals are either overweight or obese in school. So this is an extreme problem. And out of these, more than 2 complications are found in 50%. So what we are seeing is that 20% of children actually have some metabolic complications which never happened in this setting earlier. So this is something which is very important and there are a lot of issues to look at. One thing which people often ask is how much loss of weight is important. And Prashant did talk about whether we want to have a weight stabilization in children or not. So our own data clearly suggests that if you lose 5%, BMI SDS. So I'm talking about delta BMI SDS, less 5% and more pre-diabetes will go. If you want to reverse MASLD, you need 15% of loss. So MASLD is the first to come, last to go. And if you want to reverse type 2 diabetes, this is our type 2 follow-up cohort which Dhwani had authored, we need 10% of BMI SDS. So a minimum 10% is reasonable. And if you can achieve 15%, that is something which we really want. But what sort of efficacy options do we have? And how much benefits do we get in that perspective? So if you look at the options, we can either go for lifestyle. There are pharmacotherapy options available. And finally, bariatric surgery, which the child was referred to in that perspective to go forward. Now, lifestyle interventions clearly have shown that they would be a good initial weight loss. But as soon as there is a fall of leptin level, the body will start thinking that this patient is going to die, is going to starve. They are then going to have a regain phenomena and the weight will really regain because the leptin has got down. So most lifestyle interventions are talking about maximum of 3 to 5% of BMI SDS loss during studies, and this is not sustained. So this is not going to be very beneficial in that perspective. So there is always a ceiling effect. So lifestyle may be good for some preventing obesity. It is very good for children with overweight, but not for somebody who has established obesity. Those who are coming to us in the endocrine clinic in that perspective. Now, what about the other things like bypass? So there are studies about gastric bypass and gastric banding, and you can see they are very, very effective. They do show a BMI SDS loss of around 20 to 25%. So most complications will go, but this is a very massive procedure. A lot of complications will happen, and we cannot just take it as a simple procedure and go from there. So there are always risks. So what do we really want? So most problem with lifestyle is not sustained. Medications that were available had variable effects and adverse effects as well. And the issue here was there was morbidity and mortality with bariatric surgery. So this really leads us to need of agents which are safe, which are selective, and which are effective, causing at least 10%, and we can say maybe 15% will be very good in severe obese cases. So this is what we really want. So how do we design a therapy for somebody with obesity? Obesity ultimately is the issue of energy balance, how much energy you are taking out, which basically depends upon your hunger, your satiety, and then how much are you expending in that perspective. Now, one thing is very clear, if you focus on expenditure part, that is not going to be very, very beneficial. Remember, one of the earliest medications people used was thyroxine. They gave thyroxine to euthyroid people maybe 50, 60 years ago, thyroid extract, and thought that this will result in loss of energy. But what it resulted was loss in muscle mass, loss in bone mass. So energy expenditure is not area which people are focusing. However, novel agonists of thyroid which are working on specific subtype receptors are being explored. So maybe this may come up, but we are not talking about energy expenditure at the moment. What we are focusing is in terms of intake. Now, when you talk about intake, the question is whether it is the hunger or it is the satiety. So what should you focus on that perspective? So clearly, if you look from that perspective, the food intake has got multiple parts. One, we are hungry, we are eating. So it's like a homeostatic eating, which we talk about. It is based upon energy. But most of us do have other types of eating, like for pleasure, like which is basically opioid mediated. When you get stressed up, you're working at night, you will do that, which will again be the amygdala switch. And then, of course, social clues. Everybody is eating, you also start feeling hungry from that perspective. So homeostatic is less, pleasure is extremely important. So people thought, let's focus on pleasure. So what they started off, they started with the sibutramine, they started with fenfluramine, agents which altered these opioid balances. The problem is once you do that, there will be other impact as well. There will be psychosocial issues, suicidal tendencies, and that was associated with a significant drawback. So most of these medications are now withdrawn from the clinical perspective. So we are focusing on homeostatic regulation, which becomes important. So when you look at a food cycle, actually what happens is that you are not eating continuously. You feel hungry, you eat, and then you have satiety, and then the hunger stops. So whether hunger is more important or satiety is more important. Hunger is largely driven via ghrelin, while satiety, we have got multiple factors, including GLP-1, which is the talk of the town in that perspective. So if you look at it, if you really stop hunger, so ghrelin was diagnosed much earlier and people thought if you use ghrelin antagonist, they may be beneficial. But ultimately it was found that it was not beneficial because hunger has a very important mechanism overall. Ghrelin antagonist is basically being used predominantly for Prader-Willi. I'll talk about that, how that agents have come up in that perspective. But mainly satiation is to focus. So if you want to cut down energy balance, focus on energy intake, focus on satiety. That is what I'm trying to come back from that perspective. So satiety is the major factor in that regards. So what you really want is that if you look at the overall control process, there is a central processing unit which is there in the brain, which gets signal from the periphery, and it then decides about how much you are going to eat and how much is the energy expenditure. So from that perspective, the signal is coming from various forms. Leptin is going to tell you how much is the energy status. And based upon that, you also get signals from the vagus and the stomach, whether it is full or not. Based upon that, multiple pathways will come in. If you are too much in, if you are deficient in energy, the orexogenic pathway will come in. You will eat more and then you will be spending less in that perspective. While if your food is full, there will be secretion of GLP and GIP, which will come from the incretin pathway. It will say, okay, you are full, you don't need to eat more. And this is the normal mechanism to work. The anorexic pathway will come on. So now other thing to remember is that whenever you are using the lifestyle intervention and you are restricting your foods, the energy expenditure also comes down. Because body thinks that you are going into a starvation mode, and that really limits the ceiling effect I was talking about. So we want an agent which causes decrease in overall food intake, but not decrease in terms of the energy expenditure. And that is something which is pivotal from that regards. So the agents which are available include the GLP analogs, the GLP-GIP analog, The MC4 receptor, which is a major area. So this is also a target area. I'll talk a bit about that. Leptin and related treatment, which now are approved only for children who have leptin problems. They're not approved for other people because most obese individuals are leptin resistant. Giving them more leptin is not going to help out in that regards. And of course, incretin modulation is an important pathway, and ghrelin agonist also we will talk about a bit from that perspective. The energy expenditure part, the treatment options are limited from that regards and which are not there. So what about the drugs which are available? Orlistat is the only drug which is easily available, but it is hardly effective. The loss is approximately 3%. So that is somewhere around lifestyle factor mark. So orlistat is not going to help you out reverse anything. Neither pre-diabetes, nor MASLD, nor diabetes as we discussed. So this is a drug which we should not be considering too much. The cost itself is not that less in that regards. A lot of people use metformin, particularly to cause anorexia. Remember, metformin is not an anti-obesity drug. Metformin should only be used if there are evidence of type 2 diabetes. It is basically approved for type 2 diabetes in adolescents. In certain situations like plus minus MASLD and PCOD, you may consider metformin. Do not expect dramatic improvement. Maybe again 3 to 5% is what metformin will be doing from that perspective. What about phentermine and topiramate? So topiramate is an anti-epileptic agent, and the neurologists found that when you use this drug, weight gets less. And it is a reasonable drug. Many studies do talk about 10 to 15%. This is in fact an NEJM article which talk about around 8 percentage point fall in BMI. So it's like double of orlistat, but always be wary of centrally acting agent. So this is basically an agent which is altering the neurotransmitters, and what will be the harm, we don't know. So if you have a patient who is on anti-epileptic drug, shift to topiramate. I think that will be a better option rather than giving every obese child phentermine and topiramate, which may cause more harms from that perspective. So this is not something which has become very popular in terms of combination, but it's a centrally acting drug. Finally, coming to incretins. So incretins have been known for a long time. So the Banting and Best group actually talked about substances which were secreted in response to oral intake of glucose in 1940s. So they were talking about substances which are secreted by the GIT which cause insulin release, and they called them incretin. So now we know that whenever we have a carbohydrate intake, the duodenum and the ileum secretes both GLP-1 and GIP, which have multiple factors. Now, what do the incretins aim for? They want that their glucose surge. Now, what Prashant was talking about, rapid surge will cause more fluctuations. We want that surge to be blunted. So they will decrease the gastric emptying. They will have an impact on inducing satiety at the central processing unit. And also they will have benefit in terms of insulin and glucagon secretion. Remember, insulin itself is also a satiety-inducing agent. So if your insulin is working fine, you will do better in terms of, so it will be a second response here. More importantly, the resting energy expenditure is not decreased after you have given a GLP or a GIP. What does it mean? That ceiling part is broken. So I think this is where the glass ceiling is really broken from that perspective and becomes important. So there are multiple GLP-1 receptor analogs. Now they're available for decades. We have liraglutide, which was there, exenatide, and I'll talk about them as well. And they were found to be, they were approved for children with type 2 diabetes as well as obesity. But the figures, when you see, will be like 5%, 6%. So they were not a next generation, so to speak, in that regards. Semaglutide was the agent which really changed the whole perspective, starting first from adult with diabetes, with adult with obesity, children with obesity, and now in India also we have approval beyond 12 years. So this really resulted in a double-digit reduction of around 12%, 15% BMI SDS loss. Then came the dual agents, which are combination of GLP plus GIP, tirzepatide, already approved in adults, talking about loss of approximately 20%. So this is going towards even higher level from that perspective. And then there is a talk about triple agents which are coming up. So I think this field is really broken up, and we'll talk a bit about the various evidences and what the clearances are there in that regards. So liraglutide was the first GLP which was approved in children. This was published in NEJM, and they did find a good response in that regards. Now, what you're looking out here is a loss of around 5 to 7%. So it's not going to be dramatic. It was reasonable. And the other part to look at is this rebound which is happening after they stopped the therapy. So it was there, but it was not extremely effective. It was a moderate effect, and a bounce back was there. One of the leading trials was the once weekly trial of semaglutide in adolescents. And what we are seeing here is a minus 15% loss. So this was the first drug which is talking about super 10% and above and 15%. So 15% is what we talk about in the setting of MASLD. So if you lose 15%, pre-diabetes, diabetes, MASLD, everything can go off if it was treated in the right time. And this study really showed that more than 20% loss happened in around 1/3 of individuals. So this was a very effective therapy which came out. And if you look at the efficacy outcome, again, stratified showed a good response. So semaglutide clearly, after the adult evidence, also shown in pediatrics to have a good outcome. And there was a good response. And this was the primary endpoint, minus 16%. So this is a very big figure in that perspective, in that regard. So this is something which was effective in that perspective. But we always want more in that perspective. So newer drugs started coming as well. Tirzepatide, this is the adult data, which specifically looked at tirzepatide or Mounjaro at that point of time at multiple doses. And the figure went down to around 20 to 23%. Now, what is the ideal figure or the target that we are looking at? Bariatric surgery typically causes around 20-25% loss of BMI. So if a drug is able to achieve that 25% mark, I think we will close the shop for most bariatric surgery, because that's of course a surgical procedure, has complications, is difficult. So this drug really was found to be effective at the adult level, and this efficacy was published recently. Now, recently, there was a trial of tirzepatide in type 2 diabetes in children, the SURPASS-PEDS trial, which again showed a very promising result of HbA1c reduction of around minus 2.23 points. So when we talk about HbA1c, if you look at SGLT2 inhibitor, the HbA1c reduction is around 0.8%. DPP4 inhibitor, that is 0.8%. Sulfonylurea is 1.5%. So you have a drug which is causing 2.5 reduction, which basically means something like insulin. So this is a very good option. So obese, if you use insulin, weight gain will happen. And here you are losing weight as well. So clearly these groups of drugs are going to be effective for type 2 diabetes in children. And in our own data, when we published about type 2 follow-up, we did realize that if somebody is on insulin and you wanted to remove, you need to use GLP-1 analog. And at that point of time, we had used other agents like liraglutide or liraglutide. So these agents will really take them off insulin. So type 2 diabetes, we need to watch the space for these agents to come up, and these have been found to be effective. There are other agents also in the marking. So there is a combination of amylin analog, which is cagrilintide, and semaglutide, which is cagrisima, in adults, again showing a very promising result of around 20 to 23%. So now we are talking about 20% and above reductions, which are happening with that. Already pediatric studies are being planned, and hopefully this will be another agent to come out from that perspective. Now, ye dil mange more. So now we have got triple therapy also, which has come up, which is a combination of glucagon, GIP, and GLP. And what they are talking about is 24-25% loss of BMI in adults. So what we are basically looking now is that maybe in the next time when we have the session, or maybe at least 2-3 years down the line, pediatric surgery will stop and we'll have all these agents to be there. But remember, these agents also come with adverse effects. So what are the common adverse effects? The most common adverse effects are GI symptoms. We should not give them in somebody who has got pancreatitis, in somebody who has got a family history of medullary carcinoma, thyroid. Around 30 to 40% may have GI symptoms to begin with. 6 to 9% may have to stop the drug also. So it has to be cautious. You have to tell the children that they should take a limited amount of food more frequently, small feeds, eat only when hungry and eat only till hungry. That is a very, very important concept in that regards. So these drugs are really coming up. So in this case, what we can think of is using a GLP-1 receptor analog could be there. Until now, we did not have any option with regards to the overall availability of GLP-1. But recently, we had got approval in India of the use of Wegovy, which is a Novo Nordisk agent in the use of semaglutide in teens. Specifically, this approval is for that particular innovator compound. So now there are many other semaglutides which are available in India. Beyond 18 years, they are approved, but till 18 years, only brand-specific approval has been given by CDSCO because proof have to come from all the other agents to prove that they are effective in that perspective. Now, coming on to the other scenario. So we talked about the general obesity. What about other conditions like this genetic obesity? So this girl has a leptin receptor defect. What are the options? So here we can think of the POMC pathway, how it works. So leptin stimulates POMC, which then produces MSH acting on the MC3, MC4 receptor. So if you use agents which are targeting the MC4 receptor, which is setmelanotide, it is going to be effective in many scenarios. So MC4 receptor agonist is now approved in many of these conditions like POMC defect, proconvertase defect, leptin receptor abnormality, and they are found to be quite effective. There was a lot of talk of leptin being used, but now it is clear that most OBs are leptin resistant. So there is no role of using leptin in that perspective. So setmelanotide will cause huge. So this is the effect of leptin in obese individuals, and you can see massive decline, which is happening in terms of obesity. And this is about MC4 receptor, again, 20-25% fall in weight. These drugs are not yet easily available in India. They are expensive, but I think for specific conditions, they will have a role in multiple monogenic causes. So for monogenic causes, think of a MC4 receptor defect. Now, what about the other conditions of syndromic obesity? So Prader-Willi is a common condition and we always struggle managing weight with them. Growth hormone has some improvement in body composition, but is not extremely effective. So people tried GLP-1 receptor analogs in Prader-Willi syndrome. The response is ambiguous. This is not something which is that effective here because the problem in Prader-Willi syndrome is hunger. It is not satiety. So they have continuously hungry. If you finish satiety, it may not be of much benefit in that regards. Now, as I promised you initially, ghrelin analogs are coming up now in treatment of Prader-Willi, but again, very, very early study, as are oxytocin-based therapies as well. So there may be something coming up in Prader-Willi, but the space is a bit limited as that regards. So just to summarize, Orlistat 3% weight loss, more of steatoria, GI symptoms, not very effective. Metformin only if there is diabetes, PCOS or other abnormalities. Phentermine topiramate, we will not be going ahead that much because that can have other central parts. I think the time is mainly for the GLPs, and it's good that now semaglutide is approved in India. And we are trying to bring up recommendations as part of ISPE, at least at the expert level, as to who should be used, how it should be used, and what short we should go forward in that perspective. The other agents coming up may be tirzepatide, not yet approved in children for obesity. It's approved in US for type 2 diabetes between 10 to 18 years of age. So whether we can get this dream of really going ahead from bariatric surgery is something to watch for, but hopefully these things are there. So what our aim was to have a safe, selective and effective therapy probably is coming out in that perspective. And we should go forward. If it's an exogenous obesity, if it's really morbid and lifestyle is not working, think of GLP. If it's monogenic, think of setmelanotide. Syndromic, oxytocin is something which is available. And newer agents like cagrilintide, tirzepatide, and rutatride are the agents which are going to come up maybe in the next couple of years. We'll talk about that in detail. So I think this was the part we wanted to discuss on. I'll hand over to the MOCs.
I request sir to present mementos to the speakers of this session. Dr. Mahesh sir. Dr. Chetan sir. Dr. Prashant Shukla. Thank you, sir. Now, with this, we end the obesity workshop. I hope all of you had a scrumptious meal and have replenished your ATPs for the next session. State of the art therapeutics. Pediatric endocrinology is rapidly evolving with advances in genetic analysis, improved affordability, precision medicine, and targeted therapies. And it is very important that we evolve with it as well. To guide us through this session, I invite Dr. Manisha Maurya, Dr. Anamika Saha, and Dr. Aradhna Singh to grace the dais and preside over the session.
First. Yeah, start.
We begin with a topic that has witnessed remarkable progress in the recent years, skeletal dysplasias. I now invite Dr. Arun George to deliver the first talk for the session.
Just one second. Maybe you can start off with the introduction. We're just loading the presentation. Okay. So Dr. Arun has been closely associated with us for so many years, and it's good that he was able to come here. Dr. Arun has done his training in CMC Vellore and then he did his DM in pediatric endocrinology from PGI Chandigarh and currently is working as the assistant professor at CMC Vellore again. And it's a pleasure that he is here and he'll be talking about such an important topic of how skeletal dysplasias have changed from that perspective. So over to you, Dr. Arun.
Good afternoon, everyone. I thank Anurag sir for this wonderful opportunity. And today I'm here to talk about what's new in skeletal dysplasias. So I'll be talking about two of the important drugs which have been approved. One is vosoritide and something about the drugs which are in the pipeline for skeletal dysplasias. We all have a lot of we all get a lot of patients with skeletal dysplasias into our OPD for their growth perspective. Unfortunately, we don't have much to offer them. But what in from this presentation, what I would like to tell you is that over the next 5 to 10 years, we would probably be having therapeutic agents to target the molecular mechanism of each of these skeletal dysplasias, and we might be able to give a much better quality of life to these patients. And achondroplasia is the most common skeletal dysplasia present in 1 in 25,000 live births, and over 80% of them arise de novo, though it's an autosomal dominant condition. And most importantly, 98% of these patients have a variant in the P-GLY 380 variant in FGFR3. So just starting with the physiology part. So here, this is a chondrocyte and a fibroblast growth factor binds to the FGFR3, fibroblast growth factor receptor 3, which is a transmembrane receptor in the chondrocyte. And this leads to two important pathways. There are many other pathways, but the two important pathways are the RAS-MAPK pathway and the other one is the STAT1 pathway. And these two pathways have an inhibitory role in the chondrocyte hyperplasia and differentiation. So what happens here is the FGFR3, the downstream pathways both have inhibitory role in the chondrocyte proliferation. And there is another pathway in the chondrocyte, which is the CNP. The CNP binds to its receptor NPRB, which increases cyclic GMP levels and which in turn leads to an inhibition of the MAP kinase pathway. So this inhibits a MAP kinase pathway, which leads to increase in chondrocyte proliferation and growth. So basically what you have to understand is that the FGF and the FGFR3 leads to a break in the chondrocyte proliferation. That is, it leads to inhibition of growth, while the CNP pathway inhibits this pathway and leads to increase in growth. So what happens in achondroplasia? In achondroplasia, there is a constitutively active FGFR3 receptor, which leads to a continuous activation of both the RAS-MAPK pathway as well as the STAT1 pathway. And this leads to inhibition of the chondrocyte differentiation and chondrocyte proliferation. So going into the mechanism of two of the important drugs, one is vosoritide. Vosoritide acts at the CNP pathway. The CNP, so if you can see the CNP pathway, the CNP binds to the NPR2 and which leads to increase in cyclic GMP and in turn increases GTP levels, and this inhibits the RAS-MAPK pathway, and this leads to increase in chondrocyte differentiation and hypertrophy. The other important drug is infigratinib. Infigratinib acts at the level of the FGFR3 receptor. This is a tyrosine kinase inhibitor specifically targeting fibroblast growth factor receptors 1 to 3. And this leads to inhibition of both these RAS-MAPK pathway as well as the STAT1 pathway, and which in turn leads to chondrocyte differentiation and hypertrophy. So now we've looked at the mechanism of these two important drugs. Let's look at the evidence behind these drugs. So the first drug is vosoritide. So vosoritide is a CNP analog. So CNP is present in the body and it has a half-life of a few minutes. But what is interesting in vosoritide is that the developers of this drug, Biomarin Pharmaceuticals, they've actually made an analog which is much more longer lasting in the body. This makes it resistant. Basically, they made the drug resistant to endopeptidases and has a once daily preparation of this subcutaneous injection. And the pivotal study was first published in Lancet in 2020, was a phase 3 trial which showed in this randomized control double-blind placebo-controlled trial, they looked at more than 5-year-old children with open growth plates. They've assigned 60 children to vosoritide arms and 61 to the placebo arm. And at the end of 52 weeks, what they've noticed is that there is an increase of 1.5 centimeter per year of annualized growth velocity in the vosoritide arm as against the placebo arm. And so 1 year data looks good. So what they did was they did an open label extension study of this of the initial study. So they looked at the effect of vosoritide over the next 6 years. So and over 6 years, what they've found out is that in the 3 years of the height outcome which they have measured, they found that more than 5.75 centimeter increase in height in these children who is on vosoritide over those who are on placebo. And they also found that there is a significant improvement in body proportions in these children who are under 11 to 12 years. And they found that there is a favorable safety and efficacy in these children till 6 years of follow-up. So now they've looked at 1 year outcome, then they did an open label extension till 6 years, and then they looked at children between 3 to 59 months, that is under 5 years of age. What is interesting in this study, which was published in 2024 and again in Lancet, there is only a modest increase in height of only 0.8 to 0.9 centimeter per year. But more importantly, these children had a greater midface and foramen magnum growth. This is a very clinically significant outcome. That means there is decrease in sleep apnea, otitis media, and foramen magnum stenosis. And last year, another systematic review and meta-analysis was done to look at the real world and pooled evidence of vosoritide. And here they found that over 10 studies with more than 696 patients, there was an increase in growth velocity of 1.82 centimeters per year. And now we know that it is efficacious. We should look at the safety profile. So over 460 patient years of data is available, and there are no serious drug-related adverse effects in vosoritide. The most common side effects noticed were some mild injection site reactions and some transient asymptomatic decreases in blood pressure. And you can see that now US FDA has approved in October 2023 for vosoritide for all ages with an open growth plate. So after vosoritide, what next? We know that all our patients with type 1 diabetes on insulin, our patients always ask for kuch tablet de do, I don't want insulin, I want a tablet. And here comes the tablet preparation for achondroplasia, which is infigratinib. This is the first oral FGFR3 targeted therapy, which is given as a once daily oral preparation. And this is a tyrosine kinase inhibitor targeting FGFR receptors 1 to 3. So the initial trials were the PROPEL trial, which was an observational study. And this observational study, they just looked at baseline characteristics of children with achondroplasia. And then they did the PROPEL 2 study, which is an open label dose finding study in 72 children aged 3 to 11 years across 5 sequential cohorts. And they looked at different drug doses, and they found that at the dose of 0.25 mg per kg, these children had an annual increase in height of 2.5 centimeters per year. And there were no treatment discontinuations and no hyperphosphatemia, which were expected in this selected cohort. And then this year came the PROPEL 3 study, which is a global, they've done this RCT in 6 different countries, randomized in a 2:1 ratio. It was a double-blind placebo-controlled trial for children from 3 to 18 years with open growth plates. And at the end of 52 weeks, what they found was that there was an increase of 1.74 centimeter per year of annualized height velocity in these children. And then looking at the safety considerations, in the phase 3 trial, there were predominantly mild to moderate adverse effects, but none of them were drug related. And there were no discontinuations throughout phase 3 trial. However, there are a few concerns. Importantly, this infigratinib was actually initially developed as an anti-cancer drug for cholangiocarcinoma and bladder cancer. And there they use a much higher dose of 10 to 100 times of what is used for achondroplasia. And in these higher doses, they develop hyperphosphatemia and some retinal and corneal defects. So we need to really look into long-term outcomes of this infigratinib in achondroplasia before this is approved for routine use in children. And the current studies which are ongoing are the PROPEL infant and toddler for children under 3 years, and also another phase 3 study in hypochondroplasia. So after these two important drugs, another drug was approved this year in February 2026, that is navepegritide. So navepegritide is something similar to our long-acting growth hormone. So if you remember the mechanism of lonapexometropin, which is a pegylated form of growth hormone. So this navepegritide is again, you can see the term peg in the name itself. So this is again a pegylated form of CNP analog. So here, this preparation can be given as a once weekly preparation, like our long-acting growth hormone again, and this gives a continuous systemic CNP exposure. And this important trial called the Approach trial, which was published in JAMA Pediatrics this year, showed that in 1 year, there was an increase in annualized growth velocity of 1.49 centimeters per year. So there are many other drugs in the pipeline like recifocept, which is a soluble FGFR3 decoy, RBM007, which is an anti-FGF2 aptamer, and growth hormone has been approved only in Japan with few modest non-targeted effects on final height. So I'm leaving you all with this final slide. So uh, this is achondroplasia has this complicated mechanism, and there are multiple drugs which are some of them approved, some of them in the pipeline to hopefully improve the height as well as quality of life of our patients in the future. So maybe after 5 to 10 years, we might be prescribing these drugs, and our children with skeletal dysplasias might be doing much better. And I'll leave it with you this. And this is our one of the gardens in our campus in Vellore. And this is our team, the pediatric endocrinology team at Vellore, with 6 faculty, with 4 fellows and residents, and 4 endocrine nurses and 1 dietitian. Not all of them are present in this picture, though. I would like to thank you all for this opportunity.
Thanks a lot for the informative talk, sir. We doctors are told that to take best care of our patients, we should think of them while treating as if they are our family members. If we think about this thing when treating, then we would want to give them the state of the art medications and treatment basically. So continuing further with our state of the art therapeutics workshop, I request Dr. Dhwani to kindly come on stage and talk on pubertal disorders. I'm not sure how to switch it. Any idea where is this KISS15 modulators? Okay.
So Dr. Dhwani is consultant pediatric endocrinologist in Amrit Hospital, Chhapra. And she has done her fellowship from CDR Regency here from Kanpur under guidance of Dr. Anurag. And she has 15 peer-reviewed publications, authored several chapters for Mediclass, Basic and Advanced Textbook of Pediatric Endocrinology, and contributed chapters in Recent Advances in Pediatrics, Volume 1, 2024, and Practical Pediatric Endocrinology, IGP 2024, awarded as Kaichi Kida Award for Best Original Paper in APPES 2024. Area of interest, pubertal disorders, DST, bone and mineral disorder. Over to you, Dhwani.
Thank you so much for the kind introduction, ma'am. First of all, I would like to thank Anurag sir for this opportunity. Thank you so much for giving me a topic that I found genuinely fascinating exploring. Pubertal disorders are a common presentation to a pediatric endocrine clinic. And yet, these remain some of our most challenging cases. Not because we don't understand puberty, but because we sometimes cannot answer the basic question: has puberty really started? Will it progress on its own? Do I need to treat this child? And if yes, what is the best option I can give my child? Let me take you through two common cases that we encounter in our day-to-day practice. The first is this 2.5-year-old girl presenting with Tilaki. Anxious parents, you take history, you examine the child, and then what do? You ask the pituitary and gonads, have you started making hormones? On the other end of the spectrum is this boy with delayed puberty. Again, you go through the same drill. Different scenario, yet you're asking the questions of the same two organs, the pituitary and gonads. Have you started making hormones? Will you start making them? When we know that puberty starts right here in the hypothalamus. During childhood, GABA, MK-iron-3, and DLK1 actively suppress puberty. But when the right genetic, nutritional, and environmental cues converge, the first to awaken are not the GnRH neurons, but the KNDY neurons. These neurons form an elegant regulatory network where kisspeptin provides the signal for GnRH secretion. Neurokinin B acts as the accelerator, recruiting surrounding KNDY neurons to amplify the signal, and finally comes dynorphin, which acts as the brake, ensuring that this signal remains pulsatile and not continuous. And this rhythmic kisspeptin secretion translates into pulsatile LH secretion, which in turn initiates the pubertal hormonal cascade. So if kisspeptin really is the master regulator of puberty, have we been asking questions to the wrong organ all this while? Let us look at our own case. If kisspeptin is truly the master regulator of puberty, can it tell me if puberty has started? Well, studies say yes. Kisspeptin levels are higher in girls with premature Thilaki and central precocious puberty compared to age-matched controls. The levels correlate with bone age advancement and also correlate with peak LH levels. Moreover, what is interesting is when you give GnRH analog therapy in these precocious girls, kisspeptin levels fall to near normal levels. This looks promising, right? Well, does not translate into clinical practice as easily because there has been large overlap between the levels in premature Thilaki and central precocious puberty. Different studies have used different assays resulting in different proposed cutoffs for this value. And most of these studies have been done in females, giving us very little male data. So as of now, it looks like a lucrative adjunct to our investigations of central precocious puberty, but cannot replace GnRH stimulation test. Well, if the levels are higher in precocious puberty, can they be used? Can they be blocked to suppress puberty in precocious puberty? Again, what we have so far are preclinical trials, and it does suggest that peptide 234, which is a kisspeptin antagonist, chronic administration delays vaginal opening, reduces uterine and ovarian weight, and suppresses gonadotropin secretion. Moreover, it also comes with a therapeutic advantage of no initial flare that one may see with GnRH agonist depot preparation, and a rapid reversal of this pubertal suppression once the therapy is stopped. But it again comes with a major challenge of a very short half-life and currently remains limited to experimental models. But what shines through in this as a therapeutic option is NKB antagonists. Now, nature itself has given us this clue. TAC3 and TAC3 receptor, which encode for the neurokinin B and neurokinin B receptor, defect in these genes have been shown to result in normoosmic gonadotropic hypogonadism. And this truly highlights the role of neurokinin B in normal pubertal progression. So the next logical question was, can blocking neurokinin B result in suppression of puberty? Preclinical studies say yes. Neurokinin B receptor antagonists did result in decreased GnRH pulse frequency, reduced LH, and reproductive maturation delay. Moreover, studies from adult females, mostly done for postmenopausal vasomotor symptoms, also suggest that neurokinin B antagonist administration resulted in reduced LH pulse frequency and reduced sex steroid levels. As promising as it looks, it also comes with an advantage of being an oral therapy. However, It does look like a promising therapy for precocious puberty on paper. We still don't have any pediatric trials in central precocious puberty. However, it still looks very promising. Moving to the other end of the spectrum is this boy with delayed puberty. Can kisspeptin or the hypothalamus tell us if the child will spontaneously enter puberty? Well, studies show that while the baseline kisspeptin levels are nearly similar in children with congenital delay of puberty and congenital hypogonadotropic hypogonadism, once kisspeptin is administered, they behave very differently. Administration of kisspeptin results in robust LH rise in CDGP where the clock is working but the initial signal has not started. Whereas in HH, where your clock itself is dysfunctional, kisspeptin failed to mount LH response. Moreover, this study by Abara et al. Also showed a good diagnostic accuracy of kisspeptin stimulation test to differentiate HH from normal children. The data in female remains limited. However, this is again a place where kisspeptin therapy shines through and can be a promising stimulation test to look out in the future. So we investigated this child and we found that the LH was low, testosterone was low, inhibin B was borderline, and MRI hypothalamus pituitary was normal. At 3 months follow-up, he is still at TANA stage 1. The parents and the child are both anxious about what way to go forward. And we are left wondering whether we go for a GnRH stimulation test, whether we treat with a short course of steroid and see for reversal. And that's where we wanted to ask if the hypothalamus can still come and rescue us. So can kisspeptin treat hypogonadotropic hypogonadism? Well, preclinical studies say that kisspeptin has an excellent use where the defect lies at kisspeptin deficiency, that is in kisspeptin-1 knockout mice. Once the defect is at the level of KIS1 receptor or distal to it, kisspeptin therapy did not show benefits. Therapy also comes with other pharmacological disadvantages. It is a peptide therapy, so you need and has inherently a very short half-life. Plus, it needs to cross the blood-brain barrier to be clinically meaningful. To overcome these barriers, scientists came up with synthetic kisspeptin analogs which showed a longer half-life and good LH response. But that's when biology intervened and said, "Hi, son, not too soon." And soon we had reports coming in where prolonged kisspeptin administrations resulted in a reduction in the LH response and tachyphylaxis came in. This was another challenge that was realized in using kisspeptin as a therapy. We now await results of this study, which is by Dr. Stephanie Seminara and her group. They've recently completed recruitment, and the study aims to look at the impact of administering kisspeptin therapy in children, in adults with hypogonadotropic hypogonadism, and then assess the change in LH pulse amplitude and frequency. If this translates and shows good results, it has implications way beyond congenital hypogonadotropic hypogonadism. It could perhaps become a more physiological way of inducing puberty in self-limited delayed puberty, where you give short course of testosterone and maybe someday also become an interventional option in mini puberty that could result in better gonadal development and fertility options in the future. Beyond puberty, kisspeptin has become has an emerging role as a PCOS biomarker, where ovarian kisspeptin hyperstimulation results in higher kisspeptin levels in the follicular phase, and if validated, it could be an early marker to help identify girls at risk. Another upcoming indication is functional hypothalamic amenorrhea. Now here low leptin levels result in low kisspeptin, which leads to low LH pulse frequency in these individuals. Some of these individuals, despite gaining weight and maintaining it, fail to resume normal menses, and that is where kisspeptin therapy has come to shine through. So as a therapeutic option to reinitiate menses and ensure long-term fertility in these children. Like any new molecule, it comes with its inherent challenges. So for diagnostic purpose, I think we still need standardization of assays and pediatric reference values before we go for any robust pediatric studies. And as therapeutic, I think we need to figure out how to manage peptide delivery, cost of therapy, and the long-term safety implications. But I believe the hypothalamus has a lot to tell us. If we'd only listen, perhaps when we treat the same child, similar child again in the future, we will be asking more questions of the hypothalamus. Thank you.
Expert opinion, then I'll.
So, since this is very much experimental, Dr. Dhwani, what do you think? Which one is the most upcoming thing? Because you talked about diagnostic role as well as therapeutic role. So
Ma'am,
which one is expected to come sooner?
it's still a long way in the pipeline. I
Yeah.
think it's hard to say which one will come sooner, but I think two options where it looks extremely promising is the kisspeptin stimulation test to differentiate CDGP from HH, and a neurokinin B antagonist therapy could be promising in pediatric CPP trials, although we don't have any studies yet.
Actually, this topic is very interesting because 20 years ago, when kisspeptin was discovered, it was actually discovered by a pharma company. So what they did at that point of time, they did a whole genome sequence. Nobody was doing that. They took a cohort of children, individuals who had hypo, and then they looked at what genes may be implicated, and then we can alter their therapy. So then they identified that there was this protein which is working, and this was earlier known as metastatin. So it was actually identified for something else. And then because, how did it get the name kisspeptin?
So it was basically discovered in Hershey's. So Hershey's is kisses.
Chocolates,
Yeah.
small chocolates. So that's how the kisspeptin came. So this was actually a discovery of peptide specifically for therapy. And 20 years they have not been able to come up, but I think the where it may be of help is hypothalamic amenorrhea if they are not responding, and maybe we don't have very good options in terms of hypo actually, not excess, but deficiency is where it will be of more role, because there the treatment is testosterone, or you're giving LHFSH, or you're giving GnRH pulses. There kisspeptin will come up as a good agent on that, and maybe fertility management also it may have a role. Thanks a lot, Dhwani, for the wonderful presentation.
Thank you for the presentation. With such innovations in medicine, it brings us to question, is there a possibility of oral insulin as well in future? And if yes, then when? Anyway, for the next talk, I request presence of Dr. Vijay Jaiswal, who will be talking on osteogenesis imperfecta, the state-of-art therapeutics in osteogenesis imperfecta.
So before I going to start, just clap for yourself, because I have never seen such a self-disciplined learned audience which you are going to be there. So still we are juggling with the OI, fracture हो गया डॉक्टर साहब, फिर नहीं ठीक हुआ और भी फिर मोटा हो गया. So there are so many things. So where we are, and probably this is going to give a shine that yes, after probably few years, we will be able to have at least effective management for these poor children as well as the family who are going to. So osteogenesis imperfecta is a diverse group of genetic disorder caused by pathogenic variant in COL-A1 and COL-A2 that interferes collagen production, resulting in bone fragility and multi-system issues characterized by decreased BMD, increased bone fragility, short stature, blue scalar, which may not be there always, dentiginous imperfecta, hearing loss, and skeletal abnormality. So now, since the advent of genetics, we are going to explore so many varieties of osteogenetic imperfecta. I'm not going into detail, but yes, I'll share the references. So now coming to the newer therapies, including denosumab, anti-sclerostin antibodies such as cetuximab, so promise but need further validation through randomized trials. So yes, still we have to go a long way, but yes, there are something which can be explored in randomized controlled trial. So in children, bone growth occurs through bone modeling and remodeling process that alternates between bone formation by osteoblast and bone resorption by osteoclast.
So the principle of management in OI is going to alter or going to make the balance of this osteoblastic activity and osteoclastic activity. So these are the therapeutic strategies to treat OI. Target the bone shaping cycle by using anti-resorptive drugs to inhibit osteoclast or drugs that promotes bone formation through osteoblasts. Bisphosphonates have been the anti-resorptive drugs most widely used in OI management. So these upcoming drugs are not going to replace completely, but yes, that is probably going to be there. However, patients with skeletal symptoms have often shown a poor response and fractures have persisted despite bisphosphonate administration. So what is rankle and why we are talking about that? Rankle acts on osteoclasts through different mechanism as of this bisphosphonate. Highly expressed osteoblast, rankle is paramount regulator of bone resorption. After binding to rank on the surface of osteoclast and pro-osteoclast, rankle promotes osteoclast activity, which increases bone resorption. So binding between rankle and rank is blocked by soluble osteoprotoserine, which is naturally produced by osteoblast and promotes. From here that came the idea that denosumab is a fully human monoclonal antibody of rankle by blocking the binding between rankle and rank and mimicking the inhibiting effect of osteoprotoserine. Denosumab can decrease the differentiation of pro-osteoclast, thereby reducing bone resorption and increasing the bone mass, which can be a problem in OI. So in suppressing bone resorption, this mechanism of action seems to be similar to that of bisphosphonate. Yes, still dosage and administration are not very fully much elucidated. So the amount of rankle produced by children and effect of the disorder denosumab is being given to treat on its production seems to be still unknown. In adults, denosumab clearance depends on amount of available rankle, but in children, a low concentration of rankle antibody relative to concentration of rankle would lead to rapid elimination of the antibody. And there are studies which reported that appropriate duration of treatment and frequency of injection yet cannot be defined. So they suggested that treatment should be continued until the end of growth following the regime used for bisphosphonates. So these are the various studies done by various authors. I'm not going in detail, but I'll share the reference. So that is there, but probably after a few years, we will be coming in a robust way, in a more scientific, validated manner that how we are going to use these drugs. So denosumab appears to effectively improve BMD, but not the fracture. Again, this is a lacuna which has not been addressed fully by this drug. Continued epiphyseal activity was observed during and after treatment, as well as the reversal of bone turnover suppression after denosumab discontinuation, suggesting that denosumab does not have significant adverse effect on growth. So the child is continued to grow. So growth velocity is not going to be hampered. So in the pilot prospective trials conducted by Kuhn et al., mobility assessed by the gross motor function measurement neither improved nor deteriorated. So another author observed mild or moderate side effects such as hypocalcium, which is desired, probably that is anticipated during denosumab treatment. Similarly, in clinical trials involving children with OI6, no treatment discontinuation based on unexpected side effects were reported. Now coming to the second, probably second wonder drug which is going to be there after some time, that is sclerostin encoded by gene SOST is an osteocyte secretory glycoprotein that was identified as a negative regulator of bone formation. So despite decades of research and attempts to treat OI with anti-resorptive and anti-osteogenic drugs, there is currently no still satisfactory management. So that's why we are exploring again and again. Genetic and pharmacological evidence indicated that therapeutic potential of sclerostin inhibition for promoting bone formation in OI. And this inhibition was demonstrated to promote bone anabolism and restore phosphate homeostasis in X-linked hypophosphatemic rickets. However, severe cardiovascular events were found in phase 3 clinical trials, which was actually done for osteoporotic postmenopausal female. So this studies was again re-explore that yes, if there is any other agent of this group which can have not adverse effect on the cardiovascular but good effect on this bone. So that is there, that is selected sclerostin loop 3 inhibition by therapeutic sclerostin aptamer showed bone anabolic potential. But again, this is a model, mouse model, mice without cardiovascular risk. So that is a promising, probably after a few years we are going to get. It indicated the critical role of sclerostin in osteogenesis imperfecta. Subcutaneous administration of therapeutic sclerostin loop 3 specific aptamer significantly promoted bone formation, enhanced bone mass, and improved mechanical properties in the models. So the bone anabolic potential of sclerostin inhibition for type 15 osteogenesis imperfecta in growing. So again, this was not cared by bisphosphonate, and they have given a promising result. So potential predictive strategies for responsive population sclerostin inhibition in the clinic, the serum sclerostin level were reported to be higher in young patients with type 1 OI than age and sex matched healthy controls, while were similar between young patients with type 3, 4 OI and healthy control. So it is desirable to investigate whether the therapeutic response of OI to sclerostin inhibition strategy could be clinically predicted by serum sclerostin level. So what is take home? That denosumab is a promising anti-resorptive drug that could be used as a targeted intervention in children with musculoskeletal disorder that affect Rankel pathway. Further studies should evaluate the effect of this treatment approach on mobility, bone density, and fracture rates. Focus on potential adverse effect related to bone turnover rebound and serum calcium homeostasis. The posology and administration interval also require more investigation. So aptamer specifically targeting sclerostin loop 3 promoted bone formation without increasing cardiovascular risk in mice model. And these are the references. So again, we can expect that within few years, we are going to have some robust data and dose schedule that how we are going to help the children who are suffering with OI and multiple fractures. Thank you so much.
Thank you, sir. Thank you for your wonderful presentation. I have a question to you, sir.
Yes.
When you advise bisphosphonate or denosumab to your patient?
Okay. So I think that we have to make a diagnosis and the severity of OI. And depending upon that, yes. First, we have to see that bisphosphonate is not going to reduce the rate of fracture. So if the child is immobile or say if pain is there, bone pain and other things are there, probably we can help and it is going to make the bone more resilient rather and it is going to symptomatic improvement. So it is going to be there. So rather and we can follow the bisphosphonates. I am not going in detail, but release protocol can be followed for the patient selection criteria.
Thank you, sir.
Thank you.
Thanks a lot for the
One point. So I think the reason we brought up this study was that there are a lot of new data coming on with setrusumab, which is a sclerostin agonist, which has been tried in children with OI also. The initial data suggested a significant improvement, and then the subsequent data did not show that much improvement, so it was not FDA approved. But why are we more wanting to go for a sclerostin agonist is because that is an anabolic therapy. So if you have a therapy which is anti-resorptive, it will only allow bone from not getting resorbed. While this will result in new bone formation. So like I always say, if your swimming pool is there, you can increase the water level by either decreasing the drainage or adding fresh water. So it's always better to add fresh water. Sclerostin will give you a better thing. PTH is not approved in children anyway because of the osteosarcoma risk. So this is one good agent, but I think very nicely covered by Dr. Vijayan.
Moving forward to add the fresh water of knowledge into our brains, I invite Dr. Aisha Ahmed to talk about state-of-the-art therapeutics in one of the most common disorders now, thyroid disorders.
Can I have my slides, please? The presentation.
We are all together.
Acha, okay, so good afternoon, everyone. So thank you, Anurag sir, for giving me this opportunity today. And I am happy to admit and proud to admit that I'm one of the old hands here and have been closely associated with Apes from almost its inception. So today, I would like to take you all through what is new as far as thyroid dysfunctions are concerned. And the flow of my talk would be what is new in diagnosis and what is new in therapeutics. So talking about what's new as far as diagnosis of thyroid dysfunction is concerned. So about ultrasound, you know, ultrasonography has been a very close friend and indispensable tool for managing a person with thyroid dysfunction, especially with thyroid nodules. So the recent advance has been advancement in the technique of performing this ultrasound, which is adding to the sensitivity and decreasing the chances of unnecessary operations and surgeries. So elastography is one form, either it's strain or shear wave elastography, which measures the tissue stiffness and helps differentiate a benign tissue from a malignant one. So this adds to the sensitivity of the sonography. Then there is another technique like superb microvascular imaging. So without the use of contrast, it again studies into the microvasculature of the suspicious nodules and again helps us in increasing the sensitivity, whether that nodule is a simple benign nodule where you can just go for a watch and wait approach, or it looks to be a suspicious which warrants a lobectomy or a thyroidectomy. So it helps with that. Then, like we have contrast enhanced CT scan, we have contrast enhanced ultrasonography available. So again, that helps in delineating. So the mechanisms are different, but the main aim is the same. These technologies have added to the sensitivity of diagnosing thyroid nodules and deciding the plan of management based on the expertise. Then there is multi-parametric ultrasound. This utilizes different kinds of ultrasounds and uses it as a you can say as a protocol and as a flow chart where you can decide based on the help from different types of ultrasounds. You can have a prediction model sort of thing, and you can decide, the surgeon can take a decision whether an operative approach has to be taken or that can be managed with a wait and watch policy. So it would be incomplete if I do not talk about the encroachment of this area also by the artificial intelligence and machine learning algorithms. There have been many studies recently which have utilized various prediction models and machine learning algorithms. Again, they talk about the same thing. What is the probability of having a nodule turning out to be a benign nodule, avoiding unnecessary surgeries, or it could be a suspicious nodule, so the decision can be taken. So this has helped us clinicians a lot in deciding about managing a child or a person with thyroid dysfunctions in a better way. So going further, so about molecular testing, again, this is not a new thing, but with the advent, as we know, we are now going into era of ordering genetics and talking about genomics in almost all the disorders. So here thyroid dysfunctions are also no exception. So you have gene expression classifiers. So initially we had just few mutations, but with the advent and more in-depth knowledge of the genetic mutations involved, so you have a panel of gene, special gene characterization. And I'm sure most of you would agree, when we have a suspicious nodule and we go for FNA, then at times we are in a fix, because what the report that we get is indeterminate. So they're not sure whether it's a benign nodule or it's a suspicious finding. So there, these mutation analysis and use of these genomic classifiers, they are very helpful, because you know the mutation, you subject that histopath specimen to genetic analysis, and you come up with the mutation. So you are more confident to take a decision again for a conservative management or a surgical intervention. So these techniques, they have increased the sensitivity of our diagnosis to as high as 90%, and they spare patients from diagnostic lobectomy, which was obviously the procedure of choice when we did not have these expertise with us. So it has become an integral part of thyroid nodule management, which no longer remains confined to just your surgical intervention. So perhaps it's not clear, but it's the snapshot of the same thing. Once you have FNA result and the result is not very promising or indeterminate, then you can go for genetic analysis and also gene expression classifiers. And based on the mutation detected, you can always take a decision whether to, which approach has to be followed. So this was about the recent advances in the diagnosis. So talking about therapeutics, what's new in managing thyroid dysfunctions? So about surgical and loco-regional interventions. So apart from the just the traditional and the conventional, the front thyroidectomy, which was done through the neck, we have now expertise in the form of better remote access. Like there was a cosmetic issue, especially for the female patients with a scar in the neck. So now with the advent of new remotely accessed thyroid surgeries, like there is a transoral endoscopic thyroidectomy vestibular approach. Now in this technique, the surgeon approaches the thyroid gland through the oral cavity. So he just gives a nick in the inner part of the lower lip and creates a vestibule and reaches the thyroid gland. Now again, there have been published studies and evidence to suggest that this technique, it's being followed in many Asian countries, and it is comparable. The sensitivity and the efficacy and the success is comparable to other the conventional technique, but definitely this requires expertise. Okay, then other I would say cosmetic benefits, surgeries with cosmetic benefits and remote access are approaching the thyroid through axilla, and also the retroauricular approach. So for conventional open thyroidectomy, which has been in use for almost for decades now, there is a recent advance in the intraoperative nerve monitoring. For traditional thyroidectomy, one of the common complication was that the person had post-operative or intraoperative recurrent laryngeal nerve paralysis because due to the damage to the nerve. So with the advent of intraoperative nerve monitoring, this complication can be avoided to a large extent. Oh, I'm sorry. So about loco-regional therapy, now again, radio frequency ablation, not a new, I won't call it a recent advance. It has been in use for quite some time now, but there is advent. This was a study which was published this year in February itself in American Thyroid Association clinical publication guidelines, that nanosecond pulse field ablation. The advantage of this NSPFA is that it is non-thermogenic. So, and it has increased the sensitivity, it shrinks the nodules. So radio ablation using a nanosecond pulse technology, it does not create heat, it does not cause scarring, and it leads to shrinkage of the nodule. And in a study, it was seen that it was about, the success rate was about, like, it led to the reduction in the volume of as high as 50 to 60%, and the more bigger nodules, they could be managed well using this technology. But these technology are not free of complications. So they have a prolonged operative time for the want of just a better cosmetic outcome. Like for a surgeon to go through vestibule, create a vestibule and grow through oral cavity all the way to the thyroid. So it increases the operation time significantly from that of conventional thyroidectomy. They have a restricted field of surgery. So obviously they are approaching from one side. So if the pathology is in the contralateral lobe as well, so at time there is no direct vision of that lobe. So that is another complication, or you can say shortcoming of these newer procedures. Then there are sensory nerve injuries, especially to the shoulder. So there have been cases of paresthesias and problems in the hand and moving shoulders after surgery. Increased post-operative pain, muscle discomfort, which might go with time, but the chances of infections are high, again, especially for the transoral route, because it's a good hub of having all the bacteria. So chances of having post-operative complications are high, and there are chances of having subcutaneous emphysema because you have to insufflate CO2, so create a field to get to the thyroid gland. So these complications are definitely there, but the results have been very promising, and they require expertise, special equipment. And if the surgeon is very experienced with that, then the results are comparable to the conventional thyroidectomy. So about the important part, that's pharmacological. What's new in the drugs that we have in treating any thyroid disorder? So we have come a long way from just simple thyroxine, which still remains the cornerstone stone of treatment for managing children with hypothyroidism, which was detected and started from 1970s to 80s. And from there, we have gone a long way from advent of TRAB, like monitoring of thyroid, which development of new antibodies. And now till present, we have now new drugs approved, especially for a particular thyroid dysfunction, like for thyroid eye disorders. And also we have advent in the form of like liquid and soft gel. The problem with the thyroid hormone is it has to be given empty stomach, and there are problem with absorptions. So with the advent of now liquid and soft gel, so even these things have been taken care of. So this is what we have in the drugs. So I'll talk about a new drug that is teprotumumab. This is Tepezza, which is a recently approved drug for moderate to severe active thyroid eye disease. So this was approved by 2020. So this is a new drug. So this is a new biological drug which helps in treating adults with thyroid ophthalmopathy that we see in Graves' disease. It has to be given IV preparation, and it's a weekly preparation for given 8 infusions. So how does it work? So as you all know, Graves' disease is an autoimmune disease, so you have different antibodies. So till now we have been talking about thyroid stimulating antibodies, thyroid receptor antibodies. So with the more in-depth knowledge of the pathogenesis, it was found out that there are other antibodies and receptors also. So we have IGF-1 receptor. So we have IGF-1 receptor, especially which is present on orbital fibroblast. So what does it happen in with the thyroid ophthalmopathy? What happens is the stimulation of these receptors, it leads to the stimulation of glycosaminoglycans, the orbital fibroblasts, they are stimulated, and this leads to inflammation and all the inflammatory markers increase in the muscle mass, and that adds to all the problems that we see, what the issues that we have with thyroid ophthalmopathy. So this is a monoclonal antibody which acts on this receptor, and it helps, it mitigates all the responses of these the IGF antibodies that can have on ophthalmopathy. So it helps in active thyroid disease, thyroid eye disease, but this is approved only for adults. So there was a study which was published in NEJM. So they studied the effect of this Tepezza in patients with thyroid eye disease. And as you can see that after giving a 24-week weekly injection of Tepezza, it was seen that was a significant improvement in the proptosis. So, and also in the in terms of clinical activity score. Now you know you have for thyroid eye disease, we have a activity scoring system. So there was a significant improvement in that CAS score, significant improvement in the proptosis, also diplopia, and also the quality of life. So similarly, there have been other studies also which have studied that this drug definitely is a life changer in patients having thyroid ophthalmopathy. Now, there are other drugs also available because, you know, it's an autoimmune condition. So there are different pathways and there are other drugs are also available which acts on different receptors. But till date, teprotumumab mumab has been shown to have the best effect of all. And the patients, they have improvement in all the aspects of thyroid eye disease. It's not just confined to the just visible that you can see. But the issue is about the adverse effect, the safety profile. So hearing loss was one of the most dreaded side effect, which was seen as high as 30% of patients. So that's the one side effect which precludes its use. And still this drug has not been approved for children. And it's not so common, you know, this thyroid eye disease in children. Then another drug is the triiodothyronine or Linorma. So this is not a new drug. This has been available for quite some time now, but it was not in use because there were many studies. It was being used as combination therapy with thyroxine. Again, the same oral preparation is available. And there have been multitude of studies in the last 2 decades, I would say. And they have studied that the combination therapy of LT3 and T4 did not offer any advantage of the T4 monotherapy. So there have been many studies, and the problem with this T3 was that it has a very rapid onset of action. So it led to very rapid rise in T3. So the side effect, the issues were that it led to arrhythmias, it led to palpitation and tachycardia. So there was these drugs were not in favor. So they and all the, as I said, most of the comparative studies did not show any benefit of having combination therapy with thyroxine. So there has been development and provision of slow release preparation. So this has taken care of this thing because this T3 had to be given 2 or 3 times in a day. But with the slow release preparation, it can be given once daily. Okay, so that is one advantage. And another thing was, as I said, genetic analysis and our knowledge of genetics has improved so much in the last decade that now it has been seen in few patients, like in a specific mutation, like DIO2 mutation. What happens? You know, T3 is the more active form of thyroid hormone, but it is converted through T4. So in the tissues, T4 is converted into T3 by deiodinase enzyme. So there are a subset of patients where there is, because of mutation, problem with this deiodinase. So T4 is not converted into T3. And I'm sure all of you would agree, at times there are some of our patients where you give them, you start them on thyroxine, the compliance is very good, and even biochemical parameters are excellent. T4 is normal, TSH is within range, but the patient is not feeling all well. They will always say, despite taking drug, I'm not feeling good. But there is something which is not working. So perhaps this is this subset of patients in which giving a combination therapy would help. And as I said, mutation has been detected, so you can go for, so it's not still not a approved drug. Like all the guidelines, they do not still approve combination therapy, but they say you can use it based on a case-to-case basis. So in certain patients, if you feel nothing is working biochemically, you are like in a good way, good place, but still the patient does not feel good. The symptoms have not improved. So there is one domain, one area where combination therapy can be used off-label. So that is one use. You have T3 analogs available, in which they are combined with different biochemicals and which increase the half-life and also the duration of action of T3. Initially, it had been useful for correction of thyroid stasis because the half-life is slow and it causes a rapid rise in T3. So it was useful in conditions where you have to rapidly bring the thyroid hormones to normal, like in myxedema coma. So as I said, the problem was it did not offer any benefit for most of the patient, and also it had side effects. Okay, so this was a big study and the systematic review which was published in 2025, which studied all the analysis on all the randomized controlled trials to study the effect. It compared whether combination therapy, it compared the side effect profile of combination therapy versus versus the monotherapy. And fortunately, it did not come up with any adverse, like this combination therapy does not have any more adverse effect as compared to the monotherapy. So one need not be scared of that. T3, T4 can be used, but again in a case-to-case basis, and not in all the patients. So what are further developments? As I said, sustained release T3 is one, because problem with T3 was it requires twice or thrice in a day dosing. So with the sustained release preparation, definitely it's going to be a game changer. Then with the advent, with the knowledge of new mutation being detected, you have another selective analogs which are there. Then you may have transdermal delivery, you may have, but these are all experimental things, still not approved, but in the pipeline, I would say. Then about targeted therapy, as for almost all the conditions, as our understanding of the pathogenesis improves, so improves the advent of the drugs. Once you know the enzymes and the chemicals which are required at different stages, so you have targeted therapy still under experimental stage, not approved for public use, but for commercial use. But we have many drugs coming in the line, and maybe in the near future, we'll have better options to control thyroid cancers and also all forms of thyroid dysfunction. So this is all I have to say. Thank you so much.
Very beautifully explained, Dr. Aisha.
Yeah.
Lenormand, I think, to sum up with, I can say Lenormand one should be used case-to-case basis in which the treatment is not, the patient is not improving with T4, which we can start with the combination therapy. And of course, we can do the genetic testing before this. And do we have any evidences regarding its use, any phase 1, phase 2 trial about teprotumab?
Yeah, it is approved.
In children,
Not in children, in adults. No studies
trial
in
being,
children. No, and I could not get hold of any studies even currently going in children. So it's approved for adults. And all the studies, there are many studies, but all have been done in adults, perhaps because thyroid eye disease is not so common in children. So still, they have not tested that.
Okay, thank you so much.
One place where Lenormand has been considered is neonatal hypothyroidism, which is very severe. So suppose your FT4 is 0 and you start giving T4, it takes time for levels to build up. So there people have said that maybe you start off with Lenormand and see how it progresses, and then you can switch over to T4. That is one area. The other, of course, is that your mesenchymal tumors and hemangio, all that hepatic tumors in which you have got increased DiO2 expression. So that is one scenario.
Sure, thank you.
Not yet, not yet.
Thank you for the informative talk, ma'am. I request, I invite Dr. Pradeep Kumar to kindly come on stage to talk on state-of-the-art therapeutics in 21-hydroxylase deficiency.
So Dr. Aisha has been associated with our programs right from the beginning. And I think she has been there coming. I think this must be your 12th visit, I think, to Kanpur. So that's great. And the good part is that most people who are there associated with us have been there for all the time. So that is a good thing. And the other, Dr. Pradeep, who has come also, I think this must be your, how many visit?
I think 7th year, sir.
7th year, but I think visits must be even more. So yeah, so we'll just quickly go through the. So Dr. Pradeep, yeah, over to you, the chairperson.
Okay, good afternoon. So my job is to tell you, take you through the newer options which are available since last 5-6 years in terms of the treatment of congenital adrenal hyperplasia, mainly 21 alpha hydroxylase deficiency. So what is the treatment goal in when we treat CH patients? We need the suppression of androgens while we don't want the side effects of glucocorticoid.
and we need to maintain the normal growth, fertility, and better quality of life in our patients. So these are the newer therapeutic options at from proximal to distal level. Right now, we have immediate release hydrocortisone as the option we treat our patients, but we can also have alternative hydrocortisone formulations like continuous subcutaneous hydrocortisone infusion, various modified release hydrocortisone preparations, hydrocortisone granules. We can also have steroidogenic inhibitors. Next, the proximal defect, the corticotropin releasing factor antagonist like crinecerfont and tildacerfont. We can also target the ACTH, block it, and this LUAG13909 is still in primitive stage. We can also have the MC2 receptor antagonist, atumelnant, and other options like gene therapy, cell therapy are still in pipeline. So let's see one by one. We'll not talk about much about this steroidogenic inhibitors and androgen receptor antagonist and aromatase inhibitors. So what is the limitation of conventional glucocorticoid therapy? So pharmacokinetic limitations wise, we need multiple daily doses. 3 doses we usually give. The limitation of the tablet itself, especially the small kid, we need to crush it and give it. If we give it in this water or other liquid, the overall efficacy gets reduced. This conventional hydrocortisone usually has this poor circadian mimicry, and we observe that the variable disease control is there. On the other hand, there are lots of metabolic and developmental limitations, like the child may have hypertension, insulin resistance, obesity, advanced bone age, growth suppression in terms of the treatment and in terms of the disease itself. So what are options we have? We can modify the hydrocortisone. We can have the modified release hydrocortisone as option. We can have continuous subcutaneous hydrocortisone infusion as option. We can also have hydrocortisone granules to give specific and titrated dose to a child. So first, let's discuss about the Alkindi sprinkles, which is the granules when the child requires less than 2.5 milligram of the doses. So as of now, there were various various, people have tried to make it the hydrocortisone in liquid, make syrup, suspension, but still it does not, there's no evidence that it works well. There's no efficacy at all. So as an option, we have Alkindi, where there is microdose granule is there, which was approved in 2020 in UK, and the lowest possible is 0.5 milligram. So it can be sprinkled in the food or directly it can be given on the tongue, and it has been seen that there is better efficacy in terms of the precise dose to the child. So this was supported by this study where they have studied about the absorption and tolerability of taste mask hydrocortisone granule in neonate, infant, and children younger than 6 years of age, and it was seen that it was well tolerated, and it was easy to administer to the neonate, smaller kids, and there was this after giving it after 60 minutes of giving it, the cortisol level was stable. Seeing the normal physiology of cortisol and ACTH, what we see is that it is a pulsatile hormone. So we need to give a drug which mimics this normal physiology. So when we give immediate release preparation, so what you see that there is no cortisol at all at night. Then when you give it in the morning, there's too much drug, and it has got also too little drug when actually there is pulsatility needed. So what options we have? They have tried dual release hydrocortisone so that it releases in 2 phases. The plinadrin is the drug where it has got immediate releases coating, and there is extended release matrix inside the core. But it was tried in PAI. primary adrenal insufficiency. Regarding the CH in adults, there's no data which supports it because it is given once daily. So what was seen that the daytime 17 OHP and cortisol was stable, but it was seen that the evening time it was not, it failed to replicate the normal circadian rhythm. So this is the scene that the peak is when it is given like intermittent release hydrocortisone, but gradually it is not like the normal circadian rhythm, our normal physiology. So this champion study, which this compared the uh, chronocort, that is F-MODI and plenadren. So they concluded that while plenadren provided effective daytime cortisol replacement, its once daily pharmacokinetic profile does not support adequately the normal physiological cortisol secretion, making it less effective than chronocort. So later on, this was not approved for treatment of CH as such. Then came the hard capsule modified release hydrocortisone, that is F-MODI, where it has got delayed release coating. You give it at night, there is delayed release, and when it is required in the early morning, so there is huge suppression of ACTH, there is cortisol release, and that inside the core there is multiparticulate granule which gives it a little bit stable release. So it was licensed in 2021, 12 years or more age. When it is given, there is gradual, because you give normally supraphysiological dose of glucocorticoid. So when you give it, it suppresses the androgen, and ultimately there is decrease in glucocorticoid requirement also. So what we see, it is given in toothbrush regime. So before going to bed and after getting up from bed, you take it, and the morning androgen suppression was seen. So to support this, uh, this uh, this this extended release hydrocortisone formulation, this study was concluded that there is potential to restore the full 24-hour circadian rhythm compared to previously we have seen. And then various studies, they show that all studies like Verma et al, he used once daily. So again, he had seen the same thing which there was in the plenadren, that daytime suppression was not there. And the most important study, Melapa et al, that twice daily FMOD, which approximates the physiological cortisol secretion, and it was well tolerated and effectively controls the androgen. So all the studies using twice daily regimen, the major dose is given at night and minor dose is given at the morning, and it consistently suppresses the 17 OHP level. The phase 3 trial in 122 adults, it shows that it significantly improved 17 OHP control with 91% achieving target level in the morning at 6 months. So long-term benefit was also seen, and it improved the clinical outcome. This study, this was in 42 children, a study done in 42 children, where it was seen that there was no major increase in adverse effect. The safety profile was there, and morning 17 OHP was decreased from 3 nanogram to 228 nanogram per liter. Now, what is the next option? So the people have tried continuous subcutaneous hydrocortisone infusion as to see that, like we see in diabetes, there is time in range. So it was postulated that we can try this as continuous infusion, and we can see that whether there is this shows the time in range like that. So the insulin pump device was used, and it was seen that there is physiological circadian cortisol secretion, it mimic like that. And there was improvement in ACTS, 17 OHP, there was good androgen control, and there was good quality of life also. But again, the issue is cost, and to use it, it is burdensome, and it is not suitable for many of the patients. To support it, there are lots of studies where the safety was okay, but the main thing was the burden of using it. Okay, what are the non-glucocorticoid options? So as we have discussed, we can antagonize it proximally using crinecerfont as a CRF1 antagonist. We can also distally MC2 receptor antagonism. We can also do using atumelnant, and the newer option that ACTH antibodies, which are there in the pipeline, we can also use. So our target is CRF1 receptor. So the idea is what we do, we give it the high doses of glucocorticoid we give supraphysiological doses to suppress ACTH. So what they have postulated that what if we suppress CRF1 so that lesser ACTH secretion is there. So ultimately what will happen that the child will need lesser glucocorticoid, maybe in physiological dose. So lots of studies are there. So phase 2 trial it shows that it has got almost 57% reduction in ACTH, 69% reduction in 17 OHP, and also 58% of reduction in androstenedione. It was well tolerated. And next, the phase 2 trial in 18 adults, it shows that ACTH and 17 OHP reduction was approx 53 to 66%. Androstenedione was also reduced to 64%. And in females, testosterone also reduced to 74%. So ultimately, it has good meaningful suppression of ACTH and adrenal androgens, supporting its long-term use can also be it can be used in potential newer drug. The phase 3 trial in adults, it shows that compared to the placebo, crinecerfont, there was reduction in glucocorticoid requirement, approx 27%, while placebo it was 10% only. At 4 weeks of androstenedione, it reduced significantly compared to the placebo. So, and simultaneously, it was also studied in pediatric patients where in crinecerfont group, the androstenedione reduced to approx 197 nanogram per deciliter compared to the placebo, where there was rather rise in androstenedione to approx 71 nanogram per deciliter. At 28 week, there was significant reduction in glucocorticoid requirement in the crinecerfont group, which was approximately 18% compared to the placebo, which was rather requirement increased to 5.6%. Another agent was tildacerfont, which initially promised show some positive response, but later on after phase 2, it was stopped. The trial was stopped because the tolerability of the subjects were not there. So the newer concept is you block and replace. So proximally you can block giving crinecerfont, and distally there will be reduction of glucocorticoid requirement. So instead of giving 12 to 15 milligram per meter square, you can give 6 to 8 milligram as physiological dose. The next agent is MC2 receptor blocker, atumelnant. So it has also got lots of initial, trials showing some good efficacy in terms of suppressing the androgens and decreasing the requirement of glucocorticoid. ACTH antibodies is still in the nascent stage. Lots of the data still has to come. Maybe the treatment will be very costly. We are maybe कितने सालों बाद हम use कर पाएंगे इसको. Next is the gene therapy, which was tried, but it was terminated because it did not show any efficacy. Cell therapy, people are postulating that if you give iPS-derived adrenal cell, which might produce cortisol in response to ACTH. So the data has still not come. The trial is ongoing. So whatever I have talked, most of the drugs, unfortunately, is still not there in our country. FMOD is not there. Crinister font it is available in our country through some named patient import system. So you give there is a process through which you can bring it to our country. The cost is very high, approx 30,000 to 40,000 per month a patient will require. So still this talk was there, but we are still left with that hydrocortisone tablet itself. So we have to use that judiciously. So thank you very much. Any questions?
Your presentation was very beautiful, actually. Although all those are in pipeline, but I think Crene-Serpent is promising, seems to be promising.
Yes, yes.
So, what is your take, sir, on you, of your opinion?
Non-steroid option which has been explored and been found to be effective. So that is actually what we want. What we want is that you reduce the requirement. So we always talk about you need to give 15 milligram per meter square per day of hydrocortisone as against 10 which may be physiological. So if you give 10 and you block CRF, that 5 will be lost. For every 10 milligram per meter square per day extra dose, you are losing more than one standard deviation score in height. And I'm just talking about height. What about other parameters, obesity, bone, and everything? So that is the best agent. The sprinkles also have been very, very effective in younger children. You sprinkle the medicine. I think that is something which is very effective because many of my UK colleagues and Australian colleagues, they have had a good experience with that also. Because giving tablet, we always dissolve it in water and all that thing. How much is it effective or not? So I think that is something L-Kindi is the one which is quite good on that. But definitely from a actual next, let's say from 0 to 1, that will be Chrysanthemum. That will be much better.
But none is available in India right now.
Chrysanthemum, nobody is going to take it for 40.
Patient import system.
But why would you use it? Huh?
Otherwise, most of the drugs are not.
Anyway, hydrocortisone has to be used.
But
just
I
in case
remember when 20 years ago, we did not have hydrocortisone available. This was imported from outside and we were using prednisolone, half tablet and also things have changed, but definitely I think maybe 10 years or something, we might get these things up on.
Let's hope for the.
Okay. Thank you. Wonderful talk, Dr. Pradeep.
Thank you for the talk, sir. I request Dr. Manoj Agrawal to please come on stage to talk on genetic obesity.
So Manoj is again one of our fellows who is now based out of Ahmedabad. And Manoj is actually the sports endocrinologist of Gujarat state. So is that mean that you are sporty or you are looking after sports person of Gujarat? So sport person of Gujarat. So Bumrah and everybody are part of your this thing. So anyway, wonderful. Manoj has been doing a lot of work in terms of other aspects of nutritional awareness, and his program Dal Roti Ka Sawal, I think those who are connected with him will know that how good he is taking out from that perspective. So it's good to have Manoj here, and he's been given a topic of his area. So that would be about the role of genetic obesity and what's the new development from that perspective. Over to you, Manoj.
Thank you very much, sir, for such a nice introduction. It is about the sport person. I am not sporty one. So, if I would like to start with the question that we are talking about the obesity, and this is the era of obesity. And already Anurag sir has been talked about, like how GLP-1 analogs and the tirzepatide is changing the world. If you are asking anybody, then they are talking about the population medication. That is you suppress the appetite, you will be get rid of the obesity. But what about the pediatric population? Does this fit the same in terms of the adolescent or the adult obesity? I think the answer would be no. Because the pediatric obesity, here we have to talk about the precision medicine. And when sir has been given me this topic, I read the genetic obesity and that he mentioned about the set melanotype. So this is a very important topic that we have to highlight in our pediatric practice, because right now, from the population's medicine, we are talking about the precision one. So we are targeting the specific switch. So this is about the pediatric obesity, and this is my real life case scenario. That is 2 months ago, one mother has been came to me with the shameful feeling. And what was the issue? Because she could not able to lift her 2-year-old child. What was the weight? It was a 22 kg. Yes, it is not typing error, but it is a 22 kg. She could not able to lift the child, and that was the scenario. So here the child has a severe obesity, and child always was demanding for the food, and the food portion size was like this, not like this. The children should have been, and the real cause, what could be the cause here? Just say, I would like to ask you then, does it the lifestyle issue? Does it the exercise issue? Does it the hunger issue? Or does it the satiety issue? It is a satiety issue. So here we are very well trained since childhood ke khana kam khao, exercise karo. So we are talking about our willpower. So here the willpower was not issue, but behavior versus the brain was the issue. So this was the a child, and what mother was doing, she has repeated visited to the multiple dietitians. They have given the multiple diet restricted food. It was not working. They were having been the lifestyle approach, because the many pediatricians and the many people has been told that parenting, you are bad parent, and that was the issue. So here the parenting was also not issue, and the parental guilt was there. So this story was not about the lack of the willpower. It was a not behavior, but it here brain is defaulting. So that is why the genetic obesity is very, very important. So I have divided my presentation into 5 to 6 parts, and we will talk about the entirely why it is happening. So remember this story of the child that we have discussed. We will talk to again regarding this story and story. So what is a normal hunger look like? Child wake up with the hungriness, and when you fed it time, they should be satiated enough. They have they respond to the small portion size, and whenever you are having the normal feeding, that time child will be the satiation. And what the normal abnormal hunger look like, they will never have a satiation. So mother was always telling कि night में भी उठ जाता है और night में उठ के भी खाता है. So this kind of the feeling child would have, and instead of the small portion, child is picking the big portion. And the diet and exercise that was trained from our perspective, that was not working in that child. So calorie restrictions, probably it would be working in terms of the less food intake, but not it is going to the brain. It will tell to your pathway to have a proper effect. And here the behavior therapy is also not very, very helpful. So raise your hand if you have treated or you have seen this child, this kind of the child in your pediatric practice. So I think the most of the people have been seeing this kind of the cases in the day-to-day practice. So what the mother were trying to do here to having the good parenting and the good lifestyle, but it was the case of the genetic obesity. And it is beautiful, it is looking in the one slide, but this one slide has a 30-year history. So in the 1980, this was a very good story. In the 1980, the scientists have seen that uh, some children are eating so rapidly and with a so nice portion, their BMI is increasing. And they were trying everything that diet and the lifestyle modification done. But they have seen the leptin. The leptin deficiency was there, and the scientists came with the leptin deficiency. Then after so many years, they have felt that no, leptin is enough. Then also it is not working. So it would be the not leptin deficiency, but receptor is not working. Then the entire roadmap has been decided. Suppose think like a condition, you have a doorbell, but the wire is not intact. So that means you cannot able to press the bell and nobody comes to open the door. So this is the same condition that precision medicine tells about. And after that, they have invented POMC, PCSK1 and the MC4 receptor. What was that? It was a final ultimate doorbell. So you want to open the door, you have to press the doorbell. This is the final doorbell. And the setmelanotide is working for the MC4 receptor. So your doorbell is intact. suppose if wire is broken and everything is broken, no tube light, no fan is there, but doorbell is intact, then that means it is working on your medication. So MC4 receptor is that kind of the things. And what is the hunger pathway? So your fat tells to your brain that you have to secrete the leptin that goes to the hypothalamus, and from the hypothalamus there is the activation of the POMC, and finally the end step would be the MC4 receptor. So remember, the MC4 receptor is very important rather than the pathway. Suppose if you are driving a car and the highway is broken, so what you will do? Instead of the correcting the road, you will take the bypass. So the setmelanotide is this kind of the medication. It is not correcting the pathway, but it will act as a bypass pathway to act on the MC4 receptor. So this is the complex pathway. As Dr. Anurag sir also has told about the exogenous obesity, that the stomach is the issue. You will suppressing the appetite by giving the GLP-1 or tirzepatide, but here the entire thing is issue. Here the stomach is not issue, but the brain is the issue. So the adipocyte leptin goes to the hypothalamus. It will activate the pathway. MC4 receptor is working, and it gives the signal. Now you have to stop eating. And what happens? Suppose if somebody has continued this action on the MC4 receptor, so you will not feel hungry. So to antagonize this, stomach release one hormone that is a ghrelin, and that will goes to the MC4 receptor and antagonize. So you will have a hungerness. So think like a condition. Now you have eaten enough, so your leptin is going, MC4 receptor is working. But after 2 hours, might be your ghrelin is working for you. So that is the pathway. Leptin deficiency is less common, but if you are talking about the MC4 receptor, that deficiency is more common in the clinical practice. So this is the birth of the setmelanotide happen. So they have seen that all the pathway is broken. Then you can't correct the whole pathway. You have to correct the bypass, and you have to create the bypass, and that is the MC4 receptor. And they have seen that by correcting just the doorbell, you will have a less satiation, you will have a less hunger score, you will have a greater weight reduction. So this is the target. And if we are comparing about the GLP-1 analogs that all the world is talking about versus the setmelanotide, GLP-1 analogs is a population medicine that is working for all the person with the type 2 diabetes with the adult, while the setmelanotide is only working for the selective pathway where the brain is in issue, while here the stomach side has been reduced and mainly working on the appetite perspective. So how it can be given? If we are talking about the world, then Rhythm Pharmaceutical is making this product in India. Off label, it is available by the Insibri Pharmaceutical, and that is a once daily injection. You have to give the once subcutaneous injections to the patient, and hunger center is suppressed. So you imagine the child, what mother was crying because not because of the healthy child, but because of the severe obesity child, and child is failing the satiation after this medication. So it is not a appetite stimulant or appetite suppression you are thinking about, but just it is correcting the bypass pathway. So what is the landmark trial has been done? So the first trial has been done in the pivotal phase 3, that is a POMC, and that has been published by the Lancet. In that study, they have seen that 16 patients that has been from the 10 hospital and the 7 countries has been involved, and they have seen that if you are giving the POMC or the PCSK pathway, your more than 80% patient can able to 10% of the body weight reduction. Why I'm talking about the more than 10% body weight reduction? Whenever you are talking about the anti-obesity medication, then your ideal weight loss should be more than 5%. Then it is approved anti-obesity medication. You can talk about the metformin or the dapagliflozin in the adult population. Off label, it is anti-obesity medication, but it is not causing the more than 5% of the body weight reduction. So it is not approved for the weight loss reduction. Here, it is causing the more than 5% body weight reduction. Why this number is very important? Because whenever you are talking about more than 10% body weight reduction, Dr. Anurag will also agree with me that you are talking about correcting your metabolic syndrome. Suppose if the diabetes or hypertension or anything in adulthood is there, might be the corrections would be achieved with the more than 10% of the body weight reduction. So more than 80% patients were able to lose 10% of the body weight reduction. And if you're talking about the leptin deficiency, that is a more proximal pathway, that the effect would be lesser. But again, more than half of the patient, you have seen that more than 10% body weight reduction has been done. And what about the hunger score? You have seen the more than 27% and the 44% hunger score improvement would be there. This is about the Bardet-Biedl syndrome. What is the defect in the Bardet-Biedl syndrome? It is not the pathway is broken, but because of the trafficking, your signal is not going to the MC4 receptor. So it is not a pathway problem, but here the trafficking is the problem. That has been this setmelanotide is approved for the Bardet-Biedl syndrome just recent 3 years. When I have spoken in the 2023 Apes, that time it was approved. So after 2 years, now it is officially approved and the larger data is there. For the 32.23% is benefited with the more than 10% of the body weight reduction. This is about the hypothalamic obesity. Why it is important? It is a severest form of the obesity. When I was doing my endocrine training with the Anurag sir, that time I have published, we have one lecture about the hypothalamic obesity. And it was very, very difficult to treat the hypothalamic obesity because your entire pathway has been gone. So you don't have anything that is working properly. So you give the GLP-1 analogs. Sir has been said just before 1 hour, it is not working. You give the GLP or metformin, it is not working. You do the bariatric surgery, it is not working. So here in the hypothalamic obesity, it has a wonderful result. It has a 14.8% mean BMI change with the setmelanotide by just switching the doorbell outside of your door. And this is the all the score improved in terms of the patient management. So just I would like to ask one questions to you. This is the 4-year-old child, severely obese, and the age is only 1 year. The clue is there, red thing, the hair is there, recurrent hypoglycemia, and the cortisol deficiency. So what would be the next step? Is it a leptin deficiency? You have to follow the diet, what we have trained, that eat less, move more. It could be just a normal case. You have to reassure the child. You have to check cortisol axis, and you have to do the genetic testing, and you have to refer for the bariatric surgery. So the 1 year bariatric surgery would be not good option. Probably at this high BMI, the reassurance would be not needed. So what could be the it could be the BOMC. So here your precision medicine is working for you. So this is about the comparisons and the clinical cause. We trained about the lifestyle, and now this is the era of the GLP-1 analogs, but it is for the population. With the setmelanotide, you can continue having the lifestyle modification, but the MC4 receptor correction is very, very important, and it is not working on your stomach. So here the GLP-1 analogs would be not that much useful rather than the setmelanotide. When to suspect the genetic obesity, I'm coming to the main point. Whenever child is there, you are the ideal person as a pediatric endocrinologist or pediatricians. You suspect if the child is age is below 5, because no lifestyle is working in this age group. You have any kind of the marked hyperphagia, family history or associated feature is there, then you have to think about the genetic obesity. That time the suspicious index would be the very narrow, and the confidence and the pre-test probability would be very high. So what are the suspicious of the diagnosis? Whenever clinical red flags are present, you have to always rule out the secondary causes. It could be the hypothyroidism, or it could be the cortisol excess. You have to always exclude the genetic secondary causes. You have to do the genetic test. You have to confirm the variant, and by that you have to talk about the setmelanotide eligibility. Now, if we are talking about the drug, then we have to talk about the side effect as well as. So what is the main side effect? In the adulthood, they have seen the more hyperpigmentation or navy would be there. But in the pediatric population, they have seen the injection site reaction, nausea, vomiting was there, depression was there, because it is acting on your hypothalamic system, brain reward system. So the depression was there, and the same system is working for the sexual arousal. So the spontaneous penile erections would have been noticed. So whenever you are starting that medication, you have to counseling the family members about the side effect, and then you have to start this drug. There are the health chances of the hypersensitivity would be there, and the chances of the adrenal insufficiency, because the POMC and the adrenal ACTH has a close relationship. So you have to work on the adrenal insufficiency side effect, or the sodium imbalance would be there because of the increased AVP secretion. So it is a once daily therapy. Weight based titration is there. 0.5 milligram would be the starting dose, and then you have to up titrate, and then you have to do the regular review in terms of the depression, so suicidal feeling, or the spontaneous no, sexual arousal, or the spontaneous erection. So these are the clinical cases. This is the toddler who, again, the case who has never satiated. History was there, 18-month-old girl. BMI is more than 99 centile. See, the things are 6 months. Everything is normal. Here, there was a low cortisol, normal thyroid, and genetic pattern has been seen. And they have seen it is not exogenous obesity. Rather than that, it was a POMC deficiency. So, red hair, early obesity, adrenal insufficiency, you have to think about the POMC deficiency. Why? Because very good drug is available right now. This is the hypothalamic obesity after surgery, 9-year-old boy after a post-craniopharyngioma. The rapid weight gain was there, and there was a disturbance of the MC4 receptor. So now, no GLP-1 analogs, no diet, no bariatric surgery will work in that case. The MC4 receptor would be the good time of the precision medicine. So whenever you are going to back on the Monday in your city, you have to remember that if the child has a age less than 5 and that time the obesity is there, always think about the genetic obesity. Keep the narrow suspicion. You have to order the genetic test early, because right now the precision medicine is available. If we are talking about the setmelanotide, don't think it is a stimulant or the suppression. It is just bypassing the pathway. You are installing the doorbell and the right position, and the evidence is there. So now the phase 3 trial has been done. Whenever you are giving the setmelanotide, you have to think about all the side effects that have been mentioned and do the review monitoring. So with that, precision medicine is not just about the obesity. It is about the treating the child to obesity. So this is our campaign last time, Dal Roti Ka Sawal Hai. So just I will brief about that campaign, that we have started this campaign for the Gujarat state and the policymakers and the doctors for the Gujarat. If we are talking about the nutritional knowledge of the doctor, that might be we learned about ourselves, or sorry, about our patient, but not about ourselves. So we have started this program with the Gujarat government, and the many IPS officers, IS officers, president of the Adani was part of this program. So this was just about this event. So with this, I am concluding my sessions. Thank you very much.
Thank you, Dr. Manoj. It's really a great message that a young patient with severe uncontrolled obesity, when it came to your OPD, not every time it's due to bad parenting. We should think of other ways, and genetic workup should be done to diagnose the patient early. I want to know, what about your patient, 3-year-old boy? You start with the patient. Did you prescribe this medicine for
So
this boy?
unfortunately, right now it is not available. If you are asking about the cost, then it would be the 35,000 to 40,000 per monthly therapy. So the right now, the medicine is there, but the availability is the issue.
Okay.
So
And costly.
yeah.
Okay.
So within 1 or 2 year, I think we will publish the clinical experience, what is our data, and you know.
Yeah, how long it should be given? Lifelong?
So the data is there. The data is for the 52-week and the 88-week. The effect was very good. But I think whenever we are talking about the genetic obesity, probably we have to continue for the lifelong, because there is a higher chances of the metabolic complications is there.
Thank you.
Thank you very much. On the GLP-1 analogs, What you were asking?
Setmelanotide.
Yeah, so the setmelanotide, it is working? It is working on the MC4 receptor.
Yeah.
So if you are talking about the POMC receptor and the PCSK9 receptor, that is a combined molecule, and the PCSK9 is chopped into the ACTH, MSH, and the MC4 receptor. So whenever you are talking about the MC4 receptor, might be you are talking about your chopping activity more. So that is why your ACTH is not working. In some cases, they have seen it is causing the only 5% cases. The chances of the adrenal insufficiency is much more.
What if adrenaline insufficiency occurred while on the therapy? Then will you
They may anyway have adrenal insufficiency even without treatment.
Okay.
And generally, the treatment may actually benefit it also. Because when you're giving that particular agent, so if it is there by chance, treat the adrenal insufficiency.
Treat
This
that.
is not a contraindication for that.
And since the beginning, it is the issue is there, then you can diagnose it is a POMK deficiency. So then also it would be very much beneficial.
It may benefit it out actually.
Yes, thank you. I request sir to please come for felicitation. I request and invite chairpersons, Dr. Arun, Dr. Dhwani, Dr. Vijay, Dr. Aisha, Dr. Pradeep, and Dr. Manoj for felicitation. Yes. Dr. Manisha, Dr. Anamika, and Dr. Radna, kindly. Okay. Dr. Anamika, ma'am, kindly. And Dr. Aradhana Singh, please. Dr. Arun, Dr. Dhani, please. Dr. Dhwani, Dr. Vijay. Dr. Vijay, please. Dr. Aisha. And Dr. Pradeep. For the next workshop, it's a very interesting discussion on diagnostics. I request Dr. Nimisha to kindly take over.
You're giving a GLP or you're giving POMC?
So the sport person, it would be probably the Serena Williams incidents. So people are right now is taking the GLP-1 analogs, but the sports person is sports person because of his lifestyle. So we just have to modify his diet. He will be enough motivated to do having the reduce obesity. But I have seen while practicing, if we are talking about the adolescent sport people, then they do have a delayed puberty because of the intense activity. And when I was in UK, that time we have seen the relative energy deficiency. So rather than the obesity, they do have a more central hypothyroidism or the hypothalamic amenorrhea. So that should be the target at first rather than the obesity. Thank you.
Thanks a lot. Bula.
For our next grand rounds on genetic diagnosis, I call upon Dr. Ganesh, Dr. Mahesh Maheshwari, Dr. Sayan, and Dr. Sandeep to preside as panelists.
So, Dr. Ganesh, so now genetics is becoming extremely common from that perspective. Yeah, there. We'll be asking questions to them. So genetics is becoming extremely important because a lot of endocrine disorders have a genetic basis. And we will be using this as a template to discuss common cases and scenarios where confusions happen. Especially after NGS, there has been a lot of confusion as to how do we really manage them and whether these reports are right or not. So I'm really honored to have a very esteemed panel. We have got Dr. Ganesh Javelikar, who really showed his real wonderful experience on AID today. We have got Dr. Mahesh Maheshwari, who is a professor at Ames Bhopal. We have got Dr. Sayan, who is fresh out of his DM and he's now working in Kolkata again. And Dr. Sandeep recently has completed his training and he's joined in the Ahilya Nagar Medical College. And I'm joined by Nimisha, who will also be putting the difficult questions. They will be directed towards the consultants. I'll just be talking about the baseline aspects of it. So whenever we talk about any disease and you want to understand whether it is a genetic basis or not, we have to look at two things. How much is the prevalence of the disease and how much is the penetrance of the disease? So classically speaking, when we talk about Mendelian disorders, they have a high amount of penetrance and they have a low prevalence. While as we go towards complex traits like diabetes or obesity, we are talking about lower levels of penetrance but higher levels of prevalence. So I think this is the common thing to remember. So most diseases will have a genetic basis, but the number and amount of genetic basis will vary. So inheritance can mostly, we are talking about monogenic disorders in which we have Mendelian pattern, in which we can have autosomal dominant and recessive disorders. Typically, every generation affected, we say dominant, skipped generation, we say recessive. X-linked, of course, is that there is no father to child transmission and there is transmission mainly coming from mothers who are carriers. But we also have a number of non-Mendelian disorders like mosaicism, imprinting, mitochondrial and penetrance. Oligogenic inheritance is becoming more recognized, particularly for hypogonadotropic hypogonadism and obesity syndromes like Bardet-Biedl. And I talked about polygenic. So inheritance pattern, we all know about that, so I won't go too much into detail. I try to summarize that also, is that if you look at how many generations are affected, if you look at whether father is transmitting to the child or not, whether mother is the exclusively transfers, you will know whether it is a dominant, recessive, X-linked, Y-linked or mitochondrial disorder. And that will give you a clue. So for that, definitely you have to create a pedigree chart, which becomes absolutely important from that perspective. Now, what are the exceptions? So mosaicism is something which is a post-zygotic mutation. So after that mitotic division, there is an error. So some cells will be affected while others will be normal. So you may have, if after first division it is 50%, 25%, 12.5. Many of the disorders like McCune-Albright syndrome, Turner syndrome, Down syndrome do show this sort of mosaicism. Then, of course, we need to understand what is penetrance and expressivity. So in a dominant disorder, how many children are actually getting affected is what penetrance means. And expressivity means that if somebody is affected, how severely they are affected. So if you say a particular disorder is associated with short stature, how many of them are short will give you the penetrance, and how short are they will give you expressivity. This is the way to understand, and this is very important because in NGS you see lot of reports, but whether they are relevant or not is the question in that perspective, and this becomes important from that regards. The third important non-Mendelian pattern is imprinting. So normally we say you get the gene, you will have the disease, but if you get it from the father, you may have the disease. In the mother, you may not have the disease. So if the paternal origin or the parental origin decides whether you have a disease or not, that is your imprinting disorder. And many of the endocrine disorders, be it Beckwith-Wiedemann, Prader-Willi, Angelman, Russell-Silver syndrome, neonatal diabetes, SDS, they are all imprinting disorders and they are difficult to pick up on your conventional assays. And you need to go forward with regards to second level assays in that perspective. There is, of course, a locus heterogeneity in which multiple genes can cause one particular disorder. So if you have XY-DSD, manifestation is same, but you can have multiple genes affecting that. So there are a lot of confusions and we will seek expert opinion on those confusions. So Nimisha, you can start off with the case.
Thank you, sir. So we'll begin with our first case. There was a 3-year-old boy who was diagnosed with achondroplasia, but here the family was unaffected. So the parents were reassured that they were concerned about their next child being achondroplasic. So they were reassured this as a novel mutation and was sent back. However, the next child again developed achondroplasia. So how would you like to explain this, Dr. Ganesh, sir?
Yeah, typically the testing of individuals happen on peripheral blood cells. Now, testing on peripheral blood cells sometimes may not pick up changes that are seen in the gonadal cells or germ cells, basically. So, if you have had a unaffected family and two affected children, it could sometimes be seen in germline mosaicism, means that the mosaicism is present only in the germ cells. So, this is an indirect evidence for a germline mosaicism.
Very important. So when you are giving counseling somebody with achondroplasia and parents are normal, don't say that the risk is population risk. The risk may be higher than that because of this very important germline effect.
This was not an apparent novel mutation. It was a germline mosaicism, which resulted in inheritance in second child. Moving to the next case, a 2-year-old girl presented with vaginal bleeding. On Tanner staging, it was B2, PH1. There was cafe au lait spots, ovarian cyst were present on ultrasound. And however, the LH-FSH levels were pre-pubertal. The child was diagnosed as McCune-Albright. On sending GNAS1 test, it came out to be negative. How will we proceed with this, Dr. Mahesh, sir?
So I think I just continue with where Dr. Ganesh left. So this child is actually having a precocious puberty, and it looks like to be most probably a peripheral precocious puberty in view of ovarian cyst and capillary spot. And this is definitely not a central because LHFSH is on a normal side. So clinically, all of us know that this is totally fitting in a McCune-Albright syndrome. And as in general, we usually send GNS in blood. So, and the labs usually do this testing. So they did it negative. So just like Dr. Ganesh says, actually the mutation happened after the fertilization. So when this is happened after fertilization, it's depend on at what time of fertilization the mutation happened. If the mutation happened in the early in the fertilization, then at that scenario you may get all these classical clinical features of McCune-Albright, that is endocrine excessiveness, exacerbations, and then fibrous dysplasia and this make cafe au lait spot. So the best thing in that scenario, the organ which is affected, if it is a late mutation, you may not get all the clinical manifestation. So just like in our child, there are two organs that is affected dermatologically and ovarian cyst. So if you take the sample from there, then there may be a positivity. So it's very important to understand that whenever you are sending this sampling, the sample from where you are sending, in that you need to interpret.
So because now there are reports that if you have recurrent ovarian cysts with no other manifestations and you do a genetic testing there in the ovarian material, you will find GNAS1. So it means that McCune-Albright may be isolated with just the cafe au lait spot, just the cyst. And this, of course, is very relevant for Turner's also, where we want to have maximum lines which are
The
there.
morning we seen that.
Yeah, typical case. Yeah.
Moving on to the next case, the 5-year-old girl who presented with hypocalcemia. Calcium was 5.6. There was hyperphosphatemia. However, the creatinine was normal. The PTH was inappropriately low with respect to the calcium levels. There was growth failure. However, on sending the NGS, the diagnosis came out to be RET1 mutation. However, there was no family history of medullary thyroid carcinoma. So how will we proceed with this report, sir?
Now, actually, this case, you are expecting something to do with hypopara, but suddenly you find a RET1 mutation and it has nothing to do with the clinical phenotype that you have. Now, this is what Sir started off with, that you can have mutations, but they do not express. So this is something which is non-Mendelian. Mendelian says that if you have a genotype, you will have a phenotype. But coming forward, we found that there is non-Mendelian inheritance, where even when the gene is there, you might have no disease. So this is what it is. In certain cases, you can have full penetration, but in certain cases, you can have variable penetration. But when the disease is penetrant, you will have complete expressivity to the other end, where you can't predict penetrance or expressivity. So this has to do with penetrance, and it has nothing to do with the clinical phenotype, so we can ignore the same.
So this is a genetic incidentaloma, but then they read that RET1 is a very, very adverse mutation and you have to go for so many other procedures and sometimes you have to go for thyroidectomy and other parameters. So what would you recommend to the family?
So when you have a RET1 mutation, you will also have the point where the mutation is there, the single nuke. So it is very well documented in red mutations according to the site. So as far as I can understand, you will have a site which is non-pathogenic for this gene. So you can counsel the parents accordingly.
Even if it is pathogenic, what is very important to understand is that if somebody has a family history, then the chance pretest probability is 50% to have the disease. But this is a routine general population, the pretest probability is very less. So if your pretest probability is less, even having those defects will not have the same implication as in a family. Because if you say somebody has AIS, but he also produces more testosterone, there may be other genes which are compensating from that. So therefore, you cannot use the same logic of a family based ret mutation here. So this is a very, very important thing, and genetic incidentalomas are very common. So that is something we need to be very much aware of. Very nicely pointed out by Dr. Sayan from there.
So coming on to the next case, this was 10-year-old boy who presented with obesity. He was normal till 3 years of age. However, after that, there was rapid progression of obesity. There was history of hyperphagia and food foraging. And there was small phallic size. Child was diagnosed as Prader-Willi and fish was sent. It came out to be normal. So, Dr. Sandeep, how will we interpret this case now?
So as from the history, child was normal till the age of 3 years. Then rapid progression was there, hyperphagia was there, small phallic size. So clinical diagnosis was Prader-Willi syndrome. And for Prader-Willi, there are three kind of defects: deletion, there is uniparental disomy, and also methylation defects. So fish can just detect the deletion, but the other two will not be detected. So the right test in this clinical scenario will be a MSMLPA test.
So I think that's a very, very important finding to consider, that when you're choosing the test, choose the test wisely. Because as you have mentioned, there may be a problem only in the methylation site. There may be a uniparental disomy in which there is no deletion at all. So that will never be picked up on the fish. So I think this is very common, but now most people are doing MSMLPA. But somehow our yield of Prader-Willi, the suspicion versus diagnosis, is still very low. So what is the experience, Dr. Ganesh? What do you think? Where we think this is Prader-Willi, it turns out to be negative even on MSMLP often.
Yeah, I think MLPA has been like in wider availability only in the last few years.
Yeah.
And when we used to do fish, this incidence was much more commoner. In the recent past, largely this percentage has come down, I would say. With MLPA, we have been able to diagnose them better. But it happens with many conditions, not just Prader-Willi, that you are certainly sure that this is the condition, and then it turns out to be normal genetically. For example, Turner syndrome. Sometimes you think that it is Turner syndrome and the report comes normal. True.
So that is a very important message by Dr. Sandeep, that don't do fish, go for a methylation study with multiplex ligand assay. That will give you a better outcome.
So moving on to the next case, this 21-day-old boy presented with irritability. There was mild dehydration. Calcium levels were very high and PTH was also high for this calcium levels. The urinary calcium creatinine was low, so calcium sensing receptor defect was suggested and the child was suggested for surgery. However, it improved over the time. So Dr. Ganesh, sir, how will you interpret this surgery?
So I think Nimisha very mildly just said something that it was very high, but the calcium is not very, I mean, not, it could be in a neonatal severe hyperparathyroidism. The calcium levels could go to 18, 19. So although she said very, it is mild dehydration and calcium was 14. So probably it is a less severe sort of presentation. And the child was lucky, I think. Probably somebody would have subjected the child to have surgery, but the child was lucky to escape surgery and improved over a period of time. So with such degree of hypercalcemia, one should suspect neonatal hyperparathyroidism, which is basically a mutation in the calcium sensing receptor. The function of whose is to sense the calcium levels and to switch off the parathyroid secretion. So here, if both, I mean, if single allele is defective, that condition leads to milder forms such as hypocalciuric hypercalcemia, which is mild hypercalcemia. But if it is both alleles defective, then it can present as severe hyperparathyroidism. But I think the message that one wants to convey here is that even if both alleles are defective, the defect may be, one of them may be severe, the other one may be milder, or it could be both milder. So that can lead to milder presentations, and one need not have one single rule for all the cases. Do you agree, Dr. Anurag?
Yeah, I think that's important. And there is definite variant in which there is a inheritance from the father. If you get the inheritance from the father, they will sense their mother's calcium is low, and therefore they'll start producing more calcium. And once they come out of the placenta, the fetus comes out, there will be a normalization. So this is what is known as neonatal hyperparathyroidism as against neonatal severe hyperparathyroidism. So this will improve over time. So I think that's a very big message. And very nicely pointed out by Dr. Ganesh, the levels are not 18-20, where surgery is essential. Here, wait and watch. Maybe give them a course of zoledronic acid, maybe give them cinacalcet. Other things may also help out in that regards.
Moving on to the next case, this was 7-year-old boy who presented with.
Could you explain the word pseudo imprinting?
So
Because
pseudo imprinting basically means that normally we say that the manifestation vary depending upon the gene is coming from the father or the mother. So that is a classical imprinting. But here the gene is coming from father is having a different sort of a phenotype. If it had come from mother and mother is also affected, there will be no problem in the child. So this is what they will behave like a normal hypocalciuric hypercalcemia in which nothing has to be done.
This was a 7-year-old boy who presented with growth failure. Height was 102 centimeter, weight was 16 kg. He was short, doll facies with growth hormone stimulation being done with peak growth hormone was 2.1, hence diagnosed as GHD. However, there was liver which was 10 centimeter enlarged. There was ALT levels which were raised. He was induced on fasting, and on fasting blood sugar was 32 and the ketone were positive, so it was ketotic hypoglycemia. Dr. Mahesh sir, how will we proceed with this case?
Whenever a child present with 7-year-old child presented with growth failure, height is 102 centimeters. You usually expect somewhere around 120 centimeters. So this child is primarily presented with a growth short stature, and the doll facies and peak growth hormone is 2.1. So initially we thought about growth hormone deficiency and maybe a growth hormone deficiency diagnosis was made. But later on, whenever the history was taken and the clinical examination was done, this hepatomegaly with deranged enzymes and non-ketotic hypoglycemia will definitely take us to a clue that most probably I am dealing with a substrate disorder, that is a glycogen storage disorder. And there is a possibility that this algorithm is also showing if the ketones are present and the lactate are normal and with the organomegaly, you start thinking there is a possibility of GSD 3, 6, or maybe sometimes 9 also. So whenever you think about a confirmed diagnosis as a clinician, we always think just to save some amount of money and we just send the single gene. So if you send the single gene, then there is a possibility this may come negative. And I think in the beginning you talk about, so this is actually a classical example of local heterogeneity. So there may be a clinical phenotype is same, but the genes may be different. So if you send only the single gene, there is a possibility you may miss that particular diagnosis. So it's better to send the clinical exome sequencing or a complete exome sequencing.
So I think that's a very important message that maybe if we had done a targeted panel for GSD, we would not have missed. But just sending one single GSD, you will miss that in that perspective. So this was the locus heterogeneity. So now big question comes in, genetic test is there. Shall we do it in everybody? No, there are 4 S. So if it is soon, severe, segregating, and syndromic. So if it is happening at an early age, if it is having obesity is extremely severe, if it is happening that there is a family history or there are syndromic features, then should the genetic testing be done in that regards. Now, next big question is which test to choose. I think that's very important. If you think there is a monogenic disorder and there are only 1 or 2 genes, go for Sanger sequencing. See, Sanger sequencing will be the best as far as the depth of reading, and you will be sure about that. While NGS is good at width. So what you're looking at, whether you want to go wide or you want to go deep. So Sanger is deep. So if candidate genes are 1 to 2, go for sequencing. Up to 10 to 20, like for GSD, we could have gone for targeted panel. While if you are not clear, you go for exome sequencing. So go for whole exome sequencing, that will be there. And if you find abnormality, you can do a functional study. Now, sometimes you are strongly thinking that this disorder is there, but the whole exome sequencing is negative, then go for promoter region, regulator region. Then you can go for the whole genome sequencing in that regards. So long reads and those things are there. Very importantly, if you don't think monogenic etiology, do not do the test. Otherwise, you will get hundreds of reports and you will always be worried about that from that perspective. So if you have single gene, single hotspot, go for hotspot analysis. If you have single gene with multiple variants, go for Sanger sequencing. If you have multiple candidate genes, go for a targeted NGS panel. If you don't know the cause, you go for a clinical exome sequencing. If there is a copy number variation, so often you may not have a single nucleotide variation, it may be 2-3 nucleotides or 2-3 areas may be there, go for array CGH or MLPA, which is a good test from our perspective. Complex disorders, go for karyotype, which becomes important. Aneuploidy, of course, karyotype. And for imprinting disorders like Prader-Willi, you should go for methylation study and MLPA. So you decide which test is to be done. And now there is this OGM, which is a long read, which is going to become available, in which you can do all the tests in a single one. So this is something which is coming up. And of course, for mosaicism, you do from the tissue. Dr. Mahesh talked about ovarian cyst, you do from the ovaries. So this is how you decide about which test has to be chosen from that perspective. So I think that becomes important. And next is when you get the report, how do you know that this variant is significant or not? So now there are clear-cut guidelines as to classify. Pathogenic means you are 99% sure that this is a significant disease, while likely pathogenic is 90 to 99%. So if you get that report, you have some doubt. If you say uncertain significance, it is anything between 10 to 90%. So that means that you may have result may or may not cause the disease. And if it is less than 10%, this is likely benign. So these are the various cutoffs that you should use and read the data from there. If you have VOS, follow them up, because maybe new genetic data comes up and tells you whether this disease is actually causing that or not. And if it is benign, then don't worry about this is less than 1%. So this is more like your TIRADS classification or your FNA classification, something like that has been developed by the genetic people as well from there. But how do you know that this person has got this variant and this is pathological or not? To decide that, there are various ways which are used. One is whether it is aggregating in the family, whether the gene frequency is low or more. So if it is more than 0.1%, it is unlikely to be pathogenic. Whether it has been conserved for a long time, millions of years, the same gene was there in different species, this is going to be pathological, this is significant. Whether it is correlating clinically, whether it is functional, and finally they use the in silico model. They use the gene and predict and see in the AI or the computer as to whether this is going to damage or not. So these are the things which are important. So there are clear-cut recommendations as to how to do that. And if you find incidental findings, how to report on that perspective. So now 12, yeah.
12-year-old boy who presented with obesity, weight was plus 2.2 standard deviation, height was plus 1.2 standard deviation. There was normal facies, normal development, and child was ordered genetic testing. So Dr. Science, sir, how will we proceed?
So this is the first slide that sir told us. It is neither soon nor segregating in the family, neither do you have a syndromic features. So you do not need to go ahead with a genetic test in this case.
So again, that would be a waste of money. So as you said, soon, severe, segregating, and syndromic.
At the similar, another case, a 2-year-old girl who presented with obesity, rapidly progressive, hyperphagia, and weight was 24 kg. Now, is the genetic test advisable, sir?
Now, this is the case which Dr. Manoj just showed of a child who could not stop eating. And you all remember the story. So this is a fit case for genetic testing. And if you get the genetic test right, maybe you can find a PCSK defect as Dr. Manoj found.
So this has got everything early, severe, unusual, and this was found to have a leptin receptor defect, which will also respond to setmelanotide because it is distal to that pathway.
Now moving to next case, day 3 child who presented with atypical genitalia. There was no gonads, Prader stage 4. On doing ultrasound, Mullerian structures were present. Karyotype was 46XX. 17 OHP was mildly elevated. The child was labeled as CAH and was started on hydrocortisone. On subsequent follow-up, the hydrocortisone dose was tapered, and now the child has normal 17 OHP and hydrocortisone has been stopped. During adolescent age, child again presented with delayed puberty. There was history of maternal virilization during pregnancy. Dr. Sandeep sir, how will we proceed with this case?
So basically, this is XX-DSD, Padder 4, no gonads, Mullerian structures present, 46XX. But there are 17 OHP is normal and there is no requirement of hydrocodone as such. And very importantly, there is delayed puberty and a very peculiar history of maternal virilization is there. So we can pinpoint the diagnosis on this clinical picture that it is a case of aromatase deficiency. So we can directly go for sequencing of CYP19 alpha 1.
So clearly we can go ahead with that particular one. But because it is XX-DSD, we went for a clinical exome sequencing. And this is the result. This is CYP19A1, again aromatase, and it is saying autosomal recessive and likely pathogenic. So do you think, how do you interpret this finding?
Because sir, the history, the maternal history and the clinical picture is matching up with this, so we can consider it as a pathogenic one.
So I think pre-test probability was very high. So this is 100%. So I would say this is clearly pathogenic. It is not likely pathogenic, and it will give all the information from there.
Next case, day 14 child who again presented with atypical genitalia. There was bilateral gonads present. Now there was no uterus on doing ultrasound. The karyotype turned out to be 46XY. Testosterone was there, 50 nanogram per deciliter, and there was salt wasting, and 17 OHP was again mildly elevated. Ganesh sir.
So this is a XY individual who has, who has palpable gonads but under virilized. So which means there is a defect in the androgen biosynthesis, and the finding of low sodium and high potassium suggests that there is a defect in the mineralocorticoid and or glucocorticoid axis also. So if we go by the steroid pathway, the enzyme which would affect all these three pathways would be 3-beta hydroxysteroid dehydrogenase deficiency. So that would be the clinical possibility. Because it is a XY-DSD, which involves a lot of conditions, so one would go with exome sequencing.
And it did show your 3-beta HSD there, and it was reported as pathogenic. So I think we agree that this diagnosis is clearly pathogenesis on that. So how will you predict pathogenicity? So we have got this report. If you can just explain how they have decided on pathogenicity.
So the pathogenicity is decided by several parameters. So ACMG gives this classification of the entities that you described: pathogenic, likely pathogenic, etc. So it depends on the submissions that have happened with the reported mutation with the pathogenicity. So it includes clinical parameters, which include whether it has been found in how affected individuals, whether more a number of reported individuals with the same mutation, more likely that the mutation is pathogenicity.
So
another is that in studies or in animal studies or in functional studies or in silico models, if it has been shown to cause a disease, then it is likely to be pathogenic.
So in this case, they said this was a stop codon. So
Yeah.
generally, if there is a stop codon, that means the whole gene expression will go off.
The functional
So function will be totally tree contation will be there. So this was clearly in that regards.
Next case, day 3 child presented with atypical genitalia. Prader 4 stage, no gonads. On doing ultrasound, uterus was present. Karyotype was 46XX. There was salt wasting and 17 OHP was now very elevated, 120 nanogram per ml. Dr. Mahesh sir, how will we proceed with this case?
So I think till now we are clear with this diagnosis. We should not misdiagnose. So there is no doubt about that. This is a 21 hydroxylase deficiency. Definitely the next step is to send the genetic investigation. So probably some genetic test was sent in that.
Sir, next genome sequencing was done and it came out to be normal.
So don't get disheartened if the NGS comes normal in this particular scenario, because probably this may not be a right test. Because just now recently Dr. Anurag said in the previous slide, so there is something, the commonest cause for defect is actually this CYP21A2. And there is a nearby CYP21A1 is also there in the nearby. So probably this is not a, you want to go deep or you want to go in extent. So in this particular scenario, when the computer started seeing this particular report, there is a more frequency of CYP21A1 and not the CYP21A2. So he's not picking up that CYP21A2 and picking up only primarily the CYP21A1. And this is the reason it reported as a normal. So this is probably just an example of a pseudogene that was present there. So in this scenario, we should think about sending the Sanger sequencing, just like you said that you want to go deep. So if you go deep, then you will be able to find it out. Or in the next scenario, you can go the further investigation by sending the MLP or
So now everybody goes for a whole exome sequencing. Do not do that. If you know this is 21 hydroxylase, go for hotspot testing. CMC Velo, there was a wonderful study which looked at the hotspots which can identify that. Or go for Sanger sequencing if you want genetic confirmation. But do not go for NGS.
I think this confusion also quite frequently happens in non-classic CAs.
Yes, yes.
If you are suspecting in a teenage girl or in a premature adrenarche, often the WS is sent. It comes as normal, but WSS has a poor coverage for CYP21A2 gene and also misses deletions. So therefore,
thank you.
So the Sanger sequencing was advised in this case, and it came out to be 21 hydroxylase deficiency. Moving to the next case, 15-year-old girl presented with delayed puberty. The breast stage was 4. There was pubic hair stage 2. Inguinal gonads was present, however. On doing ultrasound, there was no Mullerian structures. FSH was 120, very high, and doing karyotype, it came out to be 46XY. Testosterone levels were also of the male range. Dr. Sayan, sir, how will we proceed?
So as far as the flowchart goes, so this clinical phenotype is typically fitting into androgen insensitivity syndrome. Now, did we go ahead with the genetic test?
Yes, we did the biochemical test, testo-DHT ratio, which came out to be 8, and whole exome sequencing was done. It came out to be normal.
So,
So you said it is a genetic diagnosis, but genetic test is negative.
So, as we are all talking about things that we suppose will happen but turn out and do not happen. So this is again a situation where we are clinically strongly suspecting, but we do not find the genetic diagnosis. Now, when we are going ahead with whole exome sequencing, we are only looking at coding regions. Now, this coding region is also under some regulatory genes. Now, these regulatory genes happen to be in the intron and also can be there in the promoter region. Now, whole exome does not pick this up. And as sir just said, we are having newer.
While we get a lot of many reports with uncertain.
We are sitting here, 20, 30 mutations will be found in us, not mutations, variations, and which may actually be pathological. But when you see we don't have any disease, what does it mean? Because of penetration, expressivity, and everything. So there are certain conditions which has to be reported. Mostly they are pre-cancer situations, hyperlipidemia, but otherwise they also ignore the report also, as Dr. Sandeep said. So I think that is something which is again extremely important. So I think this was a wonderful session. Thanks a lot, Dr. Mahesh, Dr. Ganesh, Dr. Sayan, Dr. Sandeep. Thanks a lot, Nimisha, for this discussion. We will be breaking the program here and start the inauguration session now, and then we will continue with this diagnostic session at the second level. So I'll hand over to Dr. Kirti to continue with the inaugural session. हुआ उनको यहाँ पर तब तक बुलाते हैं
Respected dignitaries, distinguished faculty, honored guests, colleagues, and delegates. A good evening, and on behalf of ISPE, Grow Society, CDER, and Medi Classes, I extend a warm welcome to each and every one of you. The 7th Advanced Pediatric Endocrine Symposium is a celebration of our shared commitment to advancing pediatric endocrinology through science, collaboration, and compassionate patient care. Over these 2 days, we come together as clinicians, researchers, teachers, and trainees to exchange ideas, learn from each other, and continue our collective pursuit of excellence. It is my honor to invite our distinguished dignitaries to kindly grace the dais. I invite Dr. R.N. Chaurasia, sir, Dr. Rishi Shukla, sir, Dr. Yutika Bajpayee, ma'am, and Dr. Anurag Bajpayee, sir, to grace the dais. Thank you. Lighting the ceremonial lamp symbolizes the triumph of knowledge over ignorance and marks the beginning of an auspicious journey. May I now request our dignitaries to kindly proceed for the ceremonial lamp lighting. To share the vision behind this year's conference, I invite our program.
And I'm joined by Ria, who will be posing difficult clinical questions, particularly about endocrine diagnostics. So when we talk about hormone assays, this is something which is extremely important in terms of assessment. They often are game changer, but often we get results which are confusing and complicated. So what we'll be talking about is common errors which happens in terms of endocrine evaluation. So challenges that we see is that these are large molecules with wide range of references. Puberty and other factors are also influencing it, and there are a lot of variations which happen in that perspective, and these all will be highlighted. So when do we do an endocrine test? We do it for a screening investigation, for diagnosis, and for monitoring purposes, but do a test only if it is going to change your decision. I think that is something which is extremely important from that perspective, and only if there is a high pretest probability which is there. So when we do write a test and we get a report, we often say, okay, we have written this test and we got this report, this will be 100% right. No, that is not the case. What we have to really look at in that perspective is that there can be a lot of problems. Whether the test we selected was right or not, whether the timing was right or not, whether the sample that we took was right or not, whether it was stored properly, and whether the assay was right. And then finally, as they said, that the most important part of a stethoscope is in between the two ears. Similarly, again, once you get the report, how you interpret it also becomes important. So most common errors that happen in hormone assays are not analytical. 50% are pre-analytical. So you can have 30% as analytical and 20% as post-analytical. So again, the type of test, as I said, sampling, labeling, and tube, processing and technique, 30% are analytical, whether the technique and the lab is at error, and 20% again is how we are perceiving those from that perspective. So the first question you have to answer is, which test should I order? So if you are looking at molecules like thyroxine, FT4, cortisol, testosterone, order the test. That they are good enough tests from that perspective. In certain scenario, things like insulin or vasopressin, these tests will be so short-lived that you will not get the result. So you go for co-secretors like C-peptide or copeptin. Then sometimes you don't get the test, you look at the effect. So very importantly, if you're looking for PTS, look for what the calcium levels are. If you're looking for ketone, whether hypoglycemia, ketosis is there or not, insulin will give you a figure in that perspective. And sometimes you do metabolites, particularly for the steroidogenic pathway. Now, sample options we have is whole blood. Whole blood is not something which we routinely use. It's usually for point of care test. This is very labile. We can use plasma, which is basically minus the blood cells. And this basically again is used for things like ACTH and PTH. So doing the right sort of test becomes important. And if you remove that, it becomes serum, which is a very stable test. And for most situations, you will be doing a serum analysis in that perspective, which becomes important. Other sample types that you're looking at would include urine, which may be difficult in children because there are 24-hour collections which are there. You have to correct for creatinine. And then saliva is emerging as an important test, particularly for free cortisol, as a good option on that perspective. We should do the test, particularly if there is a pulsatility. The option that we can have is either we do a stimulated test or we do a pooled test. Then there could be a diurnal variation, particularly for cortisol. There could be a menstrual variation for a lot of these reproductive hormones, and seasonal variations, which you will see for estradiol, testosterone. So all those things have to be considered. Just that you've got one result does not mean that you've got the final scenario. So if there's a pulsatility problem, do a pooled sample. What do we mean by pooled sample? You take 3 samples, 0, 15, and 30 minutes, combine it and run it at a one time. You don't need to do 3 samples. That is very important. You can do it in the morning like cortisol. You can do co-secretions like C-peptide and dynamic tests like growth hormone or GnRH. Transport, remember, if you have to transport ACTH, insulin, PTH, do it in ice or do it immediately processing. Otherwise, the results will be affected from that regards. Don't freeze ADH or IGF-1, and some samples are not dependent upon temperatures, which will be most of your hormonal assays. So we'll now start off with cases and where confusions happen.
Thank you, sir. We'll start with the interesting clinical scenarios. So first case, a 10-year-old boy came to us with growth failure. His height was 127 centimeter, which is minus 2.4 STS. Weight is 14 kg, which is minus 4.8 STS. Normal screening workup was seen. So IGF-1 level was done, which was low for the age, and growth hormone stimulation test was done, which was normal. So I would like to ask Dr. Shalini ma'am if you are happy with this diagnostic approach.
Yes. So I think we have a variety of endocrine tests, and because they're available, we tend to order all these tests also. But if you look at the first line, what we see is that weight is the parameter here which is more affected than the height. And probably because of the chronic malnutrition, whatever the cause of that would be, height is also affected. Now we know that IGF-1 is one molecule which can come low in malnutrition, it can come low in liver diseases also, right? So here, rather than going straight away for the growth hormone stimulation test, just because an IGF-1 level had come low, I think we would definitely like to investigate why the child is so much wasted also, right? So here, I think IGF-1 level could have been avoided.
So clearly this was a malnourished case. Don't do IGF-1. If it is less than 5 years, don't do IGF-1. And remember, IGF-1 is a screening test. It is not going to give you a diagnosis.
Moving on to case number 2, it's a 15-year-old boy came with obesity. On examination, he had violaceous tria and hypertension with a BP of 140 by 90. After an overnight dexamethasone suppression test, the cortisol was suppressed to 40 nanomole per liter. So I would ask Dr. Manisha ma'am to approach this case.
Also.
So overnight dexamethasone suppression test was normal because it was less than 50. So
The main problem happened later on
Hmm.
is that when they did an investigation, they did find that the ACTH level was high. So they were very much concerned about that this is a case of Cushing's. So they got a ONDST, they forgot about that, they got the ACTH done and then advised MRI. Do you agree with that approach?
No, ACTH should not have been done. First, we should confirm at least 2 screening tests has to be done to confirm Cushing. Then it has to be decided whether it is ACTH dependent or independent. In this case, ACTH was high. It could be because the sample for which the ACTH was collected, it would have been a wrong sample. So ACTH should always be collected as a plasma sample, because it is a labile hormone, as discussed earlier.
So choice of test becomes very important, whether you're choosing IGF-1 or growth hormone, and choice of sample also becomes important, whether it is serum or plasma.
Moving on to next case, it's an 11-year-old boy who came to us with growth failure. His height was very low. It was 98 centimeter, which is minus 5.4 STS. He had immature faces with normal screening tests. Basal growth hormone level was done, which was 0.1 nanogram per ml. So my question is to Dr. Chetan sir, if we will go ahead with the treatment with this single basal growth hormone level.
As discussed earlier, growth hormone is a pulsatile hormone. So there is no fun in doing any random sampling for growth hormone, including basal growth hormone. If at all we want to go for growth hormone stimulation test, child should be fit into the severe growth failure criteria. And then we should be doing growth hormone stimulation tests, proper clonidine stimulation test, and based on stimulated growth hormone level, ideally we should be diagnosing growth hormone deficiency.
So we should have done the growth hormone stimulation test clearly in this scenario.
So moving on to next case, a 13-year-old boy came with weakness and increased pigmentation. Sodium was done, it was 141 millimole per liter, and potassium was 4.6 millimole per liter. Cortisol was also done. It was 120 nanomole per liter. So Dr. Sajali ma'am, how do you proceed further with these investigations?
So, looking at this case, I'll first like to know the timing when the cortisol was done.
So the patient got it done in the afternoon itself when it was ordered. So it's
So, yes, then we all know that cortisol has a circadian rhythm. It also has pulsatility and the rhythm. So, what is most important is the appropriate timing of collecting the sample. So, in this case, ideally, we should do a cortisol in the morning at around 8 to 9 a.m. And then we can say whether the cortisol is low or no.
So clearly diurnal variation. So if you're looking for deficiency, look in the morning. If you're looking for excess, look it at night. That is what we should have done in that case.
So the wrong timing. We should choose the timing according to the circadian rhythm. So next case, a 15-year-old girl came with the concerns of hirsutism with menstrual irregularity. On examination, she had a Ferriman-Galway score of 12. On investigations, LH was 22 and FSH was 10. So Dr. Shalini ma'am, how do you proceed with these high levels with FGS of 12?
Yeah, so definitely the child has menstrual irregularity, hirsutism, and now the blood levels have been done, and somebody is going to label this child as PCOD because you get a very high LH. But I think it's important to know when these levels of LH and FSH are done. And also, again, to stamp somebody as PCOD, we don't need actually LH and FSH levels. So, if I may know, when were these samples done?
It was done on day 20 of.
Right, so we know that there is a peak effect of LH that happens just before ovulation, and it will take some time for the LH level to get back to the normal level, right? So we know that these metabolites have to be done between the 3rd to 5th day of the menstrual cycle only. So there are many such blood reports which in a girl are going to be affected by the menstrual cycle. So again, when the timing of the sample collection happens is very, very important. So if we do a repeat sample, it's possible it's going to come back normal.
Yes. So repeat sample was done.
So
It's not absent menses, right? हाँ, तो जब भी आता है उसका 3rd to 5th day ले सकते हैं.
or
otherwise
if
we
you
can
want,
false report.
yeah, or you can do is give a withdrawal. You can give a withdrawal and do the test. And as Dr. Shalmi said, LHFSH is of no value. Anybody with hyperandrogenism will have a high LHFSH. PCOS diagnosis, you don't need to get these LHFSH levels done.
The repeat test was done on day 2 of period and it was normal. So LH was 4.4 and FSH was 6.2. So again, the timing becomes very important. We are moving to the next case. A 6-month-old girl child came to us with seizures. The calcium was low. It was 5.4 milligram per deciliter and phosphorus was also low. It was 2.2. Parathyroid was 2.4 picogram per ml and vitamin D level was less than 3. A provisional diagnosis of hypoparathyroidism was kept. So I'll ask Dr. Manisha ma'am to consider.
So low calcium with low parathyroid or normal PTH level, we can have a diagnosis of hypoparathyroidism, but the phosphorus level is also low, which goes against the diagnosis. So in we are also having vitamin D deficiency in this child. So most likely this is a vitamin D deficiency. The PTH sample could have been taken wrongly, because of which it has come out to be low. So can we have the samples in which the PTH should always be taken in a pre-chilled container for
So in this case,
transportation?
it was taken by a collection center. Now, a lot of collection centers have come up, they have taken the sample and they have not processed it properly. They have sent and kept it for hours. That is why the PTH is low. So always look at your clinical correlation, as Dr. Manisha nicely, clearly pointed out.
So repeat PTH level was done after following the proper protocol and it came out to be 250 picogram per ml. So incorrect transfer was the main issue.
So now we have talked about pre-analytical issues. Second will be analytical issues. Analytical means which machine, which platform which we have used, whether they have followed quality control or not, and whether they have done the proper technique. So there the lab is in the main question mark. So which technique? There are broadly two techniques. Most of the hormone assays that we get are enzyme immunoassays. Now immunoassays are very good for large molecule, but they need larger volume. They are not good for steroids, testosterone, and many other things where you will be getting cross reactivity with many other metabolites. So for those situations, you can use mass spectroscopy, which gives you a much better thing. Classical example is neonatal period where cortisol levels may be quite variable. Estrogen levels in males, estrogen levels in prepubertal girls, testosterone in girls. In all these situations, GCMS may give you a much better picture. They also need lesser volume. So for steroids, you should prefer this technique. Then you have to also look at whether your laboratory is doing the right thing or not. So whether you have sensitivity, which is good, which basically mean the lowest concentration of how you detect. And we get all these reports of sensitive TSH, ultra sensitive TSH. They are all just telling you whether you're detecting 0.1, 0.01, 0.001. Second will be specificity. You are detecting only the analyte. So you're not measuring cortisone instead of cortisol. Accuracy, that means that you are actually measuring the true value. Precision means you are reliable. So precision is every time you measure the value will be the same. Accuracy, you have to do it via external control. So you have equals for that. Precision, you do level controls every day and see how your lab is doing. Whether there is a carryover effect, a previous sample is having an effect, and finally how stable these measures are. So this is precision versus accuracy. So this person, the levels are on both sides. This is accurate and precise. This is on one side. So there is a bias which is basically happening in this perspective. So clearly what we are seeing is this is a case of accuracy systemic error, and these are random errors. So we can measure many things and there can be many abnormalities which can be there. One of the very common ones which we are seeing is biotin. So biotin is being used out as many products and it interferes with thyroid, PTH, LSFSH, and you can have a lot of variable results. Heterophile antibodies are antibodies against animals which develop in humans, and they cause problems in terms of levels which may be low or high. Macroprolactin and macro TSH are two scenarios in which you get levels which are high, but when the actual bioactivity is not high. Antibodies against the protein may mask the disease. This is typically seen in thyroglobulin, particularly for malignancy of thyroid. So you are following a patient, levels are low, but antibodies are causing the low levels. You can have hook effect if the levels are extremely high, and hemolysis can cause confusion. So this is a table which will help you out as to identify what problems can be there from that perspective. So heterophile antibodies can cause falsely low or falsely high. So what you do, you use a different technique, do the different platform, and you will get the right result in that perspective. So we'll go forward.
Thank you, sir. A 7-year-old girl came to us with the signs of early puberty. On examination, she had a breast stage of 3, pubic hair stage 2, bone age was advanced to 10 years, LH was 1.2, FSH was 2.2, but an undetectable estradiol level. So, what could be the cause of undetectable estradiol level in this patient, Dr. Chetan?
So this is looking like a clear-cut central origin of precocious puberty in which this LH-FSH will lead to high estradiol. But on our assay, which is usually chemiluminescence, estradiol might be low because it's not that sensitive to detect a minute change in the estradiol. So definitely we should be switching over to mass spectrometry if at all we want to detect the estradiol. So change of the test is ideal.
Or you assume that this estradiol has no value. That is also important. So if your estradiol is high in a young girl, that is very significant. This is what you should think of. If it is low, don't bother. But if it is 30, 40, even that is very high. That is what you should be considering if you're looking at an immunoassay.
A 12-year-old boy who's a diagnosed case of 21 hydroxylase deficiency. He is currently on hydrocortisone 15 mg per meter square per day. He came with a report of 17 OHP of 4 nanogram per ml. Since the cutoff was 3 nanogram per ml, it was repeated, which came out to be 2.4 nanogram per ml. So, Dr. Sajali ma'am, how do we interpret this report?
So the cutoff of 3 with the two reports having showing results variable, like they are 2.4 and 4. They are not very far, but they are near the cutoff. So this can be explained by coefficient of variation. That is basically it is the test to detect the imprecision of the test. So when we know that the test is the cutoff is one number, but the test can have coefficient of variation above and below, which can explain in this case that the child has normal levels and does not need any management here or change of dose.
I think the biggest question is whether the cutoff really makes sense. We have got cutoffs for everything, but we have to interpret that cutoff in so many things. Many times people say TPO level is 30 and 32 is positive, 29 is negative. This doesn't work that way. You have to see how far you are from that particular region and then your chances will become the same. So 2.4 and 4, they may sound 1.5 times away, but from a clinical perspective, both are acceptable. You want to keep it less than 10.
Otherwise, we'll end up over treating this child with steroids.
Yes, absolutely. So
we
I
will
think
not
that
change the dose. So next case, a 16-year-old girl came to us with galactoria. Her prolactin level was in the normal range, 16 picogram per ml. She also had headache and vomiting. MRI was done, which showed a large pituitary adenoma. So what could be the cause of normal prolactin level with such a symptomatic patient and large adenoma, Dr. Shalimir?
Yeah, so I think in this girl here, we are definitely suspecting hyperprolactin levels to happen, but the reports have come back normal. Now we know that prolactin levels in very high level undergo something known as the hook effect, right? So basically what happens is we kind of measure the prolactin levels using the sandwich technique, where you have one base antibody, the analyte will attach to the antibody and then another binding antibody attaches. So it is the whole sandwich antibody that we are going to measure. But when we have too much of the analyte, each analyte individually attaches to the antibody, right? So eventually the sandwich antibody measured is very less. So though the measure of the analyte is very high, eventually because you are measuring the sandwich antibody, it comes out to be very low. So in this case, what we do is we dilute the sample. So we have less number of analyte and more number of antibody, and therefore we are able to actually measure the sandwiched antibody.
So after dilution, the levels were very, very high.
A 17-year-old girl who is a case of papillary carcinoma thyroid, she was managed with thyroidectomy followed by radioactive iodine ablation. Now she has come in follow-up and recurrence was suspected. So thyroglobulin levels were done. It was undetectable. Although in radioactive iodine scan, they showed a lesion. So what could be the cause of undetectable thyroglobulin levels in the presence of recurrence? Manisha ma'am.
Since radioactive scan shows the lesions, it's obviously a relapse. Thyroglobulin level is undetectable, maybe because of some thyroglobulin antibody which was present and which has caused the level of thyroglobulin to be falsely low. So we can choose the other test, or we can use GCCMS.
So this is very important because otherwise you will counsel that this patient is normal. So as a rule, whenever you're doing a thyroglobulin level in follow-up of papillary carcinoma thyroid, always do a anti-thyroglobulin as well. That is absolutely important.
Moving on to the next case, an 11-year-old boy came with the complaints of lethargy. His free T4 levels was 3.2 nanogram per ml, which was increased, and TSH level was in the normal range. There was no goiter, and TPO antibodies were negative. The repeat tests were done, and now the T3, T4 levels were normal. So, what could be the cause, Dr. Chetal?
So just a single symptoms of lethargy without goiter and antibody negative with normal T4 and T3. So there might be some issues with the free T4 measurement. And particularly in this free T4, there is a phenomena called heterophile antibody, which interferes with the sandwich formation, and it gives usually falsely high levels and high readings. So definitely either we should be using anti-heterophile antibody in a mixture to measure the actual level, or we can change the test and see the actual free T4 level.
And often if you change the platform, so when we say platform means machine. So somebody is using Roche, somebody is using Alexis, somebody is using Beckman Coulter, you will get the different results. So that is something which we recommend send to a different lab who is using a different platform.
So, normal free T4 was found on different assay. A 14-year-old boy came with the complaint of gynecomastia. He was breast stage 2 with testicular volume of 12 ml and pubic hair stage 3. On hormone profile, LH was 1.8, FSH was 2.4, and testosterone was 120 nanogram per deciliter. Prolactin was also ordered, which came to be high, 120 picogram per ml. So, in order to rule out the prolactinoma, MRI head was done, which came out to be normal. So, how do you explain high prolactin level in this child?
Clinically looking at this child, he looks like a case of pubertal gynecomastia. When we suspect hyperprolactinemia, galactoria is one of the important complaints that should be present. Only gynecomastia does not suggest hyperprolactinemia. But if prolactin levels are high, this may be because of some lab errors, like it can be a macroprolactin. So we need to rule out the results are because of macroprolactin. So we can order a test which is pegylated prolactin levels, which can tell us the actual levels of prolactin.
And very importantly, hyperprolactinemia does not directly cause gynecomastia. It is through hypogonadism. So if your testo is 120 in a 14-year-old, this basically means this is a pubertal gynecomastia basically, and this prolactin should not have been done. So again, as we said, do not do tests when they are not required. So now finally coming on to the post-analytical. So this is basically where we make errors. So remember, people talk about what is the cutoff of PTH. But remember, there is no cutoff of PTH. It will depend upon how much your calcium is. If your PTH is 20, 25, let's say, and your calcium is low, that is hypoparathyroidism. If your calcium is 16, then this becomes high hyperparathyroidism. If calcium is normal, this is normal. So do not go by that cutoff. If your LH is 0.1 in a 18-year-old male, that will be low. But if it is there in a 12-year-old male, that is normal. So there's so many other things to look at. And one important thing is, what is your pretest probability of a disease? So as the prevalence of disease increases, the predictive value of a positive test increases. So do a test only when you think that there is a problem. Otherwise, don't do a test in that regards. And of course, use age appropriate level, especially for gonadotropins and testosterone, and do a contextual assessment. The classical example is thyroid. If your FT4 is low and your TSH is not high, it is central. I think that is the big message. If FT4 is high and your TSH is detectable, that is again a big problem. So always do contextual assessment, which becomes important, and look at, as I said, for calcium and PTH, if you have the same level with hypocalcemia, interpretation is different. Normocalcemia is different. Hypercalcemia, it is different from that regards. And lot of things like glucose, insulin, sodium AVP, growth hormone, IGF-1, similar interpretations have to be done in that perspective.
Thank you, sir. A 8-year-old girl came to us with the complaints of short stature. Her height was 128 centimeter, which is minus 1.5 STS. Weight is 28 kg, which is minus 2.2 STS. Screening test was done, which was normal. Growth hormone stimulation test was also done, and the peak growth hormone level came out to be 9.2 picogram per ml. So how do we proceed with these, Dr. Shalmi ma'am?
So I think in this case, I wouldn't say that the child is short, right? So if you plot on the growth chart, the child is more than the 50th percentile, right? So it's not again less than -2 standard deviation. So if you're not suspecting the child to have a growth hormone deficiency, it's better not to order the test, right? That is number one. Now, again, for the growth hormone level cutoffs that happen on a growth hormone stimulation test, some people do believe a cutoff of 7, some people believe a cutoff of 10. So I think if the child is otherwise normal, right, say, the mid parental height, that could be on the lower side, and that is why the child is right now like this. So probably the child does not have a growth hormone deficiency. So if you're not suspecting a condition, it is always advisable to not go for the test. Otherwise, you'll have some erroneous result, and then you're just moving around there.
Same as we talked about genetic incidentalomas, wherein you have got somebody, you routinely you do a test, you find one mutation, and then you are confused. So here the pretest probability is very low. So then this is not going to increase your predictive value.
So there was low pretest probability, so we will not start with any treatment. A 12-year-old boy came with the delayed puberty concern. His testicular volume was 2 ml and there was no pubic hair. The bone age was 10 years. LH was less than 0.1, FSH was less than 0.1, his testosterone was less than 10. In order to rule out hypogonadotropic hypogonadism, MRI head was planned. So how do we proceed, Dr. Manish?
So this is a 12-year-old boy. Since this is a pre-pubertal age, this is still not we will not call it as a delayed puberty till 14 years of age. The levels in pre-pubertal, the gonadotropin will have a age-appropriate level, which is appropriate for the child. During pre-puberty, the gonadotropins are low, and in this also, the gonadotropin and the testosterone level in the pubertal range, which is normal. So this is a inappropriately over-tested child. So we should not
has
done.
hypogonadotropic hypogonadism, but all prepubertal children will have hypogonadotropic hypogonadism. So why should we do the test? I think that is what you clearly mentioned.
So moving on to the next case, a 12-year-old boy came with lethargy. His FT4 was 3.2 picomole per liter. TSH was mildly elevated, 12. Cortisol was 44 nanomole per liter. ACTH was 5.6 picogram per ml. LH was less than 0.1. FSH was less than 0.1. Testo was also less than 10. So Dr. Chetan sir, how do we interpret these results?
So, looking to the high TSH, first of all, we might think that this might be the primary hypothyroidism case, but simultaneously, cortisol is low in coordinates with the low ACTH, as well as FSH, LSH is low. So overall, if you think that this might be the central thing rather than the, you can say, primary hypothyroidism, which is leading the cause. So this might be the actually pituitary thing to look out for and to have the diagnosis of hypopituitarism.
So always assess for context of the end hormone levels. Low FT4, TSH should at least be more than 10 or more than 20 at least. If it is not elevated, that is central in that regards.
A 7-year-old girl child came with tetany. Her calcium was 5.4 and phosphorus was on the higher side, 7.7. Creatinine was normal and PTH was in the normal range, 15 picogram per ml. So, what is the interpretation here, Dr. Sajli ma'am?
So this is a clear-cut picture of primary hypoparathyroidism because we know calcium is low, phosphorus is high, and the PTH, though it looks normal in the range, but it is low for the calcium levels. So that's why it is a primary hypopara.
So I think that is again very important. So there is no normal level of PTH. There is no normal level of TSH. What is your FT4? What is your calcium? That will give you the clue in that perspective. Any insulin during hypoglycemia is significant. It doesn't matter if it is, but if hyperglycemia, then insulin becomes different. So this again is a very clear. Yes.
Phosphorus was high.
Yeah, so vitamin D was done in this case. So what we found was that the PTH was not elevated. So vitamin D deficiency became very less likely. And ideally, it will do obviously vitamin D in this case, and phosphate is high also. So that makes vitamin D deficiency a bit less likely. But definitely, everybody with hypocalcemia, we should do vitamin D in this case. So I think this is what we were trying to discuss and highlight, and it's really been a wonderful session. Thanks, Dr. Shalmi, Dr. Manisha, Dr. Sajri, and Dr. Chetan, and Ria for conducting this. We have been able to give messages that errors are not always because of the lab. The error may be in what we have written, what the person whose sample he has taken, whether they have labeled properly or not, you get the right result or not, how you interpret. So I think these all become extremely important. And that's why we combined these two sessions on genetics and diagnostics. So they were split ultimately, but I think they gave the big message on that perspective. I'll request Dr. Nimisha to give a memento of appreciation to Dr. Shalmi. Carry on.
I thank the moderator and the panel for a truly engaging session. Now we move on to the next session. Glucose connects many conditions that we encounter as pediatric endocrinologists, whether it is identifying the cause of hypoglycemia, choosing the right regimen for diabetes, or tackling dysglycemia. Every topic is a different chapter of the same story. In this session, we will be discussing all these topics under one umbrella. I invite Dr. Aisha Ahmed, Dr. Rahul Mopal, and Dr. Saksham Pandey to kindly take their seats and grace the session.
So Dr. Saksham and Dr. Rahul, we like you to be as the chairperson.
I invite Dr. Rajni Sharma ma'am for our first talk on postnatal, postneonatal hypoglycemia.
And Rajni doesn't need any introduction to the audience. She is a professor in pediatric and pediatric endocrinology at Ames. And our association goes a long time ago. I think she joined in 1994. So she was 1 year after me there. So it's been a long time. And Rajni has been doing a wonderful work in a lot of areas of pediatric endocrinology, particularly DSD, and as well as glucose disorders as well. So hypoglycemia. Thank you, Rajni, for coming and accepting our invitation.
Thank you so much, Anurag. And it's a great pleasure to be here. And thank you very much to the team for the opportunity. So we'll be discussing postnatal hypoglycemia. Basically, we all know as pediatricians that glucose is an essential energy substrate for the brain, and infants and children having a large head size have increased brain glucose requirements. So hypoglycemia is a medical emergency. If not treated and not prevented from recurrence, it can lead to permanent neurological brain damage. And it's not a diagnosis, but an indication of underlying pathological process. And diagnosis and appropriate management are paramount for optimal development outcome. So this is a common case in the emergency. A 15-month-old boy brought to the emergency with seizures, no vomiting or fever, and slept last night without dinner. The last meal was at 6 p.m. And similar episode occurred 1 month back. On examination, when we examine, we always do the ABCD and the airway breathing, the circulation. But we always have to remember not to forget glucose, because many times we forget glucose and the diagnosis of hypoglycemia is missed. So his blood glucose was low. What is the normal physiological response to hypoglycemia? So basically, the blood sugar has to be maintained above 70, and at that time the insulin levels are suppressed. And whenever the level falls less than 70, there is a neurogenic or autonomic response in which the hormones kick in. And these are the glucagon, epinephrine, cortisol, and growth hormone, which lead to autonomic features like palpitations, tachycardia, sweating, tremor. And when the level reaches 50, which is the danger level, there are neuroglycopenic symptoms, that is the lethargy, coma, and even death can occur, seizures and death can occur at that time. And 50 remains the target for terminating any provocative test for hypoglycemia. So what is the normal physiological response to growth hormone? So I just want to say one thing. I think the old slides are here. I had sent a new slide, but it's okay. It's fine then. So glycogenolysis is the first response in which the glycogen is broken down to glucose 6-phosphate by the enzyme. And this one will ultimately get converted into glucose and be released, or it can be converted into lactate. Then the second response is gluconeogenesis, in which the pathway in which the fuel acts to form glucose for lactate, alanine, fructose, and glycerol. They are converted into glucose. If I can have the old slides, actually, this is a little longer presentation because this will take longer then. That was for the printout, actually. And the third mechanism is the fatty acid oxidation defect. The fatty acid oxidation which occurs, these are processes in which the ingested fat are converted into acetyl CoA, and acetyl CoA is converted into enters the citric acid cycle to release energy. Otherwise, the acetyl CoA can be shunted to form ketones, and they will be transported to various tissues for brain for production of energy. So now coming to the physiological response to fasting. So what happens is that when there is fasting occurs, then after the fed state is over, then glycogenolysis sets in and releases glucose into the blood.
ये नया होगा. You want to start? You want to start?
I think this is the... Okay, fine. So then what happens is that there is fatty acid oxidation. There is, first of all, there is glycogenolysis. Subsequently, it is followed by gluconeogenesis and the lipolysis, ketogenesis, and fatty acid oxidation. So these are the responses to fasting. So what is the relation between plasma glucose and ketones? So what happens normally is that, as you can see, on that side is the plasma ketones, and on this side is the lower x-axis is the plasma glucose. So whenever the plasma glucose falls, in a normal child, there is a response that the ketones will increase. But if you see the lower line, because of the lack of insulin. But in hyperinsulinism, the ketones are not produced and there are low ketones. So that is diagnostic of hyperinsulinism. So let us come to the etiology of postnatal hypoglycemia. The first is, of course, less supply. That is severe acute malnutrition in which the substrates are less. Then over demand like sepsis or congestive heart failure. Then Reese syndrome in which the liver is involved. And then comes the inborn errors of metabolism, like the first being glycogen storage disease, then defects in gluconeogenesis. The three main enzymes involved are fructose 1 bisphosphatase, phosphoenol pyruvate carboxykinase, and pyruvate carboxylase. Then comes galactosemia and fructosemia, amino acid defects, organic acidemias, and fatty acid oxidation defects. Then comes the hormone defects like growth hormone deficiency and adrenal insufficiency. Then hyperinsulinism, in which there is excess insulin either due to congenital hyperinsulinism, which could be syndromic or non-syndromic, or factitious hypoglycemia in which exogenous insulin has been administered, and sometimes insulinoma in older children. Then comes the ingestion of various drugs like sulfonylurea, alcohol, or ackee fruit. And then is the ketotic hypoglycemia, which is common in infancy. I'll be discussing this. So let's come back to another case of a 15-month-old who presented with recurrent episodes of hypoglycemia. The baby was asymptomatic till 7.5 months of age when he had brief episode of lethargy with fever. And then he came to the hospital when he was diagnosed to have hypoglycemia. So in the history and examination, what are the important points? First of all, the age of onset. If it occurs in the newborn period, then it most likely is inborn error of metabolism, hyperinsulinism, or hypopituitarism beyond the 72 hours of life. And 6 months of age, generally glycogen storage disorders become apparent because the duration of between the feeds increases and then the child is more dependent on glycogen. Then comes fructose intolerance when sugar is introduced into the diet. At 1 year around, benign ketotic hypoglycemia would be a more common cause. Then coming to the relation to the feeds. If it is post-feed, then it could be hyperinsulinism, which is a random, it can occur at any time, the hypoglycemia, or it could be galactosemia or fructose intolerance in which some toxic metabolites are formed due to which glucose is not released from the liver. So these are generally post-feed hypoglycemia. Ketotic hypoglycemia generally occurs after prolonged fasting or after missing meal. And in sickness, adrenal insufficiency is generally the cause for causing hypoglycemia when the child is sick because gluconeogenesis does not occur. If there is a history of aversion to sweet food or sugar, then it goes in favor of hereditary fructose intolerance. Presence of short stature, micropenis, midline defects suggest panhypopituitarism or hypopituitarism, and hyperpigmentation means primary adrenal insufficiency could be a cause. So on examination, this child had normal vitals, and but you can see the head circumference is at -3 microcephaly because of the recurrent episodes of hypoglycemia. There is no dysmorphism or hyperpigmentation, and there's some mild hepatomegaly. So coming to the critical sample, what are the important things we have to take? And critical sample, generally we take the blood sugar to be around 50 when we collect the critical sample. So we have to do an arterial blood gas, looking at the lactate levels. The lactate levels are increased in glycogen storage disorder and defects of gluconeogenesis. If there are ketones, ketones are the most important thing to check. The normal response, as I mentioned, would be more than 3 millimole per liter of blood ketones, but they would be absent in hyperinsulinism and fatty acid oxidation defect, that is less than 1.8 millimole per liter. Then we have to check the insulin levels. So the insulin levels by a highly sensitive test would be increased more than 1.2 milli-IU per ml per liter, and the C-peptide would also be high, more than 0.5 nanogram per ml. If the C-peptide is, say it is low, but the insulin is high, then that would suggest some exogenous insulin administration. Growth hormone level should be more than 7. If it is less than 7 nanogram per ml, it suggests growth hormone deficiency. Cortisol level, ideally at the time of hypoglycemia, should be more than 18. Less than 18 suggests adrenal insufficiency. And we also measure free fatty acids. Generally, this is not available, but if they are, then they are increased in fatty acid oxidation defect, but they are low in hyperinsulinism because no lipolysis is occurring. And we also measure ammonia levels. which are the non-critical, and ammonia levels may be high in some kinds of amino acidopathy and some kinds of amino aciduria, as well as some even some cases of congenital hyperinsulinism. Some variants may have increased ammonia levels. So coming to the case one, this child then was diagnosed to have hypoglycemia. He was given IV dextrose bolus, and he had a high requirement of GIR of 10 milligram per kg per minute. The critical sample was collected and the ketones were low, less than 1.8. Ammonia was high. Lactate is normal. As we can see, insulin is high, 10 unit per ml, a microunit per ml, and C-peptide is also increased, which suggests endogenous insulin. The growth hormone levels are low and the cortisol is also a little bit low. So this is common in hyperinsulinism because the stores get depleted, and so you could have low levels in hyperinsulinism. So this is suggestive of non-ketotic hypoglycemia with hyperinsulinism. So this typically presents in newborns or infants as persistent hypoglycemia. The defect is in the KATP channel in the pancreatic cells, and around 12 known genes are there, of which the most important are ABCC8 and KCNG11 in more than 80% of cases. And hyperinsulinism, hyperammonia syndrome is the next common cause, which is due to a gain of function, autosomal dominant mutation of the glutamate dehydrogenase gene, and it causes protein-induced hypoglycemia. So the children, when they take protein, they have hypoglycemia. And management includes adequate treatment with diazoxide and a diet restricted in protein. So this child was diagnosed to have GDH mutation. Now, these are the diagnostic criteria for congenital hyperinsulinism. That is suppressed beta-hydroxybutyrate, suppressed plasma-free fatty acids, inappropriately large glycemic response to glucagon. I'll come to this, how we do the glucagon test. And increased requirement. When do we suspect? When the GIR is more than 8 to 10 in a neonate, or more than 3 milligram per kg per minute in adults, and somewhere in between for children. And evidence of excessive insulin secretion in the form of high plasma insulin and high C-peptide. So I'll come to this later. Now, this is the glucagon challenge test. So what happens in this is, normally when you have hypoglycemia, we don't expect the liver to have any glycogen stores, except in two conditions, that is hyperinsulinism, in which insulin levels are high, or in glycogen storage disorder. So if you give glucagon, then the blood sugar should not rise, and it won't rise in glycogen storage disorder because there's an enzyme defect. It would only rise in hyperinsulinism. So what we do is we give glucagon. Once the blood sugar is less than 50, you give glucagon around about 30 microgram per kg, and you check the blood sugar every 10 minutes, and it should increase by 30 milligram per DL, and that is diagnostic of congenital hyperinsulinism. We also have to be sure that we are doing this test when there's an IV line and there is IV dextrose, we have it at the side, because we may have to administer if the blood sugar falls further. Now, these are some syndromic causes of congenital hyperinsulinism, like Beckwith-Wiedemann syndrome, which is due to a methylation defect of 11p15 gene. And here you can see the clinical features, like they have protruding tongue, umbilical hernia, overgrowth syndrome. So these children, you always have to look for these features of dysmorphism. Or you could have Kabuki syndrome, in which they have developmental delay. Sometimes the developmental delay is more than expected, and they have certain features like everted eyelids, high arched eyebrows, depressed nasal bridge, and hypotonia. So this is Kabuki syndrome due to mutation in KM2D gene. Now coming to the management, so oral diazoxide is the first line of therapy, which is in the dose of 5 to 15 milligram per kg in 3 divided doses. And we also add hydrochlorothiazide, 1.5 to 2.5 mg per kg per day, to prevent fluid overload, because diazoxide complications are, it can cause fluid overload, it can cause pulmonary hypertension, and neutropenia in some cases, rarely. So we have to give it for a minimum of 5 days and increase the maximum till 20 milligram per kg before saying that it is diazoxide unresponsive. And when it is found to be unresponsive and we're not able to taper GIR, then we add injection octreotide, 15 to 20 microgram per kg per day, maximum being 50 to 60 microgram per kg per day. Sometimes sirolimus has been used, but nowadays we are not using sirolimus because it has been found to have a lot of immunosuppression and causing sepsis and even severe cardiac shock. So children have died also due to sirolimus, so it is best avoided nowadays. Once the child is controlled on octreotide, then we switch over to long-acting octreotide, generally around the age of 6 months, because it has a lot of GI side effects. So the age normally to transition is 6 months of age. And the daily dose of octreotide is multiplied by 3, and that is the depot dose that we give. And slowly we taper off the daily dose. The target blood sugar is 70 actually, but sometimes when you're not able to maintain more than 70, we can even target 60. Feeding has to be 2 to 3 hourly and given either orally or by nasogastric tube if required. Uncooked cornstarch can be given after around 9 months of age, around 1 to 2 gram per kg per day, or sometimes you can mix glucose 0.5 gram per kg per feed. And it's very important to ensure compliance of medication and regular feeding as well as blood sugar monitoring in the child. Now, what are the side effects of octreotide? Octreotide basically is a somatostatin receptor analog. So what it does is it can cause, it generally suppresses the insulin level, but it also affects the pituitary, and it can cause low TSH, low growth hormone. So it could affect the growth and cause central hypothyroidism, as well as a lot of GI side effects like gallstones and vomiting. So all these side effects have to be monitored, and generally we do the follow-up every month for the first year of life, and then every 2 to 3 monthly. Anthropometry and development assessment are performed. Liver function test, it can also cause transaminitis. And thyroid function tests are done every 3 months, and ultrasound abdomen for gallbladder stones is done every 6 months. So coming to the newer developments, like sometimes we also give an infusion of a glucagon. When we're not able to taper off the glucose infusion, we can give a infusion of glucagon. And but what is the problem with glucagon is it's highly unstable. So nowadays we have a new preparation of glucagon, that is dasiglucagon, which is more clinically, it's an advanced form which is more soluble, and it can be given through subcutaneous route. So there was recently a study in which dasiglucagon was given subcutaneously infusion, and it helped in tapering the GIR in the initial phase. Then coming to the other forms of therapy, like if you have, suppose, a focal lesion. So if you have a focal lesion, then what happens is that then how do you diagnose that? So nowadays we don't do dopapet in all the patients. We only go for dopapet in those who have a paternally inherited mutation, because these are the children who are likely to have a focal lesion. So we do not have to do imaging in all the patients. I would just like to share our experience. So this is an article which was published in Indian Pediatrics. So what we did was we just reported 42 patients of congenital hyperinsulinism. So they were divided into diazoxide responsive and diazoxide unresponsive. So what we found was that the diazoxide responsive are presenting at a later age. That is, the mean age of presentation would be around about, the presentation was 1 month to 12 years. They can be diagnosed anytime. And only 50% of them were diagnosed to have a mutation. And generally, these patients have more severe neurodevelopmental adverse effects because they're diagnosed late. Then the second group was the diazoxide responsive on octreotide. They presented early, and they had mutations were found in almost 100% patients, ABCC8 or KCNJ11. And what we found was that the neurodevelopmental outcomes were quite good because they were diagnosed early and managed appropriately. So now I would just like to discuss a few more cases. Like this is a case of a 4-year-old presenting with loose stools and multiple episodes of GTCS. And you can see that he had hypoglycemia. On examination, he was found to be severely wasted. And as you can see the hyperpigmentation. So this case, he had hypoglycemia, was treated with IV dextrose, and the blood ketones were normal. They were elevated. Ammonia, lactate, insulin, all were within normal range, but the cortisol came very low at 0.7 microgram per DL, suggestive of ketotic hypoglycemia with low cortisol. So this patient had adrenal insufficiency. And in this patient, we did a synactin stimulation test, though it's not required once the cortisol is low. Only if you have a suspicion, then you can do a synactin stimulation test. And post ACTH also, the cortisol levels were low. ACTH levels were very high, and 17 OHP was normal. So this was a case of primary adrenal insufficiency. And normal adrenals were documented on the ultrasound. and genetic panel is awaited. He was started on hydrocortisone 10 to 12 mg per meter square. This is a typo. And he was advised to take stress dosing during fever and diarrhea, that is, increase the dose to 3 times. So it is important to remember that many patients can suffer from hypoglycemia during stress and develop seizures and neurodevelopmental. They can even have death can also occur. Always teach the parents how to give IM hydrocortisone in emergency. This is another case of a 1-year-old child with recurrent seizures, and on examination his weight and length was severely affected. There was no hepatomegaly, genitalia showed micropenis and bilateral undescended testes. There was a history of breech delivery, and the critical sample showed ketones were there, lactate and bicarb were normal, cortisol levels were borderline, and growth hormone levels were very low. IGF-1 was low, and thyroid, as well as subsequently a growth hormone stimulation test was done, which was shown normal, low value of growth hormone. So this case was a case of growth hormone deficiency, and there was a hypoplastic anterior pituitary with a normal stalk, and subsequently child was started on growth hormone, and there was no further episode of hypoglycemia. So this is another case to consider. Then we come to a 15-month-old brought to with generalized seizures, and there was a history of having late dinner and missing a meal. The last meal was at 6 p.m. and subsequently he was diagnosed with hypoglycemia. And as we can see, his weight is low, Z score of -2.29. Weight for height is at -2.6. He had no dysmorphism, hyperpigmentation, hepatomegaly, and genitalia were normal. So again, the critical sample was done, and we can see that the ketones are high and rest of the investigations are normal. So this was benign ketotic hypoglycemia. It's one of the most common causes of hypoglycemia in toddlers and young children who do not have diabetes. And the age ranges from 6 months to 6 years, peaking around 2 to 3 years, and frequently seen in children who are naturally thin. The common triggers are overnight fast or acute gastroenteritis. And management is to avoid prolonged fasting and illness management. When the child is sick, we proactively give them frequent feeds and sips of carbohydrate-rich fluids like juice, regular sport drink, or popsicle. And bedtime snacks are ensured that there are complex carbohydrates. There is a glycogen storage disorder, which is known as glycogen storage disorder 0, which is the glycogen synthase, in which no glycogen is formed. And this can mimic benign ketotic hypoglycemia. So how do we distinguish this from benign ketotic hypoglycemia? These children generally have, after post-meal, they would have hyperglycemia. So if you check their blood sugar after the meal, 2 hours, they would have hyperglycemia as well as lactic acidosis. So we can distinguish it from there, and that has to be ruled out. Coming to one cause which we have heard a lot about, that is the lychee, the hypoglycemia, Muzaffarnagar, a lot of hypoglycemia cases were occurring. And this was found to be due to a dual toxin in lychee. And when the children took it empty stomach, these toxins, they blocked fatty acid oxidation in the liver and caused hypoglycemia. This was similar to the ackee fruit that is in Jamaica, which causes hypoglycemia. So this is just a kind of algorithm which you can use. Whenever you have a case of persistent or recurrent hypoglycemia, you check the critical sample and the ketones. If the ketones are high, you look at whether hepatomegaly is present or not. And if it is present with lactic acidosis, it is glycogen storage disorder, gluconeogenesis defect, and without acidosis, other forms of glycogen storage disorder. If hepatomegaly is absent, then you will suspect growth hormone deficiency, primary adrenal insufficiency, or idiopathic ketotic hypoglycemia, or GSD0. In the critical sample, if you have low ketones, then you check for insulin levels. If the insulin levels are low, if they are present, then it is hyperinsulinemic hypoglycemia. If the insulin levels are, low, if they're high, then it is hyperinsulinemic. If they are low, then it is either fatty acid oxidation defect or hypopituitarism, galactosemia, or fructose intolerance. So this is an algorithm which can be used. And so in conclusion, it's important to recognize that hypoglycemia to avoid life-threatening events and neurodevelopmental sequelae. Don't ever forget glucose. And we have to have a systemic approach to history and examination. The importance of the critical sample. And the guidelines for congenital hyperinsulinism, consensus guidelines can be followed for treatment. It's important to treat adrenal insufficiency with stress dose of steroid, and timely diagnosis and prevention will lead to favorable outcomes. Thank you.
Thank you, Dr. Rajni, for such a wonderful presentation and covering such a topic in such a nice manner. Do we have any questions from the audience?
Thank you. DST.
GST.
Yeah, GST is quite common. I mean, it's seen quite.
And I think GSD probably what sort of that is the main problem that often happens in terms of dietary approach. So maybe
Yeah.
you can tell, because a lot of fellows were also asking in
Okay.
that regard. Yeah.
Yeah, GST actually. So when we get a case of GST, what we say normally is that they would have ketones, right? But many times the GST patients don't have ketones, and so you can confuse. But they have the typical doll-like faces, and from the genetic test and all, you could diagnose GST. So we give them overnight feeds with the cornstarch. The dose being 1 to 2 gram per kg, and overnight they get these feeds, nighttime feed, and nowadays, we're also doing CGMS, continuous glucose monitoring in these patients, though we know that it may not be that, accurate when the levels are low. But generally, if the levels are within normal range, then we're a little bit assured that there's no problem in the hypoglycemia.
Thank you. I'll request Dr. Ria to give the memento of appreciation, Dr. Rajni.
Thank you so much, ma'am, for the excellent overview. We now shift our focus to one of the most dynamic areas of pediatric endocrinology, type 1 diabetes. I invite Dr. Shalmi Mehta to speak on type 1 diabetes in 2026.
So Dr. Shalmi is a pediatric endocrinologist in Ahmedabad. EndoKids and Dr. Shalmi is the organizer of the forthcoming ISPE meeting. So all of you, I think, should try to register for the ISPE meeting in Ahmedabad. We are having in October. This is a specific meeting dedicated to diabetes. I think it's going to be a very good academic program.
Thank you, sir. So I think it's a very interesting talk because we are going to talk about what is going to happen or what has happened so far in terms of type 1 diabetes in 2026. So I think after a long time, we have had some exciting news about maybe the treatment, maybe the technological advances. So we're going to just brush up on what has happened. It's going to be advances in insulin, advances in technology. We're going to speak a bit about advances in prevention because, a lot is being talked about teplizumab and what is happening in terms of cure. So I think what has happened drastically, which might change, the lives of some kids, is that inhaled insulin is now approved in children. So that approval just came in May 2026. Inhaled insulin is now approved for the use in type 1 diabetes for kids more than 6 years of age.
You carry on. It's not coming up. You carry on.
Yeah.
Not big shared.
No, it's coming, sir.
Zoom in.
Acha, sir.
You carry on.
So we know that these human insulin molecules are adsorbed on this technosphere particles, and then they are used as an inhaler to deliver to the lung tissue upon inhalation. The most important advantage I see of this insulin is the rapid absorption, right? So within minutes, it reaches the bloodstream and starts working. Right, so we know that this is typically how, the yellow line, how insulin typically works after you have taken a meal, and the line in purple shows how the inhaled insulin works, right? So it comes into action early and it gets out of the system also very early. So it's ultra rapid acting and the onset of action is within minutes. It is available as these inhalers. So I think there still needs to be some work done on this because it is available right now only in 3 formations: cartridges of 4 units, 8 units, and 12 units. So if somebody is on a larger dose of insulin, then maybe they'll have to use more cartridges. They have to just simply put a cartridge in the inhaler and take it as an inhalation. Right? And this is what they have recommended. So typically, if you have a kid on subcutaneous insulin and you want to now use the same dose as a bolus insulin, what they say is you have to double the dose if you're talking about inhaled insulin. So say if somebody is on 4 units of subcu insulin, they'll be taking 8 units of inhaled insulin. If somebody is on 5 units of subcu insulin, that double is 10, but then you round off to the lowest available cartridge, which is 8 units, and then basically you just titrate your dose. If somebody requires a larger dose, say 16 units, then maybe 2 puffs of 8 or 12 and 4, whatever combination they want to take. So as I said, the conversion of subcu insulin is around 2.5 is to 1 unit of this insulin. Now, something that comes in the market definitely has its pros and cons, right? So let's talk about few pros of inhaled insulin. We know that because it is ultra rapid acting insulin, the lingering effect of insulin is less, and therefore there is less chance of hypoglycemia. You can have a faster correction of higher sugar levels and therefore improve time in range, right? All of us have moved from HbA1c to better time in range levels. So definitely, if your sugars are getting corrected faster, you can expect an improved TIR. I think this is one of the most important advantages. It is stable at room temperature. So when you're traveling or say the kid is in school, no, often in Ahmedabad, the school timings are 8 to 3. So where they take a big lunch at school and then often they're not ready to take insulin injection at school. So again, just taking an inhaler at school would be comfortable because this insulin is stable at room temperature and therefore easy to carry also. But yes, because it's very, very short acting, you will need more frequent doses. So maybe every 2 to 3 hours, you may need a dose based on what type of a meal you are getting. As we said, the dose taken is more as compared to the subcu insulin, right? So say somebody is on 8, this child will need now 16 units of insulin. And because there is no lingering effect, we sometimes love regular insulin because somebody's snacking, that lingering effect of insulin helps in the snacking. But because there is no lingering effect, the chances are we may end up giving more basal insulin also. So maybe it can be used as an adjunct to a heavy meal or a big snack, or while the child is in school, or maybe while traveling. And definitely it helps in avoiding pricks, but it is contraindicated in kids who have got asthma or lung disease. And right now it's quite expensive. So about 1 unit is about 27 rupees, right? So maybe that restricted use might apply and that might change the scenario here. Weekly ones, basal insulin, I'm sure Ganesh is going to talk a lot about the newer insulins, but not approved for kids with type 1 diabetes. So we are going to restrict that. And again, I'm sure Ganesh is going to talk about smart insulin, but people are trying to work on insulin, which maybe has a switch, right? So based on what the sugar looks like, the switch goes on and off. So we hope such insulin comes into the market earlier, but they're still undergoing preliminary trials. Let us look at a few advances in terms of what's happening in terms of technology. So what's happening in insulin delivery devices or monitoring devices? So why do we need these devices? We have got like Medtronic's latest pump here. So why do we still want to make things better? Because we want to make the pump smaller. We want to make the pump tubeless. So many kids don't like the tube hanging out of their clothes, or sometimes there is a kinking of the tube that's happening. So we want to make the pump look smaller, tubeless. We want to be able to accommodate more insulin. So less frequent cartridge changes, right? So that somebody is on, say, 60, 70 units of insulin, they have to change their cartridges very frequently. So maybe we are able to accommodate more insulin to make entering carb count easier. I know we have now given, automatic delivery of insulin. So you're saying, ma'am, at least carb counting to karna hi chahiye na, but some kids are still not ready to do that. So we want to make carb counting also easier so that the human effort can be minimized, and we are going towards more automation, more closing the loop of the artificial pump. We want pumps to work better with the CGMS, and definitely we want to prolong the duration of pump use. And that is why continuously new research keeps on happening in terms of technology. So These are not available in India, but definitely they've started their use in the United States. Like a tubed pump, so a very small, teeny tiny pump is there, or like this twist AID system where some parts can be reused. So again, that will decrease the cost of the pump. Tubeless pumps, again, they will be just very easy to just wear on the skin like a CGMS, and easy to wear and change, and definitely might be preferred in children, especially girls. They don't want to wear their pumps to the school. So this would be a good option for them. This would definitely make a change because still we are not able to tackle the problem of hypoglycemia. So people are working on developing a pump which uses both insulin and glucagon. So less hypoglycemia and therefore better TIR can be achieved. Now these are the hopes and goals that these pumps do enter the Indian market sooner. In terms of monitoring devices, definitely people are working on introducing more metabolites. One thing I really liked about this, though not approved in kids less than 18 years, is the implantable CGMS. So while I was just researching for this topic, I came across a lot of videos of people using the CGMS. It's a very easy technique to just insert the CGMS below the skin. Now it is able to last for more than 1 year, and then there's just an attachable Bluetooth device that hangs on it. So I think if we have something for the younger kids also, maybe a little bit non-invasive, it's definitely going to decrease the cost also of the CGMS, which we have to change every 7 to 14 days. So this is the Eversense 365, which is available in the US and Europe. It's an implantable CGMS. It can last for up to more than a year, but not approved for children less than 18 years. Libre. So Abbott is again coming up with a new CGM, which will be able to check the ketones and the sugars. It's approved in the European market, but still pending FDA approval. We don't know when it comes in India, but yeah. So these are some of the advances that people are working on to make life easier to live with type 1 diabetes. Screening. So again, there is a big confusion, a doubt, and a debate where screening should be offered to the siblings or the relatives of kids with type 1 diabetes or not. We definitely know that there is an increased risk of the sibling or the first degree relative of a type 1 diabetes kid to develop type 1 diabetes. And the more antibodies that are present in that child, the higher the risk of progression. So we have these antibodies that you can screen for. And right, if more than 2 antibodies are positive, there is a high likelihood of this child developing into type 1 diabetes. But then comes the question that we do not have a cure. So why offer screening? So again, definitely for a country like India, it may not be feasible, but now there are places where there are certain drugs which are available, which are now used for prevention or at least delaying the onset of clinical type 1 diabetes. So we know the various stages of type 1 diabetes, right? And we know that if we want to do any intervention in terms of preventing progression, it needs to be addressed on stage 1 or 2. And the latest to come into the market is teplizumab, right? So I think definitely not giving us a lot of hope. But when we didn't have anything, this would definitely be a small ray of hope. So it's an anti-CD3 monoclonal antibody, which binds on the receptors of T cells. Now we know that all the autoimmunity works through the T cells. So here we are kind of exhausting the action of T cells and therefore decreasing the autoimmunity. So more and more beta cells can be preserved. So the main role is it delays the onset of clinical type 1 diabetes. It is administered as a 12-day course, daily IV injections given 6 months apart. So maybe can be offered where a screening program is available, right? So as of now, what the latest recommendations and this is that if you have been diagnosed with a stage 2 type 1 diabetes where you have got more than 2 autoantibodies positive along with dysglycemia, then age 1 year onwards, and the lower part shows that that just came in June, that if you have just been diagnosed with type 1 diabetes, so stage 3 clinical disease, within 6 to 8 weeks of the diagnosis, teplizumab can be offered to delay the progression of clinical disease. It has shown definitely improvements in the C-peptide levels, in the time in range, in the insulin doses as well. But remember, it is not still available in India. Somebody might want to import it. It's around 1.62 crore for that 12 to 14-day regimen. Such 2 courses 6 months apart have to be given. It is not a cure. It is just going to prevent the progression of the disease. So I think in India, still the best policy would be we educate our parents and say maybe if you have a type 1 diabetes in the family, to look for the symptoms. Now, the 4 T's that is becoming very popular now, right? Thirst, toilet, tiredness, and thinness. So maybe we just educate our parents so that the earliest sign of these symptoms, we pick up the kid and it is diagnosed. So I think still in India, population based or high risk screening based may not be a viable option. And again, the question remains, what do we test for if we do not have a cure or an intervention which is available? The latest is advances in cure. Now, again, nothing much is happening here. But what I found fascinating was this. That is the next slide. This is the previous slide. So, we all ask, why is cure for type 1 diabetes so difficult? The first question is, we are not sure why this happens, in whom this happens, when does the whole process start, and can we prevent it or not? So if I know somebody is developing type 1 diabetes, can I cure it or not? So a lot of these options people have been using since the 1990s. They have been using pancreatic and islet cell transplantation for somebody who's going to undergo a kidney transplantation, or say for somebody who's got a very retractable hypoglycemia, but it comes with a major risk of immunosuppression. The other question is availability of the cells. So either it could be a factory made cell or it could be a cadaveric cell. Again, that would limit the amount and the availability of cells. But again, the question of immunosuppression comes. So you find out something which is available. Can this be used to all the masses of type 1 kids which are available? So whether it is scalable or not, that is the biggest question. And we know that all these clinical trials take decades to come, right? So probably that is why the cure of type 1 diabetes is becoming difficult. But something exciting I found was the trial done by the Eledon Pharmaceuticals, and they just published their data. So what they have done is they have used the cadaveric islet cells, but the immunosuppressant that they have used had minimal side effects. All the 12 patients, adults who had been living with type 1 diabetes for more than 25 years, are now insulin free for more than a year. Right? So I think it is a tegoprubart immunosuppressant, which is looking very exciting because it has got the minimal side effects. The people are just living their normal lives, traveling without the risk of extra infections. So as I said, it's an anti-CD4OL antibody, but again, the islet cells were gotten from the cadaver. So again, the supply becomes an issue. It was an investigator-driven trial, not FDA approved, but let's see what happens there. So I think 2026 has been exciting so far. Inhaled insulin now approved for kids more than 6 years. So maybe in certain scenarios, we should definitely offer the benefit of that. Um, Technological advances to try and close the loop. Teplizumab, a small step to prevent in stage 2 and stage 3, and better immunosuppressive drugs we need so that more patients can be offered islet cell transplant. Still 2026 is not over yet. So I invite you all to the ISPE midterm meeting. I've already got Dr. Chetan, Dr. Manoj, and Dr. Riddhi here. So on behalf of Gujarat team, I invite you all to the ISPE midterm meeting in Ahmedabad. It's going to be on 24 and 25th October. We have got three nice workshops, basics in diabetes, advances and obesity. So I invite you all there. Thank you very much.
It was an excellent talk, ma'am.
you.
I would like to.
I wouldn't know most of the answers because so many stuff is not available in India. But yeah, please go ahead.
Yes, ma'am. I would like to share my experience. I have used this inhaled insulin last month only. So she's a known case of type 1 diabetes. From past 10 years, she was under Rishi sir's follow-up. So she came to Rishi sir and then she was taking Tozio and taking bolus insulin 4 times. So last month only she came. So we shifted to 4 times Efriza. So now the issue was that with Efriza, it's very short acting. So she was having very high glycemic index, like the blood glucose was not getting controlled. We applied the CGM also. So then I shifted to 2 times subcutaneous insulin and 2 times the inhaled insulin. So with breakfast and with evening snack. So it was working good, inhaled insulin. But when the patient is taking a high meal, like a lunch or a dinner, so that time we can't give this inhaled insulin because
So
it's very short acting.
yeah, as you said, maybe like a small meal, a meal
Yes.
which is not a very fatty meal. So maybe the school cut dabba or the 5 p.m. evening snack, so that it lasts for a shorter duration and it is over before the next lunch or dinner dose comes into picture.
Yes.
Yeah, so I think that's a great observation.
And child was so happy because uske 2 prick kam ho gaye.
Correct.
And she was so happy, though she was very eager to take it. Even she was taking 2 doses because it was 16, the dose was 16 units. So it's difficult to give, ma'am. 12 and 4. So
And it's very expensive also
very
right
expensive.
now. So
But
if
she
somebody
was
wants to
happy.
do a conversion,
Uh.
but yeah, definitely.
So how much is the cost difference between the two?
So ma'am, 1 unit of Afreeza right now is 27 units, 27 rupees per unit. Per unit.
That's quite expensive.
So it's quite
per
expensive.
pregnancy.
Yes, sir.
I think inhaled insulin is good. Everybody should use it at least once to experience it. Maybe you can use it for lunchtime also to experience it. So that is very important. Second thing, I just wanted to highlight a basic thing. You mentioned about the pump. My experience is many T1D on MDI 4 pricks or 5 pricks are not controlled. So if you put them on pump and insulin augmented pump, their A1C goes down below 7, 6.5, and that too without hypoglycemia. So again, my point is at least you should once talk to the patient and the family. Don't get overwhelmed by the fact that no, they can't afford insulin. So this is one important thing. The person working with me, Dr. Saurabh, he says when adolescent comes to him rather, he says next time you come and write an essay on insulin pump. So they find out and write. So at least they're expert. And he says that when you grow up, when you do your job, you go ahead with the pump. So this is very important that type 1 teplizumab is one thing, type 1 on pump, almost non-diabetic. So this is one thought that should be impregnated into every children's family.
So, sir, what we have done now is any new kid comes, we ask the parents to open a bank account and start putting
Very good.
some money so that in the next 3-4 years, they're able to at least buy a pump for that.
Very good, very good.
One last addition from my side, like suppose if we are putting on the Afrezza, as it is short acting, so we have to decide what kind of the food is taking. In the high carbohydrate diet, it is work accidentally, but the glycemic index would be much higher. But the patient is taking when protein and fat, that time the effect would be only lasting for 3 hours, while the protein and fat effect would be lasting for 6 to 7 hours. That time late hypoglycemia would be there.
Thank you, ma'am, for that hopeful glimpse into the future of type 1. Advances in genetics are increasingly helping us identify children with monogenic diabetes. It is my pleasure to invite Dr. Chetan Dave to deliver our next presentation.
Now from type 1 diabetes to a very less common but unique diabetes that are MODY, maturity onset diabetes of young. MODYs are due to single gene defect, whether it might be in the gene which might be involved in the development of pancreas, development of beta cells, or insulin production or insulin release. But they are the single gene defect disorders. In worldwide, there are 40 million children with MODY and half are there in Asia. Mostly they are misdiagnosed as either familial type 1 diabetes or familial type 2 diabetes. Because of the increase in the incidence of obesity, almost all families obese and all have diabetes, and we diagnose them as type 2 diabetes because father is obese, father is on medicine, grandfather was obese, he was also on the medicine or insulin, and now the kid is 70 kg at 15 years, the kid has got diabetes, so we label them as type 2 diabetes. So majority of the MODYs are misdiagnosed as either familial type 1 or familial type 2. But they are unique because usually the defect is in the insulin secretion, not in the insulin action. Few have minimal defects on insulin action, which can be taken care of. And if we know the etiology, if we know the perfect genetic mutation, which are monogenic in nature, we can change the treatment and even change the life of the patient. So it starts from HNF1 beta gene, which is responsible for the pancreatic development as well as beta cell development. After that comes the role of HNF1 alpha as well as 4 alpha, which are specifically beta cells gene transcriptional factors. And after that, beta cells are generated, which is producing insulin. But these beta cells have a sensor called glucokinase. So with the help of glucokinase, beta cell senses the glucose level in the blood, and after having some threshold which has been crossed, then and then these beta cells release insulin, and in this release there is a role of ABCC8, KCNJ, as well as other few you can say channel which is opening and closing, and then we have insulin release. So if there is a defect in any of this step, it will be resulted in impaired insulin level in the blood, resulting in diabetes. So HNF1 beta has also role in the development of nephrons and kidneys. So if HNF1 beta is affected, we called famously as modify, in which there is a diabetes along with the renal abnormalities. And remember, this gene is responsible for beta cell development. So there will be almost zero level of insulin secretion, and therefore insulin is necessary in modify or HNF1 beta. After that, there are two genes which are almost similar, HNF1 alpha and 4 alpha, which is famously called as MODI1 and MODI3. They have beta cells transcription defect in which they are more sensitive to sulfonylurea because they are responsible for more of an insulin secretion. So if you can diagnose as MODI1 or 3, definitely you can switch over to sulfonylurea and patient will be free from the insulin level. After that, we have MODI2, which is a GCK defect. It is just a sensor defect. Insulin has been produced normally, but insulin has been released in the blood after having some high threshold. So in normal patients, insulin is released at 100. In this patient, insulin will be released at say 130, 140 milligram of fasting. So this will have stable hyperglycemia, particularly fasting hyperglycemia. And after that, insulin will be released and patient have normal postprandial blood glucose. So this is called as MODI2. After that, we have famously known as ABCC8 or KCNJ11 MODI, which are responsible for the channel opening and therefore releasing in the insulin, in which the defect might lead to insulin sensitive diabetes, in which insulin might be needed. But nowadays research is showing that sulfonylurea high dose might be effective in ABCC8 as well. And then we have INS gene defect. It is called INS MODI, in which there is an abnormal insulin production. So if we know all the pathway, if we are able to get the genetic diagnosis, then we can definitely target that specific defect and we will have insulin free person. So this is the common treatment. MODI to GCK defect, usually no treatment except pregnancy is needed. HNF1 and 4 alpha, they are very sensitive to very low dose of sulfonylurea. So we can quickly switch over to sulfonylurea. After that, HNF1 beta usually requires lifelong insulin. ABCC8, KCNJ, we can try sulfonylurea, which usually are effective but might need insulin in the later phase of the disease. And if we have insulin gene defect, then we can counsel the parents that this child will need insulin for life. So this is called a precision therapy, in which if you have practical and probable genetic diagnosis, it will guide the treatment. So if we will talk about HNF1 alpha and HNF4 alpha, very low dose of glimepiride will do the job. Patient will be stable, patient will be off glucose monitoring, patient will be off insulin shots, and the life will be changed forever. So if you have positive family history in 2 to 3 generations and the child is having though obesity, still you should go for genetic testing, because if this genetic defects are turned out, then definitely oral medication is the treatment of choice and no insulin is needed. In later on life, if sulfonylureas are non-effective or effects fade away, then recent trials suggest then you can go for SGLT2 inhibitor as well as GLP-1 analog as an add-on therapy to sulfonylurea. MODI2, as we discussed, usually no treatment needed, but during pregnancy, earlier is the dictum that GCK mother pregnancy, we should be testing the fetus for the same defect. But nowadays, we have got NIPT, which is a non-invasive testing for the fetal mutation as well. And this is a perfect example of precision therapy. So if the mother is having hyperglycemia, if mother is having confirmed GCK mutation, you need to do this NIPT. If the fetus is having mutation, then there is no need to treatment the maternal hypoglycemia. If the fetus is normal, then there are chances of macrosomia in fetus. So that's why if the fetus is normal, then you need to treat the maternal hyperglycemia. So this is the perfect example in which maternal as well as fetal diagnosis will lead the treatment, whether to start the treatment or whether you should not the treat the mother as well. ABCC and KCNJ, again, high dose sulfonylurea might be successful, but with this kind of mutation, there is usually history of neonatal diabetes is also considered. And after that, sulfonylurea failed, insulin is the only therapy. HNF1 beta, ideally insulin for lifelong, but there are nowadays studies in which SGLT2 inhibitors are also effective and they might be as an add-on therapy to decrease the insulin dose as well. Remember to monitor the renal function because HNF1 beta is also responsible for the development of kidney as well. These are all other modis in which usually insulin is required, but the most frequent modis are those who has been discussed earlier. So in a nutshell, genetic confirmation you should do if there is a familial history of diabetes, whether there is familial history of type 1, familial history of type 2, genetic diagnosis should be offered. Non-invasive fetal genotyping in GCK pregnancy is the most recent advance and it should be offered to all. Another is sulfonylurea is gold standard in all this kind of MODI and it is the perfect example of precision therapy and we should be quickly changing from insulin to sulfonylurea whenever we have confirmed genetic diagnosis. So with this, I would like to end my talk. Thank you very much.
Thank you, Dr. Chetan, for lucid talk on the MODI. In fact, if you diagnose the MODI precisely with the genetic testing, we can change the life of the patient.
Yes.
For the diabetic patient, getting relief from the insulin is a big thing. So we should take the proper history and then send the genetic testing proactively. That's one message.
I think one comment, Dr. Chetan, if you can answer it, whatever is the defects are at the level of two, either at the level of insulin secretion at whatever level or at the level of action. So two molecules, SGLT2 and GLP-1, probably we can use almost in all of them as an add-on therapy.
Yes.
So this
Even
is
SGLT2 inhibitor trials are there in type 1 diabetes as well. So mostly SGLT2 inhibitor will come up with all the MODIs as an add-on therapy in short future in guidelines. Yes.
Right.
No, I haven't used personally. If anybody has used for modify, no.
ABCC 8 I have used, not for modify I have not used. ABCC 8.
Thank you, sir, for highlighting the role of precision medicine in diabetes, especially monogenic forms. While our understanding on diabetes evolved, so do the therapeutics needed to treat it. I invite Dr. Ganesh Javlikar, sir, to speak on the insulins for the future.
Hello, everyone again. I'm going to dabble a bit in past and present and then move on to future. Partly inhaled insulin has been covered, so I won't dwell a lot on that. Why do we need better insulins, first of all? And what are the maybe some practice pointers about the currently available insulin formulations? Then we will run through inhaled insulin and then discuss briefly about once a week basal insulin and talk about possible strategies or what are the future developments that are expected. Uh, you all know that in 2021-22 was the 100th year of insulin discovery, and in these 100 years, insulin therapy has undergone significant changes. I mean, even in the last, and the pace of these changes has increased a lot in the past couple of decades. So, for example, when Anurag and we started practice, that time we had to use the NPH-based formulations, combine them in a syringe. A majority of our children were receiving regular insulin that time. I think we also had these bovine fast act and long act fast act, long act, those insulin, and now they are just a memory. At least the bovine insulin ones, porcine insulin. Um, and Rishi sir, of course, has seen much more. You've seen glass syringes and longer needles and everything. But now we have come a long way after that. Uh, as I was talking that although we have come a long way, why do we need better insulin is because we are still not matching the ideal physiology, which is basically variable amount of basal insulin secretion in response to the various physiological stimuli, and prandial secretion, which is in response to the meal-related glucose rises in the first and second phase of insulin release, and also exactly matching the meals. So endogenous insulin is immediately responsive to glucose. It is directly released in portal circulation. And there is a first and second phase to the insulin secretion. And insulin secretion switches off whenever there is a drop in the glucose level. So first response or first protection against hypoglycemia is switching off of insulin secretion. So this is what we aim to achieve. There is also a delicate balance between insulin and the counter-regulatory hormones, which is why the body maintains it perfectly. And as of now, despite of significant advances, we have not reached closer to God or nature or whatever we call it. These are the currently available insulin formulations. In the last few years, we have had the addition of ultra-rapid aspart and ultra-rapid lispro. This year has seen the arrival of inhaled insulin in India, although it was launched way back in 2015 in the United States. This diagram shows the pathophysiology. So as we grow more in the insulin formulations with respect to the basal insulins, we are becoming flatter and flatter. So NPH had a relatively higher peak. Compared to that, glargine and detemir had relatively peakless profile. Degludec has further, Degludec and glargine 300 has further flattened action profile and has given us a longer, more reliable 24-hour basal insulin coverage. And now we are in the third generation basal analogs, which we will discuss subsequently. And the mealtime insulin, although regular insulin is matching with the exact sequence of the human body's insulin, but it had a lesser amplitude in terms of the rise of the insulin value after the injection, and had a longer tailing effect, which kind of made us have compulsory snacking. Now we have come closer to the physiological insulin. So ultra rapid acting acts within the 5 to 10 minutes of the administration and peaks at about 1 hour after the insulin administration. Some practical considerations of the current insulin formulations. I've also already discussed about NPH and regular. Glargine typically causes a burning or stinging sensation. Often you will complain, often children will say that it hurts a lot because the pH in which it is reconstituted is acidic. So therefore glargine often causes this burning or stinging sensation. Degludec, whenever we start, it achieves a steady state concentration within 3-4 days of the initiation. So in the first 3-4 days, if you're not getting a good glucose values, don't get stressed. It will take some time for the concentration to develop. Although you may be bombarded with the information that rapid acting analogs can be taken after meals, it's always a good practice to take the rapid acting analogs before meals. When we started initially as students, we were told that Humalog, Lispro can be taken after meals. But over a period of time now, the data clearly shows that the best results are seen if Aspart and Lispro are taken 15 minutes before meals. Similarly, with the ultra rapid analogs also, at least in my practice, I encourage children to take even ultra rapid insulins before the meal. So a little bit about Fiasp and Lumje. Fiasp works, Fiasp is the faster acting aspart. Here nicotinamide was added to the aspart formulation, which accelerated the absorption, and arginine was added to stabilize the insulin molecule. Whereas in ultra rapid Lispro, that is Lumjev brand name, there is addition of treprostinil and citrate. Treprostinil is like a prostacyclin, which causes vasodilatation and faster absorption of the monomers, and citrate also adds to that. FIASP is now shown to be compatible with insulin pumps, and comparable glycemic outcomes are seen in AID, just like the conventional aspart. It's been shown to have better post-meal control when it is used in insulin pumps without a AID, which means open loop, or the previous formulations of the previous older pumps, basically. In the Lumjev, or ultra rapid Lispro has been shown, I mean, here the post-meal administration was also shown to be non-inferior to Lispro, but as I said, that at least in my practice, till I get more data, I would not be comfortable injecting any mealtime insulin after meals. Hypoglycemia incident was similar. It's as of now approved for adults with type 1 and type 2 diabetes. Coming to once a week basal insulin, it's on the horizon, already launched in some countries. It's about to be launched here. The need for once a week insulin is somewhat similar to other once a week formulations, basically issues with compliance. Nearly 40% of people with type 1 diabetes miss at least one basal insulin dose per month. And it has been shown that missing 2 basal insulin doses over a 14-day period would be associated with more than 5% decrease of time in range. So missing insulin doses is common, and it is not healthy because it leads to reduction of time in range. So Icodec, or brand name Avicli, has been launched. It's a once a week basal insulin. Basically, the modification consists of 3 amino acid substitutions and the addition of a 20 carbon icosane fatty diacid, which basically causes slow clearance of insulin and reduced receptor affinity. This leads to a half-life of almost 196 hours. The steady state concentration is reached after 3 to 4 weeks of treatment, and maximum concentration of insulin is achieved at 16 hours of the injection. The maximum concentration has been shown to be relatively higher if the injection has been given in arms or abdomen rather than thighs, but the clinical relevance of this is not known. When we start with multiplying the total daily basal insulin dose into 7, and 70% of this dose is given as a once a week dose, preferably same time and same day of the week. The first dose, loading dose, that is it is given as 1.5 times the initial calculated dose, and subsequently the other doses will be the 70% of the daily basal into 7. So there have been a series of these onwards studies in type 2 diabetes as well as type 1 diabetes, comparing once a week Icodec with Glargine and Degludec. It's been shown to be superior to Glargine in terms of glycemic control in type 2 diabetes in adults. In type 1 diabetes, this is the trial which compared Icodec with Degludec, again in adults. It's a 52-week randomized open label phase 3 study with adults with type 1. As you can see that the time in range achieved with Icodec and the Degludec and the glycated hemoglobin was comparable, was comparable. Clinically significant or severe hypoglycemia from baseline to week 26 was slightly higher in Icodec, significantly higher in Icodec than Degludec. In Glargine, this observation was not seen, but in Degludec, this was seen. So hypoglycemia rates were lesser with Degludec compared to Icodec. Now, anything that one company launches, there's always other competitive company, or there is, so you will see this with respect to insulin as well as growth hormone and several other formulations. So Efsitora Alpha is a once a week long acting basal insulin of Eli Lilly. It's a single chain insulin variant fused to a human domain of IgG2. So it's a fusion protein, which basically slows its absorption. Half-life is about 17 days and steady state achieved over a period of 2 to 3 weeks. There is a phase 3 study called as Quint study, where it was shown to be non-inferior to Degludec, once a day Degludec. Again, higher incidence of hypoglycemia was seen in type 1 diabetes compared to Degludec, especially in the first 12 weeks of use. I would not go into details of inhaled insulin. Shalmi has covered most of it. Historically, Exubera was launched in 2006, but it was large, cumbersome, patient uptake was very poor, and possibly there was lung cancer signal in smokers, and it was a commercial failure. It was withdrawn within 1 year of its launch. There are some other insulins such as ARX and Lingita, which were also discontinued as they failed to demonstrate any superiority in phase 3 studies. So the technology was changed to Technosphere insulin, and Afreeza was commercially launched in 2015. So it's available as these cartridges, which are 4, 8, and 12 unit cartridges, and taken with the help of a inhaled device, just like your asthma devices. There is this Inhale 3 study based on which the approval of Afreeza has been given to in pediatric age group. So in this study, it was compared with Aspart, and it was shown to be non-inferior to AID or MDI in maintaining glycemic control. This is how the cartridges are color coded, and they look like this. They are single use. They are to be disposed after use. And this is the dosing guideline for the conversion of your mealtime insulin into the inhaled insulin formulations. So if you have to take 16, you'll have to take 1 of 12 and 1 of 4 units. Remember that this is only a substitution for rapid acting insulin. It is not a substitution for basal insulin. So don't stop degludec or glargine if you're going to try this as mealtime insulin. As somebody suggested, trying it for a snack or something like that may be a good idea till you develop more trust and faith in it. These are the steps to take the cartridge. Lastly, talking about some future innovations. So, what would be interesting to see is glucose responsive insulin, which means that it has a faster onset of action, uh, adaptation of the biological activity based on the fluctuations in blood glucose. So, if it can switch off its action based if the glucose levels go down. So for this, insulin is conjugated to either PBA and polyoil to a single insulin molecule, and they work something like a gate sort of a thing, which allow the insulin to be released at a certain level and close the insulin gate when the glucose levels drop. So these glucose responsive units can be concanavalin A or glucose oxidase, but because of the cancer risk, concanavalin A is not used. Glucose oxidase is the one, glucose oxidase is the one that is used in these trials, or these are under development insulin. So the first of them, this NNC2215, is undergoing a phase 1 proof of concept study as of now. There are challenges with respect to biocompatibility, adequate insulin release, toxicity of carrier molecules, and particle stability. There was a lot of hype around this oral insulin that Biocon was going to market or produce, but it failed again to show any efficacy. So it has been, I think, discontinued. But there's another insulin called as this Oramed, which is currently undergoing phase 3 trials. So it uses this nano formulation technology where these nanoparticles kind of protect the insulin from the gastric acidity, and then subsequently the insulin would get absorbed. Other than insulin, there are, as Shalmi pointed out, fully implantable insulin delivery plus glucose sensing systems, AI-assisted dosing, microneedle patches, and all of you have heard of this Vertex trial of stem cell in type 1 diabetes. These are the things that we hope will reduce pain. As I said that couple of my Western colleagues did discuss about the fully automated insulin pump, and they were saying that soon, very soon, doctors will be of no use in type 1 diabetes management. To conclude, advances in insulin therapy have brought it closer to physiological insulin secretion. but there is potential for improvement in terms of faster onset of action and rapid delivery to circulation. Weekly basal insulin approval has been received for type 2 diabetes. In European Union and Canada, it's been approved for adults with type 1 diabetes. As of now, it's not approved for use in children. Inhaled insulin is now approved for more than 6 years of age as a replacement for prandial insulin. And smart insulin are being developed for dynamic insulin delivery. It would be really interesting to see this field about what happens in the near future. Thank you so much for your patient listening.
Thank you, sir, for the crisp and very precise talk on the insulin and beyond, and what are the advances in the field of type 1 diabetes in therapeutics. If there are any questions.
You're talking about we will be jobless, which is correct. Actually, I put one patient on insulin pump, and then automated pump was, I think 7-8 years back, was not totally launched. 680G, when hypoglycemia persisted, then cutoff occurred. Then he totally understood the algorithm. He's intelligent fellow. And then after 1.5 years, he stopped pump and he started using MDI. His calculation and algorithms are so good.
So good.
And I think he meets me somewhere in party, doctor, how are you? So this is going to be our stage. So please do put your patients on pump to make them insulin free.
Okay, so thank you, Dr. Ganesh, for taking us
Thank
into
you, sir.
future and giving a stream. So where are we as far as pancreatic transplant is concerned? Where do we stand?
Pancreas transplants have been happening for, maybe a couple of decades now, but largely they happen again as when somebody is undergoing a kidney transplant, for example. So SPK is the most commonly done transplant. I don't think anything has changed with respect to that field because the issues remain of unavailability of donors and the need for immunosuppression. So therefore, SPK is the most commonly done procedure. Second common is PAK, that is pancreas after kidney transplant.
Nothing in the future.
Yeah. As of now, I don't think that there's anything changing. But with respect to stem cells, yeah, I mean, there would be.
I think stem cells will go forward because even islet cell people have left out mostly. So it will either be stem cell whenever they are available. However, biologics always do better as compared to the devices. This has been shown that if you are able to get a real C-peptide, you will do better, even the better than the best of the pumps you have.
Thank you.
Thank you, sir, for taking us through the exciting advances of insulin. As childhood obesity continues to rise, so does its impact on metabolism. I invite Dr. Anurag Bajpayee, sir, to deliver the next talk on obesity, dysglycemia, type 2, and beyond.
So I think we had a wonderful session on glucose with so many interesting talks, particularly related to insulin-treated monogenic diabetes, newer insulins and options. Uh, Type 2 diabetes is becoming a bigger challenge now. And in many places, particularly across the world, we are seeing more adolescents with type 2 as compared to adolescents with type 1. And this is something not yet in India, but probably this is going to happen soon from that regards. So we had this 16-year-old boy, and I discussed about what approaches in the workshop as well, who presented with a massive weight of 127, not very unusual, BMI of 46.7, so massively obese, and all the complications, be it type 2 diabetes, MASLD, and was advised bariatric surgery. So what do we do? So we need to understand how the journey from obesity develops into dysglycemia, into type 2 diabetes, and how we can work at different phases to prevent that from that perspective. So if we look at the data, this is our study which looked into 282 children with obesity. And what we found was that more than 2 complications were present in around 50% of individuals. And dysglycemia was there in a significant proportion. So a lot of these children are having complications, and particularly more than 2 complications also in 50%. So the question that we wanted to know is, how do these children with obesity progress in terms of glucose abnormality? from obesity to prediabetes, prediabetes to type 2 diabetes, and finally beta cell failure, and what can be done at each stages to get a good outcome and avoidance of these complications from that regards. Whether they could be a reversal of type 2 diabetes, whether there could be a reversal of prediabetes, and what is required for this reversal to happen in that regards. The questions were, how do we screen these children? Questions are, what is the course and what are their predictors, and how do we go forward from each and every step? So first question, of course, is screening. Because in our study on type 2 diabetes, what we found that children who were diagnosed with screening were much more likely to remit than those who were diagnosed on symptomatic presentation. So screening, of course, is important. So we have a 12-year-old boy with BMI of 28, acanthosis, family history of diabetes. The question is, how do we screen them in that perspective? We all know about that the pediatric cutoff and the adult cutoffs are the same, and we are all following the ADA criteria of 100, 140, and 5.7 as the range for normal, and anything above 126 to 106.5 as far as the abnormal ranges. But the question is, do we really think that all these adult cutoffs can come down to children? Whether there are ethnic issues, in particular about HbA1c, this is something which we are seeing. If you see any report, nowadays we have got so many people who come to us with all the 20-page reports, children who have no problems, and you will find their HbA1c is 5.8, 5.9. Everything else is normal. There is no obesity also. So what is the significance of that? And if you follow these guidelines, what is the issue? So ISPAT clearly says that anybody after 10 years of age who is overweight needs to be screened for dysglycemia. And we do recommend fasting, 2R, and HbA1c as a primary strategy. What we need to understand that these three things are looking at different things. And what I'm realizing now that type 2 diabetes or dysglycemia is like an elephant. And we all have heard the story of the blind man and the elephant, and we are looking at different things. So some may be picking up fasting, some may be picking up high 2R value, some may have high HbA1c, and some may have high abnormalities on CGM. So if we look in that perspective, HbA1c is theoretically the least sensitive, but most specific. And 2R value is basically telling you what will happen if you go out and eat. So fasting is what is happening at when you are hungry for some time. HbA1c is the average, and when you go out and eat maybe a sumptuous meal, what happens to your sugar? That will be a 2R value. So there is always a confusion as to what will be really looking at in terms of the how do we define that. So in this perspective, we've got the results of fasting of 96, HbA1c of 5.3, and 2R value of 123. Now what do we do? So clearly we cannot just say, okay, you don't need to repeat it. The ISPAT guidelines do talk about that after every 3 years in a overweight obese individuals, you monitor them again for these scenarios. Another case, 9-year-old girl with obesity, again, no acanthosis, family history, HbA1c of 6.5. Very common presentation nowadays. And when we did a OGTT, the levels were normal. So the big question which comes in, how was this HbA1c done? So even if we discussed before that the validity of HbA1c, we should know the technique and the methodology by which the HbA1c was done. And this is clearly recommended that what HbA1c should be done should be NGSP standardized, and it should not ideally be the point of care test. Now, there are some new point of care tests which are really going back to the DCCT data, but you should have a clear-cut idea whether this HbA1c was done appropriately or not. So in this case, it was a point of care test. Repeat test was 5.4. So just don't rely on a single isolated HbA1c to make a diagnosis. 16-year-old girl with more obesity, BMI is now plus 2.6 STS with acanthosis, so more likely to have diabetes, family history of diabetes, and this is a big problem which is happening now. So fasting is normal, 2R is normal, and HbA1c is 5.9 on a standardized assay. So what does that mean? And we often talk about the discrepancy between fasting, 2R, and HbA1c, and how do we manage or interpret in that perspective. First point, it has been shown that for adolescents, if you repeat their test after some time, there will be a variability. So there was this RISE study which clearly shows that you cannot say that every time these tests will be the same. So maybe single test may not be good enough. And the biggest variability was for HbA1c. So isolated HbA1c elevation should not be equal to dysglycemia. I think this is the message which has been given from there. There is a lot of talk about Indian ethnicity and even Asian ethnicity where HbA1c levels tend to be higher than the Western counterparts. So again, in our setting, HbA1c may not be the same. So HbA1c of 5.7 will not be the same in an Indian as compared to a Western counterpart. Probably that's also something which is coming out from that perspective. So people have studied a lot in that regards about HbA1c in children. So I talked about ethnicity, but what about children? And it has been suggested that if you use this ROC curve, HbA1c cutoff of 6% will be more meaningful. So if you use 5.7 to 6, you will pick up many children, but they may not really have insulin resistance. So this is something which has been suggested in many of these studies. So cutoff of 6% was proposed. So we did this reasonably big study in around 250 children in which we evaluated the various parameters, adolescents, about fasting, 2R and HbA1c as to how they are really telling us in terms of diagnosis. So what we found in that perspective that HbA1c did have less agreement compared to the other parameters. So in 25% cases, there were discrepancy of HbA1c. So it means that HbA1c would have both missed and overdiagnosed also the scenario of OGTT. And when we drew these curves, what we found that the best thing will be to combine HbA1c with fasting. If you have an abnormal fasting or an abnormal HbA1c above 6%, again a cutoff of 6% is suggested, not 5.7%, then you do a proper OGTT and you will identify in most cases. So clearly, isolated HbA1c elevation was common, but it did not predict OGTT hyperglycemia. But the interesting phenomena which we thought, and I'm thinking now again, is that as I said, maybe it is like an elephant and we are all blind. Fasting is looking at one thing, PP at other thing, and HbA1c at other. So whether these children who had isolated HbA1c elevation, were they normal for other metabolic parameters or not? So what we found, normoglycemia 138, OGTT abnormal 33, and isolated HbA1c 34. So individuals who had isolated HbA1c elevation were closer to OGTT abnormal than those who are normoglycemic. What we are trying to say is that the prevalence of MASLD, the ALT level, the lipid profile was higher for these individuals. So it may mean that this may be the stage of disease. It's not that they are absolutely normal and we can say nothing is there. They already have a disease, but they have a different manifestation of this insulin resistance. So I think this is important. You look at ALT levels, they were highest in those who had isolated HbA1c elevation, which means these children also have something which we need to follow up in that perspective. And this was very, very well similarly found in our study, which was published recently in pediatric obesity, where we looked at another parameter. We did CGM. As a pilot study, we did a CGM fasting to our HbA1c in obese adolescents. And what we found was that there was no correlation, there was no prediction of CGM with fasting to our HbA1c, but CGM was a better predictor of MASLD, better predictor of dyslipidemia compared to your fasting 2R or HbA1c. So maybe it is picking up signals which are not being picked up by other parameters. So what we need to understand is that our definition of quote unquote dysglycemia is based upon metrics which may not be telling us everything, but that's how we have been working and managing from that perspective. You need to watch the space. So now 16-year-old girl with obesity, again, what we are seeing here is that fasting HbA1c again was isolated elevation. Repeat HbA1c was normal, so follow up. Now again another individuals. Now what we are seeing here is that we have elevated fasting, elevated 2R value and HbA1c of 5.9. So all three parameters are fitting into that bracket of prediabetes. So the question here is, what do we do in that perspective? So till now, there is no therapy which is approved. In a way, at least no metformin is approved. We can think if they are obese, we can think of other therapies, of course, but there is no anti-diabetic therapy. Maybe GLP-1 from an obesity perspective we may consider. So this is what we looked at. How do we improve the outcome of these individuals? And we found that around two-thirds of them, 63, remitted. And who remitted? Simple answer is loss of BMI SDS. If a child loses 5% BMI SDS, they will remit. So whichever way you reduce weight, you will be better off. This is what we found. And pre-diabetes is much easier to go off. I talked in the morning that for diabetes in children, you need 10% BMI loss. For MASLD, you need 15% loss. So 5% for pre-diabetes. So if you want to do something, do it at that point of time. Now, 15-year-old boy with obesity, pre-diabetes, what should be done? So metformin is not very clearly indicated, but was given metformin and the child improved. So whichever way you lose 5% weight, it will be fine. Now we go to the next step, late diagnosis. 16-year-old boy with polyuria, blood sugar of 440, HbA1c of 10%, and ketotic. Now this child was managed with DK and insulin, and then the requirement came down. Then he was referred to some other person who found that this child is obese. There is acanthosis. There is family history of diabetes. And he said, this is type 2 diabetes. Why are you giving them insulin? So what they did, they said it is type 2, stop the insulin. Now what really happened is that this child then developed DKA. The reason for that is now obesity is increasing, and unless and until we have done an antibody assessment, we should not diagnose somebody as type 2. So ISPAT guidelines clearly talks negative islet antibodies. Obese individuals who are antibody positive behave differently compared to those who are antibody negative. So I think that's a big message, and we should not have discontinued. So again, this is an important message to do. GAD antibody in all obese adolescents in that regards. Now, type 2 diabetes is increasing, and this is a figure I got from India, which talks about a very, very low prevalence. But then we realized it was only from 2 centers in Delhi and China. This was a youth diabetes registry. So these numbers were very low, but we are seeing many more type 2 now in that regards. So 14-year-old girl with obesity, blood sugar 140, 220, and HbA1c of 8.2. So this child, and GAD negative, of course, so we have excluded type 2. Now, what options do we have in terms of management? So this is very important to understand the plan. So what we need to understand is that children with type 2 diabetes, adolescents with type 2 diabetes have a much more aggressive course as compared to adults. Adults lose around 7% of their beta cell mass per year. Children, adolescents lose more than 10% per year. So the Today trial, which was a remarkable trial which looked into this data, found that within a few years, metformin stopped working. And they used rosiglitazone at that point of time. That also stopped working in adolescents. So what was established by this Today trial was that type 2 diabetes in children and adolescents will progress rapidly. We have to do something if you want to really intervene. Our own data, and Dhwani is not here, but she was there in the morning, about follow-up of type 2 diabetes in children clearly again shows a much more rapid course, requirement of double agents very quickly, and insulin requirement. One thing which we also identified even at that point of time was that if you wanted to take off insulin in somebody with type 2, you should use GLP-1 receptor analogs. And what we used that time were not the newer ones. We used liraglutide, dulaglutide. So GLP-1 is a very, very effective therapy is what we found even that time. This is now many years ago in that perspective. Now, what options we have in terms of therapy? So we talk about what different systems are affected and what therapies are there. So options, of course, insulin. Insulin you can use, but if you use insulin in type 2, of course, in acute phase you will cause more weight gain, and often the insulin requirements may be high. So insulin is not your default mode of choice. You're treating resistance and you're treating deficiency. Second option, of course, metformin. Everybody should receive metformin unless there is a contraindication. You can get a benefit of around 1% in HbA1c using metformin. And this is something which is clearly indicated. Now, GLP-1 receptor analogs are agents which are clearly becoming agents of choice. And I talked about obese adolescents, they may be doing better as compared to the older age group. And I'll talk about that, the recent data also in that regards. So liraglutide was initially approved, then dulaglutide. Now even tirzepatide has been approved in US and Europe after 10 years of age. So a lot of changes are happening in type 2. Because I remember a decade ago, there was a lot of hue and cry that we don't have any treatment for type 2 in adolescents. So that's why they're doing more aggressive approaches in terms of management. SGLT2 inhibitor is basically going to cause leaking of glucose in the urine and it will reduce the glucose load, a good drug, and it has already been approved. Dapagliflozin and empagliflozin both have been approved in children 4 years ago, but not very effective. I would say 0.7, 0.8% of HbA1c is what you can expect in that scenario. Other agents like DPP4 inhibitors are not effective in the pediatric age group. Glucosidase inhibitors are again not going to be very effective, and TZDs have always going to cause more obesity, so we are going to avoid that. So clearly metformin along with SGLT2 inhibitor. Then if you go for injectable, you can go for a GLP-1 analog or you can go for insulin, especially in the acute phase. So metformin clearly is of course doing a MAP kinase action and it is going to improve. You start with 500 and can go up to 2000. There will be GI side effects and multivitamins, especially B12, have to be given. Avoid if the EGFR is below 60 or ALT is more than 80. This is a catch. Many type 2 diabetic will also have MASLD, so we often use it if the baseline ALT is very high, with careful caution on that. Contraindicated in mitochondrial disorders and clearly those who have acidosis. In sick day, so if you have a child who is type 2, has developed vomiting or fever, stop metformin. And of course, if they are going for surgery, you should stop metformin. Now, this is what I was talking about today, trial which clearly shows that metformin will respond earlier, but ultimately you will need a second therapy pretty quickly. So this is one agent which has been clearly shown. SGLT2 inhibitors, as I said, they are mild drugs as far as pediatric adolescents. So maybe if somebody has a HbA1c of 8%, you want to start metformin. Along with that, you can start a dapagliflozin or a empagliflozin. It has been approved in the setting of pediatric type 2 diabetes and it has been used, but I'm not very happy with the response in most cases in that regards. And this was both for EMPA as well as dapagliflozin. And that brings us to the incretin pathway, which basically, as we discussed in the afternoon, when there is a carbohydrate intake, you have a production of GLP, which reduces gastric emptying, which causes satiety and increases insulin and decreasing glucagon. So this clearly has got option at multiple levels, and that's why it is very efficacious from that perspective and that regard. So this is something which is there. So DPP4 inhibitor is not being used in children, not very effective. GLP-1 receptor analog is clearly the agent which has been found to be quite effective and it has multiple sites of action focusing on most cases. Liraglutide was being used initially as a daily option and now we have got many more options from that perspective, including dulaglutide, which was once weekly, semaglutide and tirzepatide also, as I said. Two conditions we have to watch for: pancreatitis history, if it is there, and medullary carcinoma of thyroid in the family. We have to avoid these medications on that. So liraglutide did have benefit, but the BMI loss, as I said, even for obesity was 3 to 5%. So it's like a modest drug from that perspective, but it does help to reduce insulin from that perspective. Once weekly dulaglutide, again, found to be effective, but these were first generation GLP-1. Now, second generation one, semaglutide, this is not for type 2, this is the obesity study, which is showing 15% reduction as far as BMI SDS is concerned. So again, a good drug. And this is a drug which is now approved beyond 12 years of age in Indian adolescents for obesity. So this is a good option now which is available for us to use. This is the latest result of tirzepatide Tharpa Speeds trial. And what it shows is excellent. It is showing us reductions of HbA1c of around -2 to -2.5 percentage points. So most therapies, metformin 1 to 1.5, DPP maybe 0.8, SGLT maybe 0.8. This is 2.5 HbA1. So it's a very good drug. So somebody had a HbA1c of 9 and you add this with metformin, you will bring it down to 6.5 and you may even remit. And they also found substantial weight loss. So based upon this, in Europe and USA, it is approved beyond 10 years of age for use in type 2 diabetes. And of course, the side effects are GI side effects. You have to be cautious in eating, but this is a good drug to go forward. So this is the ISPAT guidelines, which categorizes based upon HbA1c of 8.5% into insulin. But I think 8.5 will be too aggressive. Most patients who come to us will come to us at around 9, 9.2. They are absolutely normal. They are non-ketotic and they never agree for insulin also, even the basal insulin. So what we have been doing over the last year or so is that we are checking them very carefully and starting them on maybe metformin along with SGLT2 inhibitors, checking the ketones and calling them in a few days their sugars come down. So clearly, if there is ketoacidosis, in that scenario, you should give insulin, avoid metformin, but otherwise maybe insulin may not be needed in many of these cases. Of course, beyond 10, 10.5, we still consider that the agent. So our simplified approach basically is that we should hit early and hit hard. Don't avoid, don't delay. If you have marginal elevation, consider treatment, consider lifestyle aggressively. If there is decay or honk, you give insulin, then add metformin. Otherwise, I would say this HbA1c could be somewhere around 9.5. There is no figure to tell, but we tend to now be more liberal in terms of avoiding insulin, especially if they can come in 3 days' time. And you add metformin, and then GLP-1 analog is going to be something which agent which can be added at this point of time. So coming back to this case, fasting 188, 2-hour value 340, HbA1c of 10.1, and there is mild ketosis. So better would be here we should start off with a basal insulin, add metformin, and then see how the child will respond. Now at 12 months, adherence is poor, weight gain is there, HbA1c is persistently high, ALT is high. So we can consider in that regards GLP-1 receptor analog as a agent. Or maybe I'll say that now we should consider GLP-1 receptor analog right at diagnosis. Adolescents do better with them and they have a chance of remission. So I think this is the pre-good strategy. I'll go from that. So I'll thank all of you for patient hearing.
Excellent talk, sir. Any questions from the audience? Yes, sir. Yes, sir. Sure. Yes, sir.
Actually, this is off-level clinical experience. When a borderline adolescent coming to you, 16 to 20 years of age, and they're not ready for GLP injectable. So you can use oral semaglutide also. So this also works very nicely.
Yeah. वाला कहाँ है?
तो पहले वाला GLP वाला कहाँ है? Obesity, obesity.
Obesity. ये वाला. और इसके बाद इसको. So Dr. Rishi is the leading leading endocrinologist of the whole North region. And for the last, I think, 30 years and more, 32 years to be more precise, since 1994, when I think I joined medical school, 1993. So somewhere around the same time, he has been working as an endocrinologist in this region. His work in type 1 is immense and he has done wonderful job. And I think anybody who has attended the meeting, last tie-up meeting, would really realize how much work and how much goodwill he had in terms of all the patients and everybody around. And type 2 work, of course, will be like 100 times more than that. So I think it's a pleasure to have Dr. Rishi here, and being part of the same team is also very honorable. So Dr. Rishi, please.
Good evening, friends. Thank you, Dr. Anurag. I think all of you, please stand up. Please, please. And now clap. For whom? For whom this is clapping? Can anybody say? For us, because I was looking at the schedule 10:30 till 9:30, 12 hours. So please sit down. Thank you very much. I think that it is very challenging to do like that. So credit goes to him, but I would suggest I'm very lethargic and he gives me a lot of respect for my age. But next time I would suggest if I'm there, make me architect of your scientific program, not the scientific advisor. So I can do something very useful that will give more energy to the people and they'll have more laughter, more happiness, maybe more learning. So I have two talks, one short talk and one more talk, a small surprise to you. This is about obesity. Uh, the GLP we have been discussing and it is a useful molecule, but look at the central picture. Only 1 to 3% people are using uh, GLP-1 receptor agonist. So the lot of gap is there. And adolescent obesity, all are pediatric endocrinologists. I need not go, but this gives a very good food to all of us. I mean, use seed and we treat them. So this is, I think if we block them the way Dr. Anurag is doing, we screen them, and I think if you can reduce the obesity, you can take care of all those things. The sleep apnea, depressions, pre-diabetes, CVDs, all those things are there. Lifestyle again, I remember a story. I mean, one thing I always remember the stories. And 130 kg lady, BMI 50, came to me and I said, you are overweight. Yes, doctor. Husband was there. Yes, she is. Then I said, you can do lifestyle, this and that. Yes. Then I asked, you can take one of these molecules. And then said, no, doctor, I think I can do very nicely with lifestyle. So, and I looked at her without any smiling, any comment, in a very neutral. I said, you can try. And I think she will never come back to me. She'll jumping from one place to another place, then herbal course, and then online course, then online dietitians. And next time when she comes, she'll be 140 kg and 145. So this is the way, this is the real story of life. Everybody has so much overwhelmed by the lifestyle, but it works very differently. I remember about this tie-up meeting when I lost 5 kg because reasonable amount of stress was there, and again I regained 3-4 kg. So there is a gap. Lifestyle is very important. It works well, but you need to be very strongly motivated. And the next jump is bariatric surgery. I don't know. I think we have a group of pediatric endocrinologists. How common is bariatric surgery in pediatric age group? Is it very common or not? Not being done. Not Dr. Ganesh. How, not very frequently being done. So what to do? And this gap can be very nicely bridged with the GLP agonist. So look at the GLP agonist, 15 to 70% with semaglutide. Then we have tirzepatide, 22%, and triple combination, retatrutide, around 30%. So this is a huge thing. We have three molecules, rather four: semaglutide, tirzepatide, liraglutide. Liraglutide we have been using; it worked well. But semaglutide is, I will call, a wonder drug, and it works well, and we have seen wonders. I think it is established benchmark. The step program, step 1, 2, 3, 4, 5, 6, where it was tried in adult population, like with placebo, with glargine, with degludec, with many other molecules. So like this, then maintain. Look at the right side, 15% mean weight loss and 20% major adverse cardiovascular events, severe risk, chronic kidney disease, and MSALD. So this is a very, very rewarding drug. I'll share the effects and side effects both when I move. Step teens is now it has entered into adolescent population as well, and it has been recently approved by DCGI. And up to 2.4 milligram is indicated in adolescent ages 12 to 18 years. This is the trial, and as all of us know, this was a 68 weeks trial. Around 201 total number of adolescents were there, and what they did, there was a gradual increase. Start from 0.25 on monthly interval. I think you go to the maximum dose, and look at here up to 1.7, and then if patient could have tolerated 2.4 or not, and the population spread was all were non-diabetic obese. Average weight was 107 kg, and majority and different all tenor stages were there, but dominant was stage 5. Look at the abdominal girth on right side of slide, 110 kg. Very impressive weight loss at 68 weeks, 17%. We were talking of 5%, but it is 17, 3 times more. Look at this picture. I think everybody needs to look this carefully. The 5% weight loss in 3/4%, that is 75%. But what happened to 25% patients? That gives us the clue that every patient is the not responder. Maybe 25% patient will not respond. So we should advise, we should suggest, we should tell, but we should not be overwhelmed. However, it works well. The 20% weight loss in 1/3 of patients. I think, where is Dr. Nimisha? Dr. Viva, come here. How much weight loss did we see in our patients? Tirzepatide. जोर से बोलो. अरे इसमें बोलो, जय माता दी नहीं बोलना, जोर से बोलो. We have seen up to 53 kg with tirzepatide. So this is a remarkable weight loss we have seen. It is now indicated that BMI more than 27 and at least one weight related comorbidity, and more than 30, no need for any comorbidity. Tirzepatide, I was sharing, it is again a next wonder drug. It works more. Dr. Anurag was saying uh, it has been approved in US but not approved yet in India. So that is another. But semaglutide has advantage in terms of pleiotropic benefits. The cardiovascular benefits, the renal protections are lesser seen with tirzepatide compared to semaglutide. And it is OSA approved also. And there are trials when obesity and diabetes coexist. Both molecules work, tirzepatide and the semaglutide. It is safe and tolerability, and what to counsel. The GI side effects are very common. Nausea, vomiting, diarrhea, constant. One side effect that they always mention that I have seen in real life is pain in abdomen, and all types of pain are seen, mild, moderate to severe. So very severe pains are there. And what is important is, if you look at the left bottom slide, 25 to 40% of lean body mass. But the basic dictum is, whenever you lose weight, whenever we lose weight, whenever our patients lose weight, the lean body mass will be lost, whatever may be the mode. Don't blame the molecule. If we lose by simple lifestyle, the lean body mass will be there. So whenever weight loss diet or anything is there, I think always encourage for two things. One is high protein diet, and second is physical activity. And a sub part of physical activity is resistant physical activity. Small dumbbell, push-ups, all those things are required. And take a history of medullary thyroid carcinoma, and I think I don't give it in patients with history of pancreatitis. And the titration methodology probably has to be individualized. You start with 0.245, patients is symptomatic. Don't increase after a month. Maybe you increase after 1.5 months. Or sometimes we give 0.25 and zero point 0.5 on alternate. So it depends, you have to titrate individually. So we have the surpass speed style on type 2 diabetes. And what it has shown up to 2.2 HbA1c reduction with superior BMI improvement. And we have surmount surmount adolescent, again obesities with comorbidities, and surmount adolescent 2. All these trials have, but the results of these two trials are pending. The oral GLP-1, as the topic was given to me, orogliflozin is up to 11.2%, and this is by Lilly. Molecule is in process to develop, and no fasting anytime you can give it. So it is a useful pill. And oral semaglutide 25 and oral semaglutide up to 14 are available in our market. However, they are not approved for pediatric population. Retatrutide, one more molecule you add GIP, GLP, and glucagon agonist. And what glucagon receptor does, it increase energy expenditure, drives lipolysis and hepatic fat oxidation. And by virtue of these two things, it has additional benefit loss. So retatrutide, the mechanism of action is, I think I have shared with you. GIP, what is important is what these molecules do. They worked at the level of hypothalamus to reduce appetite. They worked at the level of GI to reduce the intestinal motility. They worked at the level of pancreas to increase the insulin secretion. And GIP also acted at the level of fat cells for to enhance lipolysis. There are a number of other mechanisms that I'm not going to detail. And finally, my thoughts about this molecule. This is a useful molecule. I've been using quite a lot. Brings unbelievable weight loss, I shared with you, but not without side effects. And you have to individualize side effects. Some people have intractable vomiting. They just cannot tolerate it. So, and again, I shared the data of teens trial. 25% were not the responders. So you don't know who would respond and who would not. So that is very important. And again, you should respect patients' enthusiasm. One of my patients, I put her on liraglutide long back. She had very severe gastritis, needed admission. After 15 days, she calls me, doctor, when will you restart? So they're both spectrum, but one should be really careful. One has to individualize. Some people gradually tolerate, and some don't. So that is very important. And all types of GI side effects are seen. So that is again very, very, very important. Not all those four. Everything can happen as far as GI is concerned, from upper, middle to lower GI tract. So thank you very much. I'll not be going to detail. I think can we go for the next talk? Oh, इसमें कुछ questions, anything, comments? Anybody? Quick. I think we have been, yes, please.
Thank you, sir. Sir, we have found some patients in adolescent group or even in adults, those who have a very high BMI, like more than 34, or morbidly obese, who have already developed some metabolic complications, including prediabetes, diabetes, and also dyslipidemia. And one of our patients who developed hypertriglyceridemia, and at one point he developed pancreatitis. The cause was that hypertriglyceridemia. After resolution of the pancreatitis, in such cases, can we use GLP-1 receptor analog?
That is very controversial, actually. Very controversial. Principally, I don't use DPP-4 and SGL2 in pancreatitis, but I used in 2 or 3 patients. One patient was drinking every day, and everything was uncontrollable, 150 units of insulin. Me and my gastroenterologist colleague, we decided, देते हैं जो होगा देखा जाएगा. And it is almost 7-8 months, his blood sugars have gone down. And important thing is GLP reduces alcohol intake also. का सर मन ही नहीं करता, आपने तो साधु बना दिया हमको. So that is the way, I think, inform them. And he was saying you can't give it. Then we have decided we have to give it. But you have to take patients into confidence. So
Thank you,
that is that. One, again, a small case history. I was saying, I was talking to Sanjeev Gulati, nephrologist in Delhi. And he noticed adult doctor, 25-30 years, obese, presented with acute kidney injury, 6 or 7 needed dialysis, and then biopsy was done. It turned out to be glomerulonephritis and fat-laden cells were there. I don't remember. And they put her on GLP, lifestyle, and everything reverted back to normal. And so this is a systemic disease, obesity, and treatment has to be on lifelong basis. So that is important. But again, you can give it, but take patients and family into the confidence.
One more question, sir. As an anti-obesity medication, we have to use tirzepatide in a very high dose. So after achieving that targeted weight loss, can we reduce the dose and continue the medicine for
I
a
think I
long
learned
time?
from Dr. Anurag what he uses reverse mechanism. Somebody was saying
There are no guidelines like if you have achieved your target weight loss, so what we have to do, that is not till now approved. There are two approaches. You can go either way. Either you can keep the patient on the maximum tolerated dose, or you can reduce the dose. Like patient has achieved a sufficient amount of weight and you cannot go beyond that. So in that way you can reduce the dose. But one thing is for sure, you will not stop the injection.
I think
That has been proved.
yes.
Thank you.
Bas.
I think Bob, the compliance rate in real life goes down. If you start with 100 and after, yes, Dr. Hemchand, please. I have not, I have no experience that Dr. Anurag can tell better about.
So in Prader-Willi, there have been trials on that and they have not found to be effective. So I think the major effect in Prader-Willi is more hunger rather than satiety. So there things which are working are ghrelin agonists and oxytocin ones, but not GLP-1. So we have also used in 1 or 2 patients, we did not find benefits. Then we discussed with somebody, he told that they also didn't find, and then the results have come up for studies which have got minimal effects in Prader-Willi.
Thank you. Yes. Mike.
Thank you, sir. Sir, when we encounter GI side effects, should we skip the dose for 1 week or reduce the dose for the next week?
I think most important thing is spending time with patients. This is what I've learned. Counsel them, tell them, because immediate reaction is stop it.
Okay.
Immediate reaction is stop it. So one thing is go gradual, and you titrate not as per the guidelines. You titrate as per the patient's requirement. Instead of 1 month, you can increase it after 2 months also.
Okay.
Maybe you stop it for a while, right?
Okay.
And plenty of fluids have seen yielding a better result. And you can use antiemetics also to support the patient.
Okay, sir.
And most important thing, as time passes, most of them tolerate.
Okay, sir. Thank you.
Yes.
Like in the tetrapeptide, it is a GLP plus GIP agonist. So if we are talking about the further future molecules, then they are developing the GIP antagonist. So one way they are talking about the agonist effect, and another way they are talking about the antagonist effect. So how actually it works from the physiology perspective. And second thing, suppose the patient has a cholelithiasis after a weight loss, then does the ursodeoxycholic acid will be beneficial in this that kind of the basis?
Because we talk about cholelithiasis, if it is asymptomatic, you can continue it. And I don't know whether this would be beneficial or not, because the answer is not very clear as yet. So I don't know. About antagonism, I think I need to. Anything, Dr. Anurag, you can comment about antagonism?
So often when we talk about antagonism and agonism, there is also overlap in that perspective. So when you talk about inverse agonist, that is a real blocker. So antagonist, there is some variability which is there. So it's acting in some receptors, some sites, and not on others. So that is the variation which is being used in that.
Like when you use glucagon, the triple Glucagon usually we use in treatment of hypoglycemia. Here, by virtue of insulin secretion and glucagon also has some secretory function, we don't see any hyperglycemia. So maybe this is what he wanted to emphasize. Now, the final 10 minutes. Ah, this is something about Dr. Narag. We have been there for last 17 years. So I thought I'll not speak about my topic. I'll speak because now I started speaking more from heart. Science is always there and it is also evidence based. So what am I going to talk about? A lot of things about Dr. Anurag. 17 years back, he came to Kanpur and he shifted from Melbourne. At that point of time, probably not comfortable with practice. Dr. Kapoor, the owner of our hospital, came to my room. I was sitting on the first floor, I remember. And as Dr. Anurag's dad met him, that my son is coming, how should he be put? He asked me how you want to work independently or together. I, at that point of time, I was doing very nicely and I said, साथ साथ काम करेंगे? And then my colleagues' reaction came very interestingly. I am sharing colleagues, class 3, class 4 employees. Sir, आपने 17 साल का काम है. You will share with a guy and he will take away. Sorry, first time I am sharing in front of you because I think hardly anything is to be hidden from me. You know me quite a lot. Then I used one line with them. If you pass it on to the people, everything enhances. बांटने से बढ़ता है. And that thought, again, I'm sharing. I shared 5-7 years back with some of those guys, some of very, very close doctors, close attendant. They came to me, you should be independent. And then after 10 years or 12 years, they said, nice, you're right. But when he came here, I made his job tougher by requesting him to see a bit of my adult patients so that my workload could be shared. I had been little lethargic mentally. I work physically quite a lot, but mentally I have been He was a core pediatrician and pediatric endocrinologist. He was a bit hesitant, but accepted the request. These are some of the glimpses. And look at his quality, acceptability and flexibility. All of you want to grow, you need to have flexibility, not in terms of transferring, but flexibility has to be there. Initial few years, he did outstanding work in pediatric endocrinology, sorted out many clinical clues and picked many faults. He never ever uttered a word against anyone. These are some of the glimpses you can appreciate, Dr. Anurag. I think now you look more handsome. From adolescent, from pediatric to adolescent to adult. So I think best quality that I could notice is speaking through your work. Never try to show that he's great. So I was in England for I think 6 months in 2001, and there a lot of footballer cricketers used to be in malls and all. Then people just say we'll meet them in the ground, how nicely they perform. So he performs so well. Dancers platform is the stage, our platform is our patients, so we should speak through our work. So and this is one quality. That another quality, academic components, he became known within few months. He started speaking for local forums. He transformed the understanding in pediatric endocrinology. These are some of the glimpses. I think the right one is just recently we ended national type 1 meet. And he started sitting in Max Gurgaon, Prayagraj, Gwalior, along with weekly, twice a month at Fathers. Look at the amount of hard work he could do. And how he managed it was, I don't know. Then meetings, public meetings. But the moral of the story is one has to work hard. Howsoever good are you, need to come out from your comfort zone. So whatever you are, you have, if you have not come out of your comfort zone, probably you will not be successful. Doing 10 to 4 type of job or It's again everybody's choice. Research. He realized that best way to express yourself is to through your published work. He started work in Pete Enro on Indian perspective and generated data which was not readily available, and he came out with lot many things, all books, publications, paper. I need not share all those things, but this is Dr. Anurag's mom, Dr. Sudha. He created so many apps in research which are now being used frequently into clinical practice. I never thought that understanding endocrinology may be so crisp. So this is one thing, he made endocrinology easy. And I warned him also in my introductory lecture that what he should do. These are different apps and I'll not be going into details. If you see his publication, again very important thing, if you see his publications, all are named by his fellows and keeping his name as last. Otherwise it goes the other way around. Look at the giving character. Generosity should be reflected through deeds. Into roots, his dad passed away within very short time. I think within 1 or 2 years, Dr. Anurag. And he did lot of pain for him. I met his dad number of times. That is another story. I'll not be going into details. He continued doing regular OPDs, social activities, celebrating festival at his hometown in Fatehpur. His mom, Dr. Sudha Bajpayee, passed away 2 years back, and he very nicely cared her. I saw him caring his parents so nicely, and I wish all of us should be cared, and also wish that our children should care ourselves when we reach to that stage. So this was a beautiful experience. This is his family, Grow India. I'll not be going into details, but people usually forget their roots when they are busy, famous, and successful. Which village, which India, from where are you? He continued to stick to roots. So this is beautiful. Mentorship. His students never have lots of respect and adorance for him, and he stands like a shield with his fellow. I think one of his fellows used this line for him. This is his mentorship. I'll not be going out of pictures were shown in the morning. And finally, why am I talking about him? If you love somebody from heart, if you truly love somebody from your heart, you should say it in your lifetime. I feel this is probably last active phase of my life, so I should say him that I love him. Wishing a healthy, purposeful, researchful, and I'm full with love, minimalist. I never say long life because life should be useful and meaningful. So healthy, purposeful, researchful, full with love, and minimum stress life ahead. Thank you so much for listening to me. This was the picture that very recent. I think Dr. Anurag is with his mentor. Simon Hill is Sheffield where uh, Dr. Vibha worked. He's a big man in field of hypoglycemia. Dr. Menon is there. So this was the meeting and he helped me right and left. So this is with these words. Thank you so much, Dr. Anurag. And now all of you, I request you to stand and give him a standing ovation. And I'll request all my fellows to come here, whosoever are there. Manoj, Vibha, Priya, Nimisha. And thank you, Dr. Nimisha, for giving me the feedback. Thank you, Dr. Vibha, for giving me. And thank you, Mrs. Meena. Meena is a qualified pump educator. So can we have photographs? Thank you, Dr. Anurag, for being into our life. And we are blessed to have you.
I request Dr. Saksham sir to receive his memento. I request Dr. Rahul to come forward.
Sorry for the delay. Uh, We'll continue with our session and we'll invite Dr. Hemchand for the presentation of bone age. Dr. Hemchand, I think this is your 12th time, 10th time. So Dr. Hemchand has been coming from a long, long time. And it's really a pleasure to listen to him. He needs no introduction for the audience here. Which one is this? Yeah, this one. Oh. Bone age. So Dr. Hemchand is from Mehta Children's Hospital and he has done a stupendous job for the last 15 years in pediatric endocrinology in the entire country, particularly in South India, and he has been very active in spreading the message. So it's a pleasure to have Dr. Hemchand here, and he'll be talking about a very important topic of bone age assessment, practical and very, very relevant for all the pediatric endocrinologists.
Uh, Good evening, everybody. I think it's so nice to continue after that inspiring presentation and inspiring talk. Uh, Thank you, sir, for being the leader for all of us and being an inspiration for many youngsters. So over the next 30 minutes, I think myself and Dr. Viba, thank you, Dr. Viba, we've planned the session on bone age this way. So we thought we'll have it as all of you are familiar with bone age. So we will have it like a practical session. You can do it along with us to keep it going. And then it might not be possible to complete the whole thing in 30 minutes. So you can continue it at home as well. So bone age, sugar titration, anthropometric assessment are three things which, if you are confident about, you can be successful pediatric endocrinologist. And I think bone age is the most important tool, and you should know it. It is almost that every alternate child requires a bone age, growth disorders, developmental disorders, pubertal disorders. It has multiple benefits, multiple diagnostic clues, therapeutic decisions are centered around bone age. And I don't think this audience needs to be told. We are all aware of conventionally three methods of bone age assessment, Tanner Whitehouse, Grulich and Pyle Atlas, Gilson's and Ratib Atlas. Of late, there has been a lot of developments with Indian researchers coming up with newer tools to look at bone age assessment. So Tanner Whitehouse, based on European children, affluent children, it gives a detailed analysis of the epiphyses and their scoring. And Grulich and Pyle, thank you. Grulich and Pyle is based on the American children, well-to-do affluent children, and every maturity, every bone is assigned a specific maturity indicators. Gilson's and Ratib, a relatively recent one done on a population of around 500 to 600 children attending the Los Angeles Children's Hospital outpatient department. Recently, Indian researchers have come up with the 3-bone method and 5-bone method, which I thought we should be familiar with, which is based on the x-rays of Indian children, and very innovative tools have been adopted. And this table speaks about the techniques that are involved. The different techniques have given different, some have given verbal, some have given line diagrams, some have given radiological pictures. And this is the age in which this radiological tool can be used in growing children. So Tanner Whitehouse method, the conventional, I think nobody can replace Tanner Whitehouse method. It old is gold. Nobody can question the validity. It's the most studied, and it's the best and most accurate. And there is enough Indian studies also to support the use of the Tanner Whitehouse method. It focuses on looking at the epiphyses of 13 bones, assigning them verbal scores, converting the verbal scores into numerical values, and converting the numerical values into a bone age. I think the handout that has been provided kind of gives you an orientation of how to do it. If you look at the third or the fourth page, it gives you the epiphyseal morphology of the different epiphyses. And if you look at the fifth page, it gives you the scores for the corresponding epiphyses. All you need to do is look at the epiphysis, look at the morphology, convert it into an alphabet, convert the alphabet into a number, add up the numbers, and once you add up the numbers, you get an RUS score. And if you look at the last page, the RUS score is converted into a bone age, that is table 3C. So if you see the first page, there is an X-ray, so you can try doing it. So this is a case, a 12-year-old child comes with concerns of growth. The weight is 30 kgs, 135. He's at the third percentile. He's concerned about his final stature. So what will his final height be? So let us just try to do the X-ray is there on the first page. So let's just try to do it. Yeah, the video is being played. You look at the X-ray, you look at the 13 bones, the radius, the ulna. Not sure if it's being played. Videos. So you can look at the X-ray, look at the radius, look at the ulna. The X-ray is there on the first page. The radius, the ulna, then the metacarpal 1. Yeah.
It's running it.
Yeah. So you look at the sex. First, look at the radius 1, and you'll see the different scores A, B, C, D, E, F, G, H, I, and see which matches the most. And you convert it into an alphabet. So methodically, if you're a beginner, start off with A, then go to B, then go to C, then go to D. And you convert the epiphysis into an alphabet. So this one, I think it matches the most with probably a G. I hope you're convinced about that. So I think you will have to look into the epiphysis, the verbal description, the technical description of the image, as well as the cartoon, and assign the skeletal maturity. Every bone, metacarpal 1, 3, 5, proximal phalanx 1, proximal phalanx 3, proximal phalanx 5, probably matches F. Third finger middle phalanx probably matches F. Fifth finger middle phalanx probably matches F. Thumb distal phalanx matches F. Third finger distal phalanx matches F. Fifth finger distal phalanx matches F. So all these alphabets are looked into, and subsequently what you need to do is convert these alphabets into numbers as it has been provided. Now technology does everything for us, but this is just to strengthen the fundamentals, and you get what is called as the RUS score. Once you get the RUS score, again look into table 3, see the corresponding bone age for the RUS score. The bone age would come at somewhere around 11.25 years. So this boy at a chronological age of 12 years has a skeletal maturity of 11.25 years. I think this RUS score, keep a watch on that. We will need it subsequently. So this is how you would do a bone age assessment based on the Tanner-Whitehouse method. So Grulich and Pyle Atlas, again, all of you must be having a copy of the Grulich and Pyle. This is the Grulich and Pyle Atlas. You can have a look, probably there are a lot of digital pirated versions are available. You have the different X-rays, and the verbal description of the points to focus on are mentioned on one side, and the image is mentioned on one side. You can use the atlas, and for this X-ray, I have taken the because the chronological age is mentioned as 12 years, conventionally about 2 to 3 years on the left side and 2 to 3 years on the right side image, you should probably start matching with. And yeah, so you can look at the second part, annexure 2. So the Grulich and Pyle Atlas, this is the child's X-ray. And you can see the X-rays at different ages. So because he's mentioned as 12, I'm starting with 9. 9, does it match? No. Try to look at 10. Does it match? Probably no. 11. I think if you look at the original atlas on the left side, it gives a very beautiful verbal description of specific points you should be focusing on, which gives you a kind of a focused guidance. 11 and a half years, probably it matches the most. If you read the verbal description, look at the X-ray of the child and look at the X-ray of the skeletal image, you would probably be matching it around 12 and a half years. No, the epiphyses are more advanced. Definitely 13 years also, it is more advanced. So this is how you would do the bone age assessment by the Grulich and Pyle Atlas. So Gilson's and Ratib Atlas, again, look at the X-ray, look at Annexure 3. You have the X-ray on the first page. And you have the images.
Not the video.
It's a video.
This,
Yeah. So you can see the X-ray on the first page and look at the images, digitalized images. Again, the pirated version of these atlases are also available. I have a copy with them. Anybody needs can use a. So these are the images at different. Does it match with 10 years? An idealized image and the image of the child? Probably a no. 11 years, I thought matches the best. Look at the different epiphyses, look at the X-ray, and choose whichever image matches the most. If you see the images of Grulich and Pyle and Gilsons and Ratib, you will see technology has made a big change. The idealized image really focuses you to facilitates and makes your work easier. And second thing is because it has been done more recently, the age distribution is more favorable for us. You have a yearly distribution. In Grulich and Pyle, you have very peculiar ages, 8 years, 10 months, then suddenly you have 10 years. So probably based on the norms of X-rays they had at that point of time. The third and the most recent one is the 3-bone method. I think this is again published in an endocrine journal, validated. And yeah, so you can see the fourth page. It looks at 3 specific bones. Look at the radius, look at the hamate, and look at the distal phalanx of the third bone. You look at the radial epiphysis and look at these images and choose which matches the most. So you have an array of images, see which it matches the most. It makes your work really easy. The bone age is the bone age is mentioned as per the sex. Second bone to look at is the hamate, based on the appearance or non-appearance of the hook. For different ages, it's mentioned there. And the third bone to look at is the distal phalanx of the third finger, based on the maturation of the epiphysis. For every epiphysis, it gives the for different sexes. All you need to do is look at the three epiphyses, look at the ages and take an average of that. So it's 11 years for radius, 13 years for hamate, and 11 years for distal phalanx D. The arithmetic mean is 11 and a half years. Bone age by this method is 11 and a half. It's almost the same as what Grulich and Pyle told. Or I'm not saying this is going to replace that, but I think this is an easier way. This has to be tested on a larger sample. And 5-bone method, I think Vibha will be covering. This is just a videographic of the same. Yeah. So there is a need to download the Mediclass app. She will be covering it in her part. Look at the X-ray. 5 bones: radius, ulna, and proximal middle phalanx 3. Yeah. So she's looking, all you need to do, this is really making your life smooth. If you have the app, all you need to do is put the sex, put the date of birth, look at the X-ray, look at the image match. It's like something which even kindergarten children do, you know, comparing and contrasting two pictures and choosing. All they need to do is choose, and the app gives you the bone age. So it's really making your life really easy. So now if you look at the bone age assessment by the different methods, it's almost 12 years, 11 and a quarter, 11 and a half, 11, 11 and a half, 11. It's almost the same. So I think there is a cafeteria of choices available for you. which is probably suitable in your setting, you'll have to choose. Just to complete a note on final height prediction. Final height prediction is not possible as of now on the newer bone age assessment tools, but there is work going on that, and it's being peer reviewed. Maybe after a couple of years, that facility also would be available for the 3-bone and 5-bone method. So this is a study to say that the Tanner White House is indeed old as gold. And there is no doubt that automated bone age is, but either financial viability and economic feasibility remains the biggest constraint. So how do you do predicted adult height? Again, this is the Bailey pinout tables, again provided in the Grulich and Pyle Atlas. I have provided a copy of that. All you need to do is look at the bone age, look at the height in inches on the y-axis, bone age on the x-axis, and the point of intersection gives you the predicted adult height. So I think it's as simple as that, just, but you have different tables for children with advanced bone age, normal bone age, and delayed bone age. You have to choose the right matrix and do a predicted adult height. Tanner White House method, there are tables that are provided in the Tanner White House. All you need to do is the RUS score, which you calculated while using the doing the bone age assessment. You have to fit it into it. The coefficient and constant are provided. So if you just solve this algebraic equation, you get that. You have the current height of this boy. This was a 12-year-old boy with a height of 135. 135. The RUS score on the Tanner White House was 376. It is multiplied by a negative value and a constant. So the concept is more advanced the bone age, more compromised will be the final height. So more higher is the RUS score, you're going to have a compromise in the final height. The lesser is the bone age, you're going to have a better, reflecting the growth potential. And this is the Gilson's and Rathi Atlas, same concept as Tanner White House. They have given very beautiful tables. All you need to do is look at the height coefficient, the bone age, and the constant, calculate it, and you will get that. For the same child, if you see the predicted adult height, based on Tanner White House is 163, the Bailey pinout tables is 164, and the Gilson's and Ratib is 164. Is there? You can probably in the room go and attempt to do it and kind of get a hang of what this is all about. Ultimately, there is nobody, no studies have been done on Indian children to say this is the best and the most accurate tool. What you are comfortable with, what you are feasible with, the more you use them, you will, you'll take a lot of therapeutic decisions treating precocious puberty, delayed puberty, growth hormone deficiency. I think these conditions, bone age assessment and final height prediction is extremely important. So to take over, I request Dr. Vibha.
Thank you so much, sir. As you have rightly said, that Tanner White House is the gold standard and nothing can replace it. And before going to the newer technologies, you all should know what are the basic ones. So moving forward to the newer technologies, and that has been developed in our own setting. So yeah, it's true. Bone age assessment has their own challenges. The manual methods, there is a inter-people variation, intra-people variation, and there are biases. It takes expertise to assess the bone age, and definitely it takes time also. And yes, bone expert is really the best one, but it is AI based tool and it is based on the Western data. And definitely it is the expensive one. So based on all these challenges, and as sir has said that GP, Glissans and Tanner White House, each and every one is good, but they take time, they need expertise, and there are biases. So keeping all these in our mind, and as we have we have made different tools in different fields, like for the growth failure, diabetic ketoacidosis, for the diabetes, that is the diabetes interpreter, obesity interpreter, puberty interpreter. So we have some expertise in the development of applications. So while using this, we use these expertise, and so we decided to move a step forward. And in this era of technology, and definitely mobile is the most handy tool, so we decided to develop a tool which will be available in the mobile application. And in the Tanner White House and all the, there are number of sites that we have to look for. So we decided to decrease the number of sites from 13 in the Tenet White House to 5 sites. So that would make the bone age assessment more quicker. And as sir has mentioned that we have developed this MediClasses bone age applications with the help of, with the hard work of Dr. Chetan, Dr. Riddhi, Dr. Sajali, and definitely under the guidance of Dr. Anurag. This is available in App Store. And as you can see, we have to match the proximal phalanx, this middle phalanx of the middle finger. I'll switch on that. Sorry. So definitely select male and female, give the date of birth, and you have to select the middle finger of the distal phalanx, middle phalanx of the middle finger, the thumb, the radius, and ulna. And this will give a bone age interpretation within 2 or 3 minutes. So as we have developed this application tool and we find it very helpful in our day-to-day OPD practice, and it makes our bone age assessment very easy and rapid. And for the validation, when we look at the result, there was a similar inter and intra-individual concordance as compared to the Tenet White House, which is the gold standard. And we have published this development of this novel application in the last few years. And after developing this app, we decided that bone age assessment is not enough, because to make the endocrinal diagnosis, we need some more things like anthropometry, pubertal status. We decided to club them all in a single tool, and we decided to develop a web tool for the guidance of evaluation of children and adolescents with growth and pubertal disorders. So it is a web tool, not available in the mobile. You have to, it is available in the web. And it is a very simple tool. You just has to put the anthropometry. Then you have to select the pubertal status by matching the image of the breast, the pubic hair, give the menarchal status. And for the input of the bone age, you can give the bone age by the selection of these 5 sites, or there is an option of manual entry as well. So within a click, within few seconds, you will get this beautiful pictorial growth chart, which shows the height, the weight, the MPH, and also the bone age. And you can see this is the detailed interpretation of all the parameters that are required for the diagnosis of various endocrine patterns. You can see there is a target height SDS, corrected height SDS, height SDS for bone age, and in the last, you can see there is also upper segment for the lower segment ratio, pubertal staging, and most importantly, it gives us what is the growth and the pubertal interpretation based on these findings, and it helps us what the next step worker should be done in each and every scenario. So this is the way where it gives the bone age, and also it gives the body mass index, sorry. So, and for the validation, when we looked at the result, we found that it showed, the big had showed a high concordance rate and has it improved the concordance by 96%. And when we see that the trainees and the pediatrician, the trainees missed lot of pathology, like in about 20% cases, and the pediatrician do overwork by 20%, 20.4% cases. And in this, we looked for the error, like in the normal patients, they were marked as short or precocious puberty. And when the endocrine etiology was overdiagnosed, when the normal etiology was overdiagnosed endocrine etiology, and Big has showed that when there is no requirement of any work done, the reassurance and follow-up was advised by the Big, and only in 6 cases it misdiagnosed the cases. So after developing the amazing tool, we decided that there is definitely a gap we are not able to reach the peripheries where all these web tools and mobile interpreters are not being used. So we decided to make a simple tool like we can just get the image and get the result in hand. So we collaborated with the IIT Kanpur and we developed a deep learning tool for the bone age assessment. There is all the steps that we have done. And in this algorithm, they have used the 5 sites that we have used in the mobile applications. And finally, it is a very easy tool. Just you have to, sorry. So, just you have to upload the X-ray and click on the whether the female and the male. Oh. So, and just on a single click, you will get the bone age in the months and the years. And I think it is pretty easy for the persons who are sitting at a long distance and they have the X-ray in their hand and they want to know what is the bone age, especially for the non-pediatric practitioners. Those for the bone age assessment is really tough. I think this tool is very helpful for them. And still we have validated, but still we need a multi-centric validation. And when we validated the tool, we have seen that the mean absolute error by using this deep learning tool was only 0.81 years, which is quite acceptable and very good result of an AI tool. And for this, we are aiming for multi-centric validation and integration of this just image-based tool in our big app. And we definitely want to incorporate in the EMR, and we are looking forward that more and the more people use this MediClasses application, the big web tool, and definitely this just X-ray image tool, which will be very helpful in the bone age assessment. As sir has rightly said, each and every tool is very important and equally like right in their own aspect. It is your own choice to use, whether you want to go through the Atlas, you want to go through the Tenet White House, or whether you want to go through these technologies. It's up to you, but the main aim is to this evaluate the right bone age assessment, which is important for the diagnosis of various endocrinal etiology. Over to you, sir.
Okay, Vibha has said like the spread in the dinner, you have a cafeteria of bone age tools available in front of you. But let's not forget Tanner Whitehouse 3 is old as gold. It's the most validated, most accurate, time tested. It allows you to predict height. Grulich and Pyle Atlas can be a good alternative. You have to use a Bailey pinout tables to do final height prediction. Gilson's and Ratib Atlas, more recent idealized images, its own prediction equations should be used to do a final height prediction. If the Indianized 5-bone method and 3-bone method are available, they should be used, but they have to be validated on larger sample, and the accuracy has to be tested in bigger samples. I think with that, I thanks for this opportunity. Thank you so much. And I request all of you to try out these with the X-ray that is there, the final height prediction, so you get a hang of how to do it on in your day-to-day work. Thank you.
Thanks a lot, Dr. Hemchand, for a wonderful discussion, and thanks for Dr. Vibha. We'll now request Dr. Nimisha to kindly honor Dr. Hemchand with a memento. हाँ और बाकी उन लोग हाँ बोला बोलिए जस्ट ओपन कर लेते हैं तब तक.
Good evening, everyone. Moving on to the last session. Last but not the least, we have a very interesting grand round on pituitary disorders. So I invite Dr. Rajni, Dr. Arun, Dr. Mahesh, and Dr. Aisha to chair the session. Now, handing over to Dr. Kirti to moderate the session.
We are in the last leg of today, which was very, very long, started at 10:30. And many of you would have been having these 10, 12-hour sessions for the last 3 days. So I'm sure this is very there, but we'll keep it crisp and we will keep it relevant clinically. I am really honored to have a very, very empowered panel. Professor Rajni Sharma from AIMS New Delhi, Professor Mahesh Maheshwari from AIMS Bhopal, Professor Aisha from AMU Aligarh, and Dr. Arun, who had a wonderful talk on skeletal dysplasia today from CMC Vellore. And I'm joined by Kirti, who is our fellow, at least for today. And then we'll go from there. So we'll be covering three broad areas: MPHD, most important, most common, hyperprolactinemia, and about AVP disorders in that perspective. So when we talk about the hypothalamic pituitary thyroid pituitary axis, remember that there is hypothalamus, then there is pituitary, and then there is an end organ. Generally, most signals from hypothalamus are stimulatory, with the exception of dopamine, which is inhibitory. So the tone generally is stimulatory except for dopamine. So if you have a lesion in the pituitary, obviously all hormones will be gone. But if you have a lesion in the hypothalamus or a lesion in the stalk or above, you would basically have a scenario where all the hormones will be low with the exception of prolactin. So prolactin is a very important marker of site of lesion. I would give you two more clues. One is diabetes insipidus. If you have a child with MPHD who has diabetes insipidus, the lesion is not in pituitary, it is in fundibulum or higher. And third is visual defects. If you have early visual defects, it's usually the pituitary lesion rather than a suprasellar lesion. So that is an important factor to look at. Radiation is a very common injury. In radiation, the first one to go is usually growth hormone. You may have initially precocious puberty and then higher doses will cause delayed puberty. ACTH is the last one to go. So ACTH is usually resistant to radio factors. But when we talk about autoimmunity, ACTH may be the first one to go. To infundibular hypophysitis, ACTH is knocked off early. Assessment we all know. So MPHD is two or more anterior pituitary hormone defects. So what we really do in that setting, you can use growth hormone testing. You can use T4. So FT4 low and TSS less than 20. This is what we consider central hypothyroidism. ACTH stimulated cortisol less than 550 and low levels of testoestrogen and water deprivation or copeptin. This is what will be a marker for AVP states from that regards. Management, of course, you use growth hormone, thyroxine, cortisol, and various other combinations in that regards. Remember, treatment of one condition may affect the other condition, and this is very, very important to understand. So when we give growth hormone, we are going to inactivate cortisol to cortisone as well as increase the metabolism of thyroxine. So we would be causing deficiency of thyroid and cortisol. So we need to increase the dose and screen for these conditions. Similarly, if we are treating for hypothyroidism, that may also trigger cortisol deficiency. So this interaction becomes important and you should monitor that. So anybody who has a central defect, hypothyroidism, always exclude cortisol deficiency. Similarly, cortisol actually inhibits AVP. So in individuals who have cortisol deficiency, AVP deficiency may be masked. And once you treat, the conditions may improve on that. So it may cause unmasking of DI. When we give estradiol, there will be increased growth hormone requirement because if you give oral estrogen, it is going to cause growth hormone resistance. Transdermal is safer in that regards. Estradiol will cause reduction in IGF-1. It will also increase TBG and your LT4 requirement may go up and your CBG requirement may also go up. So we'll now go on to the cases, Dr. Kirti.
Let's start with the first case. Here is a 12-year-old boy who presented with lethargy. On investigating, his free T4 was found to be 3.2 picomoles per liter. TSH was 2 units per liter. Cortisol was low and ACTH was 5.6. LH, FSH and testosterone, all three were low. So clearly there is multiple pituitary hormone deficiency. So this question is for Rajni ma'am. Ma'am, how do we proceed in this case and how can we localize the lesion to pituitary or hypothalamus?
Hello, Kirti. And as Dr. Anurag has mentioned, we would have to look at the prolactin levels, because if the prolactin levels are normal or low, if they are low levels, then that would suggest a pituitary lesion. Like as we can see here, that dopamine is the one that is antagonized. All the rest are stimulating from the hypothalamus, like GHRH, TRH, CRH, GnRH, are all stimulatory, but the dopamine ones are the antagonist. So if they are involved, then if there's a hypothalamic lesion, then it would lead to high prolactin. And if it is a pituitary lesion, it would lead to normal or low prolactin. So we have to look at the prolactin levels.
Yes, ma'am. So the prolactin in this case was 1.2 nanogram per ml, which suggested a lesion at the pituitary level. So, ma'am, what would your key messages be in this case?
So basically, that the workup of a MPHT is required, and there is central hypothyroidism because of low free T4 and normal TSH or low TSH, and the low prolactin level suggests a pituitary lesion.
Thank you, ma'am. So for our next case, we have a 1-year-old boy with seizures, and the blood sugars at that point was found to be 24 milligram per deciliter, and ketones was 2.8. Cortisol was 24, and growth hormone was 4 picogram per ml in the critical sample, and a stretched canal length was calculated, which was also 1.8 centimeter. So this question is for Mahesh sir. How do we approach this case, and are there any particular eye signs that we should look for that will help us diagnose this?
So yeah, so this is a presentation very early in the life. The 1-week-old child was presented with the hypoglycemia, and with hypoglycemia at the same time, there is a ketotic hypoglycemia, and cortisol is also low, growth hormone is also low, so counter-regulatory hormones are not working, and stage penile length is also 1.8 centimeters. There is a clear-cut sign that probably this is an MPSD, and such an early onset is definitely associated with probably a genetic cause or maybe a congenital malformation. So eye signs are very important eye signs. If there is a blindness or nystagmus, it is suggestive of septo-optic dysplasia. That is one possibility, or SX1 gene mutation. So these are the two common possibilities that will clinch just on the basis of asking one important history.
Right, sir. So like sir rightly pointed out, on eye examination, this child was found to have nystagmus and blindness, which was suggestive of SX1 mutation. So the key messages in this case, sir?
It's very important in any early onset child that you need to see hypoglycemia with micropenis is most commonly suggestive of MPSD, and blindness plus MPSD, you start thinking about septo-optic dysplasia.
Thank you, sir. Our third case is a 17-year-old girl who is a follow-up case of multiple pituitary hormone deficiency. She was already on growth hormone and thyroxine, now presented with delayed puberty, for which estradiol was started. She now complains of headache and lethargy, and an 8 AM cortisol was found to be 74 nanomoles per liter. And someone went ahead and got an MRI done, which showed an enlarged pituitary, and the clinical impression was pituitary macroadenoma. So this question is for Aisha ma'am. Would you agree with this, and what else would we want to do?
So here again, we have a girl who is a known case of MPHD and is on multiple hormone therapy. So, as very rightly pointed out, in such a case, once one axis is affected, so you always have to keep monitoring. Whatever the age might be, you have to keep monitoring. And this brain imaging is a very handful tool, so that should be. And look for other pointers in the history examination, and also what the pituitary findings might be. So as seen in the previous case, it was a congenital case, though on treatment. So keep monitoring for involvement of other axes, and look for features in the MRI findings, radiological features which might point towards a particular mutation, and ascertain the etiology of the underlying condition. So here in this case, as you could see, there was an enlarged pituitary. So look for other axes, involvement of other axes also. So there was definitely cortisol deficiency here. And also, so what I mean to say is the axis, the involvement, they might be evolving. So you have to keep monitoring and managing the child as the case may be.
So I think that is very important. So prop one is very unique because it is in the transaction. If you look here between the early growth and the late growth, it is like an orchestra which switches off the gene and then switches on the subsequent gene. So prop one defect can actually cause growth of previous genes. So unnecessary pituitary growth will happen. So that enlargement may happen. Size may be more, less, or equal also in that
Mimic
case.
a mass, but actually that was a genetic, a congenital cause.
So key messages in this case, ma'am.
So the message would be in case of enlarged pituitary and congenital the involvements, always think of a prop mutation and always look for other evolving hormone manifestations.
Thank you, ma'am. Our next case is a 17-year-old girl who presented with lethargy, weakness, and amenorrhea. She also had visual complaints in form of decreased visual acuity. Her LH was less than 0.1, FSH was less than 0.1, and prolactin was 60. Her cortisol was 16 and free T4 was 4.6. So, Arun sir, how would we go about this case?
So this child has presented with multiple pituitary hormone deficiency, as you can see from the investigations, and the prolactin levels are mildly elevated. So when there's a mild elevation of prolactin, you would, in the context of a multiple pituitary hormone deficiency, you would really think of a stalk defect mostly, and I would proceed with an MRI of the cella. So here in this MRI cella, you can see significantly thickening of the stalk, and so in a child, especially an adolescent with thickened stalk, you should always think of various differentials, including germinoma, LCH, sarcoidosis, and autoimmune uh, lymphocyte hypophysitis. Some of the other rarer differentials would be like neurotuberculosis or an IgG4 disease. And since this child is presenting in adolescence, there is a high likelihood that this could be an autoimmune condition. But however, we should never forget to rule out germinoma and LCH in this child before labeling this child as autoimmune. And even if we label this child as probable autoimmune in the beginning, we should continue to keep this child under follow-up. That is also very important. Somebody who has a stalk thickening.
Thank you, sir. So the key messages in this case.
So any child with multiple pituitary hormone deficiency, MRI of the cella is essential. And any child with stalk thickening, especially in adolescent age group, autoimmune is highly possibility. But we should always also think of other differentials like germinoma and LCH.
So I think in this setting, maybe getting a HCG, AFP level, maybe a CSF HCG, they may also be indicated. And definitely, if you're not doing, you should follow up MRI after 3 months, 6 months. That becomes important.
Thank you, sir. Our next case is a 15-year-old girl who presented with low-grade headache for a while, followed by sudden increase since morning. So on presentation to the ER, she was actually found to be in shock, and her sodium was 120 and potassium was 3.8. Cortisol was 16 and free T4 was 4.6. So Rajni ma'am, what would the differentials be in this case, and is there anything we need to do on an emergent basis?
This girl has suddenly developed headache and maybe some features of raised ICT, and she's also in shock. So all these features, and based on what she had previously, we would suspect pituitary apoplexy because her electrolytes are, sodium is also low, and she has features of adrenal insufficiency and TSH deficiency also. So pituitary apoplexy, basically it can result from trauma, medications or anticoagulants, and then it would result in severe and sudden headache. And then secondly, it can result in hormone deficiency and pressure effect. Pressure effect can result in headache and ophthalmoplegia due to various third, fourth, and sixth nerve involvement. At the same time, patient can also have neck rigidity, and some features can present like meningitis as well.
So the key messages, ma'am.
So if you have a patient who presents in shock, who has features of ophthalmoplegia and headache, vomiting, then you should suspect pituitary apoplexy, especially if there's underlying condition also affecting the pituitary, and give urgent steroids for
I
management.
think one point which we forgot to mention was that she did have a ptosis which was there, and that was classically the giveaway sign in that regards. And the history was that she was having headache, but this was the most severe headache she ever have in the life. So like we say for subarachnoid hemorrhage, even for apoplexy, this is the typical presentation.
Thank you, ma'am. Our next case is a 16-year-old girl who presented with delayed puberty. Her height was 144 centimeters, which was short, and weight was 41 kgs. Her LH was 0.1, FSH was 0.3, estrogen was 10, prolactin was 32, and cortisol was 24 nanomoles per liter. So, Mahesh sir, what would we think in this case, and how would we go?
So I will just extend Dr. Arun's presentation. I think this is almost behaving in the similar way, but only thing that will probably make the other differential diagnosis other than the LCAs and autoimmune of hypospicitis is the height is 144 centimeters. So that height is a little on a lower side. So that says probably there may be a possibility some congenital malformation that is presenting a little late. So obviously in any, just like Dr. Arun said, the message was to do an MRI. So this MRI is clearly showing there is a cystic mass rising from the salar region is if with the fine margins. So it's most probably a Rathke cyst and is causing the compression on the pituitary, and that is the reason why this MPHD clinical features are appearing at this point of time. So
and the very characteristic feature, if you go back, was this basically enhancement. And the enhancement around the membrane is a characteristic feature of Ratkes cyst. Yeah.
Right.
Yeah, so management wise,
Go back.
yeah, so management wise, if you ask Rathke cyst management, most of the time it will not require any specific management. But if this is really large, cause producing a symptoms of raised ICT, then definitely you need to manage and do a surgical intervention. Otherwise, you can just manage the MPHD and just like Dr. Rajni said, first treat cortisol, then thyroid, and then start with the other hormonal preparations.
Right. So for our next case, we have a 16-year-old girl, a case of MPHD. She received growth hormone and was also on thyroxine and estrogen. Now she presented with lethargy and weakness. Her cortisol ATM, however, was 156 nanomoles per liter, and even after synactin stimulation test, it was 620 nanomoles per liter. So she was discharged at that point of time. She was reassured and kept on follow up. However, a few days later, she had fever and presented with shock and a sodium of 120 millimoles per liter. So, Dr. Aisha, ma'am, what do you think happened in this case, and how could we avoid it?
So here again, we have a adolescent girl who's a diagnosed case and already on treatment. And she had features, and as you can see, so you suspected maybe involvement of some other axis, and you suspected cortisol deficiency to be the reason, to be the culprit. But on biochemical evaluation, it came out to be normal. Okay, so that's perhaps that's why the child was reassured and sent back. But again, there was the point, something was missed. So always, as it was very nicely discussed by Anurag sir, that whenever a child, a person is on hormone treatment, so always suspect interactions. Okay, so these hormone treatments might affect not only the drugs but also the biochemical evaluation as well. So the child went eventually into, she had cortisol deficiency and eventually went into adrenal crisis. So because the catch here was she was already on estrogen. So estrogen, as it was suggested, that it leads to high CBG, or that report actually was falsely elevated. So always look at the clinical context and interaction between the hormones and also the drugs the child is on.
And that is very, very difficult because the cortisol levels may go very, very high.
Yeah.
So the options theoretically is some people talk about salivary cortisol.
Yeah, because
But
that is
we
not
don't have much.
affected.
Do you use salivary cortisol in this setting? Cushing's, but even for the adrenal insufficiency, some people are talking about that. But that needs more validation on that. But
Yeah.
that will give you a free picture.
Yeah, another thing could be that there should be use of transdermal estrogen because that does not affect
Yeah,
CBG
the effect will
levels.
be much lower than that. Yeah.
Thank you, ma'am. The next case, we have a 4-year-old boy with multiple pituitary hormone deficiency. He was on thyroxine of 50 microgram per day. Now he was started on growth hormone for at 25 microgram per kg per day. And on his follow-up, his free T4 was found to be 6 picomoles per liter. So Arun sir, what do you think happened here and what is the cause for this?
Okay, in this child with multiple pituitary hormone deficiency who had central hypothyroidism and already on thyroxine, once this child was started on growth hormone therapy, we've noticed that the free T4 levels have come down. Actually, there are multiple causes for this. One is that growth hormone leads to increased conversion of T4 to T3, and also it also increases the metabolism of thyroxine, and so it usually even those children who are not hypothyroid in the beginning, sometimes they develop the unmasking of hypothyroidism occurs once growth hormone is initiated. So it is very important to monitor the thyroid function tests in these children when they are on growth hormone therapy.
So the key messages, sir?
So the key messages are that growth hormone therapy can unmask central hypothyroidism, and for central hypothyroidism, we should always do free T4 monitoring, not just TSH.
Thank you, sir.
Yeah, so again about hyperprolactinemia, it is less common in pediatric, but definitely in adolescent age group, we do see a lot. And lot of drug-induced hyperprolactinemia is becoming common because children are getting a lot of these antipsychotics, their SSRIs and domperidone and everything is becoming common. So hyperprolactinemia basically could be because of various reasons. You most sinister, of course, we are worried about is the PITNET, which is the pituitary neuroendocrine tumor. Remember that if you have a pituitary neuroendocrine tumor, the prolactin level will be very high, at least more than 100. So that will be the clear-cut cutoff if you talk about prolactinoma, or now we call it PITNET. The larger the size, the larger the prolactin levels. If it's a macroadenoma, it should really be beyond 300, 400. Other reasons could be a stalk lesion or a stalk compression, which we talked, because the inhibitory influence is gone, so prolactin will go up. In this scenario, it rarely or it will never go above 100. So if you have a large lesion with a prolactin between 40 to 100, you start thinking of a non-functional lesion, or we discussed about the other assay issues of hook effect, which can also be there in that perspective. So hypothalamic lesion or radiotherapy, usually the levels again will be less than 100. Pregnancy is a very, very important condition to remember because pregnancy is the most common cause of hyperprolactinemia, most common cause of amenorrhea, most common cause of galactorrhea. In that setting, the prolactin may go up to 400, and we have had burnt our hands in adolescent girls whom we are working for amenorrhea and prolactin was very high, and then you will find that they had pregnancy. So this is something which is important. Drugs, and I would say drugs, three drugs: domperidone, risperidone definitely is one agent which causes huge elevations, go up to 200 nanogram per ml. Hypothyroidism can also cause 50 to 100 because when you have hypothyroidism, TRH goes up. That causes dopamine, that causes direct effect on prolactin as well because it's a prolactin stimulating hormone. Liver and kidney disease cause minor elevations. So that becomes important. Also, there are analytical issues in which you may have more immunoactivity than bioactivity, which is basically a macroprolactin. You don't have symptoms, you have high prolactin. Or when you have symptoms, the levels are not high, which is the hook effect. So here you need to do a pegylation study, and here you need to do a dilution study, which will give you the clear-cut idea. Very important differential often is a pituitary mass or a cellular mass in which you think of it as functional versus non-functional. So if your prolactin is very high, it is prolactinoma. If the size is very high, then only non-functional will cause high prolactin. Small hypothalamic lesion will not cause. That is important. And of course, symptoms will be much more with non-functional tumor in that perspective. So if your prolactin noma is less than 10 mm, it's usually less than 200. If it's between 10 to 20, so as I said, it is a size dependent scenario, which will give you a picture. Just a word of when you have a large lesion with prolactin less than 100, it could be a cystic lesion, undifferentiated lesion, hook effect, or a non-functional lesion. And this is the final approach we like to do. First, exclude secondary causes and then repeat the level. If the levels are above 100 and there are no drugs there, you should do an MRI head in that perspective. If they are on drugs, stop it for 72 hours. That is good enough to really recover. If it is 20 to 100, you repeat and then start thinking of a non-functional. Do not let them go from that perspective. Treatment, I think, in most cases will be dopamine agonist cabergoline, and now surgery may also be considered in certain scenarios in that regards.
Coming to the case scenarios, here is a 14-year-old boy who had gynecomastia, came with the complaints of gynecomastia, and he had a little bit of breast enlargement. His testicular volume was found to be 12 ml bilaterally, and he had a pubic hair stage of 3. His LH was 1.8, FSH was 2.4, and testosterone was 120 in the pubertal range. His prolactin was also done as a part of workup, which was found to be 120 nanogram per ml. His MRI head was done, which was normal. So, Rajni ma'am, what do you think should be done in this case?
So first of all, gynecomastia, the child has presented and he's pubertal in stage 3. And so LH, FSH and testosterone all within normal range. So ideally we don't have to measure the prolactin, but if we have measured it and it has come, and normally if the prolactin is a little bit high, it would suppress the gonadotrophins. Here the gonadotrophins are normal. So it's unlikely to be a cause causing any effect. So then most likely it could be an error in the lab. So due to the, or it could be due to macroprolactin, in which the prolactin has is in dimeric or polymeric form bound to immunoglobulin. And it's not acting because it doesn't enter the cell because of the large size. So nothing has to be done. What we can do is we can just document by doing a pegylation study. So this pegylation will bind to that dimeric and polymeric forms and precipitate them. And what is left is we can measure the monomeric forms. So if it is more than 60% is monomeric, that means it was a macroprolactin.
Thank you, ma'am. So your key messages in this case?
Yeah, so if we have an asymptomatic child who doesn't have manifestations of hyperprolactinemia, then we should think of macroprolactin and we should do a pegylated sample.
Yes. Thank you, ma'am. Our next case is a 13-year-old girl who presented with headache and visual complaints. Her prolactin levels were done, which was found to be 60 nanogram per ml. Mahesh sir, how would we approach this case?
So any child who is acutely presenting with headache and visual complaint, the diagnosis comes to us with some neurological pathology, maybe infection or maybe an intracranial space occupying lesion, and the prolactin is 60 nanograms. So immediately we start thinking about probably are we dealing with the prolactinoma or other intracranial space occupying lesion. But in the algorithm, Dr. Anurag is very clearly said anything that is between 20 to 100, it's better to repeat it and then confirm a non-functional causes before thinking about even MRI. So in this particular child, as you did the MRI, so there is an homogeneous with clear margins, there is a smooth homogeneous mass that is there arising from the pituitary. So probably it looks like to be just let's say physiological enlargement or because of the effect that thyroid hormone can produce.
In this
So
case, this MRI was done and somebody also advised surgery. So would you agree
sir.
with that?
So it is again surgery that those masses are usually the irregular in nature and they usually have a more arising from the pituitary base. So this looks like to be a tumor. And as in the previous slide, Dr. Anurag already said that whenever there is a hypothyroidism, a long-standing hypothyroidism will result in increased TRH, and this increased TRH has a physiological effect on prolactin, and that thyrotropes and lectrotrop both are increased, and that will increase the size of pituitary gland, and that was the reason why this is there.
Rightly said, sir. In this case, the child also had coarse faces and other features suggestive. So when we got a thyroid function test done, free T4 was 2 and TSH was more than 100.
So that is very clearly suggesting prolactinoma, so suggesting this thyroid physiology, and once we treat this thyroid, this enlargement will also come down to the normal size.
Actually, this is a very common referral we get from neurologists. And they say that there is a big lesion and then we got prolactin, it is high, you give cabergoline. And when you see the child, I think you cannot miss. It is a very clear. So it is not going to happen with mild hypothyroidism. They will be clearly hypothyroid. So we had one child who had got pituitary hyperplasia, high prolactin, also had features of von Wieck-Grumbach as well. So this is those who are absolutely very, very severe cases, but they will come to the neurologist and they will send us.
So key messages in this case, sir?
Whenever you will get a high prolactin, that is somewhere between 20 to 100, repeat the sample and do the free T4 and TSH in those cases. And always think that pituitary hyperplasia sometimes confused as a mass. So you need to be very careful when deciding the further management related with the mass.
Thank you, sir. Our next case, we have a 16-year-old girl who presented with galactorrhea. She also had headache and vomiting, and prolactin was 34 nanogram per ml. An MRI was done, which clearly shows a lesion at the pituitary level with the figure of 8 appearance. However, prolactin was 34, which was unexpected. So, Aisha ma'am, how would we go about this and how would we explain the discordance?
So while that's what we have been discussing, so you have to look at three parameters: the radiological parameters, the clinical parameters, and the biochemical parameters. So as you can see here, clinically she has a typical. So once you have a patient presenting with galactorrhea, what comes to your mind is something to do with prolactin. And then you have radiological, there you have a big mass. So you have two positive thing and you order a biochemical analysis, but the prolactin came out to be normal, which we were not expecting. So and the child has symptoms also. She has features of raised ICT. So I'm sure the audience will have a clue. This was discussed earlier as well. So perhaps the problem lies in the analysis, the analytical error, you can call it. So that was because of the hook effect. But you have to look for other reasons also, like it could be a non-functional reason. So you have features to suggest involvement of pituitary, but the biochemical parameters is not corroborating that. So look for hook effect because the assay that we have been using is a sandwich assay, So what happens when the levels are extremely high? So they bind both the tracer and the reporter antibody, the reactor antibodies as well. So the results are falsely low. So the how to mitigate, how to take care of that, rectify that, you have to go for dilution of samples. So that is what I think should be done in such a scenario.
And I think the biggest sign here was galactoria is
Galactoria.
there. So this cannot be non-functional. So
Non-functional.
prolactin is biologically there.
Agreed, agreed.
Key messages in this case, ma'am.
So key message, always look at the child in toto, look for the clinical features and then corroborate it with your radiological findings, and also take that biochemical parameters and analyze them together. And it has to be repeated in dilution, and that came out to be normal after that.
Hi. Thank you, ma'am.
Hi.
Our next case, we have a 17-year-old girl with amenorrhea for 3 months. She was breast stage 4 and pubic hair stage 4. LH and FSH was less than 0.1. Prolactin was found to be 500 nanogram per ml. Arun sir, any thoughts on this and how should we go about it?
So in this child, an adolescent girl with who's presenting with secondary amenorrhea for 3 months. So what is unexpected is that this child has known in this biochemical picture shows hypogonadism with low LH and low FSH, and the prolactin is very elevated, very high, 500 nanograms per ml. So when prolactin is so high, like 500 nanograms per ml, there are only two differentials that you would consider in this case. It could either be a prolactinoma causing the hypogonadism, or it could be the more commoner cause, like sir was mentioning. We should always rule out pregnancy before going ahead with an MRI. So here, interestingly, the estradiol levels are 400 picograms per ml. So if it was a prolactinoma causing hypogonadism, the estradiol levels also would have been very low. So here, the estradiol levels are quite high, which is in favor of child having coming in pregnancy. This is a common scenario. We've also had a few patients who adolescent girls presenting with secondary amenorrhea who are initially suspected to have a pituitary lesion. And here, the next step would be to do a HCG test to diagnose pregnancy.
So
I think
HCG was 5,000.
Yeah, just a practical tip, don't go for urine pregnancy test because then there'll be lot of issues which will be there. So better to do simple HCG, then they will get it done on that.
Key messages, sir.
So in a girl with secondary amenorrhea, always HCG to rule out pregnancy is an earlier step than going to do an MRI.
Thank you, sir. Our next case is a 14-year-old boy who presented with headache, and on workup, his prolactin was found to be 80 nanogram per ml. He also got an MRI done. So here we can see that there is a pituitary lesion, but how do we differentiate whether it is cellular or supracellular, and how does it matter, Rajni ma'am?
So basically, as we can see that the prolactin level is, not less than 100. So it could be because of the stock effect, that there is a pressure on the stock. Then we would have to, as this has mentioning, so it is 2200. Then we're going to see that, going to repeat it. And if it is again between 2200, already we have a lesion on the MRI. So that is the thing, that if it is a stock, if it is a pituitary lesion, then it could be a stock effect. And then we have to see the functioning of the lesion, whether there are any, by measuring the pituitary hormones.
Right. Yeah. Thank you, ma'am. Key messages would be if there's
That
a
if-
large.
Yeah, if there's a large mass and prolactin is less than 100, we can think of supracellular mass. And if pituitary rim is present, then adenoma.
Thank you, ma'am.
Yeah, so finally about AVP disorders, basically two things. One is AVP deficiency and AVP resistance. So we don't use the term diabetes insipidus now. So it's AVP deficiency. We can say impaired AVP effect, AVP deficiency or AVP resistance. AVP deficiency invariably means that you need to have some lesion. So considering somebody as idiopathic AVP deficiency is not acceptable. They will usually have some problem, and acquired one usually will develop germinomas on follow-up. So I think that is a big message. Congenital ones are because of malformations. Acquired are usually some tumors like germinoma. Histiocytosis is common before 5 years of age. And you can also have some supracellular lesions. AVP resistance is a different ball game altogether. The most common cause that we see are X-linked AVP resistance, which typically present around 6 months of life with failure to thrive, dehydration, developmental delay, mental retardation, and sometimes you will have calcifications there. That is something which is there. So approach clearly is that when your plasma osmolality is more than 300 or sodium is more than 146, if your urinary osmolality is less than 300, this is clearly impaired AVP effect. You give a AVP response to differentiate AVP deficiency versus resistance. Remember, long-standing DI may have quote-unquote secondary nephrogenic DI or secondary AVP resistance because of washout of the medullary gradient, and that is something we have to watch out. Copeptin-based assessments are also emerging as tools, and a lot of studies have been done on that. And if you have what I would say, they are much better to identify or exclude AVP deficiency in that regards. So you can basically use basal or stimulated copeptin levels, and various cutoffs are there. Unfortunately, the tools are not very easily available. They are still in research in India, but in Western countries, they are the way to go forward in that regards. Very importantly, if, as I said, if you diagnose AVP deficiency, don't stop there. Do an MRI. Even if it is normal, you do a follow-up MRI after 6 months, 6 monthly for 2 years, and then follow up. If the size increases, go for biopsy. If there is talk thickening, as we discussed, Dr. Arun talked very nicely about that, think of germinoma. So CSF, HCG, AFP, and skeletal survey for histiocytosis can be done in that perspective.
So our next case is a 10-year-old girl who is a case of craniopharyngioma. She underwent neurosurgery, and on around day 6 of post surgery, she developed polyuria at 5 ml per kg per hour. Vasopressin infusion was started for this. However, post this, she developed seizures, and her sodium was found to be 128 millimoles per liter. So, Mahesh sir, what do you think happened in this case, and what went wrong?
It's very important to understand that whenever we do a craniopharyngioma or any neurosurgery, it was a learning that the child is going to develop an AVP deficiency in later on. So in this child, when the polyuria was started 5 ml per kg per hour, someone thought about AVP deficiency and started vasopressin infusion, and this child developed symptomatic seizures, maybe because of hyponatremia. So here it is very important to understand that whenever a neurosurgery patient or craniopharyngioma surgery was done, there are 3 phases that is there. So initial phase is actually the swelling phase. So that because of the injury, the AVP's neurons actually got swelled up, and that will result in decreased AVP supply. So AVP deficiency will be there, and that will result in transient DI. And that transient DI lasted for 2 to 3 days. And after 2 to 3 days, this will go in the degeneration phase. And once this start degenerating, all the stored AVP will come in circulation. And the moment it will come in circulation, it will cause an SIAD. So, and after that, once this degenerative process will complete and there will be a complete necrosis, again there will be a AVP deficiency and child may develop the permanent DI. So this whole process actually require almost in 2 weeks, but it's not necessary that all children will go in this phases. So we need to be very careful when we are thinking about the treatment part. So when we think about the treatment, most of the time in the transient DI or the acute DI phase, it can be managed on the basis of fluid alone. So if you give the 40 ml per meter square n by 4 and add the urine output for, on 5% dextrose above, maximum is 120 ml per kg per ml per meter square per hour. The one drawback that this can cause dehydration if the polyuria is significant enough. If the polyuria is more than 5 ml per kg per hour, in that scenario, you need to add the arginine vasopressin. So in our child, what will happen, the moment we started arginine vasopressin, the child is actually gone into the SIAD phase. And this is the reason the child develops sudden hyponatremia, and that hyponatremia resulted in seizures. So this is very important to understand.
Yes.
And avoid the desmopressin to fixed dose combination, start with the low dose titration.
So the same child came for follow-up 1 year later, sir. She is currently on DDAVP at 100 to 200 microgram per day. She has now complaints of decreased urine output, and her serum sodium was found to be 128 millimoles per liter. She also had lethargy and weakness.
So again, we can just think of that is this an improvement? But we already seen that there isn't diabetes insipidus develop in the later phase. And again, because the decreased urine output, serum sodium is started going down. Someone may think that this arginine vasopressin is started actually working. But this is not true in this particular case. There is a secondary adrenal insufficiency that start evolving in the later phase. And that is adrenal insufficiency. And in the beginning, only in the MPSD introduction, Dr. Anurag said there is an inverse relationship between the cortisol and the AVP. So if the cortisol will come down, the AVP will start acting more. So in this child, the same scenario is happened. And because of this cortisol deficiency, there will be a more AVP effect. And that will resulted in actually this hyponatremia and lethargy and weakness. And her cortisol is also came down to 74. So it is definitely low. So you need to start the treatment as per the, and so this will mask the DI if there is a cortisol deficiency.
Rightly said, sir. The cortisol ATM was found to be 74. The key messages here, sir.
So you need to you need to understand there is a triphasic phase after the surgery. So you need to remember that avoid preferably AVP in the acute phase. If required, then used to be in a controlled manner. And cortisol deficiency masks the DI. Once you give the hydrocortisone, again the DI will manifest. So it is very important to understand.
Thank you, sir. Our next case is a 3-month-old girl who presented with dehydration and had doughy skin on examination. Her sodium was found to be 162 and urine osmolarity was 120. So a water deprivation test was done here. And post this, the child developed seizures and also intraventricular hemorrhage. So Aisha ma'am, do you think this should have been done in this case?
So here we have an infant who presents with doughy skin and hypernatremia, which is quite severe. So the instinct is to subject the child to water deprivation test, which was done here and which was not proper because the child had even full water deprivation test. So there are certain conditions where water deprivation is not required, and the findings, the baseline findings itself point towards the diagnosis. So thus with such high sodium levels, water deprivation test is not warranted at all. Then there are other conditions like if urine osmolarity is more than 600, so there is that rules out diabetes insipidus and does not warrant any further treatment. So in this infant, the baby had sodium more than 145. So actually this water deprivation test was not needed at all for this. And in the serum sodium is very low, like less than 130, then that rules out diabetes insipidus. So it's not always that in every case of hypernatremia, you have to go for water deprivation test.
So that will be really hazardous. And similar thing will happen if you have somebody who has a severe DI and you tell them don't drink anything from night, come in the morning. And by the time they will develop hypernatremia. So if there is severe DI, tell them, okay, continue drinking and then maybe 5, 6 o'clock, then you can stop. That is something important.
Yes. Thank you, ma'am. Our next case is a 12-year-old boy who is a case of central diabetes insipidus and has been diagnosed 2 years ago. At that point, an MRI was also done, which was told to be normal, and he was started on vasopressin. However, now 2 years later on follow-up, he presents with seizures, headache, and serum sodium, however, was found to be 142 millimoles per liter. So, Arun sir, how would we approach this case?
So, like Sir had previously discussed, any child with an AVP deficiency would most probably have an etiology, underlying etiology. Even if the MRI is initially normal, we should still keep these children under follow-up. Ideally, they say you have to monitor 6-monthly MRI until a period of at least 3 years, and then annually. So MRI should have been done in follow-up for this child. So despite the child having a normal sodium, child has developed seizures and headache. So I would think of a new of probably an intracranial lesion which is developed. So in this MRI, you can see that there is a like a germinoma. There is a mass sitting in the penile region with some calcifications, and also another suprasellar mass as well. So this child probably has germinoma, and the message is that in a child with AVP deficiency, an MRI head should be done, even if it is normal. They should be followed up 6 monthly for at least 2 years, and then annually. And if they are stable, and biopsy if there is stalk thickening more than 6 millimeter, or if there is an increase of more than 15%. And if there is stalk thickening in the baseline itself, you should always, like Sir said, we should do a CSF, HCG, and AFP to rule out a germinoma, and a skeletal survey to rule out LCH.
Thank you, sir. Our next case is a 3-year-old boy who presented with polyuria, and on investigation, his serum sodium was found to be elevated, 154. His urine osmolarity, however, was 180. And on examination, his mother also complained that the child had persistent rash, which was on the head, which was not going away with treatment. So, what would be our suspicion in this case, ma'am, and what diagnostic test would help us?
So basically, this patient has polyuria, hypernatremia, low urine osmolarity. So this suggests that it is diabetes insipidus, and he has a rash, seborrheic, maybe dermatitis, and perhaps he could have ear discharge as well. So all these things point to LCH. And so we have to rule out LCH, and for that we may have to do a first we can do a skeletal survey to look for any punched out lesions on the X-ray skull, and then we have to proceed to biopsy, skin biopsy.
Right, ma'am. So he actually had evidence of punched out lesions and seborrheic dermatitis as well, as we can see here. So this child was planned for chemotherapy, and he was advised adequate hydration. However, post this, he developed respiratory distress and subsequent pulmonary edema. So what would we advise in this case, ma'am?
So basically, when they give chemotherapy, they give increased amount of fluids. So was this child on desmopressin? So if he was on,
No, ma'am.
okay,
No, he was on desmopressin.
yeah. So then he would have been on desmopressin, and that was the reason why when we gave excessive fluid, then he went into he had fluid retention, then he had respiratory distress. So we always have to be a little careful when we give such children fluids. So at that time, we may have to, discontinue the oral and maybe give a controlled amount of, infusion of AVP. And we have to monitor the urine output to keep it at around 2 to 4 ml per kg per hour so that he doesn't develop any fluid overload or electrolyte imbalance.
Right. So key messages, ma'am?
So early onset acquired diabetes insipidus with all other features, also always suspect LCH. And when they're getting chemotherapy, then be careful, especially if they're on desmopressin regarding the fluid balance.
Yes, ma'am. Thank you, ma'am.
So the other scenario is, of course, when we have inappropriate AVP secretion, the term again has already been changed from SIADH to SIAD, because there is also a term called nephrogenic SIADH. So people have made it and nephrogenic SIAD and SIAD. Anyway, terms is different. It basically is a situation wherein you have dilute blood and concentrated urine. AVP deficiency is concentrated blood and dilute urine. So it's an opposite scenario. In that you have got plasma osmolality, which is low, but urinary osmolality is high. And this is how you will identify SIADH. But what you also mean is that you need to exclude some other conditions. You should have a normal adrenal, renal, thyroid, and liver functions. And there should be no dehydration, or there are diuretic cues, because they can all cause shifting of this curve to the left side. So you should have normal hydration, no diuretic use. This is something which is extremely important. And saline infusion should not respond. Treatment options for SIADH, I would say, are limited for children. Fluid restriction is what we should do. Tolvaptan and V2 receptor antagonist have a risk of causing rapid rise in sodium, should be generally avoided unless it is a malignancy associated. Urea is a thing which has been used in nephrogenic SIADH. Rajni, I think, has experience in use of urea. You had mentioned earlier on that. And there are newer treatment which are coming up in adults, like empagliflozin has been used in adults in that perspective. So these are there, but usually it is fluid restriction in that regards.
Thank you, sir. Our next case, we have a 14-year-old boy who presented with drowsiness. On examination, he was euvolemic and urinary sodium was 100 millimoles per liter. Urine osmolarity was 300 milliosmoles per kg. So he was diagnosed with SIADH and he was put on fluid restriction. So do you think that should have been done in this case, my sir?
I think the knowledge what we gain, I think this is the right treatment, but you need to be very careful whenever you are doing. There should not be any the dehydration, or neither there should be an hypervolemia. It should be euvolemic, but the primary treatment is fluid restriction. So whenever you do the fluid restriction, you need to be very careful. You need to do a free T4 and cortisol before making that decision of restriction of fluid or continuing with the normal fluid, because so it's very important to do in this child the free T4 and cortisol. So,
Yes, sir. This child actually had worsening after treatment.
so this probably that may be the one of the reasons. So once we do free T4 and cortisol, the child is again gone into the adrenal insufficiency and required, and the treatment in that scenario is more fluid. Here we restricted the fluid, so actually that created the more problem.
Yes, sir. Key messages, sir.
So key messages is cortisol and FT4 before diagnosing the SIAD. That is the most one of the important decision that you have to take before taking a decision of treating with fluid restriction or not.
Right. Thank you, sir. Our next case, we have a 11-year-old boy who came with traumatic brain injury. He was admitted in the ICU and with adequate management, he had improvement. However, he presented with seizures on day 2 of admission. His sodium was found to be 125 millimoles per liter, and this is a common scenario we see in the ICU. And our common differentials are SIDH versus cerebral salt wasting. So, why is it important to differentiate between this, and how would it affect our management, Aisha ma'am?
Yeah. So here we have a situation that the boy has undergone a brain injury and required treatment, and he had seizures. So as you can see, the sodium levels are low. So the point is we have to differentiate between SIADH and cerebral salt wasting, because the management will be different in both the situation. And the scenario is that the child can have both of the things. And there are many features which are common. So you have to differentiate between that. So like in the SIADH is a euvolumic state, whereas in CSW you will have a dehydration of or a hypovolumic state. So there are many parameters which are common, like the urine output would be decreased, but rather it would be increased in cerebral salt wasting. And then you have to look for serum sodium, which will be low in both the situations. The urinary sodium is a very good pointer because it will be elevated in salt wasting as compared to the SIADH. And the hematocrit would be reduced, as I said, in SIADH because of the dilution, hemodilution, whereas it will be elevated in salt wasting because it is a condition of hypovolemia. So one differentiating feature would be to have a look at the uric acid, which might be low in the initial setting, but later in cerebral salt wasting, it's high, and it's low in SIADH. So you have to look for volume status, you have to look for urine sodium levels and uric acid to differentiate between the two conditions, because the management you can see is altogether different. You have to restrict fluid with SIDH, whereas the volume has to be replenished in case of CSW. So the lower uric acid would suggest SIADH, whereas it's normal, so you have to go for cerebral salt wasting. So
Thank you,
that's why
ma'am.
it's easy.
So for our last case of the day, here is a 13-year-old girl who was a case of tubercular meningitis. She presents with drowsiness and the sodium was found to be low. Urine osmolarity, however, was 130 and was elevated given the dilute serum. She had normal free T4 and cortisol, and she was found to have SIADH. Now, an overenthusiastic resident like me reads up a few papers and comes and asks if tolvaptan can be given in this case. So, Arun sir, what do you think?
Okay, so in this child, a 13-year-old girl with TB meningitis, this is proven SIDH with all the parameters and was started on tolvaptan. So first of all, tolvaptan is quite a dangerous drug in children. We've burned our fingers also with tolvaptan with a few children during my DM period. Tolvaptan can actually cause very wide fluctuation. Tolvaptan is a V2 receptor antagonist. The problem is that in children, it can cause very wide fluctuation of sodium with the first dose, initial doses of tolvaptan, and then later they start developing tachyphylaxis. So this rapid rise in sodium can cause all these complications. And the important point is that we have to gradually correct hyponatremia. If they're symptomatic, then we should give 3% saline boluses, and then we should always maintain the correction status to like less than, if it is if they are symptomatic, you can allow 8 to 10 per day, but if they are asymptomatic, maybe 6 to 8 millimoles per liter per day of sodium correction would be appropriate. And vaptans especially should be avoided in acute hyponatremia. It is only indicated in very few scenarios, like sir mentioned, in malignancies. In chronic SIDH, it can be tried. That also not an approved indication, but has been mentioned in a few case reports.
Thank you, sir.
So I think thanks a lot, everybody, for continuing from 10:30 in the morning to now it's 9:45. Thanks a lot, Dr. Rajni, Dr. Ayesha, Dr. Mahesh, Dr. Arun, Dr. Kirti. And I think three cheers for all the audience to be there. So many audience are still there since morning. And I think there is nothing which waits between you and dinner. So I think dinner can be started now. चेतन जा रहे हैं क्या?
नहीं मतलब सुबह 7 बजे निकलना।
अच्छा 7